Now, some people. Hi, it's Conrad Fisher, and here's our next section, Hematology. I'm the Associate Professor of Medicine at Truro College of Medicine and the Director.
We will now move on to cardiac rhythm disorders. The first step to any potential cardiac arrest is make sure the patient is truly unresponsive. It is critical to make sure this patient is not sleeping or just having a syncopal event. Performing chest compressions and giving rescue breaths on a person who is breathing is counterproductive and dangerous. Next, call for help, call 911, and activate the EMS service. If he is truly unresponsive, start chest compressions and give rescue breaths. After the patient has been shown to be unresponsive and EMS is on the way, the next step is to open the airway, head tilt, chin lift, jaw thrust, check for a pulse and start compressions if pulseless, give rescue breaths if not breathing. Remember, CPR doesn't restart the heart. CPR keeps the patient alive until cardioversion can be performed. The precordial thump has been sensationalized by TV, but when is it the correct answer? When there's been a very recent onset of arrest, that means less than 10 minutes with no defibrillator available, or you know it's recent because you saw it and witnessed it yourself. There are 4 major arrhythmias that can cause a sudden loss of pulse. The first is asystole, ventricular fibrillation, ventricular tachycardia, and pulseless electrical activity. The best initial management for all forms of pulselessness is always CPR, CPR, CPR. When presented with a pulseless patient who is in asystole, besides CPR, the best therapy is epinephrine. Vasopressin is an alternative to epinephrine. What they do is they constrict blood vessels in the tissue and raise your blood pressure. They also shunt blood to critical central areas, such as the heart and brain. The best initial therapy for somebody in ventricular fibrillation is an immediate unsynchronized cardioversion followed by CPR. Unsynchronized equals defibrillation always. Why is that? Well, generally, all electrical cardioversions should be synchronized to cardiac cycle, except for VFib and pulseless VTAC. The reason is in VFib, there is no organized electrical activity to synchronize with, so shock them right away. Only VFib and VTAC without a pulse get unsynchronized cardioversion. Everybody else needs to be synchronized. Now here's an example of a 12-lead EKG with a patient in ventricular fibrillation. Notice there's no organized electrical activity. After an attempt at defibrillation, the most appropriate next step in management is epinephrine or vasopressin, then follow with another shock. Medications do not restart the heart. They simply make the next attempt at a defibrillation more likely to succeed. Amiodarone and lidocaine is given to try to get subsequent shocks to be more successful, and magnesium is given with ventricular arrhythmias without waiting for a level. Lastly, remember, beryllium is always the wrong answer on the Usmle. Ventricular tachycardia is a wide complex tachycardia with a regular rate. The management, however, is based purely on the patient's hemodynamic status. If they have pulseless VTAC, you manage it exactly the same way as if they were in VFib. If they're hemodynamically stable and having VTAC, start with amiodarone, then lidocaine, then proceed to procainamide. If all medical therapy fails you, then cardiovert the patient. Hemodynamically unstable VTAC is managed with electrical cardioversions followed by medications such as amiodarone or lidocaine. Remember, VTAC is managed with shock and drugs and CPR at all times in between the shocks. This short run of non-sustained ventricular tachycardia is very evident by its wide complex and regular rate on this 6-lead rhythm strip. What qualifies somebody as hemodynamically unstable? Chest pain, shortness of breath, hypotension, confusion. If they have these, they're not perfusing. These qualities of instability are the same for all rhythm disturbances. And a little quick tip, if you're ever given the answer choice to give direct intracardiac medication, that's always the wrong answer. Pulseless electrical activity, or PEA, is the rhythm formerly known as electrical mechanical dissociation. This means that the heart is electrically normal, but there's no motor contraction. In other causes of PEA, the heart may still be contracting, but without blood inside, there will be no meaningful cardiac output. Here's an example of pulseless electrical activity on a V2 and V3 rhythm strip. We synchronize the delivery of electricity and cardioversion of VTAC to prevent worsening of the arrhythmia into something like ventricular fibrillation or asystole. When you have PEA, look for a normal EKG and no pulse. To treat someone in PEA, you must always correct the underlying cause. The causes of PEA can be tension pneumothorax, the H's, hypovolemia, hypoglycemia, hypoxia, hypothermia, metabolic acidosis, and look at this, hyper or hypokalemia can cause PEA. A massive PE could do it, as well as a tamponade. Atrial rhythm disturbances are rarely associated with hemodynamic compromise. This is because cardiac output is dependent upon the ventricle, not the atria. Look for the following findings in the history to suggest someone is having an atrial arrhythmia. The first is palpitations, dizziness, lightheadedness, exercise intolerance, or dyspnea. And lastly, if they had an embolic stroke, you got to look at the heart as the source. When reading the vignette, if you come across irregular rhythm, this suggests AFib as the most likely diagnosis even before the EKG is done. This is because AFib is the most common arrhythmia in the United States. Atrial fibrillation and atrial flutter are two disorders with nearly identical management. So how do they differ? Well, atrial flutter is a regular rhythm, whereas atrial fibrillation is irregular. Lastly, atrial flutter is extremely indecisive. Sometimes it can change into sinus rhythm. Other times, it can bounce into fibrillation. Here's a 12-lead EKG with somebody in atrial fibrillation. Notice the irregular rhythm. Here's a 12-lead EKG of somebody in atrial flutter. Notice how there's a sawtooth pattern and a regular rate. Hemodynamically unstable atrial arrhythmias are managed with synchronized cardioversion. The reason for synchronization is to prevent the electricity from being delivered during the refractory period. That period is the STT wave. Synchronization also helps prevent deterioration into VTAC or VFib. Hemodynamic instability, as it is defined for VTAC, is hypotension, confusion, development of CHF, or chest pain. By definition, chronic atrial fibrillation is defined as lasting for more than 2 days. However, after 7 days, there is a risk of clot formation, but routine cardioversion is not indicated. The majority of those who are converted into sinus rhythm do not stay in sinus. Atrial fib and flutter are caused by anatomic abnormalities of the atria from hypertension or valvular disease. Shocking the patient into sinus rhythm does not correct a dilated left atrium. Over 90% of these patients will revert to fibrillation even with the use of antiarrhythmic medications. Therefore, rate control and warfarin for anticoagulation is the standard of care for AFib. Chronic AFib should be anticoagulated before cardioversion. Unstable, acute disease does not need anticoagulation. The best initial therapy for fibrillation and flutter is to control the rate with beta blockers, calcium channel blockers, or digoxin. Our goal heart rate is less than 100. The next step after rate control is to give warfarin until the INR is between 2 and 3. So remember, slow the rate and anticoagulate. Lastly, rate-controlling drugs do not convert a patient into sinus rhythm, so if you're given this as a choice, don't choose it. The two calcium channel blockers used to control heart rate with atrial arrhythmias are diltiazem and verapamil. This is because they actually block conduction at the AV node. The other calcium channel blockers only control blood pressure. Remember, no matter how much you might think it's better to shock every patient into sinus, it just doesn't work in the long run. Without anticoagulation, there will actually be about 6 embolic strokes per year for every 100 patients, thus a 6% a year stroke risk. When the INR is actually maintained between 2 and 3 reliably, the rate drops to 2 to 3%. You need to use heparin before warfarin only if there is a current clot in the atrium. Remember, there are 2 new drugs on the market, dabigatran and rivaroxaban. They may show up on your exams. These are alternatives to warfarin. They are for non-valvular AFib. And the great thing is, you don't need to monitor the INR. Atrial fibrillation is caused by anatomic cardiac defects that dilate the atrium. These defects do not go away with cardioversion. That's why the vast majority revert. Many patients with acute AFib from alcohol use, caffeine, cocaine, or transient ischemia will simply convert back to sinus rhythm on their own. Therefore, acute disease normalizes spontaneously, so don't force it. and chronic disease reverts into arrhythmia as well, so don't force it either. Atrial rhythm problems can cause acute pulmonary edema from the loss of atrial kick in those patients with a pre-existing cardiomyopathy. Patients with a low risk of stroke can have their embolic phenomenon safely prevented with using aspirin rather than warfarin as an anticoagulant. If the annual risk of stroke is only 2 to 3% per year, there's no point in subjecting them to the 1% a year risk of major bleeding. This is called the CHAD score. It stands for congestive heart failure, hypertension, age greater than 75, diabetes, and a prior stroke or TIA. Anyone with a CHAD score greater than or equal to 2 should be on warfarin, dabigatran, or rivaroxaban. Major bleeding from warfarin is defined as having an intracranial hemorrhage or at some point requiring a transfusion. The criteria for low risk of stroke from AFib, that means to be able to use aspirin, you must not have cardiomyopathy, congestive heart failure, or atherosclerosis, no hypertension, an age less than 75, no diabetes, no stroke in the past. Thus, the answer for management of lone AFib is rate control, but you can use aspirin as opposed to warfarin or dabigatran. Supraventricular tachycardia presents with palpitations in a patient who is usually hemodynamically stable. The best initial step is vagal maneuvers, such as carotid massage, Valsalva, dive reflex, or ice immersion. If those don't work, proceed to adenosine. Remember, adenosine can only be therapeutically used for SVT. This is then followed by beta blockers such as metoprolol, calcium channel blockers such as diltiazem, or digoxin if adenosine is not effective. Here's a 12-lead EKG showing no P waves or fibrillatory waves. The QRS is less than 100 milliseconds, and the rate is 160 to 180. The complexes are narrow. This fits SVT. Wolff-Parkinson-White is an anatomic abnormality in the cardiac conduction pathway. They're going to present it to you with 3 different scenarios. The first is SVT alternating with ventricular tachycardia. The second is SVT that gets worse after diltiazem or digoxin. And last, if you see a delta wave on the EKG, click Wolff-Parkinson-White. Remember, vagal maneuvers slow and convert SVT. They don't work at all with atrial fibrillation. On this 12-lead EKG, we notice a short PR, that's less than 120 milliseconds, and a delta wave at V2 and V3. This is classic Wolff-Parkinson-White syndrome. Remember, the short PR is due to early depolarization of the ventricle. The most accurate test for Wolff-Parkinson-White is cardiac electrophysiology studies. Procainamide or amiodarone are both useful for atrial and ventricular rhythm disturbances. Use them only if Wolff-Parkinson-White is currently presenting with an arrhythmia. Radiofrequency catheter ablation is curative for Wolff-Parkinson-White. The tip of the catheter is heated and simply ablates or eliminates the abnormal conduction track around the AV node. EP studies actually tell you where the anatomic defect is. Digoxin and calcium channel blockers are dangerous in Wolff-Parkinson-White. They block the normal AV node and actually force the conduction into the abnormal pathway. Multifocal atrial tachycardia is associated with chronic lung diseases such as COPD. Job 1 is always to treat the underlying disease. For the rhythm, treat MAT as you would AFib. But remember, avoid beta blockers as they are detrimental in lung disease. This is a classic EKG demonstrating multifocal atrial tachycardia. Note the different morphologies in the P waves. You have to have at least 3 different ones to be considered MAT. A woman comes to the office for a routine evaluation. She's found to have a pulse of 40, but an otherwise normal history and physical exam. What is the most appropriate next step in the management of this patient? Yes, the correct answer is C. Bradycardia is common. The normal heart rate is between 60 and 100. Some people just have one that's below 60. Those are usually athletes, people who are runners, joggers, etc. Bradycardia, however, can also be the initial presentation of somebody with a 3rd degree or complete heart block. An EKG is mandatory to distinguish the causes of bradycardia. Atropine is the wrong answer because you do not give someone who's asymptomatic, and you also do not know the rhythm yet. A pacemaker is a little too invasive at this point. It is used for a symptomatic patient who does have 3rd degree AV block. Electrophysiology studies seems a little too invasive at this point. Epinephrine is dangerous since ischemia can precipitate after giving it. Isoproterenol is an old, rarely used, non-specific beta agonist that speeds up the heart but also causes ischemia. And lastly, doing nothing is never the right answer. Just a tip, on your USMLE, if you're ever presented with an answer choice of isoproterenol, cross it out. It's never the right answer to anything. If a patient presents to you, as in the previous case with sinus bradycardia, and they are asymptomatic, no treatment is indicated. However, if they are symptomatic, you must use atropine as the best initial therapy and a pacemaker as the most effective therapy. A first-degree AV block is managed the same way as a bradycardic patient. Atropine and pacemakers are used only if the patient is symptomatic. Now, there are two kinds of second-degree AV block. Remember, the first one is Mbbs 1 or Wenke block. This is a progressive lengthening of the PR interval and eventually results in a drop beat. Mbbs type 1 is most often a sign of normal aging of the conduction system. If there are no symptoms, it's managed the same way as sinus bradycardia. That means don't treat if they're asymptomatic. And here's an example of Mbbs type 1 or Wenke block. Another form of second-degree AV block is Mbbs type 2. It's a great deal more pathologic than Mbbs type 1. Mbbs type 2 just drops the beat without a progressive lengthening of the PR interval. This is very dangerous for the patient. Mbbs type 2 also has the potential to progress and deteriorate into third-degree AV block. Therefore, we treat it like a patient who has a third-degree AV block. Everyone with a Mbbs type 2 block gets a pacemaker. That's even if they're asymptomatic. Here's an example of a rhythm strip, lead 2 of Mbbs type 2 second-degree AV block. Note the drop beats. Here's an example of a complete heart block, the third-degree AV block. There's complete atrial and ventricular disassociation. The P waves and T waves have no fixed relationship to each other. A 58-year-old woman is admitted to the hospital with an acute MI. On the second day, she develops sustained VTAC, even though she's on aspirin, heparin, lisinopril, and metoprolol. What is the most appropriate next step in the management of this patient? Is it A, increase the dose of the beta blocker? Is it B, add diltiazem? Is it C, an angiography? Is it D, an implantable defibrillator? Or is it E, perform an EP study? That's right, the correct answer is C. The most common cause of death in the 72 hours surrounding an acute MI is ventricular arrhythmia. Manage arrhythmias from ischemia by correcting the ischemia itself. Therefore, perform an angiography for possible angioplasty or bypass. Increasing the dose of metoprolol won't treat the ischemia. Adding diltiazem will not affect this rhythm. An implantable defibrillator isn't quite right yet because the patient's underlying cause can be fixed. And an EP study won't be appropriate because this VTAC is not from an ectopic site, but rather from ischemia. Which of the following tests would you do to determine the risk of recurrence in the patient in the previous example? Is it A, an electrophysiology study, B, an echocardiography, C, a Mbbs scan, D, a VQ scan, or E, tilt table testing? That's right, an echo. Why is that? LV function is the most important correlator to the risk of recurrence. Now, the wrong answers. EP studies at this time are really for unexplained syncope. A Mbbs scan, yes, is more accurate, but you wouldn't do it before the echocardiography. Also, we use it to check for perfusion. A VQ scan is really for somebody who's had a PE. And lastly, tilt table testing is not appropriate at this time. It's really just for syncope. A 73-year-old male has his third syncopal episode in the last 6 months. An EKG in the field shows VTAC. His stress test is normal. What is the most appropriate next step in the management of this patient? Is it A, give metoprolol, B, diltiazem, C, angiography, D, an implantable defibrillator, or E, EP studies? That's right, the correct answer is D. An implantable defibrillator will prevent the next episode of sudden death or syncope. Metoprolol is not sufficient when syncope or sudden death has occurred. Calcium channel blockers such as diltiazem are useless in preventing or treating VTAC. He's had no chest pain. His recent stress test is normal, so he doesn't need an angiography. And EP studies is useless when the person has a known etiology of syncope on the EKG. A 46-year-old man has intermittent episodes of palpitations, lightheadedness, and near syncope. His EKG is normal. The echo shows an EF of 42%. A Holter show several runs of wide complex tachycardia lasting about 5 to 10 seconds. Which of the following is most likely to benefit this patient? Is it A, pacemaker, B, digoxin, C, warfarin, D, an EP study, or E, a Swan-Ganz catheter? The correct answer is EP studies. These are useful in detecting a source of ventricular arrhythmia. A pacemaker is not correct because we don't know the underlying cause yet. Digoxin doesn't do anything for ventricular arrhythmias. Warfarin is not correct because he does not have a high risk for clot. And Swan-Ganz catheters are for diagnosing shock.
Hi, I'm Conrad Fisher, Associate Professor of Medicine, Pharmacology, and Physiology at Touro College of Medicine, the largest medical school in the United States. And this modality is unquestionably the best thing that you can do to bump up your Step 2 grade on your exam. But in addition to that, I want to emphasize that there is nothing superficial in this modality. You will be crisply current. You will be totally state-of-the-art for your rotations. This will prepare you both for your shelf examination and for any examination you have to take during your 3rd or 4th year of medical school in internal medicine. So you can be 100% certain that you can take everything in this section and memorize it. In the pituitary section, we'll be covering panhypopituitarism, deficiency of the posterior pituitary, which is diabetes insipidus, acromegaly, which is growth hormone excess, and hyperprolactinemia. As we start the endocrine section, I would like to be 100% clear you can take everything we're doing here, not just for your Step 2 examination, but you can take care of patients. This is 100% accurate for real day-to-day patient care in addition to your examination. Now, panhypopituitarism is most commonly caused by compression or damage of the pituitary gland. Now, the etiology of that compression or damage doesn't matter that much from the point of view of the output of the pituitary. Any tumor, cancer, adenoma, cyst, meningioma, craniopharyngioma, or lymphoma, anything that presses mass effect. The pituitary is a very small gland, and it's not got a cartilaginous ring like the bronchi. Any additional pressure on such a tiny, squishy gland will result in a loss of function, particularly of the anterior pituitary hormones. That's because those hormones are made in the anterior, and they simply cannot be produced if they are markedly compressed. Trauma and radiation are also damaging, because if the cells are simply killed off, they can't produce the hormones. The posterior is different. The posterior hormones are made in the hypothalamus. They're simply stored in the posterior pituitary. But the anterior pituitary hormones are not just stored there, they're produced there. Look at this terrific picture of the hypothalamus and the 3rd ventricle. And it's hard to appreciate, but that pituitary stalk is extremely small. It's extremely thin. It's very delicate. It's easy to compress, to damage, to cut. We're going to make it today so that you are able to completely understand that the releasing hormones come down from the hypothalamus. They go into the anterior pituitary. And then the growth hormone, prolactin, TSH, ACTH, LH, FSH are all actually produced in that anterior pituitary. In addition to trauma, we also have things that can replace the gland. Iron in your head. It's part of the reason you get infertility with hemochromatosis. The iron actually replaces the anterior pituitary. Those granulomas of sarcoid replace the anterior pituitary. Histiocytosis X is another granulomatous disease that could damage the hypothalamus and the pituitary. And any infection, but of course large infections like TB, fungus, parasites, or an occasional autoimmune damage where antibodies attack the pituitary or lymphocytes attack the pituitary and cease function. It's a very delicate organ. Prolactin deficiency is essentially asymptomatic in all men all the time, and it is asymptomatic in women unless they've given birth and want to lactate. Now, prolactin, you'd be amazed that I was over the age of 40 before I realized that prolactin meant it was in favor of lactation, and progesterone was in favor of promoted progestation for gestation in the placenta. But that's all it is. You see, if it's deficient, you can't lactate. So therefore, most people will never notice a prolactin deficiency because it is under tonic inhibitory control. It's inhibited most of the time by what's called prolactin inhibiting factor, or simply dopamine as it comes down out of the hypothalamus. Of course it's inhibited all the time. Why would you want to make milk when you don't have a baby there to drink it? Luteinizing hormone, LH, and follicle stimulating hormone, FSH, when they're deficient, well, if you are a postmenopausal woman or an elderly man, you may not even notice these, because as long as you don't mind living without your testosterone or estrogen, you don't particularly need it. They're not essential for life. Both genders would have a decreased libido, decreased axillary, pubic, and body hair, and men would have a decreased ability to produce both testosterone and sperm and erectile dysfunction. And remember, testosterone also makes manly man muscles. That's why professional athletes are tempted to use just a little more than they're supposed to. And if you're a person who is not sexually active and elderly, and you have been postmenopausal anyway, such as in a woman, you may not notice that specifically, beyond, say, a generalized loss of energy. A woman is unable to ovulate or menstruate, so therefore, in a premenopausal woman, it would be distinctly noticed as missing your periods. Growth hormone is not a really good name for the hormone in an adult. You see, in an adult, what is growth hormone doing in you today? What is the function of growth hormone in the post-pubertal person? And the answer is, not very much. See, in adults, it's a stress hormone. In adults, you rarely miss it, because you have 3 other stress hormone systems. You have, harken back to the days of your step 1 preparation. Glucagon, cortisol, catecholamines. So since you have glucagon, cortisol, and catecholamines, you generally won't notice a growth hormone deficiency. When you're studying, and I think everyone should look at multiple books, you may see some people talk about, wrinkles and a little low energy. But the truth is that the majority of the time, if it was just growth hormone deficiency, you wouldn't even notice it. Now, in a child, in a prepubertal, there'll be dwarfism, because you need it for bone and muscle formation. But in adults, you don't notice it. Look at this. Catecholamines, glucagon, cortisol have stress hormone function. They raise the glucose. They raise the fatty acids. You see, in an adult, growth hormone doesn't cause growth anymore. You could call growth hormone the baklava hormone, because it provides you a sudden surge of sugar and fat that helps give you a little energy. But you wouldn't die without baklava. Kalman syndrome is a genetic disorder where the person has a decrease in FSH and LH. Because there's a decrease in FSH and LH, you don't make the hormones of sex hormone, of testosterone or estrogen. It is a gonadotropin-releasing hormone deficiency, and it's associated with anosmia. Now, embryologically, it's very interesting. It has to do with the fact that the olfactory lobes don't migrate to the right position when the hypothalamus is formed. But on a step 2 exam, you really don't have to study anything more than what we just said in this tiny little slide. It might be hard to believe that's all you need. Hypogonadal guy with decreased ability to smell, decreased FSH and LH. In addition to the deficiency syndromes of individual hormones, hyponatremia occurs because low thyroid results in decreased free water clearance. Hypothyroidism is like pseudohyponatremia, psychogenic polydipsia, and SIADH as a cause of hyponatremia with normal volume status. There's glucocorticoid underproduction, and potassium levels tend to remain normal because aldosterone is unaffected, and it's aldosterone that excretes and maintains the potassium. So overall, you will notice a low thyroid and low glucocorticoids. Those are the two that must have mandatory replacement when your hypopituitarism occurs. In the center of this MRI is a white lesion that is showing a compression of the pituitary. This MRI is detecting a mass lesion compressing the pituitary and shows you how distinct the pituitary can be on an MRI. Growth hormone is first detected with an insulin-like growth factor level, IGF level, and that's because growth hormone is maximum in the middle of the night. So it is not convenient to test a hormone that has a very short half-life and is only released in the middle of the night. So therefore, the best initial test for all growth hormone abnormalities, whether high or low, is an IGF level. A testing of deficiency of growth hormone production is difficult. There are two ways to do this. One is you give arginine, and arginine should normally increase growth hormone. That would be the normal finding. If you give arginine that doesn't increase growth hormone, you have an insufficient production from your pituitary. Now, this is based on the fact that growth hormone helps proteins grow. So if I give you an amino acid like arginine, it should stimulate it for two things. One is for gluconeogenesis. The other is so it will produce IGF and help you make those proteins. Growth hormone releasing hormone stimulation is also useful because, again, a normal response would be an increase in growth hormone. ACTH and cortisol levels, high or normal levels, exclude panhypopituitarism. The problem that you have is that when the levels are low, you can't tell if you're in the normal trough of a diurnal cycle or whether or not somebody has a real panhypopituitarism. Sex hormones start out with LH and FSH and testosterone levels. And if these are elevated, an elevated level of any one of these tells you it's simply not panhypopituitarism. The problem is that these levels are all made in pulsatile fashion. Since they're made in pulsatile fashion, you can't tell if they're low. A low level doesn't mean you have panhypopituitarism. A high level excludes panhypopituitarism, and it is the same with TSH. A high level excludes. Occasionally used tests for panhypopituitarism would be metirapone. The metirapone test is a very difficult to understand test because what it basically is doing is inducing an 11-beta-hydroxylase deficiency. See, metirapone inhibits beta-hydroxylase. Well, beta-hydroxylase is necessary to produce cortisol. So if you don't produce cortisol, well, how does it test your pituitary? Well, what acts as the feedback inhibition upon the pituitary except cortisol? Well, nothing. Only cortisol inhibits ACTH. So if you had a person who's 11-beta-hydroxylase deficient and low cortisol, the ACTH level should be, a normal person, it should be up. If you have an ACTH and 11-deoxycortisol level that rise, it means that you have a normal person. If I shut off cortisol, a normal person should rise up their ACTH to stimulate the adrenals. If you give metirapone and ACTH level stays low, your pituitary is not working. Insulin stimulation has been largely discontinued because it's dangerous. A normal person, when you have a decreased glucose level, has the pituitary that makes lots of growth hormone. But if you don't rise the growth hormone level, if the growth hormone fails to rise in response to insulin, it indicates pituitary insufficiency. A normal person, when they get hypoglycemic, should make more growth hormone. A person with panhypopituitarism will not. You replace deficient hormones with thyroxine, cortisol, and sex hormones. These are the ones that are most essential, and they're given to you in the orders of the most absolutely essential. Thyroxine is by far the most absolutely essential. You don't have to replace growth hormone in adults because growth hormone is just one of the stress hormone systems. ADH and oxytocin generally don't need to be replaced just for pituitary insufficiency, because one, no deficiency disease is described for oxytocin because oxytocin just helps uterine contraction during delivery. But since delivery still occurs even if it's absent, you don't need to replace it. ADH deficiency, which is central diabetes insipidus, doesn't have to be replaced because, frankly, the hypothalamus just takes over, releasing the ADH directly. It's kind of like buying books from Amazon. If all the bookstores shut, you just get it directly from Amazon. Diabetes insipidus is a decrease in the amount of ADH from the pituitary at central diabetes insipidus, or in a decrease in its effect on the kidney, which is nephrogenic diabetes insipidus. Now, central diabetes insipidus almost exclusively happens from damage to the brain, from a stroke that kills off those cells, tumor that kills off the cells in the hypothalamus, trauma that kills off the cells in the hypothalamus, or hypoxia, things that infiltrate the hypothalamus or kill it off. There's more changes in hepatitis, in both acute hepatitis and chronic hepatitis, than you might think, so pay attention. We got new stuff here for you. Hepatitis is an infection or inflammation of the liver. The majority of cases were caused and still are caused in acute cases of hepatitis A and B. Hepatitis C, although it's the most common reason to need a liver transplantation in the United States, rarely presents with acute infection. It bypasses the acute infection and people don't feel it. They just show up 20 years later with cirrhosis or needing a liver transplant. It can be found on blood tests for abnormal liver function, and basically you have high transaminases, and hepatitis B and C serology is done. You find it that way. Or in people who are being evaluated for cirrhosis. Hepatitis D is rarely found anymore because rates of injection drug use are much lower than they used to be. Hepatitis D is exclusively a co-infection with hepatitis B and seen in injection drug users. Hepatitis E is described after D, so A, B, C, D, E. It's the worst in pregnancy E, and you eat it. It's enteric, and it's in East Asia, like Thailand, Cambodia, Laos, Vietnam. Hepatitis B, C, and D are transmitted sexually, blood, perinatal. Get it from mom for free. The food and water, the enteric ones, hepatitis A and hepatitis E, or fecal, oral fecal, you ate hepatitis A, you eat hepatitis E. But when they present you a patient who's got yellow skin, yellow eyes, you can't tell which type you have. There's no way to detect the specific type from the symptoms. All forms present with jaundice, fever, weight loss, fatigue, with dark urine. All forms present with jaundice, fever, weight loss, fatigue, dark urine. You tried to lose weight, you tried Jenny Craig, you tried Slim Fast, you tried Weight Watchers, try hepatitis. 20 pounds of weight loss, you don't have to count calories. They all could have a big spleen, hepatosplenomegaly, and they all can cause nausea, vomiting, and abdominal pain. If they present you this, you cannot answer the question, what's the most likely diagnosis in terms of, is it hepatitis A, B, C, D, E? You can't answer that just from that presentation. They all could do that. And all forms of acute hepatitis give an increased direct bilirubin. Indirect is from hemolysis, direct is from obstruction and hepatitis, viral hepatitis. There's an increased ratio of alanine aminotransferase, ALT, to aspartate aminotransferase. That's because viral hepatitis tends to elevate the ALT, and drugs tend to increase the AST. Drugs, including alcohol. So viral with the AL and drugs with the AS can also increase the alkaline phosphatase when it damages the liver enough. Now, why you get aplastic anemia as a rare complication of acute hepatitis is unknown. But it does. It can suppress the marrow. But I could say the same thing about why does Epstein-Barr do it, or CMV. What you have to know is a person comes in with hepatitis and they have pancytopenia. Why? Well, one can be just the virus. Just the virus by itself can do it. Which of these correlates with increased mortality? Which of these tests will tell you? Elevation of which of these tells you who's going to die? The answer is the prothrombin time. And that's because this tells you that There's no synthetic function. You damage the synthetic function. You could have transaminases very high, bilirubin is very high, alk phos very high, but you know what? They'll all get better fast. They can all be markedly elevated and better fast, but not the prothrombin time. If your prothrombin time is up, it means you're lost liver. Remember, your prothrombin time doesn't even begin to go up until you've lost 70 to 80% of your liver. By the time your liver is damaged enough to have an elevated prothrombin time, the majority, and I mean majority, I'm not using that word lightly, I mean majority of the liver is destroyed. But if you lost 1 or 2 or 3%, a tiny amount of liver dysfunction can elevate your transaminases. And to pop back, you could regenerate it. But not so with your prothrombin time, because all the clotting factors are made in the liver, except factor 8 and von Willebrand's factor. They're all made in the liver, except factor 8 and von Willebrand's factor. The disease-specific test for hepatitis A, C, D, and E, the best initial test for all of them is the same. IgM antibody, and IgG is long-term, tells you your infection is resolved. So IgM tells you got an acute infection. IgG tells you it's resolved. That's the same for all of them. Hepatitis C has tests for disease activity. The PCR RNA viral load level tells you the amount of active viral replication. Many people could have a hepatitis C antibody. It doesn't mean there's any significant active viral replication. We get the hepatitis C PCR to tell you if there's active viral replication, because if there's a hepatitis C PCR level that's up, it means you need to treat that person. Now, it's the first thing to change with treatment. First thing to change. If the PCR drops, you improve the treatment. If the PCR rises, it's a treatment failure. PCR for viral load tells you the response to therapy. Genotyping of hepatitis C predicts who's going to respond. The genotype. There's subtypes of hepatitis C. Why are they important? Because they can tell you who's likely to respond. The biopsy tells you how much damage has been done. The PCR, the viral load, tells you, has there been improvement? Has there been treatment failure? Genotyping tells you the subtypes, and the subtypes tell you, gee, which type is going to respond. Hepatitis B is the one that has difficult serologic patterns, but nothing has changed in 25 years. But hepatitis B is the one that has surface antigens, E antigens, core antibodies. If the surface antigen is positive, it means you have active viral replication. When your hepatitis B infection is old, past, healed, resolved, there's no more antigen, surface antigen. So the most important thing to determine chronic hepatitis is the surface antigen. If that surface antigen is going on, still positive for more than 6 months, it is, by definition, chronic hepatitis B. Chronic hepatitis B is defined as the persistence of surface antigen beyond 6 months. E antigen tells you early antigen, yeah, but it doesn't go up first. Actually, surface antigen is first. E antigen tells you the degree of viral replication. It's like saying DNA polymerase. So E antigen is always up in acute hepatitis, might be up in chronic, but E antigen indicates active viral replication in high quantities. Consequently, for a resolved, old, past, or healed infection, it's gone. Core antibody is looking at a resolution. Now, it could be that it's only just starting, so it could be an IgM. So the core can't tell you whether it's acute or chronic. It just can't. We know that an IgG core is what's up when you have a healed infection. But you should not look to core to tell you whether it's an old or an acute infection, whether it's acute or chronic. You can't. You can't. What we look to core for is to tell us, is your surface antibody, is it up because it's resolved infection like this, resolved infection as surface antibody? Or is it up because it's from a vaccine? If it's from vaccine, there will be no core. Vaccine gives no core. Surface antibody does not exist at the same time as surface antigen. When the surface antigen goes away, there's a little window period of 2 or 4 weeks. And the surface antibody comes, but they don't exist at the same time. Being able to distinguish between the type of serologic pattern is very important for answering the question, hey, which of the following serologic patterns is most likely to be found in this patient? Vaccinated patients never have surface antigen. And in the window period, well, the window is defined as the surface antigen going away. Surface antigen is gone, and surface antibody has not begun. That's the window. Highly exaggerated. It's only 2 or 4 weeks, very small. E antigen is never up in vaccine. And in the window means it's resolved because E antigen is only up when the surface antigen is up. E antigen is only up when surface antigen is up. Now, this is the whole point. Core antibody is not made with vaccine, but it is there in the window period. That's the major point. Surface antibody is positive with vaccine, and that's the whole point. Vaccinated patients only have one thing, surface antibody. And the window is called the window because the surface antibody has not had time to develop yet. That's why it's a window. Which of the following becomes abnormal first after acquiring hepatitis B? The first thing that goes up is surface antigen. Most common wrong answer is E antigen. Well, that's understandable. It's called early antigen. You would think it would come up first, but it doesn't. Surface antigen first. Before there's E antigen, there's surface antigen. Okay, viral replication rises after surface antigen. Bilirubin is after the infection has occurred and damaged the liver cell. Transaminase is after infection has occurred and damages the liver. The core antibody happens just after surface antigen, but certainly there's a delay of several weeks to months. And they're the body's in response to infection. It's not the actual infection. Surface antigen is the actual infection. By the time you make anti-hepatitis B E antibody, you have started to resolve. Anti-hepatitis B E antibody is the very definition of I'm starting to resolve. Which of the following is the most direct correlate of the amount or quantity of active viral replication? Now, this question has enormous significance because this tells us who to treat. And we have so many therapies for hepatitis B now, for chronic hepatitis B, that this issue of, gee, which of these tells us the quantity or the amount of active viral replication? That is E antigen. It could be either E antigen or DNA polymerase. Surface antigen is not quantitative. It's either positive or negative, positive or negative. You could be a carrier. Carrier is a term applied to people who just walk around with surface antigen and nothing else. It could be very low level viral replication. E antigen tells you DNA polymerase. Surface antigen just doesn't tell the quantity. Neither does bilirubin. Core antibodies, resolution, same as ALT. There's a response, and anti-hepatitis B and E, they appear prior to resolution of all the DNA polymerase activity. They tell you you're on the way to resolution. But E antigen is the most direct correlate of quantity. If your E antigen is positive, you have a 90% chance of transmitting to the baby. E antigen transmissibility. Which indicates you can't transmit infection. The active infection is resolved. I can't transmit. Which of these means you're over transmission? The answer is that there's no surface antigen. As long as there's some degree of surface antigen, you can still transmit. Now, E antigen and bilirubin normalizing are good. Transaminases mean very little because most people, in fact half the people with chronic hepatitis who are still replicating virus, they can have normal transaminases, even a normal bilirubin. So normal ALT and normal bilirubin don't mean that the infection is resolved. It means that the acute infection is resolved. It means the acute infection is resolved. You can still have chronic. Matter of fact, most people with chronic have a normal bilirubin and transaminase. So these normalized long before viral replication stops. E antigen is a measure of quantity. As I said, If you have E antigen, the viral replication is stopped, but there's still some as long as your surface antigen going on. No core is not specific enough. That just means there's no serologic evidence of disease. An E antibody, hepatitis B E antibody, appears prior to the resolution of all DNA polymerase activity. But the key issue is, although the others determine intensity, quantity, and degree of severity, as long as there's still surface antigen, you can still transmit. You can't transmit when the surface antigen is gone. Which is the best indication of the need for treatment in chronic disease? A very big deal. There are not enough livers for everybody. The one that is the best indication for the need to treat is actually E antigen, because this is the one where you can actually do something. Now, it may seem paradoxical. I just said surface antigen tells you can still transmit. But since low-level, tiny amounts of viral replication are hard to control, the greatest knockdown, in other words, is with E antigen. That tells you got something to really inhibit. At least some disease, some active disease, it might be on its way to spontaneous resolution. It wouldn't benefit the surface antigen. In other words, maybe the surface antigen was about to go away, and this treatment goes on for months and months. So we treat the people with E antigen. Bilirubin means a big nothing. Same as the core antibody, same as the transaminases. 40, 50, 60% of the people with chronic hepatitis can have normal liver function tests and transaminases. Doesn't mean anything. Anti-hepatitis B E antibody tells you that the person doesn't need treatment. It's the other way around. The indication for the need is E antigen or DNA polymerase. Anti-hepatitis B E antibody means you don't need to be treated because you're on your way to resolution. The body's response to infection shows it's a measure that the body has responded to infection. With E antibody, you don't need treatment. E antigen means lots of viral replication. E antigen, 90% of the mothers will transmit to their babies. E antigen is a qualitative test to be, tells you positive, negative. If it's positive, doesn't mean how positive. You need DNA polymerase for that, for the quantity. E antigen for the quality. Positive, negative is quality. The best indicator that a pregnant woman will transmit to her baby is E antigen. Surface antigen might be on its way to resolution, might get better any minute, but E antigen, you only have 10% transmission if the surface antigen is positive, but E antigen is negative. E antigen negative, 10% transmit. E antigen positive, 90% transmit. Bilirubin, core antibody, ALT, and these others don't tell you. If you say to the woman, I think you're going to transmit, it's based on E antigen. The others are a measure of the body's response to infection. Well, what's the treatment for acute hepatitis? Well, for hepatitis A and E, the answer is nothing. There is no treatment that we have that's effective. In any event, even untreated, it resolves spontaneously over a couple of weeks. There are essentially always benign conditions in almost everybody except people who have underlying very serious liver disease. Now, for hepatitis B, you become chronic in about 10% of cases, and there's no predicting who is going to become chronic, and we have no treatment for acute disease. We have treatment for chronic disease, but not for acute disease. The only form of hepatitis that has treatment with acute disease is hepatitis C. We use interferon ribavirin, either telaprevir or boceprevir, in acute hepatitis C. And this treatment decreases the likelihood of developing chronic infection. Only acute hepatitis C gets medical therapy. Chronic hepatitis B means surface antigen greater than 6 months. Period. That's it. End of story. E antigen means elevated levels of DNA polymerase, and you treat when both the surface and E antigen are positive and the DNA polymerase are positive, because these are the people that derive the greatest benefit, because you have the most to block. Now, here we go. I want to be clear about this. Hepatitis C, as in Conrad, gets 3 drugs. Hepatitis B, as in boy, 1 drug. Combination therapy, not used. Entecavir or adefovir or tenofovir or lamivudine or tebelvidine. Any one of them. 1. No treatment for acute hepatitis B, and chronic is monotherapy. Interferon I've put specifically at the bottom for 2 reasons. Number 1, since it doesn't have greater efficacy, first we start with efficacy, then adverse effects. And since it has worse adverse effects, it's last. Next, step 2 tests route of administration, and it's an injectable medication. It has the most adverse effects, the hardest route, and no greater efficacy. That's why it's last. Hepatitis C combo. Interferon ribavirin with C as in Conrad, interferon ribavirin and telaprevir or boceprevir. 3 drugs for C, 1 drug for hepatitis B, and only when it's chronic. The adverse effects of interferon are probably the single most frequently tested thing on interferon. Arthralgias, myalgias, aches and pains and flu-like symptoms, and lowers whites and platelets. Wow. Not only that, it makes you feel crappy, and it screws up your CBC and makes you depressed and achy and painy. You know when you have the flu and you're like, I feel crappy. That's interferon in your body. That's your interferon. That's what makes you feel crappy in the flu. And the goal of hepatitis therapy, the goal is to get rid of the DNA polymerase and convert E antigen to hepatitis B E antibody. That's how you'll know when you've improved. You get rid of the DNA polymerase and you become E antigen negative.
Now, what is the role of liver biopsy? Since fibrosis is a very strong indication to begin therapy for either hepatitis B or C right away, fibrosis and active viral replication really relieves cirrhosis very rapidly, and cirrhosis is irreversible. It answers the question, who's going to progress? Older terms such as chronic active hepatitis and chronic persistent hepatitis are not helpful anymore. They've been discarded. And that's because DNA polymerase level is helpful to know, hey, I have active viral replication. I need to go on treatment, not using a biopsy to find chronic active or chronic persistent hepatitis any longer. Now, one of the reasons that the liver biopsy can be very useful is that the ALT levels just aren't a good indication of chronic hepatitis activity. You can have very significant infection with normal transaminase levels. Often the only way that you can really know how much damage has there been to my liver is to do a biopsy.
There's no way to determine the duration of infection with hepatitis C since there's no equivalent of a surface antigen test. In hepatitis B, you have acute symptoms, you feel crappy, you feel tired, you turn yellow, you got dark urine, you have weight loss. We tested you. Oh, look at this. On June 5th, you became surface antigen positive. Now we wait. But hepatitis C doesn't have that. And that's because 80% of people never felt acute hepatitis C. So since most patients don't have acute symptoms, you can't base it on the time course. If the PCR RNA viral load is elevated, patients should be treated with interferon and ribavirin and boceprevir, all 3 drugs. Interferon, ribavirin, and telaprevir, all 3 drugs. The standard of care for hepatitis C is 3 drugs. There's an 80% resolution with 3 drugs, interferon and ribavirin, and either telaprevir or boceprevir. And the final point is ribavirin causes anemia as its adverse effect.
This next section is calcium disorders, hypercalcemia, hyperparathyroidism, and hypocalcemia. Hypercalcemia is a frequent finding for in-hospital patients. It's a very unusual finding for the ambulatory patient. Vitamin D intoxication can occur because vitamin D is a fat-soluble vitamin. Therefore, it can build up to toxic levels. Water-soluble vitamins, such as B vitamins and C vitamins, are rare to have toxicity because they don't build up. They just go out into the urine. Sarcoidosis and other granulomatous diseases cause it because sarcoidosis actually creates more vitamin D, as do the other granulomas. Thiazide diuretics are a cause of hypercalcemia by increasing calcium reabsorption at the distal tubule. Hyperthyroidism, how does that happen? Well, hyperthyroidism causes an increased metabolic activity everywhere in the body, and it also does so on the osteoclasts. So it becomes sort of like mania of the osteoclast, and it dissolves bone. Metastasis to bone and multiple myeloma. Well, multiple myeloma certainly has a very clear mechanism of activation of interleukins, which also melt away bone with osteoclasts. Metastasis to bone is simple bone destruction. And the winner for the most common cause of hypercalcemia is primary hyperparathyroidism. And the reason that this is by far the most common is that most cases simply are asymptomatic. And it turns out that severe acute symptomatic hypercalcemia is more common with cancer. For instance, if you take every 100 people that simply have hypercalcemia, hyperparathyroidism is the most common. If you take every 100 people who have asymptomatic hypercalcemia, far more of them might have cancer, because cancer just presents in a very, very severe person. Acute symptomatic hypercalcemia is mostly based on the fact that high calcium levels make it harder for neural tissue to depolarize. Calcium actually pulls the resting membrane potential away from threshold. Threshold is the point at which neural tissue depolarizes. So if you increase the distance between threshold and the resting membrane potential, it makes it harder to get up there. It makes it harder. It's sort of like raising the passing grade on step 2. That's exactly what that's like. And that would make you confused, lethargic, and stuporous as well. And now this is not just happening in the neural tissue in the central nervous system, it's also happening inside the bowel. Remember, the bowel is a big, long, muscular tube, and just makes it harder for it to depolarize, and you get constipation. If you don't contract the muscle of the bowel, stool can't go forward. And if stool can't go forward, you get constipated. So it's basically stupor of your bowel. It's bowel stupor. Bone lesions such as osteoporosis can also occur when people are acutely symptomatic, but that has more to do with the fact that osteoporosis leads to the hypercalcemia rather than the person who is hypercalcemic getting osteoporosis. It's the fact that things that melt out the bone causing osteoporosis are found in a person who's hypercalcemic. Kidney stones the same way. Well, kidney stones, nephrolithiasis, because you have more calcium, of course, to form the stone. It's supersaturated. It's like making rock candy. It just precipitates out into the kidney. Diabetes insipidus is because you have a nephrogenic diabetes insipidus. Basically, a very high calcium level makes it so that the ADH does not work at the kidney tubule. This results in a profound water and volume loss. And this is one of the most important things mechanistically, so that you understand that in hypercalcemia, it's not just an osmotic diuresis from the calcium. It is the fact that the high calcium simply renders antidiuretic hormone ineffective at the kidney tubule. So you just urinate out 10 and 12, 14, 18, 24 liters a day. Renal insufficiency is common in presentation because of the massive dehydration. Now, since it's a pre-renal azotemia, it can often resolve once you hydrate the patient. Because you have an effect on neural and muscular tissue, it's natural that both low and high calcium disorders have an effect on cardiac conduction. And when you have hypercalcemia, hyper gives you a short QT. Hypo gives you a long QT. So long in hypo that you
have an arrhythmia. Acute hypercalcemia is treated predominantly well. Think of the mechanisms. Now, you may have noticed that I gave you more things on mechanisms in this section than many others. And that's because if you understand the mechanisms, you will be able to understand all the therapies. The symptoms of lethargy, confusion, disorientation, the symptoms that might be related to renal insufficiency, a lot of this comes from the fact that there is a massive diabetes insipidus and volume loss, both osmotic loss of the calcium as well as loss of simple volume. So therefore, the number one therapy is massive volume replacement with saline. Massive volume replacement with saline. The most common wrong answer is to say loop diuretics. Loop diuretics, such as furosemide, are no longer standard of care for acute hypercalcemia in a person who's able to make urine. In any event, they were never correct before hydration. Hydration by itself will solve the vast majority of the problem because hydration will correct the prerenal azotemia. Hydration will simply correct this massive volume loss, and you'd only be giving the diuretic to a few patients who simply can't make the urine. That's a very big and important point. Bisphosphonates such as pamidronate, zoledronic acid, well, pamidronate has simply become the bisphosphonate that we use most frequently in acute symptomatic hypercalcemia. You could use any of them, and it's a class agent. It's a class effect. But the thing is that pamidronate, if you have to choose one single one, that's the one, followed by zoledronic acid. Calcitonin has one function that we use on a regular basis, and that is it works fast. Now, it doesn't last long. There's tachyphylaxis. Tachyphylaxis means it wears off. $5 word for wear off. What's the difference between wearing off and tachyphylaxis? $48,000 a year of tuition. That's the difference between those. Now, while you're doing the hydration, sometimes it doesn't work fast enough. And bisphosphonates take 2 or 3 days to work, 4 days. It'll take a couple of days to work to get that calcium into the bone. Calcitonin has the function of instantly inhibiting osteoclasts. Calcitonin is like the bumpers on your car. Unless there's a problem, unless you're in an accident, you wouldn't notice them. That's what calcitonin is like. There is no deficiency disease of calcitonin ever described and no excess disease. It exists as a therapy for acute symptomatic hypercalcemia. It's a third or fourth line drug for osteoporosis sometimes, but it's for symptomatic severe hypercalcemia while waiting for the bisphosphonates to work. Prednisone is only when it's sarcoidosis and granulomatous disease. Prednisone by itself is not going to be good in the long run because steroids cause osteoporosis themselves, but it will control the production of the vitamin D inside that granuloma. A 75-year-old man with malignancy is admitted with lethargy, confusion, abdominal pain. He has really high calcium. After 3 liters of normal saline and pamidronate, his calcium level is still very high, even on the following day. What's the next step in management? And the answer is calcitonin. Calcitonin's function is to lower that calcium acutely. Zoledronic acid is a second bisphosphonate, and there's no point in using zoledronic acid when you're using bisphosphonate because it's like wearing underwear on both the inside and the outside of your pants. What's the point? It's double coverage, it doesn't help you, and it makes you look a little strange. Plecamycin is ancient history, and the same with gallium. Plecamycin and gallium are here because I can never quite tell who's reading old materials, and that is why people can have the give furosemide first story. That is the most common wrong answer. Furosemide is only in people who are unable to make urine. So you may see it in old questions in places, in old versions of books. As a student with a limited budget, well, a big budget, which is limited to your tuition, I would say that you may be making a decision. Should I buy that book? If you look inside and it's telling you to use furosemide, the answer is no, and you can burn it to heat your house. Plecomycin and gallium are always wrong. That's old stuff. Bisphosphonates eliminated them. Dialysis will work, but you simply don't need to do that, okay, because you can control it with saline and bisphosphonates and permethrinate in the majority of cases. And cinacalcet is a drug that we use to inhibit parathyroid hormone. It is a calcium mimetic agent, a calcium mimetic agent, cinacalcet, like a little calcium. And what it does is it causes a feedback inhibition on the pituitary, and it can be useful in shutting down people's parathyroid hormone release, particularly people who have a pathologic secondary hyperparathyroidism. Primary hyperparathyroidism, very common. It's caused by a solitary adenoma in the vast majority, in 80 to 85%. And adenoma is very common in endocrinology. If we go from the top down, we will see that prolactinomas are adenomas. Acromegaly with growth hormone is an adenoma. Cushing's with an ACTH-producing adenoma in the pituitary, also same thing, hyperfunctioning, as well as in the adrenal gland. Hyperfunctioning, Conn syndrome, primary hyperfunctioning adenoma. Now, one of the reasons that you'll be able to recognize as an adenoma is that it's hyperfunctioning. It's like cellular neurosis. It's not malignant, it's not going to kill you, but just a little overfunctioning when it shouldn't be. So hyperplasia of all four glands occurs, and malignancy is a very unusual entity for the hyperparathyroid etiology. And remember that cancers, malignancies, simply don't function. Remember the thing about the thyroid? One of the ways you know a nodule is not cancer is that if it's hyper-functioning, it's not cancer. It doesn't need to be biopsied. Because cancerous cells don't hyper-function. They don't function at all. That's one of the ways you know that they're cancer. Elevation in calcium, when it's asymptomatic, is occasionally removed. So just because it's asymptomatic doesn't mean it's benign. It means we might remove it anyway if it causes some renal insufficiency. But when symptomatic, it causes osteoporosis. It causes kidney stones and renal insufficiency and muscular weakness because high calcium levels inhibit neuromuscular transmission. The anorexia, nausea, vomiting, abdominal pain is for much the same reason that you get constipation, which is that if you can't contract your bowels and move them normally, things just get stuffed up. It hurts, it's uncomfortable, nothing's moving through. Peptic ulcer disease is very hard for people to understand until you realize that calcium is a stimulant to gastrin as well. Calcium causes acid. Doesn't that make this a little bit like a Zollinger-Ellison? And the answer is yes, it does. Besides high calcium and PTH levels, you'll also find a low phosphate level because parathyroid hormone excretes phosphate at the proximal tubule of the kidney. And there's a short QT, but that's not particular to PTH. That is basically because all high calcium makes a short QT. Sometimes there's an elevated BUN and creatinine based on how much volume loss there is. And alkaline phosphatase is elevated from the effect of PTH on the bone because parathyroid hormone dissolves bone. That's why we're in this section, because that's how you get hypercalcemia, because PTH melts bone. And an asymptomatic byproduct of that is alkaline phosphatase. But these are all key issues because if you have bone effect and kidney effect, even if you're asymptomatic, you gotta get those parathyroids removed. If most hyperparathyroidism is asymptomatic elevation in calcium, then why do anything about it if you don't feel it? Oh, ding, ding, ding. Answer is, if my kidneys and bones are getting hurt, get rid of it. It's like termites. You don't need to wait for the building to fall down to get rid of them. And how you find the termites, well, just getting a bone x-ray is not a great test for bone effects of hyperparathyroidism. DEXA, bone densitometry, the same as a 65-year-old woman has a routine preventive measure on her 65th birthday should get. If you have hyperparathyroidism, everybody's got to get it. Because if you have a person with bone densitometry abnormal, time to get those parathyroids removed. Now, you do preoperative imaging of the neck. Now, that's not exactly a diagnostic test for hyperparathyroidism. Preoperative imaging of the neck with sonogram or nuclear scanning is helpful to determine a surgical approach means, well, those glands are small, and there's 4 of them. Which of the 4 are you going to remove? Ooh, I hope you're removing the right one. Ooh, boy, hey, I got some good news and bad news. What's the good news? Oh, I removed your parathyroid. What's the bad news? I removed the wrong one of the 4. Yeah, that would suck. So make sure you remove the right one. So when do I answer imaging of the neck or nuclear scintigraphy? And the answer is prior to surgery to be sure you're removing the right gland, the one that's adenomatous. Remember, 80 to 85% that is an adenoma? Make sure you remove the one that's an adenoma. You can't necessarily tell by looking at it. It's a functional problem. It's like neurotic people are not uglier necessarily than regular people. You can't necessarily tell just by looking whether there's an abnormal function. For primary hyperparathyroidism, there is only one treatment in the long run, and that is surgery. Now, this is after you might get any acute symptomatic hypercalcemia controlled. See, this is the next step. So let's be clear that we're not talking about doing this for a person who comes in who's lethargic, confused, obtunded, stuporous, comatose, or having a short QT. And then you say, well, give me your neck, it'll fix it that way. No. After you control the acute symptoms with fluids and bisphosphonates and sometimes calcitonin, then if the parathyroidism is the cause of this, then you remove it with surgery. There is no medical therapy for primary hyperparathyroidism. No medical therapy for the hyperparathyroidism itself. For the calcium, yes, but not for the hyperparathyroidism. I remove the glands, and this is the last thing. I want to be crystal clear. If there's evidence of bone involvement, if there's evidence of renal insufficiency, if there's ever been a symptom of any kind, any one of those, in other words, any evidence of a clinical or laboratory manifestation of the adverse effects of that calcium disorder is an indication to get rid of the gland. Hypocalcemia is low calcium, and low calcium means instead of being lethargic and slow and stupid and obtunded like high calcium, I can't move, and high calcium makes I can't move. Low calcium makes me twitchy, hyperexcitable, twitchy. High calcium makes me lethargic, and low calcium makes me twitchy, and hyperexcitable. If a high calcium makes it harder to depolarize, low calcium makes it easier to depolarize. The symptoms of the neural hyperexcitability are because the muscles and nerves simply depolarize more easily. And that is what you're seeing here. This is carpal pedal spasm or Trousseau sign. This is a person who, when the blood pressure is blown up, their muscles become more easy to contract involuntarily in the arm. This is Trousseau's right here. Now, the same thing happens on the face with Trostick sign. I tap the face, and the Trostick sign occurs when it causes facial spasm. Perioral numbness happens when people hyperventilate, like in a panic attack. Hey, and they get perioral numbness from decreased free calcium. Decreases the free calcium. Mental irritability happens as part of the hyperexcitability, and ultimately seizures. That's the worst form of hyperexcitability of any kind. Hypocalcemia gives an EKG which shows a prolonged QT. This prolonged QT can cause an arrhythmia because as it prolongs, it starts to stretch, then it finally snaps and causes ding, 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 ventricular tachycardia. The treatment, of course, is simply to replace calcium and vitamin D, and that will cover it.
Now we're going to switch gears and start talking about burns, followed by hypothermia. When a patient presents to you after being rescued from a fire, the best initial therapy is 100% oxygen. This will treat both smoke inhalation and the carbon monoxide poisoning. Remember, airway burn is the second most common cause of death from burns, only if there's been an airway injury. There are only 5 times you should intubate somebody when they've been in a fire. The first is if they have any signs of burning inside the mouth. Second, if they have any burns inside the nasopharynx. Third, if they're having any wheezing. Fourth, if they display any signs of hoarseness. And lastly, if they have audible stridor. If the airway burn is not present, the second most common cause of death is significant volume loss. Remember, fluid replacement is based on the percentage of body surface area burned. The IV fluid of choice for burn patients is Ringer's lactate. If Ringer's lactate is not one of the choices, give normal saline. You give 1/2 in the first 8 hours, 1/4 in the second 8 hours, and 1/4 in the third 8 hours. You give 4 milliliters for each percentage of body surface area burned for each kilogram of body weight. Remember, the head is worth 9%, the arms are 9% each, the legs are 18% each, and the chest or back are 18% each. Patients sometimes have patchy burns that aren't continuous. To assess the percentage of body surface area burned, what you should do is use the width of a patient's hand to make the estimate. Each hand width is worth about 1% of a body surface area. The short answer is always this. You give the largest amount of Ringer's lactate or normal saline listed as an answer choice, because it's usually the right answer. Remember, fluid replacement is equal to 4 milliliters multiplied by the percent body area burned multiplied by the weight in kilograms. What is the most common cause of death several days to weeks after a burn? Is it A, infection, B, renal failure, C, cardiomyopathy, D, lung injury, or E, malnutrition? The correct answer is A, infection. Because of a loss of skin, there is massive loss of body fluids and albumin. Fluid loss, if fatal, will occur immediately. After several days, the loss of the protective barrier of the skin leads to infection with staphylococcus. Renal failure is not the right choice because combined with volume depletion, yes, it does decrease renal perfusion, but rhabdomyolysis will cause renal failure, but it is not the most common cause of death. Cardiomyopathy is also not because it's not affected so quickly. It takes some time to develop. Lung injury is the immediate cause of death, and malnutrition doesn't occur that quickly. Fluid loss doesn't always mean malnutrition. The Usmle loves heat disorders. Heat cramps and exhaustion occur when you're exerting yourself and there's a high outside temperature. Heat stroke occurs in the same setting, high outside temperatures and lots of exertion. The body temperature with heat exhaustion is normal. Body temperature with somebody with heat stroke is elevated. CPK and potassium will be normal in heat cramps and exhaustion, but in heat stroke it'll be elevated. The treatment for somebody with heat cramps is oral hydration and electrolyte therapy. In somebody with heat stroke, it's actually IV fluids and evaporative therapy. The next two heat disorders present very similarly. The history will be your clue in getting the answer right. To develop neuroleptic malignant syndrome, there will be a history of antipsychotic medication use. For malignant hyperthermia, there will be anesthetic medications that have been administered systemically. Body temperature is going to be elevated in both. CPK and potassium will also be elevated in both. The treatment is dantrolene or some dopamine agonist like bromocriptine or cabergoline for neuroleptic malignant syndrome. For malignant hyperthermia, it's simply dantrolene. When a patient displays hypothermia, look for an intoxicated person. Unintoxicated people do not fall asleep outside in cold temperatures. The most common cause of death for hypothermia is cardiac arrhythmia. Therefore, the best initial test, yeah, that's right, EKG. Now, what you must realize is on the EKG, hypothermia results in marked elevation of the J point. This is not an ST elevation or a right bundle branch block, so don't start activating the cath lab. It's just the J point elevation. After a patient has drowned, you must manage the airway and administer positive pressure ventilation to increase gas exchange. Steroids and antibiotics are not beneficial in drownings. Saltwater drownings, patients present like they have CHF. They have wet, heavy lungs, and gas exchange is very poor. Remember, the wrong answers for drowning are always steroids and antibiotics. Freshwater drowning causes hemolysis. This is because too much hypotonic fluid is circulating in the vasculature. The RBC will come in contact with this hypotonicity. They will swell and subsequently hemolyze.
Hi everyone, and welcome to the pulmonary section of the Step 2 High Yield course. My name is Stephen Bagley, and I will be your lecturer for this part of the course. In this first lecture, we're going to cover asthma, and we're going to discuss everything you need to know about asthma to score highly on the Step 2 exam. To begin, let's discuss the definition of asthma, which is sometimes referred to as reactive airway disease. Asthma is an abnormal bronchoconstriction of the airways. However, there are multiple other diseases that can cause abnormal bronchoconstriction of the airways. So what is it that differentiates asthma from the others? The answer is that asthma is characterized by reversible airway obstruction, which is secondary to bronchial smooth muscle hyperactivity. This reversible component of the airway obstruction is diagnostic of asthma as opposed to some other obstructive disease of the lung. However, there are several other components to asthma in addition to this reversible airway obstruction from the smooth muscle hyperactivity. These include airway inflammation, mucus plugging, as well as actual hypertrophy of the bronchial smooth muscle. As you might imagine, if all of these processes are going on over a number of years, it can actually lead to a chronic and irreversible airway obstruction. And in this chronic situation, asthma can be quite difficult to differentiate from other obstructive diseases of the lung. Overall, asthma is extremely common in our population. The etiology remains pretty much unknown, but there are some associations with atopic disorders as well as obesity. It is important for you to remember on Step 2 that the prevalence, incidence, and hospitalization rates of asthma are increasing in our population. While the underlying etiology of asthma remains unclear, there are several causes of acute exacerbations of asthma with which we are more familiar. The first of these are allergens, such as pollen, dust mites, cockroaches, and cat dander. Infection, most notably a viral upper respiratory infection. Changes in weather, especially cold air. Exercise, catamenial or related to the menstrual cycle. And a number of drugs, including aspirin, NSAIDs, beta blockers, and tobacco smoke. For Step 2, the two drugs you should be most familiar with are aspirin and beta blockers. Firstly, aspirin can cause an exacerbation of asthma by decreasing the production of prostaglandins in the lung, which leads to increasing rates of bronchoconstriction. With regard to beta blockers, as you know, beta blockers are primarily used for their effects on the beta-1 receptor in the heart, and by blocking the beta-1 receptor, you can cause a decrease in contraction of the muscle in the heart and a decrease in the heart rate. However, there is some cross-reactivity with the beta-2 receptor, and when you block the beta-2 receptor in the lung, you can cause bronchoconstriction. GERD, or gastroesophageal reflux disease, is another cause of an acute exacerbation of asthma, and this is often better controlled in these patients when you start them on a proton pump inhibitor, and you can sometimes see their asthma symptoms improve as you treat their GERD. In terms of clinical presentation, asthma most often presents with wheezing, a high-pitched whistling noise heard throughout the lung fields on physical examination. Acute onset dyspnea and cough are also very common presenting symptoms of an asthma flare. Some patients will complain of chest tightness or a sensation that they cannot fully expand the chest wall, while still others may have increased sputum production, which is quite common in an asthma flare. Fever is only present sometimes, and most commonly is there when there is a viral upper respiratory infection as the cause of the asthma exacerbation. Remember, all that wheezes is not asthma. In particular, congestive heart failure can sometimes cause wheezing, and a CHF exacerbation is going to be treated very differently from an asthma flare. So it's important to remember that when you hear wheezing, your differential diagnosis must include asthma as well as other disorders such as CHF. Now, let's take a moment to think about some ways that asthma can be tested on step 2. One way is that they'll ask you for certain signs, either by history or on physical exam, that are very characteristic of an asthmatic patient. Here are some good examples. Symptoms worse at night, nasal polyps, eczema or atopic dermatitis on physical exam, increased length of expiratory phase of respiration. What we mean by this is that the I to E ratio, or the inspiratory time to expiratory time, decreases. Normally, this ratio is 1 to 2. For every 1 second spent on inspiration, 2 seconds are spent on expiration. In a severe flare of asthma, this ratio is going to decrease because patients will have a hard time expiring air secondary to their severe airflow obstruction. Increased use of accessory respiratory muscles, such as the intercostals, hyperresonance to percussion, or sometimes even a pulsus paradoxus can be seen on physical exam. Sometimes on step 2, the presentation of the patient may be quite obvious and may be classic for an asthma exacerbation. However, they may ask you what the best initial test is that you should perform. The answer to this question on step 2 is based on the severity of the patient's presentation. Most commonly on step 2, your patient is going to be in somewhat of a severe asthma exacerbation, as evidenced by severe dyspnea, cough, and wheezing. In this case of a severe flare, the best initial test in an acute exacerbation is going to be an ABG and or a peak expiratory flow. And if given the choice between the two, an ABG would be the ideal test. In the situation of a mild early exacerbation, the ABG may show some mild hypoxia and a respiratory alkalosis, as evidenced by a mildly elevated pH and a mildly decreased carbon dioxide level. In the situation of a more advanced late exacerbation, where the patient may actually be tiring out from overuse of their respiratory muscles, you're going to see severe hypoxia on the ABG, as well as a respiratory acidosis, which will be characterized by a low pH and a high carbon dioxide level. In asthma, the chest X-ray is most commonly going to be normal. However, you may see some degree of hyperinflation depending on the degree of air trapping that's going on. However, the chest X-ray is most useful for excluding other disease processes that may be going on instead of or in addition to the asthma flare. These would include pneumonia, congestive heart failure, or a pneumothorax. Pulmonary function testing is also often used to diagnose asthma, and it is indeed the most accurate diagnostic test. However, it's important to remember that you do not need to use PFTs in the acute setting. Rather, PFTs are best used in the stable outpatient who needs to have a chronic respiratory disorder diagnosed. In order to understand PFTs, you really have to understand lung volumes. So let's spend a minute discussing those in further detail. In order to understand pulmonary function testing, it is critically important to understand the various lung volumes tested on step 2, as well as the terminology associated with these. The first term to be familiar with is the tidal volume, and this is simply the volume of air that is breathed in and out during the normal resting respiratory cycle. You can see on your screen the small oscillations in the center representing the resting tidal volume. The next is the inspiratory reserve volume, or the IRV. This volume represents the amount of air that can be inspired on top of the normal resting tidal volume. This, you can imagine, is if you're breathing normally, and then at the peak of inspiration, you continue to inspire to your very, very maximum intake. That total volume that you just inspired on top of your resting tidal volume is the inspiratory reserve volume. As you'll see, the terminology given to these different volumes makes sense if you think about what each word actually means. Next, we have the expiratory reserve volume. Just like its cousin, the inspiratory reserve volume, this is a reserve volume, meaning that it's an extra amount of volume on top of your resting tidal volume. Only this time, we're talking about the extra expired air rather than the extra inspired air. So to visualize or conceptualize the ERV, think about a person who's taking in normal resting tidal volumes at rest, and then at the end of their normal expiration, they continue to expire all the way down to the maximum so that all of the air that they're able to expire out of their lungs is out. The expiratory reserve volume represents the amount of extra air that was expired after the patient expired their normal resting tidal volume. Next, we have the residual volume. This represents a certain amount of air that will always be within your respiratory tree no matter how hard you expire. Even when a human being voluntarily expires to their maximum, they are unable to get all of the air out of their lungs. That little bit that remains that can never be expired is the residual volume. Next, we have the inspiratory capacity. This one's simple. It's just the inspiratory reserve volume, which we already discussed, added onto the resting tidal volume inspiration. Then, we have the FRC, or the functional residual capacity. And this is going to be a sum of the expiratory reserve volume plus the residual volume. The best way to conceptualize the functional residual capacity is to think about a person resting at their normal tidal volumes, just breathing in and out comfortably, and then again at the end of expiration, they expire all the way out to reach their expiratory reserve volume, but then you add on that little bit of volume that can never be expired from the lungs, the residual volume. Those two combined together equals the functional residual capacity. Then we have the vital capacity of the lung. The vital capacity is simply all of the air that a person has voluntary control over. The best way I like to think about this is the total lung capacity, so the entire volume of air that could possibly be inside a lung, and simply subtract out the residual volume, or that little bit that can never be expired out of the lung. And if you take that total lung capacity and you subtract the residual volume, you're going to have the value that is equal to the vital capacity. Then lastly, we have the total lung capacity, which is pretty self-explanatory, and is simply the total volume of air within the human lung. The pulmonary function tests in asthma show the following. Firstly, there is evidence of obstruction, which is defined as a decrease in the FEV1, which is the forced expiratory volume in 1 second, and a decrease in the FVC, which is the forced vital capacity. And that's the total amount of air that someone is able to expire when they're forcing it out of their lungs, regardless of how long it takes to do so. Obstruction, however, is truly defined by a decrease in the FEV1 to FVC ratio. In other words, the FEV1, or the forced expiratory volume in 1 second, decreases much more than the FVC. There is also hyperinflation and air trapping. Hyperinflation is defined as an increase in the total lung capacity, while air trapping is defined as an increase in the residual volume, which, if you look back at the last slide, talked about residual volume as that remaining volume in the lungs that cannot be expired regardless of how much force is given to expiration. There is also evidence of reversibility on the PFTs.
Namely, when you administer albuterol or another beta agonist to the patient, you're going to see an increase in the FEV1 of greater than or equal to about 12%, and that is defined as reversibility, which is a cardinal trait of an asthmatic. And lastly, you can also see evidence of bronchial hyperresponsiveness. This is when you administer a cholinergic agent, such as methacholine, which is going to cause some degree of bronchoconstriction. In somebody with hyperactive airways, like an asthmatic, you're going to see a very large decrease in the FEV1. And it's actually going to drop by about 20% of their baseline, and that defines bronchial hyperresponsiveness. At this point, let's pause for a practice question, which is pretty typical of what you might see on step 2. A 15-year-old boy with occasional shortness of breath every few weeks, who currently feels well and has no medications and denies any other medical problems, is sitting in your office with a pulse of 70 and a respiratory rate of 12. Chest exam is normal, which is the single most accurate diagnostic test at this time. Let's take a look at our options. The correct answer is D, a greater than 20% decrease in FEV1 with the use of methacholine. To help us understand this, think about the point that the patient is asymptomatic. This person is not currently experiencing an asthma flare. As we discussed, asthma is a disease characterized by exacerbations where airway hyperresponsiveness results in a transient and reversible degree of airway obstruction. Looking at the other answers which were wrong, peak expiratory flow is not going to help you very much if the patient is not having an asthma exacerbation. In fact, the peak expiratory flow may be quite normal. An increase in the FEV1 with albuterol, again, is not going to be likely in a patient who is asymptomatic. Diffusion capacity of carbon monoxide is something that is used to test how well oxygen is diffusing across the membrane in the alveolus in the lung. If a patient with asthma is not having a flare, they're not going to have any problems with oxygenation or with any gas exchange across the alveolus. So diffusion capacity of carbon monoxide is not helpful in this situation. Same with AA gradient, you're not going to see one if the patient's not having an asthma flare. Increase in FVC with albuterol is exactly the same as answer B, you're just not going to see it if the patient is asymptomatic. Low volume loops on spirometry are good for fixed obstructions, such as somebody with COPD, but is not going to show much in an asthmatic unless they are either having an active flare or have had asthma so severely and for so long that they have some degree of fixed obstruction. Chest CT is not going to show much either, often is clean or just some small degree of hyperinflation. And lastly, an increased ECO2 on ABG is only going to be seen in an acute flare and one that is quite severe and causing carbon dioxide retention. Before we move on to discuss the management of asthma, let's briefly talk a little bit more about diagnostics. Acetylcholine and histamine can provoke bronchoconstriction and an increase in bronchial secretions. Therefore, anything that mimics these two types of molecules can actually be used to diagnose asthma. Methacholine is most commonly used and is simply an artificial form of acetylcholine, which, as we discussed before, can cause bronchoconstriction and is therefore useful in diagnostic testing in an asthmatic. In addition, there are a few other diagnostic tests that will help you to support a diagnosis of asthma, but in and of themselves do not make the diagnosis. These would include a CBC, which may show an increased eosinophil count, especially if the person has other atopic tendencies, such as eczema. Skin testing might identify specific allergens that can provoke bronchoconstriction, increased IgE levels to suggest an allergic etiology, and this can also be seen in allergic bronchopulmonary aspergillosis, which we will discuss in a future lecture. In terms of chronic management for asthma, the best way for you to characterize this in your mind for both your practice and for step 2 is to think about it in terms of a stepwise fashion of progressively adding more types of treatment if there's no response seen in the first level. The easiest way to think about the chronic management of asthma is to divide asthma into 4 different levels of severity. With each additional level of severity, there are a number of drugs that are recommended to be added on. If you remember this chart, you'll have an easy time answering questions about chronic management of asthma on the USMLE Step 2. Step 1 is what you use in patients who have what we call mild intermittent asthma. This is asthma characterized by symptoms less than 2 days per week or less than 2 nights per month. For these patients, there's only one typical therapy used, and that is an inhaled, short-acting beta agonist, such as albuterol, or its enantiomer, levalbuterol. Step 2 is for patients who have what we call a mild persistent asthma. These patients have symptoms greater than 2 days per week or greater than 2 nights per month. So far, all you really have to remember is the number 2. These patients, it is recommended to add a long-term control agent. This is typically going to be a low-dose inhaled corticosteroid. The following examples listed are the most commonly seen. So far, to recap, Step 1, less than 2 days per week or less than 2 nights per month, short-acting beta agonist only, and if the patient's symptoms persist more frequently than that, you're going to add on a low-dose inhaled corticosteroid. Step 3 is reserved for patients who have what we call moderate persistent asthma. These patients have either daily symptoms or symptoms greater than 1 night per week. Patients, it's necessary to add on a long-acting beta agonist. This has the same mechanism of action as the short-acting, but lasts all day long. Most commonly, these will be salmeterol or formoterol. Lastly, Step 4, being the most severe, are the severe persistent patients. These patients have continual and frequent symptoms, despite all of the therapies already mentioned. For these patients, we increase the dose of the inhaled corticosteroid to the maximum dose, and we use one of these long-acting beta agonists and short-acting beta agonist as needed. On the USMLE Step 2, some commonly tested adverse effects of inhaled steroids include dysphonia and oral candidiasis. Some other long-term control agents that we use include cromolyn, which inhibits mast cells from releasing mediators such as histamine, or other contents that result in bronchoconstriction. This is most useful for exercise-induced asthma. In addition, theophylline is sometimes used. This is a phosphodiesterase inhibitor, and by inhibiting phosphodiesterase, you increase levels of cyclic AMP in the lungs, and therefore can increase the degree of bronchorelaxation. However, theophylline has known cardio and neurotoxicity, both of which can be tested on the USMLE Step 2. Leukotriene modifiers, including montelukast, zafrelukast, or xyluton, are best for atopic patients. However, you have to remember that zafrelukast in particular does carry hepatotoxicity and has been associated with the development of Churg-Strauss syndrome, which we will discuss in a future lecture. In terms of the management of an acute exacerbation, things are slightly different. The first step, as we said before, is to determine the severity of the asthma exacerbation. If you recall to an earlier slide, this includes a decreased peak expiratory flow and an ABG showing evidence of increased AA gradient, meaning that the patient is not oxygenating well, or evidence of carbon dioxide retention, meaning that the patient's respiratory muscles are no longer able to compensate for the degree of respiratory distress that the patient is in. Either one of those on an ABG is evidence of a severe asthma flare. Remember, peak expiratory flow is basically an approximation of the forced vital capacity. So if you see a patient who has severely decreased peak expiratory flow, you can assume that they're not able to get much air out of their lungs. The degree of obstruction is quite severe. There really isn't any precise normal value for the peak expiratory flow. You have to remember that it's based predominantly on height and age and not the patient's weight. It's used in an acute assessment by basically seeing how different this number is compared to the patient's known baseline when the patient is stable and not having an asthma flare. The very first step in the management of an acute exacerbation of asthma is to add on oxygen. As simple as this might seem, Step 2 often likes to test the initial step in an unstable patient. You always have to remember your ABCs, airway, breathing, and circulation. Therefore, in an unstable asthmatic, the first step will be to put oxygen on the patient. Albuterol is then given, often in the form of nebulization, in order to ensure adequate delivery to the lungs. Sometimes inhaled anticholinergic agents, such as ipratropium, are also given, again, in effort to decrease the amount of bronchoconstriction contributing to the asthma flare. Corticosteroids are also the mainstay of treatment in acute asthma exacerbation. These need about 4 to 6 hours to begin to work, so they must be administered immediately. Whether you give them orally or intravenously does not make a difference, but they must be given immediately. Epinephrine injections are no more effective than albuterol and actually have more systemic adverse effects, so in the adult asthmatic patient, we typically do not give epinephrine for an acute flare. As mentioned on the last slide, anticholinergic agents are sometimes used in the setting of an acute asthma flare. However, it is worth noting that really no large trials have ever demonstrated that either ipratropium or its long-acting version, tiotropium, have been particularly useful in the role of asthma management. However, because these drugs do work well for other obstructive lung diseases, and because their mechanism seems to make sense to treat an asthma flare, we do often use them. Ipratropium is the one of choice. However, it does not work quite as rapidly as albuterol. And again, epinephrine is rarely used in the adult asthmatic patient and is really only a drug of very last resort. Sometimes, the role of magnesium is brought into question for an acute asthma flare. It does have some modest effect on bronchodilation. However, it is not nearly as effective as albuterol, ipratropium, or steroids. However, with some degree of help, it is sometimes worth giving. It does help with bronchospasm, and it's used only in the acute severe asthma flare that's not responsive to several rounds of albuterol, and while you're waiting those 4 to 6 hours for the steroids to take effect. For some patients, in particular those with severe persistent asthma, they can end up on chronic systemic steroids for very long periods of time throughout their life. It's worth noting the adverse effects of chronic systemic steroids in these patients so that we can avoid giving them unless absolutely necessary. Osteoporosis, cataracts, adrenal suppression and fat redistribution, in particular you see fat in abdominal distribution, hyperlipidemia, hyperglycemia, acne, and hirsutism, particularly in women, thinning of the skin, striae, and easy bruising are also chronic effects of systemic corticosteroids. While we already touched briefly on the adverse effects of high-dose inhaled steroids, it is worth noting that these rarely lead to those same adverse effects associated with prednisone or systemic steroids. Remember, inhaled steroids are only likely to cause some thrush or oral candidiasis or some dysphonia. They're not going to cause the previously noted side effects of systemic corticosteroids. At this point, let's pause again for another practice question. Here, we have a 47-year-old man with a history of asthma coming into the emergency room with several days of increasing shortness of breath, cough, and sputum production. The respiratory rate is 34, and he has diffuse expiratory wheezing and a prolonged expiratory phase on physical examination. Which would you use as the best indication of the severity of his asthma? The answers include respiratory rate, use of accessory muscles, pulse oximetry, PFTs, or the pulse rate. In this case, the correct answer is A, the respiratory rate. A normal respiratory rate is 10 to 16 times per minute. Therefore, by itself, a respiratory rate of 34 indicates severe shortness of breath. A patient breathing that rapidly will not be able to maintain a rate that quick for very long. Eventually, respiratory muscles will fatigue, and the patient will develop respiratory failure. The wrong answers here are B, C, D, and E. B, use of accessory muscles, is wrong because it's quite a subjective measure and is hard to assess. Certain patients, especially those with large body habitus, may not show you use of accessory muscles on physical exam. Pulse oximetry will not show hypoxia until the patient is very advanced in their asthma flare and at the point of an imminent respiratory failure. In fact, oxygen saturation can be maintained above 90% for very, very long time simply by hyperventilating. Truly, it's the respiratory rate and the potential for respiratory failure that is more important. Pulmonary function testing is not going to be useful when a patient's acutely short of breath. In fact, the patient won't even be able to cooperate with the necessary tests. Lastly, pulse rate does not add much in the situation of impending respiratory failure. It is worth noting that there are a number of medications which are not effective in acute exacerbations. Sometimes, step 2 will test you on these, so it is worth remembering. Theophylline is good for chronic management. Cromolyn, also good for chronic management, in particular patients with extrinsic allergies or exercise-induced asthma. Leukotriene modifiers, again, are good for chronic patients and for preventing asthma flares, but not necessarily in the setting of an acute exacerbation. Omalizumab is a monoclonal antibody, which is sometimes used in the chronic management of asthma, but again, not helpful in an acute flare. Lastly, salmeterol, which we already mentioned, is a long-acting beta agonist. This is used as a controller medication to prevent asthma exacerbations. It is not helpful to administer in the setting of an acute flare. If the patient does not have a response to your initial therapies, or if they develop a respiratory acidosis on their ABG, the correct answer is going to be endotracheal intubation and mechanical ventilation. In this situation, the patient has not responded to your initial treatments and is starting to show you, via the increased PCO2 on their ABG, that they are developing respiratory fatigue and impending respiratory failure. The only way to reverse this process is to take over the patient's breathing for them by using an endotracheal tube and a mechanical ventilator. This concludes our lecture on asthma.
Our next section is subarachnoid hemorrhage. This is unquestionably a must-know topic from top to bottom. Subarachnoid hemorrhage is caused by the rupture of an aneurysm. Now, this aneurysm is usually in the circle of Willis. Look at this MRA. Isn't that fantastic? The white is the blood going through the vessels. And aneurysms are found in a lot of people. 2% seems small until you realize that 6 million people in the United States. That is why they're not important unless they've ruptured. And it's hard to take, I understand that. I wouldn't want an aneurysm. But you don't do anything about them unless they're rupturing. Because the majority never rupture. And since the majority never rupture and the cause of the rupture is not clear, we just don't know what to do about an unruptured aneurysm. Here's a diagram to show you the blood supply around the circle of Willis and the anterior communicating artery in between the two anterior cerebral arteries. It's also very good for you to help understand why it is that the middle cerebral artery is where the most of the strokes are, and because you can see very easily from this diagram how colossally large a middle cerebral artery is compared to the posterior and the anterior cerebral arteries. One of the most common questions for your exam will be, what is the most likely diagnosis? Well, how I answer that is by I'm going to look for the sudden onset of severe headache and meningeal irritation, a stiff neck, and photophobia. You might say, well, isn't that an awful lot like meningitis? And more than you know, because it also gives you fever. So when you see the sudden onset of a severe headache, it looks like the sudden onset of meningitis. The difficult part is how are you going to answer the question so you don't say it's meningitis? Because right now, fever, stiff neck, headache, and photophobia looks like meningitis. And the answer to that is loss of consciousness. The only way you're going to be able to answer the question, what's the most likely diagnosis, is they're going to have to describe to you that the person passes out. The person passes out because there's a sudden increase in intracranial pressure. The ability to perfuse your brain is based on the fact that the blood pressure in your heart is greater than the pressure in your head. If the pressure in your head goes up, how can you expect blood to get into there? Therefore, there's a loss of consciousness, and they must describe the time course. Since meningitis can happen over a few hours, but it doesn't happen over seconds. Subarachnoid hemorrhage happens over seconds. In addition, there's focal neurologic complications. Now that by itself, which is to say my arm is numb, my leg is weak, my arm is sensory disturbance, I have ocular problems, by itself that's not enough to distinguish it from meningitis, because one of the things that the average person doesn't know is that meningitis gives neurological abnormalities in 30% as well. 1/3 of people with meningitis have focal neurological findings. But the complication here of focal neurologic findings, not just in the eyes, will help you to recognize it as subarachnoid. The bottom line on how the subarachnoid differs and allows you to answer the most frequently asked question on step 2 comes down to you just have to know 2 lines. It is sudden in onset and there's a loss of consciousness. The best initial test for subarachnoid is, well, what do you see on the right side of your picture? That is a CT scan without contrast. On the first day, you will see it in 19 out of 20 patients. It is 95% sensitive. Now, although the most accurate test is the lumbar puncture, you do not have to do the lumbar puncture in the majority of patients. Now, why don't you do it? It's not because they'll herniate. The most common wrong answer is saying don't do the lumbar puncture because they'll herniate. You don't herniate with an LP and a subarachnoid because you can see that the blood is evenly spread through both sides of the brain. It's evenly spread, left and right, up and down. So you can't herniate if you got something pushing left and pushing right. If you got something pushing from above and below, you can't herniate from that. You herniate from things where there's a blood pressure difference, where there's an intracranial pressure difference. You herniate when there's a pressure difference on one side than the other. You do the lumbar puncture only in the person who has a negative initial CT scan. Now, contrast on CT or MRI improves detections of mass lesions such as cancer abscess. You don't use contrast when looking for blood because blood looks like contrast. You lose contrast when you're looking for cancers and infections. Use contrast when you're looking for cancer and infection. A patient comes to the emergency department with fever, headache, stiff neck, and photophobia. Happens very rapidly in onset, and the patient loses consciousness. The head CT shows nothing. What is the next best step in the management of this patient? The answer is lumbar puncture. The lumbar puncture is necessary only for the 5% with a falsely negative CT scan. You see, the CSF in subarachnoid hemorrhage has a lot of white cells, but it also has a lot of red cells. And that's why when you see these white cells, it can fool you easily into making think it's meningitis. Well, how do you know it's not meningitis? And that is because in meningitis, the number of white cells is far out of proportion increased compared to the usual ratio. It means that in order to answer the question, what is the most likely diagnosis, which is the most common question on step 2, you will have to know what the ratio is of white cells to red cells. And that ratio between them is normally that you should only have 1 white cell for every 500 to 1,000 red cells. 1 to 500. That means if somebody says, oh, my lumbar puncture showed 100,000 red cells, and somebody goes, yeah, but it must be meningitis because there's like 150 white cells. You go, no, 100,000 red cells can have 100 to 200 white cells. And it's not meningitis, it's just a dilute CBC. Just like taking water and dumping it into your bloodstream. Just dilutes it out. If the number of white cells is above that ratio, then you should be thinking about meningitis. The other thing that will help you is xanthochromia. That's basically a yellow cerebrospinal fluid. Xanthochromia is the red cell breakdown product. It happens when blood is in CSF for a few hours. Now, if you have a subarachnoid hemorrhage a half an hour ago, and I do a CT and the CT is negative, and I do the LP and I find tons of red cells, you won't have xanthochromia in many people in the first half hour, couple hours. But xanthochromia is something there that happens over several hours that can help you detect the subarachnoid, particularly one that's a few hours old. The EKG, this is very unique The EKG will show something with a subarachnoid hemorrhage. The EKG will show from inside your brain you get inverted T waves? Yes, cerebral T waves. Looks like myocardial ischemia, these T waves. Cerebral T waves are from excessive sympathetic activity, or so we think anyway. The moral of the story is they can say to you, a man comes in with fever, headache, stiff neck, photophobia. His CT shows the subarachnoid hemorrhage. An EKG shows T wave inverted. What is the next best step in the management of this patient? Well, the answer is treat the subarachnoid. Now, this is a very big deal. Why don't you think back about all the drugs we use for myocardial infarctions? Don't an awful lot of them involve aspirin, clopidogrel, prasugrel, ticagrelor, low molecular weight heparin? Wow, a lot of them involve anticoagulation, so you better be sure that that's really a cardiac etiology. Subarachnoid hemorrhage causes EKG abnormality. What I'm about to say may seem paradoxical. When is angiography the answer? Angiography is the answer to what is the single most accurate test for the site of a subarachnoid hemorrhage? What is the single most accurate test for an aneurysm that's ruptured? Well, it's the angiogram. However, the angiogram is done not to tell me whether or not you had a subarachnoid. That angiogram is done to determine the site of the aneurysm, because we only need to know the site of the aneurysm. We're going to do something about it. It guides surgical lesion repair, guides intracatheter lesion repair. It guides coiling and embolization. Well, if I'm not going to do coiling or embolization, if I'm not going to do an occasional surgical repair, there's no reason to do angiography. Angiography determines the site of the aneurysm to guide lesion repair. Now, you can do an MRA in the vast majority, magnetic resonance angiography, and you can do that also to guide the location so you can repair it. Now, the diagnosis of that subarachnoid is based on predominantly the CT and 5% of the time, sometimes an LP, and the angiography is only to tell location, and the reason is you want to make sure they don't rebleed. So let's do an angiogram, find out the location, repair it with a catheter, and you won't rebleed. This angiogram is just so you have an idea of what it actually looks like. And this is clearly labeled for the internal carotid, the middle cerebral, and the anterior cerebral artery, just so you have a sense of the outpocketings we might see. It is not that you're going to be asked to read angiograms on your Step 2 exam, but let's know exactly what we're talking about when we're talking about it. The most important thing to understand first about a subarachnoid bleed is that you can't do anything to reverse the bleed that already happened. It's already happened. You can't go stuff it back in there. The major thing that we're going to do is we're trying to prevent complications. The complications is that people have subarachnoids, have vasospasm, and get an ischemic stroke. So we use a calcium channel blocker, nimodipine, to prevent a subsequent ischemic stroke. That is because when the blood vessel ruptures, blood vessels, particularly arteries, have muscles in them. Those muscles constrict to contain bleeding. And what happens is that if it constricts too much, it precipitates a stroke. So nimodipine is associated with decreased neurological complications after the subarachnoid hemorrhage. It does not reverse the subarachnoid, it prevents complications. In addition to using nimodipine, we've done the angiogram so that we can clog up the hole. 50% of people who rebleed will die. We do not want you to rebleed. When you wake up after that subarachnoid, the first thing out of your mouth should be, where is the angiogram suite? I want embolization. I want coiling. I want a catheter to clog up that site of bleeding. It will prevent me from rebleeding. It will prevent me from dying. I want my interventional neuroradiologist to place a platinum wire, and I don't want somebody chopping through the side of my head with a knife, because embolization is superior to surgical clipping for both survival and complications. Also, I think a 20-minute catheter procedure is far superior to somebody hacking through the side of my skull and lifting up my brain. We use platinum for a very simple reason. Platinum does not wear out. Platinum does not corrode. It doesn't oxidize. It doesn't have any version of what could be called quote-unquote rust. It stays up there in your head forever, pure and clear and beautiful. The third potential treatment is ventricular peritoneal shunt. Subarachnoid hemorrhage associated with hydrocephalus. That's because the red cells get clogged up in the subarachnoid granulations. The subarachnoid granulations are what drain out the cerebrospinal fluid from the brain. Red cells literally clog it up like you would have toilet paper stuffing up your toilet, and you shunt it only if the hydrocephalus develops. Remember, 50% of those who rebleed will die, so the most important thing is to get in there and clog up the site of bleeding so it doesn't happen again. What will your answer be regarding seizure prophylaxis? A person has had a subarachnoid hemorrhage. Phenytoin yes, phenytoin no. And the answer is very clear. Clearly, no. Phenytoin is not routine, nor is any other medication to prevent seizures just for having a subarachnoid hemorrhage. If the question asks, which of the following is most likely to decrease mortality, phenytoin is not the answer. In addition, as with cardiology, consultation is only right when you want to do a procedure that isn't given one of the choices. You should not need a consultant to tell you to use nimodipine. Now, although you certainly are not a person to be doing the coiling and the embolization, you should answer the name of the procedure if you can, rather than saying the word consultation. A woman is in the emergency department with a severe headache of 1 day's duration prior to admission. That's pretty sudden. She's got a big fever, 103, stiff neck, photophobia, and her head CT is normal. The lumbar puncture shows 1,250 white cells and 50,000 reds. What is the next step in the management of this patient? Looking at these answers is ceftriaxone and vancomycin. And that's because this is far more white cells than you should have for this number of reds. This question is indispensable because at a ratio of 1 white cell for every 500 to 1,000 reds, this person should only have 50 to 100 white cells. This is 50,000 red cells. They should have 50 to 100 white cells. So therefore, this is 10 times more white cells than should be there. This is meningitis, ceftriaxone, and vancomycin. And that is why when you see 50,000 reds, you shouldn't be over 100 white cells. Angiography is for the location of a subarachnoid. This simply is not a subarachnoid. Nimodipine prevents a subarachnoid stroke. This is not a subarachnoid. Embolization is a permanent fix of the subarachnoid. It prevents rebleeding, and it is done if you have a subarachnoid and is superior to the surgical clipping, because that's a worse alternative to embolization. There's no point in repeating the CT scan with contrast, because this is not what you do, one, when you're looking for blood. Contrast looks for cancers and infections. Number two, you're not going to find any mass lesions when you just did a head CT, and it is meningitis. We don't need consultation because there's no procedure that we're looking for. We don't have a procedure we're looking for, don't need them. Welcome to Cardiovascular Medicine. This is Conrad Fisher, and I am an Associate Professor of Medicine, Physiology, and Pharmacology at Touro College of Medicine in New York City, and the Director of Educational Development for the Jamaica Hospital System in New York. And the most common source of questions on all board exams is always heart disease. Whether that be the American Board of Internal Medicine, Step 2 CK, Step 3, it is cardiovascular disease. As we go through, we will be addressing each of these diseases with the questions that we have discussed that we want you to be thinking of and have them in mind during the entirety of your studies. What is the most likely diagnosis? What is the best initial test and most accurate test? What is the best initial therapy? And in cardiovascular disease, we have two questions that are uniquely more common in this section. And that is, which of the following physical findings is most likely to be found in this patient? Now, that is because this section is the one that has Usmle sign with constrictive pericarditis and pulsus paradoxus with tamponade, which has S3 gallops with congestive heart failure and S4 gallops with left ventricular hypertrophy. And we'll go through each of them. But it's very important that you understand that if you think that those physical findings are archaeologic, they are certainly not. They are alive and well and living on your Step 2 examination. And in addition, this section has more questions on the initial therapy is given and it fails, what would you do next? So subsequent therapy. So it's not enough to excel on your step 2 exam. Just knowing that aspirin or thrombolytics or aspirin angioplasty is sufficient for a myocardial infarction. You've got to know, well, what happens when it fails? Well, the thrombolytics fail. What would I do next? Angioplasty. Well, the aspirin and the clopidogrel fail. What would I do next? Switch to prasugrel or ticagrelor. Well, the therapy fails and they develop a complication of MI. What would you do next? And that is unique for this system. I am 100% confident that by the end of this section, you will have been able to extract all the questions, and I mean all, so that there will be no surprises on your test day. In this section of coronary artery disease, we're going to be looking at the definition. What is the very definition of what does it mean to have coronary artery disease? What are the risk factors for that disease? And what is the clinical presentation that will allow you to answer the critically important question on step 2, what is the most likely diagnosis? Let's be clear that the terms coronary artery disease, which is our preferred term, can be used interchangeably with atherosclerotic heart disease or ischemic heart disease. Essentially, they all mean that there's insufficient perfusion of coronary arteries, starving off the myocardial muscles from abnormal narrowing of the vessels. Now, in this case, it doesn't necessarily imply how much narrowing. It could be 40%, 70%, 90%, and it's not saying right now whether it is a critical 70% where we do surgery, but simply what are we referring to when we use the term coronary artery disease. Also, because you will hopefully be using multiple sources of books as you're studying or when you're looking at various Q banks and you see these terms, you don't want to be fooled into thinking that they're talking about anything different than simple narrowing of the coronary vessels, which basically starve off the myocardial system of oxygen, leading to chest pain and ischemic heart disease. My strong suggestion is that you pause the audio recording so that you can read the question, and I will summarize the question to you in order for it to be efficient in your learning. This is a 48-year-old woman. As 48, she is neither very young nor very old. The second thing is that this is atypical chest pain. The pain is not reliably related to exertion. There is no pain now. The location is correct, which is retrosternal, and sometimes associated with nausea is incredibly nonspecific. And she has no past medical history. So the most likely diagnosis in this case, in a woman with no risk factors, the most likely diagnosis in this case, in a young, healthy female with no risk factors, is reflux disease. Now, risk factors matter for people who are not very old. For instance, if the case describes to you a 75-year-old man who's having chest pain while walking up a flight of stairs, risk factors are not relevant because, in fact, 1 out of every 5 people who presents with a myocardial infarction, their chief complaint is, I'm dead, sudden death. You don't have to have any risk factors in an older person. However, for somebody like this, it is extraordinarily rare to have coronary artery disease in a menstruating female. In the entire 60 years of the Fmge studies, there was not a single myocardial infarction in a woman who was menstruating. However, in this case, because the location is retrosternal and there's GI complaints, by far the most likely thing is reflux disease. Unstable angina, it cannot be simply because it is not the most likely. Now you have an advantage on step 2 questions because the diagnosis questions don't say the diagnosis is. Could you say categorically that 100% there is no coronary disease? No, you could not say that. But the questions on step 2 don't say the diagnosis is. The questions simply say most likely. And 99.9% chance this is not coronary disease. So we have unstable angina if there's an emergency department, and remember we will be using the term emergency department, not room, and pericarditis gives you pain that is positional and pleuritic. It's better when you sit up and worse when you lie down. Positional and pleuritic and sharp pain. A pneumothorax is associated with shortness of breath. It also has sharp pleuritic pain, and if it's a tension pneumothorax, it will shift the mediastinum to one side. Now, the only one that is close to being a possibility is Prinzmetal's angina, sometimes called variant angina, which is vasospasm. It is an extraordinarily uncommon disease, resulting in roughly 1/10 of 1% of chest pain in the most generous of circumstances. Prinzmetal's is an extremely uncommon disorder, and it would also be impossible to look at it without seeing that there was ST segment elevation. So it is highly unlikely with this presentation. So could it be Prinzmetal's? Yes, but reflux disease is roughly 1,000 times more common, and there are also no GI complaints with Prinzmetal's angina. This patient, who is under the age of 50 and menstruating, is exactly the patient for whom risk factors are indispensable to know. In a person like this, who had no risk factors, the likelihood of ischemic heart disease is virtually zero. Menstruating women virtually never have an MI, and the risk factors are important when you're not clear. Risk factors are not important in the old man walking up a flight of stairs. Now, if you said that this person was 48 years old, but as a person I met yesterday who had been on dialysis for the last 23 years and had been diabetic since she was 13, yes, as a person who had been diabetic from the age of 13 to 40 and in dialysis of 15 to 18 years, yes, by 40 that woman could have had coronary disease. But you would have to have an extraordinarily overwhelming history of risk factors to have coronary disease in an under 50 woman. Which of the following is most likely to benefit a patient's risk of coronary disease? And the answer is, well, exercise is far more important. Now, there are a lot of things here that we thought at one point would make a difference. For instance, estrogen replacement. This was an idea in the 1990s that looked at the fact that, as we just said, menstruating women don't have myocardial infarctions. However, that did not translate out into give the women estrogen and everything will be fine. Not at all. Matter of fact, not only did estrogen replacement not decrease the risk of coronary disease, there's actually a slight increase in the mortality by estrogen replacement. So therefore, although it may be that menstruating women don't have MIs, you cannot simulate the effect of estrogen that you get from a normal menstruation by giving it as a pill. That does not work. Stopping tamoxifen is irrelevant. Although tamoxifen is a very interesting selective estrogen receptor modifier, tamoxifen is antagonistic on breast but agonistic on bone and your endometrium. Nevertheless, though, it does not translate out into any effect on the coronaries. Aromatase inhibitors result in a complete blockage of estrogen throughout the entire body because aromatase is responsible for creating estrogen in the ovaries and the Sertoli cells of men and in adipose tissue. But there's no relationship of aromatase inhibitors to coronary disease. And relaxation methods, well, we all should relax. The problem is it's almost impossible to define. It's a very nice idea, but what exactly does relaxation mean? No one can define it. And it can't measured, so therefore, since you can't measure it and you can't define it, it's been impossible to study to know reproducibly whether relaxation methods really lower a risk of coronary disease. The clearest risk factors for coronary artery disease are unquestionably diabetes, which is the worst risk factor, tobacco smoking, which is common, but not as common as hypertension. Hyperlipidemia, but hyperlipidemia as a single risk factor is not so bad if you haven't had coronary disease. The hardest one to understand is premature risk factors of coronary disease in your relatives. That the age cutoff for a male relative is if they had premature disease defined as a father who had their disease under the age of 55 or your mother under the age of 65. So the family history is 55 and 65 for male, female. Whereas your individual risk is at the age of 45 as a man and 55 as a woman. Now, we're going to say this again because those numbers are very difficult, but it would make a huge difference because let's say a person has a borderline level of LDL, like an LDL of 160. An LDL of 160 in a person with zero risk factors does not get statins. But an LDL of 160 with 2 risk factors would get statins. So that's why it is that if you are a man at the age of 46 and your father had coronary disease at 54, as annoying as those numbers may be, it means you get to eat statins for the rest of your life. If 1 year is different, you don't have the statins. Please memorize it. Thanks.
The worst risk factor would mean which of these gives the highest likelihood of developing coronary disease at the end of a certain time period? Well, the worst risk factor is unquestionably diabetes. If you take a group of people who just have diabetes, just have hyperlipidemia,
just smoke tobacco, just have a family history, then unquestionably at the end of 5 years, the group that has diabetes has the single greatest risk of developing coronary disease. Now, hypertension is the most common risk and is defined as having high blood pressure above 140/90 in the general population. That's 130/80 in a diabetic, but it is much more common to have just hypertension alone than to have hypertension with diabetes. There are about 16 to 17 million diabetics in the United States, about 10,000 new diabetics a week, but there are 60 million hypertensives in the United States, 20% of the total population. And half the people who have high blood pressure are unaware that they have it, and even the half that do have it are not sufficiently controlled. So overall, only 1/4 of people who have hypertension both know they have it and, in fact, are completely controlled in their blood pressure. Family history is not a risk factor if that family history developed in elderly relatives. If your mother, father, aunts, and uncles and your dog all have coronary disease at the age of 80, it doesn't count as a risk for you or for the patient in the question on your test. It does not matter if it's in grandparents, cousins, aunts, and uncles. It's only a risk factor if it's first-degree relatives, siblings, and parents, and if that disease is premature, defined specifically as a male relative under 55 or a female relative under 65. Which of the following is the most dangerous to a patient in terms of the risk for coronary disease? Well, this question, which I hope will be one of the easier ones, is a high LDL. Triglycerides are not as important a risk factor as LDL. Now, we simply do not know what to do about triglycerides. We know that when they're elevated, there's a modest risk. We know that when you lower them, you have a modest improvement. However, it's not categorically clear what to do about them. And even when the triglycerides are up, the best initial therapy is still a statin, not fibric acid derivatives. Fibric acid derivatives may lower triglycerides more than the other therapies. However, that's not the same thing as saying it lowers mortality. Statins lower mortality, so even when there's high triglycerides, one, as an isolated figure, it's not clear that you actually have to even treat it. We think we do when it goes above 400, but we're not clear what to do about it. The total cholesterol also has to be fractionated out. And a low HDL is a risk factor, and a high HDL takes away a risk factor. Get out there and run. Matter of fact, put this on a recording and run with it and listen to me and raise your HDL and raise your step 2 score simultaneously. And it takes away one risk factor. Obesity is a very interesting risk factor in the sense that the danger of obesity is almost entirely from the fact that it makes you diabetic, hypertensive, and hyperlipidemic. Obesity by itself, interestingly enough, is not that bad. If you have high body fat, but you don't have diabetes, hypertension, hyperlipidemia, one, it's not that big a risk. Second, if you exercise, it almost entirely reduces your risks to normal. So if you're big, just don't be too sweet, diabetic, or too greasy, hyperlipidemic. Less clear risk factors are physical inactivity, excess alcohol, fruits and vegetables not being enough in the diet, certainly emotional stress. But the difficulty is it's very hard to define a lot of these. For instance, how do you define emotional stress? Very hard to put a number on it. Can't measure it, can't define it hardly. And the issue about excess alcohol is hard to define. What do we mean by excess? Certainly 4 and 5 drinks a day is excess. Is 2 or 3 a day excess? Hard to define. Now, calcium CT scoring. This is very problematic because some of you are going to be rotating through places where your attending, who supervises you and writes your evaluation, believes that CT calcium scores is extremely important. Now, this is one of these areas where you may have to say one one thing to get a good grade on your third-year student clinical rotation or on your sub-internship, but not answer that on step 2 of CK. So you, on your rotation, should do what your attending tells you and discuss it with him. And you do not have to believe that CT scoring is unclear. You just have to answer it on step 2. Calcium CT scoring simply is not clear how that adds to thallium stress testing, regular stress testing, or angiography. So calcium CT scoring is associated with an increased risk of coronary disease, but it's not clear what to do about it, and it's certainly not a standard care test at this time. PET scanning is a test to be able to look at the content of lesions or masses to see if there's cancer in them, but PET scanning will not help at all in coronary disease. Of all of these, the hardest one to get right is the CT scoring, because maybe someday it will be a real risk factor, but for right now, the answer on calcium CT score is no. We have a postmenopausal woman who develops chest pain suddenly upon hearing news of her son's death. She develops this chest pain and shortness of breath and ST segment elevation in V2 to V4, which are the anterior leads, and the troponins rise. So this is unquestionably a real myocardial infarction. However, the coronaries are normal, and there's no spasm. There is a test you can do called ergonovine stimulation, which looks for spasm. At the same time, the echo shows apical left ventricular ballooning, outpocketing. What is the mechanism of this disorder? Well, we think that this is a massive catecholamine discharge. This is also known as Takotsubo cardiomyopathy. It was described in Asian women who developed a sudden apical ballooning and a myocardial infarction in the absence of coronary disease. Now, this is not for a person, interestingly enough, who yells and screams and is upset all the time. It's actually for someone who's calm and quiet and suddenly becomes extremely upset. That's in whom it can be damaging. Remember, Takotsubo is in a person who's not used to being upset and highly emotional. So therefore, if you're going to stay calm all the time. Now, absence of estrogen will not cause sudden death such as this. And although plaque rupture can occur, there's no plaques. The coronaries are clean. And platelet activation happens from a rupture of plaques in MI, but not in this. Again, platelet activation is when there's coronary disease. Emboli also is a very atypical cause, but can happen that you have emboli to the coronaries, but it would have been seen. Takotsubo cardiomyopathy. At this point, also, it's very important you understand that this is an excellence tool. So if you haven't heard of this before, it means that we're bringing you up to get that 270 score. There's no specific therapy for the Takotsubo beyond what you do for coronary disease. And there's no ability to fix it through angioplasty. There's no ability to fix it through thrombolytics because there isn't a plaque. It isn't a clot. Now, unreliable or unproven risk factors of coronary disease, which mean if you see them in the question, you're to ignore them, are homocysteine. This test has been around for 50 years. We still don't know what to do with it. It can be used as a diagnostic test in folic acid deficiency or B12 deficiency occasionally, and it's asked about for B12 and folic acid deficiency, of which it goes up in both. However, for a risk factor for coronary disease, it simply is unclear. Chlamydia infection was a 1990s idea that is in old questions and is essentially passé. C-reactive protein, well, we do know that's an inflammatory marker, but the key issue on all these risk factors is we simply don't know what to do about them. There is no clear benefit in therapy on any of them. So if they're up, they're elevated, they're abnormal, what do you do about it? Nobody knows, so that's why they're not clear. See, LDL is clear. Coronary disease and LDL above 100, clear. Statins. Hypertension above 140/90, clear. Lower it. Those are clear things. You can't do anything about these others. They are the wrong answers. And when you go into step 2, knowing the wrong answers can be as useful for you as knowing the right ones, because then you know what not to choose. The most common wrong answer in the risk factor questions is always the one on the family history, where people are mistaking the coronary disease in the elderly relatives. And it means that they show you a person who's old and say, is there risk factors, or what do you do about the LDL? And you make the mistake. Just remember, risk factors in a family has to be young. Correcting which of the following risk factors is going to result in the most immediate benefit? That's the key word here, immediate benefit. Stopping smoking results in the greatest immediate benefit. If you stop smoking, your risk starts to go down literally 10 minutes after you stop smoking. A week and a month and 6 months later, your risk of all kinds of diseases goes down within weeks and months. And if you haven't smoked for 7 years, your risk of lung cancer goes down almost to a non-smoker if it's been more than 7 years. But not so with diabetes, not so with hypertension or hyperlipidemia or weight loss. These other things, you must fix them, but stopping smoking results in the greatest immediate improvement in overall outcome. How do I answer the what is the most likely diagnosis question? Ischemic pain will have to be described as dull or sore. It's going to feel like being punched. Sort of like if you go to the gym and you exert yourself too much, you lift too much weights, you run too much, and it's sore because the heart's a muscle like any other. And it's described as squeezing or band or pressure-like. Like any other muscle that's starved for oxygen, it gets sore when it's ischemic. Now, ischemic muscles are not sharp like a knife or point-like. If it's described as a person putting a single finger on it, it's extremely unlikely that a single finger or point-like pain is ischemic in nature. And ischemic pain does not just last for a few seconds. Ischemic pain lasts for a few minutes or half an hour, or 30 minutes, 20-30 minutes. Non-ischemic pain lasts for a few seconds, and ischemic pain lasts for 10 or 20 minutes. The advantage of a board question is that if they want you to know the answer, they have to tell you something. Now, in life, 95% accuracy or sensitivity for chest pain would not be enough. That would mean out of every 20 patients who came to the emergency department, 95% sensitivity would mean one of those 20 would be improperly discharged. However, on step 2, if they tell you that the pain changes with respiration, it is pleuritic, especially that it gets worse when you take a deep breath, when you stretch that pleura, that is enough as a single factor to tell you, most likely diagnosis, not ischemic. If it changes with position, most likely diagnosis, not ischemic. Things that change with position are mostly pericardial. Things that change with respiration are pneumonia is pleuritic, pneumothorax, pleuritis, pulmonary embolus, pericarditis are all pleuritic. And if there's tenderness, it tells you it's not ischemic in nature. Each of these, positional pleuritic or tender, positional pleuritic or tender, tells you that there is no ischemia with 95% negative predictive value. Did you know that for every 100 people who come to the emergency department with chest pain, only 10% actually end up being diagnosed with a myocardial infarction? It's actually closer to 8%. As a matter of fact, the entire frequency of ST segment elevation MI is going down. That's because preventive medicines are so much better. When you have people from the very first moment that they're defined as having coronary disease, that they're on an ACE inhibitor or beta blocker or statin and an aspirin or clopidogrel, when you have so many of these drugs that work in lowering mortality, for every 100 people who come to the emergency department, 50% of the people with chest pain don't have anything cardiac at all. They have reflux disease, they have ulcers, there's nothing cardiac at all. And of the 50% that have something cardiac, the majority of them simply don't have coronary ischemia, and certainly not an acute coronary event. MCC, most common cause, MCC, of chest pain that isn't ischemic is in general GI things. As one group, that would be things like reflux, ulcers, and gallbladder disease. We need to be able to answer the question, what's the most likely diagnosis? In order to be able to do so, we have to be able to understand the key words in the case that will allow us to do that question. Now, if the question says that there's a duration of pain that's only a few seconds, that is not ischemic pain. And if the question says that the duration is 5 and 10 hours, that is not ischemic pain. Ischemic pain is not seconds and it's not hours. More stable angina will last a couple of minutes, but pain that is more consistent with unstable angina or myocardial infarction lasts on average 10 to 30 minutes. Now, the pain, the quality is incredibly important. Typical pain is squeezing, tightness, heaviness, pressure, burning or aching, like any other sore muscle, like going to the gym and exercising too much. It's sore, it hurts, it feels like being punched. Non-ischemic pain is sharp, sharp like a knife, point-like, stabbing, knife-like. When a patient says he can point to his pain with one finger, that is not ischemic in nature. Now, even more important is the location. Ischemic pain is substernal in location. Non-ischemic pain is left-sided. Left-sided pain is not ischemic 90% of the time just by saying left-sided. When the patient says left-sided, it's not ischemic. Ischemic pain and typical pain is typically provoked by physical activity, exertion, the cold, emotional stress, shoveling snow in winter. Ooh, that's it. Boy, that's fatal. And also the alleviating factors such as rest. Ischemic pain occurs with exertion relieved by rest. That's the story. Radiation is one of the least important things because it's not there most of the time. However, when it is there, when it radiates to the neck, the jaw, the teeth, the arms, and shoulders, that's very characteristic. And associated symptoms is very nonspecific. This is not as important to answer the question because so many things such as pulmonary embolus, pneumonia, pneumothorax can give you shortness of breath, nausea and sweating, diaphoresis, pneumothorax, pulmonary embolus, pericarditis, pleuritis, all of those can give you sweating and dizziness, lightheadedness, or fatigue. So those are not as important. That's why I bring them up last. Remember, down to the bottom line is ischemic pain is not tender, not change with position, and not change with respiration. It's not positional, pleuritic, or tender. It's not positional, pleuritic, or tender. In cardiology, not only physical findings, but the question, what's the most likely diagnosis and most accurate test are critically important. So if the case describes chest wall tenderness, your answer for the most likely diagnosis is costochondritis, also known as Tietze syndrome, or simply musculoskeletal pain. The most accurate test is, there is no real physical test except the physical examination. When it radiates to the back and there's unequal blood pressure, I saw this just today, an aortic dissection is critically important. An aortic dissection with pain radiating to the back. A chest x-ray will show a widened mediastinum, as we saw today. Just remember the CT angiogram, MRI, which is magnetic resonance angiogram, and TEE are virtually interchangeable. They're all over 90% sensitive and specific. Pain that gets worse with lying flat and better when you sit up is from the stretch of the pericardium. When you lean back, you stretch the pericardium, it hurts. When you lean forward, you unstretch the pericardium, and it feels better. You should see on the EKG ST segment elevation everywhere and PR segment depression. If the case describes that there's epigastric discomfort and the pain's relating to eating, of course. And when I say relating to eating, I don't necessarily mean it's worse by eating, because whether it's better or worse is not as important as simply whether it changes with eating, and that is ulcer disease, and you need to scope that person. Now, bad taste is because reflux disease hits the 9th and 10th cranial nerves, supply bitter taste to the back of the tongue, and that's to help you gag things out. You don't want things tasting nice and sweet back there. You're more likely to aspirate. So bad taste, the acid hits it, and acid doesn't taste good to begin with. And the other thing is that bitter taste in general is in the back of the tongue. And you need to be able to just give a response to PPIs, liquid antacids, to make that diagnosis. Now, people with chest pain, it can be very difficult. It can be very difficult to distinguish these. That's why this is a great most likely diagnosis question, to be able to say, there's sputum and hemoptysis. You also will notice that chest x-ray and the presence of fever are very important, because did you know that myocardial infarction causes fever as well? Fever can't be used to distinguish an MI from the others. That a pulmonary embolus causes fever, and pneumonia, of course, but all clots, such as a pulmonary embolus or myocardial infarctions, all clots and all collections of blood can cause a fever, not just infections. Now, if the case describes the sudden onset of shortness of breath, tachycardia, and hypoxia of pulmonary embolus, and remember that the pulmonary embolus is much more likely to be pleuritic in nature, the spiral CT is the standard of care. VQ scan has now become much less frequently done. It would be done if there was an equivocal spiral CT. If there's sharp pleuritic pain, well, sharp pleuritic pain can be with pneumonia, pneumothorax, pericarditis, pleuritis, but tracheal deviation is a pneumothorax, and you see it on a chest x-ray. The features that don't help you answer the most likely diagnosis question. Nausea is extremely nonspecific. Fever is nonspecific. Even atelectasis causes a fever. That's why a pneumothorax can cause a fever, because atelectasis causes fevers as well. Pericarditis causes a fever because any inflammation can cause a fever. Shortness of breath is far too nonspecific, because simply having chest pain itself, pleuritic pain, can simulate shortness of breath because people are splinting. Splinting. It hurts when I take a deep breath in. It simulates shortness of breath when people are splinting. And sweating is with all of them. So these features are common to virtually every form of chest pain and will not help you answer which of the following is the most likely diagnosis. Ignore them.
All right, sports fans, we're now going to discuss sports medicine. Injury to the rotator cuff, besides sidelining your favorite pitcher, is actually very common. It's essentially damage to the rotator cuff of muscles, the tendons, and the bursa all around the shoulder that leads to the inability to flex or abduct the shoulder. The presentation is actually very peculiar. It presents with pain in the shoulder that's worse at night when laying on the affected shoulder, not during actual usage of the shoulder. They may also complain of pain at the site of the insertion of supraspinatus. This is something you'll pick up on exam. MRI is the most accurate test for someone with a rotator cuff injury. You start them with NSAIDs, rest, and physical therapy. You proceed to steroids if they do not respond, and surgery is used with complete tears and those not responding to NSAIDs, steroids, and physical therapy. The cause of patellofemoral syndrome is essentially anterior knee pain secondary to a trauma, an imbalance of quadriceps strength, or simply a meniscal tear. It presents with pain in front of the knee or underneath the patella. It's worse when walking up or down stairs, and it's worse just after starting to walk after having been seated for a prolonged period of time. Ironically, though, it improves after walking. Patients with patellofemoral syndrome will present with crepitus, joint locking, and instability. If you get some x-rays, they're going to be normal. Most cases are not going to respond to physical therapy and strength training with cycling. Remember, knee braces don't help in this case because there's nothing to fix surgically. Plantar fasciitis presents with very severe pain in the bottom of your foot. It's near the calcaneus where the fascia inserts. Patients will typically say they feel like there's a tack in the bottom of their foot. It is of unclear etiology, but the pain is worse in the morning and improves with walking simply a few steps. There's also point tenderness at the bottom of the foot where the fascia inserts into the calcaneus. You can distinguish this from tarsal tunnel syndrome because the pain of that disorder worsens with use, and plantar fasciitis clearly improves with use. Now here's a patient with plantar fasciitis. It's a plain old x-ray. We don't recommend getting one because there's no real association between plantar fasciitis and heel spurs that you see here in the radiograph. The treatment consists of stretching exercises, arch supports, and NSAIDs. Steroid injection is performed if these don't solve the problem, but they usually do. Surgical release of the plantar fascia is rarely necessary. What you should keep in mind is that X-ray of the foot is not useful in plantar fasciitis. There is no correlation with the presence of heel spurs. We will now discuss osteoporosis. Look for an older person, more often a female, with vertebral fractures leading to a loss of height or wrist fractures. Asymptomatic fractures can be found on routine DEXA scans. We recommend DEXA scans for all women greater than 65. Osteoporosis will give you spontaneous fractures of the weight-bearing bones. This can help with diagnosis. The most accurate test is a bone densitometry, or DEXA scan. The T-score that's resulted from a DEXA compares bone density with the normal density of a young woman. There are two diagnoses. The first is osteopenia. This is a bone density with a T-score that's between 1 and 2.5 standard deviations below normal. Osteoporosis is a T-score more than 2.5 standard deviations below normal. All blood tests, including calcium, phosphate, and parathyroid hormone, are normal in osteoporosis. Vitamin D and calcium are the best initial therapy. Bisphosphonates are then used when the T-score is more than 2.5 standard deviations below normal. Estrogen replacement is especially useful in postmenopausal women, but it does have side effects. Raloxifene is then used as a substitute for estrogen in postmenopausal women. It also reduces the risk of breast cancer and decreases LDL levels. Teriparatide is an analog of PTH that stimulates new bone formation. That's one option for treatment. Another is used as a nasal spray. Calcitonin can also decrease vertebral fracture risk. Here's a little note for you. Bisphosphonates are very rarely associated with osteonecrosis of the jaw. It's just the news that sensationalizes this idea. Bisphosphonates that have prolonged contact with the esophagus can cause esophagitis. This is known as pill esophagitis. When you have a question about osteoporosis and multiple treatment options are presented, choose vitamin D, calcium, and then bisphosphonates. Teriparatide has caused osteosarcoma in rats. It can also cause hypercalcemia, so look out for these as two possible side effects of the medication.
Our next lecture is going to focus on tuberculosis. As you know, tuberculosis is a disease caused by a microorganism called Mycobacterium tuberculosis. Most commonly, the initial infection with Mycobacterium tuberculosis usually leads to what we call latent tuberculosis. Most symptomatic cases of tuberculosis are actually due to reactivation of the latent form rather than a primary exposure. Pulmonary tuberculosis is the most common manifestation, but really, TB can affect any organ system. Almost all patients with tuberculosis have one or more established risk factors. These include recent immigration from outside of the United States within the past 5 years. That's because after 5 years, the risk of reactivating tuberculosis is extremely low. Prisoners, HIV-positive patients, healthcare workers, anybody who has close contact with a TB patient, steroid users, patients with hematologic malignancy, alcoholics, or patients with diabetes mellitus. The clinical presentation usually includes previously listed risk factors, presenting with a fever, cough, sputum, weight loss, hemoptysis, and night sweats. These symptoms are almost always present for greater than or equal to 3 weeks in duration. Remember, on step 2, you cannot answer TB as the diagnosis without a clear risk factor. You must also have a cavity on chest x-ray or a positive smear for Mycobacterium. The best initial test for tuberculosis will be a chest x-ray, as is the case with all respiratory infections. The sputum stain and culture must be specific for acid-fast bacteria, something which Mycobacteria qualifies as, and this must be done 3 separate times and must be negative 3 separate times to fully exclude TB. If you do this, but your clinical suspicion is still high, you must pursue further diagnostics with either a bronchoscopy with BAL or through a pleural biopsy. Remember, a PPD skin test is never the best test for tuberculosis in a symptomatic patient. PPD is a screening test. The most common finding on imaging is going to be a cavity in the upper lobes. Here's a good example. Here you see upper lobe tuberculosis and some scarring that's pulling the minor fissure upwards. The scarring is from the initial infection which initially healed. The cavity is from reactivation that's probably causing the patient's current symptoms. Regarding the management of tuberculosis, once you have a positive smear, you should begin therapy with a 4-drug regimen. This includes rifampin, isoniazid, pyrazinamide, and ethambutol, which you can memorize through the acronym RIPE. Ethambutol, however, is not needed if it's known from the start of therapy that the organism is sensitive to all tuberculous medications. That's because ethambutol is given as part of this 4-drug regimen prior to knowing the sensitivity of the organism. It helps with bugs that are actually resistant to certain types of anti-TB therapy. After you use RIPE for 2 months, you can stop the ethambutol and the pyrazinamide. At that point, you continue rifampin and isoniazid for the next 4 months. The standard of care is to treat tuberculosis for 6 months of total therapy. Treatment is extended to 9 months in the following situations: osteomyelitis, miliary tuberculosis, which is widespread disease at the time of presentation, meningitis, or if there's pregnancy or any other time that pyrazinamide therapy is contraindicated. For step 2, you should also be familiar with the toxicities of anti-TB therapy. All TB medications, including the 4 we've mentioned, cause hepatotoxicity. You should not stop them, however, unless the transaminases rise to 3 to 5 times the upper limit of normal. A slight bump does not necessitate cessation of anti-TB therapy. Individual adverse effects include the following. For rifampin, toxicities are a red color to body secretions, and the treatment is going to be none, because that's simply a benign finding. For isoniazid, you can sometimes see peripheral neuropathy. The way to treat this is to use pyridoxine to prevent this from happening in the first place. Pyrazinamide has some toxicity, which is mostly hyperuricemia. Therefore, you don't have to treat these patients unless they become symptomatic with gout. In that case, you treat them the same as a gout flare. With regard to ethambutol, optic neuritis and changes in color vision is the main side effect. For this, you simply decrease the dose if the patient is in renal failure. Regarding the use of steroids in TB, glucocorticoids decrease the risk of constrictive pericarditis in those who have pericardial involvement of the TB. This can also decrease neurologic complications in TB meningitis. Remember, in TB treatment, pregnant patients should not receive pyrazinamide. One commonly tested point on step 2 is the correct use of the PPD. Indications for using a PPD test include the following. It is not a general screening test for the entire population. It's only used in risk groups previously described who need to be screened. The PPD test is not useful in those who are symptomatic or in those with abnormal chest x-rays. Again, it's a screening test, not a diagnostic test. So, what is considered a positive test? Induration is counted as positive. Erythema alone is irrelevant. You must have raised indurated skin. Induration greater than 5 millimeters is considered positive in HIV-positive patients, glucocorticoid users, close contact with active TB patients, abnormal calcifications on the chest x-ray, organ transplant recipients. Induration greater than 10 millimeters is necessary to call it positive if it's a recent immigrant within the past 5 years, a prisoner, healthcare worker, close contact with a TB patient, or patients with hematologic malignancy, alcoholism, or diabetes. In other patients, in particular healthy patients without risk factors, induration greater than 15 millimeters is necessary to call a positive PPD. Remember, everyone with a reactive PPD test should have a chest X-ray as the next step to exclude active disease. The PPD itself is actually a two-stage test. If the patient has never had a PPD before, a second test is indicated within 1 to 2 weeks if the first test is negative. This is because the first test may be falsely negative. If the second test is negative, you can be certain this is a true negative. If the second test is positive, that means your first test was actually a false negative. If the first test is positive, a second test is not necessary. If the PPD is confirmed as positive, then the first step is going to be to exclude active TB. This is done with a chest X-ray. If the chest X-ray is normal and active TB has been excluded, patients should receive 9 months of isoniazid monotherapy. The positive PPD confers a 10% lifetime risk of TB. Isoniazid therapy will then result in a 90% reduction in risk. Therefore, your lifetime risk of reactivation goes from about 10% down to 1%. Those at really high risk, such as healthcare workers, should have a PPD annually in order to screen for conversion to a positive PPD and therefore for TB exposure. The majority of risk for developing active TB actually lies within those first 2 years after conversion. Once the PPD is positive, it will always be positive in the future. On step 2, one particularly important tip is that the PPD test is one of the hardest and most misunderstood tests on this exam. You have to reread the preceding section and forget what you've learned in the past. What is given to you in this lecture is the way to approach PPD questions on step 2. Lastly, please remember that the previous BCG vaccination has no effect on these recommendations.
Syphilis, condylomata acuminata, pediculosis, which is crabs, and scabies. How do we answer the question, what is the most likely diagnosis? Because urethritis and cystitis both give you dysuria, frequency, and burning. That is to say, frequency, urgency, burning, and dysuria are in common between both disorders. However, cystitis does not give you a discharge. For urethritis and diagnostic tests, the best initial test is the urethral swab for gram stain and white cells. Now, that's for men only, that it's the most accurate test right now. And what you're looking for is intracellular gram-negative diplococci, which basically is Neisseria gonorrhea. It's always been that way. That's old standard and quite correct, because it's the only way you can tell this instant while the person's with you in the office or clinic. The most accurate test is urine, voided urine. Now, this is very important. Don't let this slip you by, that the significance of that it's a urine test. It doesn't need a physician, doesn't even really need healthcare work. You'd say pee into this cup, and the urine for nucleic acid amplification detects gonorrhea and chlamydia. The nucleic acid amplification is a DNA probe. That is the most accurate test. And that extends markedly your ability to screen lots of people. And this is one of those neat things where it's both better for the patient because it's much more comfortable. A urethral swab is very uncomfortable. And more accurate and better for society too, because it's less expensive than having to go see the doctor. Other causes of urethritis are Mycoplasma genitalium, ureaplasma, ureolyticum, and in women can do a self-administered vaginal swab. Wow, again, a great opportunity, much easier. Treatment is a combination of one drug for gonorrhea and one drug for chlamydia. Quinolones aren't the best initial therapy anymore because of resistance. The STDs have been passing around between each other, something dirty. They've been tossing around a plasmid because the plasmid between the STD is kind of like a STD, really. They've been tossing around something that's been getting around to everybody and making things difficult, a plasmid. And Because of resistance, we're going to use for gonorrhea cefixime, which is a oral third-generation cephalosporin, and ceftriaxone, which is an intramuscular. That's what we use it here in STDs. We use it intramuscularly, intravenously for most other things. The reason why azithromycin is so easy is because it's one single dose orally of azithromycin and doxycycline. So the treatment, one gonorrhea drug and one chlamydia drug. Now that means it can be cefixime and azithromycin, or ceftriaxone and azithromycin, or ceftriaxone and azithromycin, as long as you just have one from the column on the left and one from the column on the right. And this goes for both men and women as the initial therapy. Cervicitis is an infection of the cervix. It means that it's not a vaginitis. That's a very precise term because vaginitis is very different. Vaginitis is not gonorrhea and chlamydia. Vaginitis implies extra bacteria or protozoans like Trichomonas growing in the vaginal vault. Cervicitis always implies an STD. It is one that causes an inflamed or strawberry cervix on speculum examination. And the testing and treatment are identical to what we just said for urethritis, which is, except you can use a self-administered vaginal swab for the nucleic acid amplification test. Now, there's a big deal. Again, don't let it slip you by. If it says, which should seem better, which is the gynecologist does a speculum exam and gets in there and quite precisely places the swab in the cervix, sounds like it's more accurate, doesn't it? But it's not. Ma'am, hi, would you be so kind as to take this swab and to apply it inside your vagina, put it in until it doesn't go up anymore, and you do it very gently, and just put it in this container and leave it for the nurse at the desk. Thank you so much for coming. Pelvic inflammatory disease, cervicitis, and urethritis are all caused by the same bugs, which is to say gonorrhea, chlamydia, and that's why the treatment for urethritis and cervicitis are 100% identical. Single dose cefixime or ceftriaxone, single dose azithromycin, or a week or two's worth of doxycycline, one gonorrhea drug, one chlamydia drug. Pelvic inflammatory disease adds a little bit more because there's the possibility of pelvic anaerobes, and it presents with lower abdominal tenderness and lower abdominal pain, fever, well, says the infectious disease section, cervical motion tenderness, which can only be found on physical examination with bimanual examination, 2 hands, and white count up is often found. Not essential, not essential, not essential, but often found. You don't have to do blood for a white cell count, but it's contributory. So the question will say, a woman comes in with lower abdominal tenderness and lower abdominal pain, cervical motion tenderness. What is the next best step? What is the most appropriate action at this time? Now, when they say action, step, and do, does it mean a test or a treatment? In this case, it means always exclude pregnancy first and don't believe sexual histories. Once you've excluded a pregnancy as a cause of the lower abdominal pain and tenderness, you might say, well, how can just the pregnancy do that? Well, it's not the pregnancy that would do that. It would be the ectopic pregnancy that would cause the pain, fever, tender, even white count. If it's the ectopic pregnancy or the ruptured one, the most specific tests for pelvic inflammatory disease is a cervical swab for culture, DNA probe for nucleic acid amplification testing, and these tests will clarify the need for treating the partner. That's one of the reasons to do them. If you're going to treat both anyway, why bother testing? The answer is 1, to confirm what the person has. Number 2, you need to be able to treat the partner and also to be able to chase it down through the community. Culture is preferred for the gonorrhea, because the only way to be sure what the sensitivity is of the gonorrhea is with culture. That's the only way. We don't have a genetic testing way for gonorrhea and chlamydia to determine resistance. We have it for HIV. We have genotyping for HIV, where you can do it on just one single blood test, but this kind of test is not available for gonorrhea. Now, cervical testing isn't the most accurate test for PID. Ooh, that's a surprise for a lot of people. Cervical testing, such as cervical swab and stain and culture, DNA probe, is not the single most accurate. The single most accurate is. The most accurate is laparoscopy. It's only rarely needed, but it is the answer to the question, what's the most accurate? It's rather like doing a tympanocentesis or sinus biopsy in someone who has otitis media or sinusitis. Laparoscopy is the answer if and only if the diagnosis is unclear, the symptoms persist despite therapy, or there's recurrent episodes. It is certainly not done routinely. It is not even done in a significant minority. It's not even done in 10 or 15%. It's done very rarely for those people who don't respond to therapy or simply keep coming back. Why does it keep coming back? Maybe that wasn't the diagnosis. Laparoscopy. For pelvic inflammatory disease, we're going to use a combination of medications for chlamydia and gonorrhea. And this is very similar to what we said for urethritis and cervicitis, but for inpatients, it's slightly different. Cefoxitin or cefotetan is combined with doxycycline. Now, this indication is the only time you're going to ever hear us say that there's a quite specific indication for cefoxitin or cefotetan. These two drugs don't have a specific indication for anything else except this, meaning that, well, ceftriaxone is a drug of choice for community-acquired pneumonia. Ceftriaxone is a drug of choice for meningitis, and there are a lot of things like that. But here, because these are the only two cephalosporins that cover anaerobes, we use it for more severe PID because more severe PID has pelvic anaerobes. Outpatients, which is felt not to be as definitively with pelvic anaerobes, can be ceftriaxone and doxycycline. So you see that the major issue is going longer in therapy. That's why instead of single-dose azithromycin, we're going to use doxycycline. And sometimes the outpatient therapy is metronidazole to cover, again, those pelvic anaerobes, metronidazole anaerobes. Now, sometimes students who have anxiety problems will think, wow, what if they ask you to choose ceftriaxone and doxycycline, or ceftriaxone, doxycycline, and metronidazole? Wow, which one do I choose? Well, it's not like that. You don't get asked to choose things where they're both potentially right. That's just not rational thinking. That's not how it goes. If there's anaphylaxis to penicillin, remember, if there's a rash, you can use the cephalosporin. If there's a rash, you could use the cephalosporin. But anaphylaxis, meaning hypotension, tachycardia, breathlessness, use levofloxacin, metronidazole, as an outpatient, or clindamycin and gentamicin as an inpatient. And remember, only anaphylaxis. Ulcerative genital disease. How do I answer what is the most likely diagnosis? Well, it's often impossible to determine the specific diagnostic or visual characteristics that are going to allow you to answer that question. And if they want you to know the answer, they have to tell you something, period. The question has to have sufficient evidence to give an answer. All genital ulcers have inguinal adenopathy, and if all they say is it's an ulcer with adenopathy, no one would know what the answer is. If the history and physical describe a painless ulcer, often described as heaped up indurated edges, the most likely diagnosis is syphilis. And if instead it says a painful ulcer, soft and painful, it is chancroid. Chancroid, which is Haemophilus ducreyi, or ay, it hurts me, I do cry. If the lymph nodes are tender and separating means they actually burst with pus or purulent material, the most likely diagnosis is lymphogranuloma venereum. Now, why don't you look at that presentation? Lymph nodes, problem mostly? Lymphogranuloma venereum. Ooh, lymph nodes, lympho. Vesicles prior to the ulcer, and they're painful, is herpes. And when herpes loses its vesicles, because they're in the genital area, rubs up against things, and the roofs come off. And the roofs come off, and it's just an ulcer. You can't actually answer what is the most likely diagnosis until you do further testing, such as the Zank prep. What is the diagnosis and most accurate diagnostic test? For syphilis as a diagnosis, the best initial test is the dark field. Now, this is the only way to be nearly 100% sensitive in primary syphilis. The VDRL, or RPR, are only 75% sensitive. There's a 25% false negative rate on these. You need time for the body to develop a response, and that is not going to happen in primary syphilis in 1 in 4 people. That's a huge miss. So dark field microscopy is the only way to be sure. FTA or MHATP, fluorescent treponemal antibody, or the microhemagglutination assay for treponema pallidum. Wow, that's long words, isn't there? These are used to confirm things, but they're delayed. So don't let people fool you by saying, well, we don't do that. It doesn't matter what you do or don't do. What's the most accurate test? The most accurate test in primary is a dark field. Chancroid, which is a Haemophilus, because it's a Haemophilus, you can see it on a stain. Now, it may need a special culture, but since it is a Haemophilus, you can see it as a pleomorphic gram-negative coccobacillus. Pleomorphic gram-negative coccobacillus means somewhere between a coccyx and a rod. Lymphogranuloma venereum is caused by chlamydia, and since chlamydia is not visible in a gram stain, since it's intracellular, since chlamydia does not grow in regular culture medium because it's intracellular and blood agar doesn't have cells, since it's not seen in gram stain or regular culture media, you have to use special non-culture methods such as complement fixation titers, serology, nucleic acid testing, DNA probes. Herpes simplex, the best initial test is the zinc prep. The zinc prep is it's like a pap smear, honestly. You swab the lesion, you take up cells, you see multinucleated giant cells. Now, the zinc prep will not allow you to tell the difference between herpes 1 and herpes 2. As a matter of fact, it doesn't even allow you to tell the difference between herpes 1, herpes 2, and varicella. But in terms of treatment, well, it doesn't really matter whether it's herpes 1 or herpes 2 because they're all going to get acyclovir, famciclovir, valacyclovir anyway, and it's available instantly. Now, the most accurate test is a viral culture. This may be hard for some of you to grasp that we actually do culture for viruses, but we do. We don't do it a lot, but for herpes is a fast grower. And actually, it'll grow like 2 to 3 days just as a regular bacterial culture would. And it's certainly the most accurate test. Now, it may not grow in regular bacterial blood agar, but it will grow in a cell line culture. You take some cells, plate them out, you throw the virus in there, and if the virus is in there, you can tell it makes the cells misshapen in 48 hours. Really easy. The dark field exam is certainly the most accurate test of primary syphilis. And if the dark field is positive for spirochetes, no further testing for syphilis is necessary. The dark field has such tremendous specificity that no further testing for syphilis is needed because once you actually see organism, it is far more specific than indirect tests like an FTA or VDRL. Treatment for syphilis, as it was in the beginning and will be for a long time, the best initial therapy for both primary and secondary syphilis is one single intramuscular shot of benzathine penicillin. And benzathine is just a longer-acting version of penicillin. Doxycycline if you're penicillin allergic. Doxycycline for primary and secondary syphilis. For chancroid, we will use a single dose of azithromycin orally, very easy. Lymphogranuloma venereum, because it is a chlamydia, LGV can be treated with doxycycline because it's a chlamydia. It goes longer because it's more deep-seated. Herpes simplex is going to be treated with acyclovir, valacyclovir, or famciclovir, and they are identical in efficacy. For those who have recurrent treatment, and develop resistant acyclovir-resistant herpes, which can be detected on viral sensitivity testing, the therapy is foscarnet, which works through a different mechanism of action. It does not work through thymidine kinase. The most common wrong answer in that one is to say ganciclovir. And ganciclovir is a drug that works through thymidine kinase too. If you're resistant to acyclovir, you'll be resistant to ganciclovir too. So therefore, you got to use foscarnet. A woman comes to clinic with multiple painful genital vesicles. What is that next best step? What do you do? Do you treat? Do you test? And the answer is straight to treatment. When you have clear genital vesicles, you should go straight to oral acyclovir. Topical acyclovir simply isn't effective. Matter of fact, it's so ineffective as to be worthless. And I don't use that word lightly. It has the same efficacy as placebo. Remember, step 2 does test route of administration. Zinc prep is not necessary if the presentation is diagnostic. Testing is not necessary if the presentation is diagnostic. Testing is not necessary. The same answer applies to viral culture. Although it is the most accurate test, it's not necessary if the vesicles are clear and obvious. Serology is worthless because it can't distinguish genital infection from oral infections in the past. People make this mistake all the time. They think that getting serologic testing has any degree of specificity. It doesn't. 95% of the population is seropositive for herpes because if you had a cold sore from almost any form of human contact in the last 50 years, your IgG will be positive in your blood. It's worthless. PCR is what you do in a brain, not the genitals. That's for your head, not for your penis or your genitals. Primary syphilis presents with a painless genital ulcer with heaped up indurated edges. It becomes painful, it becomes secondarily infected with bacteria, and then you might say, well, how will they be able to tell the difference then? How will you be able to tell the difference from that and chancroid if it becomes painful? And the answer is, you can't, and neither can I. It has painless adenopathy. Well, what if it becomes painful? How do you tell the difference between that and LGV? Well, you can't. You see, my friends, if they want you to know the answer, they have to tell you something. And genital lesions are a perfect example of that. Chancres are gonna heal anyway, even without treatment. The penicillin may make it heal faster, but the penicillin is there predominantly to prevent later stages of the disease. That's why you're treating. It's very hard for people to realize that primary and even secondary syphilis resolves spontaneously. It's very hard to get that. Well, that's the fact. It does. And if you don't treat them, it resolves, and then it presents later on with secondary syphilis, which is palm and sole rash. Generalized, but often on the palms and soles too. Alopecia areata. Areata means in areas, like patchy. Mucus patches. And alopecia areata means patches of hair loss, and mucus patches mean patches of mucus, usually on the mouth and genital lesions. Condylomata lata on the genital areas. Now, don't be confused that with the word condylomata acuminata. Condylomata lata is syphilis, and condylomata acuminata is papillomavirus. That's genital warts. Tertiary syphilis presents with heart problems, gummas, neurosyphilis. Which of the following is the most common? And the answer is neurosyphilis. Neurosyphilis could be a shriveled up general paretic brain. It could be vasculitis in a young person. So meningovascular means the meninges and the vascular system are inflamed. It used to be much more common, but it'll describe a person who has a stroke at a young age. When you see a stroke in a 35 and 40-year-old, wow, why did that happen? Even 45 or 50, why? Why a stroke at 35? Get a VDRL or RPR. Could have been syphilis. Tabes dorsalis is loss of position or vibratory sense with involvement of the posterior columns, like B12 deficiency. It's talked about quite a lot, so I'm sure this is one of the only things that people end up knowing when they go through classes like this. Incontinence and some cranial nerve abnormalities. In addition to the tabes dorsalis and the vasculitis causing strokes in a young person, the other presentations of neurosyphilis are general paresis. Well, what does that mean? It means general weakness. It means your memory and personality change. It means your brain becomes the size of like a walnut by the time you die. It's really tiny. Or an Argyll-Robertson pupil, which is a pupil that will change with accommodation but won't react to light. It will change with accommodation, meaning when you look close at something, it will constrict, but it won't react to light. Aortitis, aortic regurgitation, aortic aneurysm, and gummas, which are skin and bone lesions where the skin and bone just break down. It's like a big ulcer or sore. Let's summarize the diagnostic testing of syphilis. For primary syphilis, the VDRL or RPR has a 75 to 80% sensitivity. A specific test, the fluorescent treponemal antibody, has a 95% sensitivity and specificity in primary syphilis. The secondary syphilis, the VDRL and RPR is essentially 100% sensitive and 100% specific. However, there's a tiny number of false negatives, but almost nothing for secondary syphilis. Tertiary syphilis, the VDRL and RPR have a 95% sensitivity, and the FDA is extremely specific. There are a lot of causes of false positive VDRLs and RPRs. This is a test that overreacts to other causes of antibodies being made in the body, such as infection, or just by being older, you accumulate a lot of previous injury and antibodies. Same way, just by being older, you get more false positive rheumatoid factors. Injection drug use, that's very common. AIDS, malaria. Antiphospholipids is especially important because the reagent in the VDRL is a phospholipid. So the antiphospholipid syndrome antibody simply reacts against the phospholipid in the test. And it's the same with anticardiolipin antibodies. The reagent in the VDRL is a cardiolipin. And endocarditis is a cause of chronic infection. Most people don't understand with endocarditis how many antibodies there are floating around there. It's a very common cause of false positive VDRL or RPR. It's a very common cause of the anemia of chronic disease, too, the endocarditis. But for false positives, titers are rarely above 1 to 8. Rarely above 1 to 8. When they're false positive, they're tiny, 1 to 1, 1 to 2, 1 to 4. A low titer is simply more often falsely positive, and high titers are rarely false positive. And can you say, you mean the higher the titer, the more likely it is to be real? Yes, the higher the titer, the more likely it is to be real. False positive ones are generally positive at very low titers. The treatment of primary and secondary syphilis is 1 single intramuscular shot of penicillin, oral doxycycline if you're penicillin allergic, and tertiary syphilis gets IV penicillin and desensitization if you're allergic. This is to remind you. Why am I saying this again? Because I don't want you answering desensitization for primary and secondary syphilis if you're penicillin allergic. That's for neuro and for pregnancy. The Jarisch-Herxheimer reaction is a febrile, uncomfortable reaction from the treatment of syphilis. When the organism dies, it releases antigens and pyrogens that simply make you briefly and temporarily uncomfortable. It has absolutely no danger to the patient whatsoever. It's just uncomfortable. You give them aspirin and antipyretics, and it'll pass. Make people comfortable. It's inflammatory. Give them anti-inflammatories. Desensitization is for neurosyphilis and pregnancy only. Genital warts, Condylomata acuminata, is a papillomavirus. Well, lots of people have papillomavirus. Yeah, but they don't have the genital warts. It's based on basically you see them. You see those lumpy white things there. They're a little paler, and that's because you don't have the normal pigments, because it's just squamous cells. You see them. You don't need to biopsy. You don't need serology. You don't need stains, smears, cultures, aerial photography, satellite imagery. How do they look? They look like a wart. You got a wart. That's it, period. Same answer for molluscum contagiosum as well. The treatment of all warts, and not just Condylomata acuminata, but molluscum contagiosum and common warts as well, is simply to remove it. And it's a bit like shaving or cutting your toenails, which is to say, in this case, just cryotherapy, freezes them off, liquid nitrogen, very cold, freeze them off. Surgery for large ones. Laser can sort of cut them off with laser, melt them off with podophyllin or trichloroacetic acid. And imiquimod is the only one that seems structurally different because, one, it's self-administered and applied locally by the patient, and it's an immunostimulant leading to sloughing off of a lesion, and you can't go too far. The problem with cryotherapy and laser and podophyllin is that the patients can experience some damage to surrounding tissue, can hurt, can burn, it's uncomfortable. But imiquimod is very gentle, just slow. It's slow. How do I answer the diagnosis crabs? Well, you see it. You see it, little dark buggies there. You see those little dark buggies there hiding out amongst the trees of the hair in your pubic area and your axilla. It's itchy. It's visible on the surface, and you treat them with permethrin. Lindane is equally effective, but it's more toxic. Lindane basically is not toxic in normal use, but when people see this sort of thing, especially in their children, they start to go too far and like, oh my God, I got crabs! and they start putting it on 5 times a day. And at toxicity causes seizures in children, because if you start putting it on, it gets absorbed, then it does cause neurotoxicity. If both answers are in the choice, then there is a clear superior answer, permethrin, because first we start with efficacy, then we go to adverse effects. And since both have equal efficacy and permethrin has less adverse effects, permethrin wins. Scabies are much smaller. They're tiny. It's like baby, scaby baby. And they dig in the web spaces between fingers and toes or elbows, around nipples or near the genitals. And they burrow and they dig and they burrow and they dig. And they're smaller than pediculosis, literally 5 times smaller. And you have to scrape these guys out. See little arrows there pointing them. You got to scrape them out and magnify them. That's the only way to find them. They're too tiny to be seen. What we actually see is the burrows. And why you itch is because as they dig underneath you, they excrete poo-poo that causes you to react, and it's sort of inflaming. Itchy, 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 because reaction to the scabies stool. Therapy for scabies is permethrin, same as it is for crabs. Now we got one extra thing. Widespread disease, often in immunocompromised people, sometimes called Norwegian scabies. It has to be treated with oral ivermectin. It's more efficacy. And this is severe disease, and all patients need repeated dosing, because what you do is you kill live ones and you come back a few days later and kill the larva. But oral ivermectin is for widespread crusted Norwegian scabies. And it will say widespread, it will say crusted, and it will often say an immunocompromised person. Hi, I'm Conrad Fisher. I'm an associate professor of medicine, pharmacology, and physiology at Touro College of Medicine, and the director of educational development at the Jamaica Hospital System. This is the neurology section. Stroke is in the top 3 causes of death in the United States, part of cerebrovascular disease, and a stroke is an irreversible neurologic deficit. It can happen at any time. A stroke is defined as a sudden onset of a neurological deficit, and it is the death of brain tissue. Now, it's not the death of brain tissue instantaneously. It can reverse, and that would be a transient ischemic attack, or TIA. But the word stroke implies that it is a completed neurological injury resulting in irreversible death of brain tissue. When the word stroke is used, it is specifically means it is not a TIA. It is past a TIA. It's not coming back. It is the 3rd most common cause of death overall, and the risk factors are high blood pressure, diabetes, hyperlipidemia, tobacco smoking, in much the same way as they are for any vascular disease. Now, there is not a specific risk factor of family history or premature disease, and the gender predominance, whether it's men or women, is not as closely present in stroke as it is in coronary artery disease. And now this is also important because the use of statin medications, which is often based on the number of risk factors a person has, is not as clear for stroke. That's for carotid disease. So the reason that knowing these risk factors is so important is because it tells you which things you can correct. And that is why in stroke, the emphasis is all on correctable and reversible risk factors, not things like family history or the individual patient's gender or the individual person's age, which are fundamentally not reversible. Now, those questions that say, which of the following is the most common hypertension, which is the following worst risk factor, those questions are still the same. The etiology of stroke, in the majority of cases, is from a blockage of flow that's either embolic or thrombotic, with embolic being far more common. Bleeding accounts for only about 15% of strokes, but this is indispensably important because it underlies the question, why is a CT scan absolutely indispensable before any form of therapy? You can't give so much as an aspirin without having done that head CT first. Indispensable. Now, the head CT may not reach its maximum sensitivity for 4 or 5 days. It doesn't reach 90 to 95, 98% sensitivity until 4 days, 5 days, and even 80% sensitivity in about 3 days. But hemorrhage is seen instantaneously. It's the embolic things from the heart
from atrial fibrillation or valvular heart disease, or a DVT going up paradoxically through the patent foraminal valley. Now, it's not enough to say, well, this person has a patent foraminal valley and they must have a paradoxical embolus. That's not enough. 1/3 of the population has a patent foraminal valley. You can't say that just because you have a patent foraminal valley, it needs to be closed. This is a hot topic and not going to be on your Step 2 exam, except to say when they say a patient has a stroke and a patent foraminal valley, what should you do? The answer is not automatically close the patent foraminal valley, because that would be like saying 1/3 of patients with strokes have a patent foraminal valley because 1/3 of the population has a patent foraminal valley. Now, carotid stenosis is the other major source of embolic phenomena up to that brain. But that bleeding, that's the most important thing to exclude in the first half hour after the patient comes to the emergency department. Let's pause for a minute and take a look at this diagram of the cerebral circulation. The middle cerebral artery has the majority of the strokes because it is by far larger in terms of flow, far larger than the anterior and posterior circulation put together. The ACA is the anterior cerebral artery, and the PCA is a posterior cerebral artery, and they're simply much smaller. They also go at right angle turns. Very hard to be able to make that turn right into a stroke. But the middle cerebral artery is both larger and a straight shot up from your heart and carotids straight into that brain. The middle cerebral artery stroke accounts for 90% of all strokes. It presents with weakness or sensory loss on the opposite side of the body from which the stroke occurred. It presents with the contralateral side, weakness, and motor loss, and sensory loss. A contralateral homonymous hemianopsia, you're losing half the visual field of each eye. The visual field loss is at the same side that the motor and sensory loss is. In other words, if I have a stroke in my left, I'm weak in my right hand. I also lose the right side of each visual field. Therefore, the eyes won't look towards the side of the lesion. If I have a stroke in my left, I lose the right visual field, and I start to look at the left. I look towards the lesion, and I have an aphasia because it's very easy to stroke out speech. Now, this happens if the stroke is on the same side as the speech center, which is basically on the left in 90%. An anterior cerebral artery stroke has the same fundamental risk factors as the middle cerebral artery strokes. They all do. Hypertension, diabetes, hyperlipidemia, and tobacco smoking. The difference for this and the other strokes is that the anterior cerebral artery stroke is a very clear set of defects, of personality or cognitive defects as you lose the frontal lobes. Urinary incontinence and leg weakness is greater than arm weakness. This clear triad should be telling you this is an anterior cerebral artery stroke. Now, the management, which is to CT scan them first to rule out bleeding, is still the same. The therapy, thrombolytics, and aspirin is still the same. Even the risk factors. But the major issue is simply getting the diagnosis. A posterior cerebral artery stroke is the only place in the body where you can have a stroke and lose consciousness. And it's very hard for people to understand that you can only lose consciousness by shutting off the brainstem. There isn't any other place with which to shut off. You lose consciousness at the brainstem, and you lose defects of both sensory on one side and motor or sensory on the other side. Wow, this is a very difficult thing because basically what you've got to do is say, gee, the brainstem is so packed in there, it's the only place you can get bilateral defects. See, you can't have a stroke of the left cerebral artery causing motor or sensory defects on the left. But since the posterior and vertebral basilar circulation is so densely packed in, you could have one stroke in the brainstem, which results in bilateral findings. And what more bilateral thing is there than loss of consciousness? That's bilateral. You can get sensory and motor problems on one side, ataxia on the other. So that's how you will recognize the PCA, posterior cerebral artery stroke. You will recognize it from 1, loss of consciousness, 2, bilateral findings, 3, that you are having dysphagia, dysarthria, dizziness. DDD, dysphagia, dysarthria, dizziness. The final issue is you don't have to have all of these findings for it to be a posterior cerebral artery stroke. You don't have to have all of them. The best initial test for a stroke is unquestionably the CT scan of the head. Of course, should it be with or without contrast? Why, at the beginning, the first scan should always be without contrast. Without contrast. No, you don't need contrast when you're looking for blood. You don't need contrast when you're looking for blood. Blood shows up just like contrast. Now, the most accurate test for stroke is the MRI. The MRI is the most accurate test. And that is not only because it shows the brainstem and because it becomes abnormal as soon as 12, 24 hours after the onset of stroke. And the MRA, magnetic resonance angiogram, why that one can be abnormal as soon as 4 or 6 hours after the onset of stroke. Wow, that's so instantaneous, isn't it? What are you going to find in that CT scan? Well, the blood is the easiest thing. The blood happens immediately, and the CT scan is done first to exclude hemorrhage. The stroke you see here in front of you is the dark parts on the left-hand side of the picture. The dark parts are stroke because they're also surrounded by edema. That's why the midline seems shifted over to the right. This is a massive middle cerebral artery stroke, and if it looks like it's extending all the way into the front part of the brain, it's because it is. It is because a massive middle cerebral artery stroke pushes around the rest of the brain. But you still need that CT scan, even though what we're really doing is saying the CT is done first, but this image you see in front of you, this is of a stroke several days later. This is of a stroke on the 4th hospital day. This is not what you would find on the first day after the stroke. You do this to start treatment. You cannot give any form of therapy directly for a stroke without that CT, because remember, almost all forms of therapy are based on anticoagulation. The standard of care in the treatment of a non-hemorrhagic stroke is based entirely on the number of hours since the onset of that stroke, and the best initial therapy when it's less than 3 hours since the onset. 3 hours is the cutoff for the use of thrombolytics. When it's more than 3 hours after the onset of the stroke, the next step is aspirin. They are not going to ask you non-FDA approved indications like up to 4.5 hours. The FDA approved indication for thrombolytics is 3 hours, and that's the answer. Period. You can trust it. If the patient is already on aspirin, you can add dipridamole or switch to clopidogrel. This is not a small issue. Adding dipridamole adds efficacy without adding complications. Brain is delicate tissue. It bleeds easily. The heart is tougher and the heart contracts. But brain tissue is delicate. It ruptures, it breaks, and the blood spills in. That is why sources that might have led you to believe that you add the clopidogrel is not correct, because dual platelet therapy is correct for the heart, it's correct post-stenting, it's correct for initially for acute coronary syndromes and acute myocardial infarctions, because in the heart it adds efficacy and in the brain it only adds bleeding. The same with heparin. In the heart it adds efficacy to unstable angina. In the brain, heparin adds bleeding. In the heart, we angioplasty routinely. It's an excellent treatment. But in the brain, no angioplasty of the brain, never. We don't have anything good to reverse a hemorrhagic stroke. And the best initial therapy is, unfortunately, nothing. So the problem with a hemorrhagic stroke is if you dig down there to drain it out, it's going to bleed more. If you decompress it, it's going to bleed more. See, hemorrhagic stroke just has no treatment to reverse it, and not only do you provoke more bleeding, you damage brain tissue as you go down there to dig into it. And that's why, unfortunately, you have to just allow people to recover the amount of function that they can. They go to rehabilitation, occupational therapy, speech therapy. So if there was an option there that said occupational therapy, speech therapy, and rehabilitation, then that is the most likely answer. Now, it's a matter of nomenclature. Do you consider that treatment for a stroke? Well, it's not precisely treatment for a stroke. What it is that it helps you in the recovery process. So is it treatment to reverse a stroke? No. Is it the management of the human being who you'll try and get them into a sort of a gym or occupational therapy, speech therapy, or various forms of inpatient rehabilitation? Yes, and then it is very useful because the future of the patient. And the answer on your test, too. In terms of evaluating the causes of those strokes, especially for non-hemorrhagic strokes, we have to do an echocardiogram to look for damaged valves. Because if there are damaged valves, maybe we're going to replace the valve. Maybe there's thrombi, and we're going to use heparin followed by warfarin to an INR of 2 to 3. What we have to do is we have to look and see where did that come from with the eye towards this question. Can I reverse it? Can I fix it? Can I prevent the next one? Can I reverse it? Can I fix it? Can I prevent the next one? If you have damaged valves of which you can have replacement, you can prevent the next one. If there's a thrombus in the left atrium, you can prevent the next one. And that's why you're going to always work backwards in your head from, will this test change management? Will this test change management? Wow, is this cool? Look at that moving heart, man. That's fantastic. Wow, look at that floppy thing. It's a valve. I think it's way cool. Well, why does it look like it's upside down? It is actually. The top of the image is called an apical view. Basically, the transducer for sound is applied down by your xiphoid process. So it's kind of like somebody took a camera and shoved it up against your xiphoid process and looked up from the bottom of your heart and looked up at your ribs, up towards your head. And that is why the chambers on the bottom of the heart look smaller, because they're the atria. And the ones on the top look bigger, and they are the ventricles. Now, you might know that anatomically, the atria on the top of the heart. Well, why do they look like the bottom here? Because you're looking from the bottom up of the heart. And this really shows you that the way a heart works is that the heart contracts from the top down. The atria contract and shove the blood down, like you're bending in a crouching position, and then boom, you jump up into the air and try and touch the ceiling with your hands. And that's what an echocardiogram is, and that's why it is at the top of the image here is those atria. And what's really cool about this is that flopping opening door, because it is a really cool 2-second repeating tape, is that if you could see a vegetation, you'd see it flopping around there as if you took a big bunch of roses on a long stem and flipped them back and forth, and the head would sort of wobble, 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 wobble. Now, it's not that necessarily you're going to get asked to read echoes on step 2 of Usmle. It's the fact that it really helps you to understand, well, why are we doing these tests? That visual really says, oh yeah, of course I'm looking for the flopping door of that mitral valve to see if there's a vegetation or a thrombus in the middle of those chambers. So it's the idea of having seen it really helps visualize forever why you're doing the test and why you need to choose it on test day. Now, the EKG that you see in front of you is much more likely to be directly seen, which is the top image is the atrial fibrillation, which shows no P waves and the irregular rhythm. And the bottom image, NSR, means normal sinus rhythm, and that is PQRST, PQRST. This is, of course, indispensably important because that rhythm on the top there is such a common cause of our clots, such a common cause of the reasons for a person having an embolic stroke. And if you had a stroke, remember that's an automatic CHADS score of 2 if you have this arrhythmia with a stroke. So a stroke with that top EKG equals anticoagulation with warfarin, dabigatran, or rivaroxaban. Now, this is for atrial fibrillation or atrial flutter, and the warfarin continues as long as the arrhythmia persists. And it could be warfarin, dabigatran, or rivaroxaban. What is a Holter monitor and when is it the answer? A Holter monitor is a 24 to 48 hour long continuous EKG. When is it the answer? When I'm looking for atrial arrhythmias and the initial EKG is normal. So you got to be clear, a Holter is to detect the arrhythmias. That Holter is not to detect ischemia. If the initial EKG is normal, we're going to do a Holter as an ambulatory event. Telemetry is the inpatient version. Telemetry is what you do when patients are in the hospital and you hook them up to an EKG that's continuous. It allows you to have greater sensitivity to detect atrial arrhythmias. It's all about greater sensitivity, and it allows you, the Holter monitor, to analyze 24 or 48 hours of recording in seconds. Here's an image of that Holter monitor, and here is just to give you an idea of how the cursor or the tracer goes zipping through from beginning to end to find that arrhythmia, and there's a lot more accuracy than you might think. You don't have to look beat by beat. The computer analyzes it automatically. These tests are standard of care: echocardiogram, EKG, Holter, telemetry, and carotid duplex. The carotid duplex is because carotid stenosis is such a frequent cause of emboli to the brain. It is such a common cause, and you're looking for that carotid duplex to see whether there's symptomatic carotid stenosis at 70%. It has to be 70% and symptomatic. If it is less than 70%, we don't do operations. That's because it's not the cause of the stroke. And we simply don't know what to do for asymptomatic carotid stenosis. This is a point that sometimes students get very fussy about, asymptomatic, but I heard, but I read. The answer is step 2 is not getting into any of that. It's either going to be asymptomatic and low levels of stenosis, or it's going to be clearly symptomatic and a high level of stenosis greater than 70%. And it is really amazing that angioplasty is not good for the carotids. You would think it'd be good, but endarterectomy is simply better. Endarterectomy is superior: greater outcomes, greater resolution, greater prevention of subsequent strokes. In stroke, to summarize, the patient presents with sudden onset of unilateral weakness. They present with a facial droop. Speech defects may be there. The first test is definitely the head CT without contrast, because if there isn't any acute process, which is a fancy way of saying, yo, no blood, man, no blood, it's an ischemic stroke. And if there is blood, then you have, hemorrhagic stroke. Remember, acute blood is 1 to bone in the body, or 800 with metal. So that's why we'll say, hey, it's 160 Hounsfield units, 180 Hounsfield units, 190. What do you mean? What's the reference? How close it is to bone. 400 is bone, 0 is water. And I guess that's the human body on a range between water and bone. Going through the management of a likely ischemic stroke, here's one of the best algorithms you're going to see in their entire life. If it's under 3 hours from the onset of those symptoms, the next best step in the management of this patient is thrombolytics, if there's no history of bleeding. Now, you could have a non-hemorrhagic stroke 6 or 12 months ago, non-hemorrhagic stroke 6 or 12 months ago, but a hemorrhagic stroke at any time means never. Now, if it's more than 3 hours from the onset of those symptoms, the treatment for that patient is aspirin, or that you add diprotamol or switch to clopidogrel if already on aspirin. Now the question comes down to, what do you do after the thrombolytics? Well, after the thrombolytics, the next best step, look at the thrombolytic box on the left. The next best step is the little arrow to the right there, adding that aspirin. Well, if the symptoms have lasted less than 24 hours and they resolve, it's a TIA, and a TIA is managed pretty much the same way as you would a non-hemorrhagic stroke. Aspirin, if you're on aspirin, add diprotamol or switch to clopidogrel. And perform some further studies to assess the etiology. And you assess that etiology by looking at echo, looking at carotid Dopplers, looking at EKG and Holter monitor. The management of a hemorrhagic stroke is to reverse the things that are causing that stroke, such as very severe hypertension, but make sure you maintain that blood pressure above 140. You want a little extra blood pressure to maintain perfusion. So if the blood pressure is super high, like above 170 or 180, you got to use medications to bring it down. We're not bringing it down more than 25%, but at least we have something that can treat the high blood pressure. We don't have anything to reverse platelets. We have things to reverse anticoagulation with warfarin. There's enormous numbers of people walking around on warfarin because of their atrial fibrillation. And if they go too therapeutic, if they go above an INR of 3 or 4, the higher that INR is, in other words, why not give put everybody in an INR of 3 to 4 and prevent all strokes? Well, because you're going to start causing them too. You're going to start making them bleed into their brain. So the first thing to do if you're bleeding in your brain is to give fresh frozen plasma if there's a coagulopathy, only if there's a coagulopathy, or to give protamine if you're on heparin, because protamine instantly reverses the effect of the heparin. Goals of therapy in that stroke, diabetes. Let's get that hemoglobin A1C under control. That means hemoglobin A1C less than 7. Now that is a specifically different number than the diagnosis of diabetes. The diagnosis of diabetes, a hemoglobin A1C greater than 6.5%. But the goal of therapy is to get it just below 7. Hypertension, get that blood pressure down less than 140 over 90. Remember, the 130 over 80 number, the 130 over 80 number is in diabetics and those with renal insufficiency, diabetics and renal insufficiency. And LDL should be brought down to 100 or less if there's carotid stenosis. Now you might say, why not just bring everybody all the way down? Because what are you going to do to bring it down if it's up at 150 and it won't come down? Well, then go ahead and add a second agent and develop myositis, because gemfibrozole and statins in combo cause more myositis. Cholestyramine gives you flatulence and abdominal pain. Why are you going to put grandma on cholestyramine for a reason that she doesn't need to have the LDL down? Why give grandma flatulence to bring her to an LDL that doesn't make any difference? The goal of LDL is 100 if the person has carotid disease. That's when it's under 100. It's not the stroke. It's a stroke from carotid disease. And everybody's got to stop smoking. I don't think that'll be too hard, because I don't think there's going to be any answers where it says, A, stop smoking, B, smoke more. Unlikely you'll get that question. Macrocytic anemia means the cell size is high. How do you answer what's the most likely diagnosis from the etiology, presentation? Normal hematocrit in a man should be around 40 to 45, and his MCV is clearly elevated as a macrocytic anemia. Now, what do you do next? Well, the next thing to do in this patient is a smear. You see, because the smear can tell you right away that the first thing is there hypersegmentation. You see, folate will not give you neurological problems, but both B12 and folate are identical hematologically. First of all, Schilling's test is never first. Not first ever, and rarely if ever done. Schilling's test to see if the B12 deficiency is from pernicious anemia, and is almost archaeologic. We're pretty close to saying it's pretty much never the right answer. Methylmalonic acid confirms you have B12 deficiency if the B12 level is equivocal. But when you have macrocytic anemia, the first thing to say is, hey, is this megaloblastic? And the big issue is alcohol can do everything that B12 can do, except alcohol won't cause megaloblastosis. Alcohol can cause a macrocytosis, big cells. Alcohol can cause peripheral neuropathy. Alcohol can cause dementia, but alcohol can't cause hypersegmented neutrophils. Megaloblastic anemia, by definition, is hypersegmented neutrophils. A normal neutrophil should have on average 3.5 lobes. If your average is above 4, it's hypersegmented. It's megaloblastic. Now, there are a lot of things that can raise the MCV, make big cells, but only B12 and folate, and some of the antimetabolite chemotherapies like 6-mercaptopurine, azathioprine, immunosuppressive agents can cause hypersegmentation. Basically, and they do it by also inhibiting folate too inside the cell. So only B12 and folate can cause hypersegmented neutrophils. And also you cannot distinguish them based on a smear. Vitamin B12 deficiency is caused by pernicious anemia. You start making autoantibodies, typical in older patients. You become allergic to your own gastric lining and start getting rid of your own parietal cells. The same way some people get monoclonal gammopathy of unknown significance, extra autoantibodies. Why is that happening? Because it does. be it vitiligo, Hashimoto's, autoantibodies, so you can with pernicious anemia as well. Pancreatic insufficiency is the one that people get wrong the most because most people don't know that you need pancreatic enzymes to absorb B12. They don't know that you need pancreatic enzymes to release the B12 from the R protein in the saliva so it can bind with intrinsic factor. Without pancreatic enzymes, you can't get your B12 attached to intrinsic factor. Dietary deficiency is very rare. It happens in strict vegans, and it has to take at least several years to get down there. And if you're a person who actually drinks milk or has yogurt, you'll be fine. It's fine in yogurt. You have to be a real vegetarian person who doesn't even drink the milk. Crohn's disease and anything else that damages the terminal ileum will block B12 absorption. And a blind loop syndrome is an older problem because that's back from when we used to do gastrectomies and gastric bypass for weight loss and mostly ulcer surgery and left these blind loops about which could overgrow. Oh, our scared little tapeworm, Diphyllobothrium latum, also used to eat up the B12 before it got into you. Celiac disease causes B12, folate, and iron deficiency. The B12 deficiency is strictly because it is one of the causes of damaging the terminal ileum. And in this sense, you can also say Whipple's disease, not Whipple's procedure, but Whipple's disease could do it as well, and so can celiac disease. Celiac damages the terminal ileum. Whipple's diagnosed damages the terminal ileum, and tropical sprue damages the terminal ileum. Folate deficiency can happen from anybody who's deficient in it by diet. And that's much easier to get than B12 deficiency because B12 stores for a long time. Folate does not store. Now, as a little tested fact here, right? Goat's milk has no folate. Wow. Don't drink those goat milk too much. And if you wonder about it, it's not just because the goats are small. It's because cow milk has the B12. Isn't that interesting? And the folate, too. So psoriasis, skin loss, cell turnover. That's why all patients with chronic hemolysis need folic acid deficiency. Cell production. Spherocytosis needs it. Cell production. Sickle cell. Cell production. And phenytoin does it also because it causes a loss of folate. Sulfa interferes with the metabolism of folate. Phenytoin causes a loss of folate. Methotrexate is a folate antagonist used in rheumatoid arthritis and also suggests folic acid deficiency. Because of increased cell production, this is why pregnant ladies are so vulnerable. The cells grow faster, and Mr. Baby uses up all the folate. Alcohol causes a macrocytosis and neurological problem, but it will not give hypersegmented neutrophils. B12 deficiency can give any neurological problem. Anything. Not just posterior column damage, not just loss of position of the vibration sense, not just posterior column, not just subacute combined degeneration of the cord, not just dementia, not just neurological things in the central, but the peripheral neuropathy is the most common. And that's because peripheral nerves are simply more vulnerable to everything. So peripheral neuropathy is the most common. Dementia is the least common. And posterior column damage to position and vibratory sense, or the subacute combined degeneration of the cord, is simply classic. It's this and syphilis. Look for ataxia as you damage the neurological reflex arcs. B12 can give either neurological problems alone, hematological problems alone, or both. You don't have to have both together. You just don't. Peripheral is the most common, but anything can occur. The labs that are common to both B12 and folate, they're both megaloblastic. They both cause hypersegmented neutrophils with an average number of lobes above 4. They both increase LDH and indirect bilirubin. They both decrease the reticulocyte count. And the LDH and bilirubin is very hard for people to understand, but I understand that. That's because you don't understand that the cells are made and then they're destroyed just as they're leaving the marrow. So you make the cells, but as they're destroyed, boom, they create LDH loss. Boom, they release indirect bilirubin. But since the cells are destroyed right after they're made, the reticulocyte count never goes up. That's why the bone marrow's hypercellular, yet there's no cells in the peripheral blood. Wee. Macroovalocytes means big cells that are in oval shapes. That's on a smear. Macroovalocytes and characteristic of B12 and folate deficiency. Now, both B12 and folate, and this is one of these tested points, that which of them gives an increased homocysteine? They both give homocysteine, but only B12 gives an increase in methylmalonic acid. That's a colossally important point. You got to know it, that only B12 gives an increase in the methylmalonic acid. The top two cells are pictures of hypersegmented neutrophils. That's more lobes than there should be. That's 5 lobes. And the one on the left and the top. That's 5, and the one on the left and the top. The one at 9 o'clock is 5 lobes. They both do, the one on the left and at the top. And that is why these two disorders are identical hematologically. You could not tell which one you have. We have a 73-year-old woman with decreased position and vibratory sensation at the lower extremities and a macrocytic anemia. Ooh, she's also got hypersegmented neutrophils. That means it's megaloblastic. The B12 level is decreased, but it's near the borderline of normal. What are you going to do next? You had a story like B12 and a normal B12 level. So you should do the methylmalonic acid level. That's what it's for. Now, intrinsic factor and parietal cell antibodies are not to tell you you have B12 deficiency. They are to tell you why. Why? Am I allergic to my own parietal cells? Am I allergic to my own intrinsic factor? Pernicious anemia is an autoimmune disease. It's like Hashimoto's thyroiditis, vitiligo. It is like a person who's having primary biliary cirrhosis. I'm allergic to myself. Schilling's test is rarely done, tells you why it is that you have B12 deficiency. If the intrinsic factor and parietal cell antibodies are normal, you go, gee, it's not pernicious anemia. Why is it? Maybe I'll get a Schilling's. And it's totally premature to do it now. There's no point in checking folate because folate simply doesn't give neurological problems, period. No neuro with folate. Folate, no neuro, period. And homocysteine just doesn't add anything. It can be up, but so what? Bottom line, what are the high-yield tested facts about macrocytic anemia? And the answer is Schilling's test is never the right answer, period, thank you. Pernicious anemia is confirmed with anti-intrinsic factor and parietal cell antibodies, and red cells are destroyed as they leave the marrow, so the reticulocyte count is low, but the B12 level is still low, and you have also a increased LDH and an increased indirect bilirubin. What are the other tested facts about macrocytic anemia? B12 and folate deficiency can cause pancytopenia too. Did you know that? All 3 cell lines could be down. You need pancreatic enzymes to absorb B12. You need it to free it from the R protein. And the neurological problems will improve as long as they're minor, like peripheral neuropathy, a little numbness and tingling, and they're not there for years. You can't take someone who's been demented for 2 years in a nursing home and expect that to reverse by giving B12. Pancreatic enzymes are more indispensable than you know. I know this will sound repetitious to some of you, but it doesn't matter, because the major issue is this is the most common wrong answer. When people think, oh, I don't need the pancreas for B12 absorption. Well, yeah, you do. You should be so lucky to get a treatment question. Gee, what do you do with B12? How about give B12? Good idea. Replace the B12 on the folate. But what's the tested question for you? Folate replacement is going to correct the hematological problem of B12, but not the neurological problem. That's the tested point. If you miss the diagnosis of B12, and you replace the folate, the red cell count's going to get better, and the person's going to get demented. That means if you're a person who with B12, and remember, you can present just with hematologic problems at first, and you get folate because it's misdiagnosed, you will fix the hematologic problem, and they'll show up demented 6 months later. So which of the following is the most common complication of B12 and folate replacement? You replace the B12 or folate and you develop hypokalemia. Hypokalemia? Really? Why? Because it's the only thing where you can package up so much potassium that you actually use it all up. No kidding. You don't get seizures with B12 and folate replacement. And it's not that you get hemolysis at all. The cells are produced rapidly, not destroyed. They're produced rapidly. Hyperkalemia happens from cell breakdown. High potassium is from massive breakdown, rhabdomyolysis, hemolysis, tumor lysis. This is the exact opposite. This is cell production. This is exactly the opposite. Diarrhea does cause hypokalemia, but this has nothing to do with causing diarrhea. As a matter of fact, B12 and folate deficiency can sometimes cause diarrhea. If anything, it should resolve. It won't cause diarrhea. It can help diarrhea resolve.
Our next section is going to be dealing with head trauma. If a patient presents to you with head trauma and it resulted in altered mental status or loss of consciousness, you must get a head CT first. But the question is, with or without contrast? A head CT without contrast is the best initial test to detect blood. Contrast actually obscures seeing blood on the head CT. It's better for mass lesions, such as with cancer or abscesses. During your USMLE, if you read loss of consciousness, get a head CT. A concussion will present to you with no focal neurologic abnormalities, and when you obtain a CT scan, it's going to be read as normal. A contusion will present with some focal findings. It's rare, but it could happen. The actual CT will show an ecchymosis, which is basically blood mixed in with the brain parenchyma. Now here's a brain CT of somebody who has a contusion. Lateral to the midline, you can actually see blood mixed in with the brain parenchyma, but it doesn't collect in a way that allows drainage. There are two kinds of hematomas you must know: subdural and epidural hematoma. They're usually associated with severe head trauma, such as those involved in motor vehicle accidents or falling from the top of a building. Now the thing is, it's impossible to distinguish without getting a head CT. A patient won't come to you and say, "Oh, I have an epidural." Epidural hematomas are also more frequently associated with a skull fracture. Here's a classic example of an epidural hematoma with the pathognomonic lenticular hemorrhage. They're usually from a high-pressure artery that's broken. One of the ones you must know for the exam is the middle meningeal artery. Now here's an example of a subdural hematoma. Notice on the left the classic crescent-shaped concave surface of blood. Note also how it crosses the suture lines and involves a greater proportion of the cerebral hemispheres. The lucid interval is a second loss of consciousness that occurs several minutes to several hours after the initial loss of consciousness in a patient with head trauma. The patient will wake up after the initial loss of consciousness, but then subsequently loses consciousness a second time due to the accumulation of blood. Time between this first and second episode is known as the lucid interval. Remember, both epidural and subdural hematomas are associated with the lucid interval. There is no specific therapy for concussion. You must, however, instruct the patient to wait a minimum 24 hours before returning to any sports. A contusion also has no specific treatment. However, there is a small group that needs surgical debridement. Patients with concussions are safe to go home. You don't necessarily need to hospitalize them, but you must instruct someone to be with them and observe them for altered mental status. If that occurs, they are to be brought back in. The treatment of a subdural and epidural hematoma are based on two factors. The first is the actual size of the bleed, and second, is the patient displaying any signs of compression? Small bleeds are left alone. Large ones, however, are actively managed with intubation and hyperventilation to reduce intracranial pressure, mannitol to take care of the cerebral edema, and lastly, surgical drainage in case the bleed is so big there is mass effect. Now, what are the three hallmark components to define a large intracranial hemorrhage? Well, first, if there's any compression of the ventricles or sulci, if there's herniation with abnormal breathing and a unilateral dilation of the pupil, and lastly, if there's worsening mental status or some focal finding on the neurologic exam. Now, to summarize severe head trauma, remember, concussions have no focal findings, whereas a contusion can rarely give you focal neurologic findings. The subdural and epidural can give you some form of focal neurologic findings. When it comes to the lucid interval, a concussion never has one. A contusion also does not have a lucid interval. The subdural and epidural can have a lucid interval. A CT scan with a concussion will be normal, whereas for a contusion, they will show an ecchymosis. On a subdural bleed, you're looking for a crescent-shaped pattern because it's a venous-type bleed. On an epidural, it'll be biconvex or lens-shaped hematoma. Remember, that's an arterial bleed. The treatment for a concussion is nothing specific. Remember, just observe them at home, and if they have any form of altered mental status, bring them back to the hospital. For a contusion, there again is no specific treatment, but in contrast to the concussion, you observe them as an inpatient. A subdural, remember, you drain the large ones, and for an epidural, you also drain the large ones. A 25-year-old man sustains head trauma in a motor vehicle accident. a large epidural hematoma is found. Immediately after intubation and mannitol, surgical evacuation is performed. Which of the following will benefit the patient the most at this time? Is it A, repeated doses of mannitol? Is it B, continued hyperventilation? Is it C, a proton pump inhibitor? Is it D, nimodipine? Or lastly, E, to give dexamethasone? The correct answer here is proton pump inhibitor, C. A PPI is always given to prevent stress ulcers. The only clear indications for stress ulcer prophylaxis are burns, endotracheal intubation, and a coagulopathy. The incorrect answers are wrong for the following reasons. We do not give repeated doses of mannitol because it does not reduce mortality. We don't continue hyperventilation because it has a very short-term efficacy and is probably ineffective after the first 24 hours. We don't give nimodipine because that's for subarachnoid hemorrhage, and dexamethasone, a very potent glucocorticoid, is ineffective for intracranial hemorrhage. The Usmle loves to give distractors. Remember, steroids don't benefit intracranial bleeding. They only decrease edema around mass lesions.
Welcome to the second part of dermatology. In this section, we'll be covering skin infections, drug reactions, staph scalded skin syndrome, and toxic shock syndrome, and finally, acne. The skin infections are based on the depth of involvement. Impetigo simply refers to the most superficial of all the bacterial skin infections. It is from Staphylococcus and Streptococcus, but it's called impetigo because it involves only the epidermis. The names of the skin infections is not based on the organism. Impetigo, erysipelas, and cellulitis, furuncles, carbuncles, folliculitis, they're all Staphylococcus and Streptococcus. And not Staph epidermidis. Staph epidermidis lives there, but Staph aureus. But all the difference is, how extensive is the infection? If it's just superficial, it'll cause weeping, crusting, oozing, and draining, and be on top. Since it's on top, you could treat it with topicals, topical mupirocin, topical bacitracin, topical retapamulin, which is easy to mispronounce because it's new, but it's a really cool drug. Now, severe disease needs oral agents, dicloxacillin, cephalexin. Cephalexin is an oral first-generation cephalosporin. Now, this is going to be difficult, but if they tell you that it is MRSA, this is only for minor MRSA infections like skin infections, doxycycline, clindamycin, or trimethoprim sulfamethoxazole. Erysipelas is deeper. It's into the dermis and the epidermis, dermis epidermis. It's more severe because it's deeper. It goes into that dermis. Now, it's still streptococci and staphylococci, but erysipelas is particularly more streptococcus. Now, the streptococcus on the skin is strep pyogenes, group A beta hemolytic strep. That's what causes erysipelas. It invades those dermal lymphatics, and it can cause bacteremia. It can cause a high white count or leukocytosis, a fever, and chills. It's a pretty severe thing. It's bad. And that's why it can be fatal if untreated. Can skin infections cause glomerulonephritis? Can skin infections cause glomerulonephritis? And the answer is yes. The skin infections can cause the glomerular disease, but not the rheumatic fever. Because erysipelas involves dermal lymphatics and it's swollen, it's very bright, red, hot, swollen, tender, warm. A lesion is on the face. There's a leukocytosis lesion on the face and a leukocytosis, and it's often systemic because it spreads. It looks like this: bright, red, hot, warm, swollen. Strep pyogenes, group A beta hemolytic strep, and it can cause kidney infections, but not rheumatic fever, but kidney, yes. Although erysipelas is more often from streptococci, you must treat for staphylococcus as well, unless you definitely have a diagnostic test like blood cultures that tells you for sure it's only strep. You got to treat for both. And the treatment of all skin infections is similar. Basically, it's the same answer for cellulitis, folliculitis, furuncles, carbuncles. The only one really that's different is impetigo can get topical antibiotics with the mupirocin, bacitracin, retapamulin, and necrotizing fasciitis, which gets surgical debridement as well. Mild disease gets oral medications. Mild means No major leukocytosis, no fever, no hypotension. Just skin infection only. And the oral antibiotics for skin, for staph and strep and staph. Oxacillin, cloxacillin, dicoxacillin, and nafacillin, dicoxacillin. Cephalexin, sometimes called Keflex. Cefadroxil, which is another form of oral cephalosporin. Penicillin allergic patients can be treated with erythromycin, clarithromycin, and clindamycin. This is especially true for people with life-threatening penicillin allergies, like anaphylaxis. If you just have a rash to penicillin, can you use a cephalosporin? The answer is, if it's just a rash, absolutely. Use that cephalosporin if it's just a rash. Use a cephalosporin if it's just a rash. Now, MRSA, and again, you'd have to be told in a question, doxycycline, clindamycin, trimethoprim, sulfamethoxazole. But that's only for minor stuff in the skin. This would not be the answers for MRSA in the bloodstream. When disease is severe, you need intravenous medications like oxacillin, cloxacillin, dicloxacillin, and nafacillin, oxclox, dicloxin, naf. Cefazolin is a first-generation cephalosporin. It's the intravenous equivalent of cephalexin. With a life-threatening penicillin allergy, remember, just a rash, use cephalosporins, but life-threatening penicillin allergy, clindamycin, vancomycin, MRSA, vancomycin, linezolid, daptomycin, tigacycline. That's the only drug in its class, tigacycline. It's called a glycylcycline. And ceftaroline, which is the only cephalosporin that covers MRSA. It's the only cephalosporin covering MRSA. The amount of cross-reaction between penicillins and cephalosporins is small. And if that allergic reaction is a rash, it's safe between penicillins and cephalosporins. You need that route of administration, oral or IV. This is a very good example of this. Cellulitis is a difficult word. What does it mean? Well, it means a soft tissue infection of the skin. It goes from the dermis down into the subcutaneous tissue. That skin is warm, red, swollen, tender. Rubor, dolor, calor, tumor. And here's a cool picture of that. The line on the right-hand side above the foot is a pen line. That's how you know when it's receding. Cellulitis. This is a picture of actually a patient from my own hospital, my own chief of infectious disease. And that is the bright red, hot, warm, swollen leg. You use a pen line to determine, is it receding? Cellulitis is more common in the legs than the arms, simply because legs have worse circulation. You're more likely to damage them. Cellulitis, by definition, means it's not a walled-off collection. You can't drain it. A walled-off collection is an abscess. This is not a walled-off collection. That's the whole point. That's why it's a soft tissue infection that's not walled off. Cellulitis isn't only at a hair follicle. If it's only at a hair follicle, it's folliculitis. If it's bigger, it's a furuncle. If it's bigger, it's a carbuncle. This is more diffuse. Skin infection is caused by Staph aureus, not Staph epidermidis. Staph epidermidis is normal commensal flora of the skin. Staph epidermidis lives on the skin as normal flora. The vast majority of people with cellulitis never get a diagnostic test. It's simply based on how does it look. How does it look? Looks like you get cellulitis, or it doesn't. The most accurate test, though, however, if you ask them a test question, is that you inject sterile saline in the skin and aspirate it and culture what you aspirate back. The problem is the yield is terrible at only 20%. And Staphylococcus is more common to grow than Streptococcus because Staphylococcus is often easier simply to grow. This treatment for cellulitis is the same as erysipelas. Topical antibiotics are just not going to get down there. They're too far. This infection is too far. This infection is too far under the skin for topicals to cover. Topicals will only cover impetigo. These are too far below the epidermal junction, and it won't reach. Well, the very name folliculitis means an infection originating around the follicle, the hair follicle. And these terms, well, they're old terms. They don't have a precise definition. There's no official exact cutoff. We can't say, oh, at 2 millimeters of folliculitis and 5 millimeters of furuncle. It's a little too subjective for that. I'm sorry. So that also means you won't be asked. Now, the issue about severe disease is important because it means severe disease must be admitted to the hospital for intravenous antibiotics. And let's say for sure what severe means. Severe means fever, chills, and bacteremia. Folliculitis, because it's smaller, is the earliest and the most mild. It's an infection centering around the hair follicles. As it gets bigger, it walls off into a teeny tiny little abscess or collection of infected material. It's a furuncle. Carbuncle is a collection of furuncles, big ones. So that means that folliculitis is the smallest, furuncle is bigger, carbuncle is the biggest, and they all get treated with oxacillin, cloxacillin, dicloxacillin, and nafacillin, ox, clox, diclox, and naf. Now, when we talk about methicillin sensitive and methicillin resistant, we really mean sensitive and resistant to ox, clox, diclox, and naf. That's what we mean by methicillin. Methicillin's been off the market for 40 years. Methicillin causes allergic interstitial nephritis, makes you pee eosinophils. This is folliculitis because it's centered around the hair follicles. The ants are swollen, tender. It often needs to be drained to get that stuff out of there. Otherwise, ox, clox, diclox, and naf, first-generation cephalosporins. If you have a life-threatening penicillin allergy, someone this severe should get vancomycin, linezolid, daptomycin. Remember, if the allergic reaction is just a rash, use cephalosporins. It's safe, it's just a rash. But if it's anaphylaxis, don't use a beta-lactam at all. Mild infections, macrolides, clenda, doxycycline, or trimethoprim sulfa, there's zero cross-reaction between these drugs and penicillins. So if there's anaphylaxis, they are 100% safe. And a severe infection gets these medications, which also don't cross-react. Vancomycin, linezolid, daptomycin, tigacycline. Other medications that can also have anti-staphylococcal potential, but they're not MRSA medications. These drugs have an equal efficacy for staphylococcus as oxacillin, cloxacillin, dicloxacillin, nafacillin. In general, they are not first-line agents because the beta-lactam, beta-lactamase combinations are not necessary for most people. But if you don't have definite proof that you have a staphylococcus, and you might have gram-negatives or anaerobes, these drugs add gram-negative and anaerobe coverage. They're not first-line drugs, but they do also cover, including the carbapenems. Imipenem, meropenem, ertapenem, and doripenem also cover staphylococcus as well. Superficial fungal infections are also called dermatophytes or tinea. And tinea, and name the part of my body in Latin, corpus in the body, manum in the hand, pedis in the foot, crus in the groin, jock itch. Now they're all managed the same way, which is most of them are treated simply empirically. You give a topical antifungal. This is an example of the word ringworm, and here it's a great reason why it is called ringworm, because they're in a ring, because also most of the organisms are in the heaped up leading edge encircling it. No matter what the organism is, KOH, fungal culture, topical antifungals. Now by KOH we mean a potassium hydroxide. Potassium hydroxide on a scraping of skin dissolves the epidermal cells, and the epidermal cells are melted away but leave the fungi intact. That's because the walls of fungi have a tough substance called chitin with the CH, chitin. It's the same as what's in a lobster shell or a crab, and it is basically makes it impervious to melting away. And this is the basis of the diagnostic test. Potassium hydroxide will melt away the skin and leave the fungi intact. The most accurate test is a fungal culture. There's a big difference between what would you do and what is the most accurate. Most accurate is a fungal culture. What will I do? I'm not going to do a fungal culture unless the person's resistant, not getting better. The best initial therapy is a topical antifungal as long as there's no hair or nails involved. Topical antifungal agents just don't get through the nails. For hair and nails, like tinea capitis in the head or nails, tinea unguum, you have to use oral therapy. And those oral therapies are terbinafine, itraconazole, sometimes fluconazole, but these are the two best for hair and especially nail infections. Now, the reason why these are much better than griseofulvin should never be the correct answer, is that griseofulvin simply has more duration of treatment. You have to give it for 6 to 9 to 12 months, much less efficacy. These medications are used for 6 weeks with 90% cure. That's pretty cool compared to griseofulvin. Topical antifungal agents are useful for all of the parts of the body that don't involve hair and nails. So let's go through those topical antifungals so you know what they are. And most all of these are available over the counter. Clotrimazole, you know it as Lotrimin. Ketoconazole, oral ketoconazole, has been used in the past to treat metastatic prostate cancer. It's so anti-androgenic it can be used in prostate cancer. Wow. The vagina and the mouth should be treated the same way. The same answers. Best initial test is a KOH, potassium hydroxide. The most accurate test is a fungal culture. The question that says, what do you do next, is neither of them. Straight to treatment with topical nystatin, topical clotrimazole, topical cyclopyrox, topical antifungal from the previous list. That's why when HIV came around in the 80s, we already knew what you could use for oral candidiasis because we simply took clotrimazole vaginal tablets and started putting them in the mouth for oral thrush and oral candidiasis because it's pretty much the same treatment. Drug reactions are hypersensitivity reactions to medications that vary in severity. Your major issue is to know the difference in severity between the different reactions. When the severity of reaction changes, the name of the reaction changes. When severity, that's what makes the name, is the severity of the reaction. They're all hypersensitivity reactions. Now, the drugs are also the same. The drugs that cause a morbilliform rash or Stevens-Johnson or toxic epidermal necrolysis or erythema multiforme, it's all the same drugs. Penicillins, 10% of the population is allergic to penicillin. 10% of the population is allergic to sulfa drugs. Now, here's where you have to go to medical school. Thiazides are a sulfa drug. Furosemide's a sulfa drug. Sulfonylureas are a sulfa drug. Propylthiouracil is a sulfa drug. Allopurinol is a sulfa drug. Phenytoin is a sulfa drug. Lamotrigine. There's very little cross-reaction with nonsteroidals, but they can. That's why they're allergenic. That's why every drug here can cause allergic interstitial nephritis and make you urinate eosinophils. The drugs that cause hypersensitivity reactions of the skin are the same as cause drug-induced hemolysis or interstitial nephritis. You don't have to learn them differently. Drug-induced autoimmune thrombocytopenia, you don't have to learn it twice. Invest your time now, and it's good for later on, too. A morbilliform rash is the mildest form of drug reaction. The skin stays intact. There's no mucous membrane involvement. That's how you tell it apart from the others. There's no specific therapy. Morbilliform just means it's in the form of measles. To the first antibiotic use in the 1930s, the guys didn't know what it was, and they developed the rash, and they said, gee, it looks like measles, because they saw measles every day. There was no antibiotics, but there was measles every day. That's all it means. Looks like measles. Wow, now if somebody has measles, most of you will never see measles. I see one case every 2 to 3 years. And that means if I saw a measles, I'd say, hey, it looks like a drug reaction. This is a morbilliform rash. Erythema multiforme literally means red skin in a lot of different shapes. It's a more severe, more widespread form of drug reaction. The lesions actually form into little targets. It's mostly on the trunk, and there is no mucous membrane involved. Mucous membranes are just not involved. It doesn't go into your lungs. Therefore, it generally doesn't kill you. Now, here's the extra one. In addition to all those drugs we mentioned, it also can happen from herpes and mycoplasma. And this thing about steroids and these drug reactions is extremely problematic. This one, steroids may benefit, and so the bottom line on all of these things is steroids doesn't clearly benefit any of them. Here's erythema multiforme, multiple small target-shaped lesions that can be confluent. That means into one big sheet. That is erythema multiforme. Again, no mucous membrane involvement. Stevens-Johnson syndrome is very severe. Stevens-Johnson means that you have 10 and 15, 20% of your skin involved. Wow, it's enormous. And it involves mucous membranes, and that's why it sloughs off that respiratory epithelium. And I have seen patients who got sulfa drugs and got phenytoin, and they ended up on a ventilator because they can't breathe. If it sloughs off the respiratory epithelium, you just can't breathe. And the big problem is that steroids just don't help. You so want them to help, they just don't. You're never going to figure out why intravenous immunoglobulins may work. We just don't know right now. But if it's very severe disease, that's what we're going to use. Toxic epidermal necrolysis is an even more severe form of the disease. It means that there's always mucous membranes involved, Nikolsky's kind, as the skin comes off in a sheet. Steroids definitely don't help, and you treat this with intravenous immunoglobulins as well. And the other thing is that it's a measure of it is simply the percentage of the body surface area involved. Stevens-Johnson is around 10, 20, 25, 30%. Toxic epidermal necrolysis is above 30%. In between 10 and 30% is unclear, but it's on a spectrum from Stevens-Johnson to toxic epidermal necrolysis. And here's a person that skin has come off in a sheet. Wow, look at that huge denuding of skin. Staph scalded skin syndrome and toxic shock syndrome are very similar to each other in the sense that they both cause major denuding of skin. They are both from Staphylococcus toxin. They both are throughout the entire body. They're different severities of the same event. You see, if that toxin from the surface of the staph results in skin involvement, with staph scalded skin looking similar to TN, including the Nikolsky sign, but toxic shock syndrome has skin involvement as well as life-threatening multi-organ involvement, low blood pressure, renal failure, liver dysfunction, CNS involvement, and confusion and delirium. That's why toxic shock is definitely something that will kill you right away. And both are treated with the anti-staphylococcal medications, oxacillin, cloxacillin, dicloxacillin, but particularly oxacillin and nafcillin, most effective. Cefazolin is essentially equal. Remember, it's okay if you have a penicillin rash, but remember, antibiotics are not going to reverse the disease. They are just to kill off the staph that produces the toxin to prevent progression. You think about it like this. If there's staph somewhere in sutures, nasal packing, it used to be tampons in the past, but nasal packing and sutures somewhere where the staph grows and you can't see it and it's hidden and it makes that toxin, you'll want to kill off the staph that's causing the toxin to be made. Mild acne is treated with topical antibacterials. Benzoyl peroxide, you can get over the counter. Now, if it doesn't get better, if it's ineffective, you add topical antibiotics, erythromycin, clindamycin, to control the disease. And a lot of people will control just with this. You don't automatically have to use vitamin A derivatives. The best initial therapy, topical antibacterials. Now, moderate acne needs the topical vitamin A derivatives. And the topical vitamin A derivatives, like tretinoin, adapalene, tazarotene, are added to the topical antibiotics. And if there's no response to the topical vitamin A derivatives, you can use oral antibiotics like minocycline and doxycycline. Finally, the most severe acne, and only the most severe, it's got to specifically say recurrent, progressive, benzoyl peroxide didn't work, topical antibiotics didn't work, topical vitamin A didn't work, oral antibiotics didn't work. It's stepwise. Then oral vitamin A. Then oral vitamin A. Only we go to isotretinoin because it causes hyperlipidemia, causes teratogenicity, can be very problematic. But you go in order. Benzoyl peroxide first, topical antibiotics, topical vitamin A, oral antibiotics, and finally oral vitamin A. Wow, ding! You just became a dermatologist for the first 5 visits.
Welcome to the Step 2 High Yield Emergency Medicine section. My name is Niket Sonpal. I am the Chief Resident at Lenox Hill Hospital, North Shore LIJ Health System, and Assistant Clinical Professor at Touro College of Medicine. To start today's lecture, we're going to begin with toxicology, poisoning, and overdose. The USMLE loves to ask questions on this because it's a very simple cause and effect and treatment modality of questions. A 32-year-old female with a history of depression comes to the emergency room with gastric lavage, C, psychiatric consultation, serum chemistries, E, urine toxicology, F, cathartics or laxatives, G, whole bowel irrigation, H, to administer naloxone, or I, to administer flumazenil. The correct answer here is actually B, gastric lavage. The reason why A is incorrect is when ingestion is extremely recent, it is possible to try and remove the substance from the body prior to its absorption. Gastric emptying has very limited value because there's not much time between the ingestion and passage of the pills beyond the pyloric sphincter from where they cannot be removed. Pills on an empty stomach can leave in as little as 30 to 60 minutes. Therefore, gastric lavage can be attempted up to 2 hours after ingestion, but it will remove only about 50% of the pills at 1 hour and only 15% at 2 hours. After 2 hours, it is completely useless. Now, going through each of the choices, although serum chemistry and urine toxicology screens should be done, they are not helpful this soon after the ingestion. Ipecac and the induction of vomiting is wrong when a patient is already in the emergency department. Inducing vomiting needs 15 to 20 minutes to work and only delays the administration of antidotes such as N-acetylcysteine, which can be given orally. Like I said, inducing emesis can cause caustic injury if you don't know what she consumed. A psychiatric consultation is always wrong because any consultation is always 99% the wrong choice on the USMLE. Serum chemistry, it takes too long, and it's too soon after ingestion to show any differences. Urine toxicology, it won't show up yet because the pills have not been ingested and metabolized. Cathartics and laxatives take too long, and they haven't really made the transit time to the colon. Whole bowel irrigation, same reason why cathartics and laxatives won't work. The pills have not made it yet to the colon. Naloxone won't work because we don't know if it's an opiate, and flumazenil is not indicated because we don't know if it's a benzo. The best step, and I repeat, the best step after ingesting an unknown chemical and knowing how soon after is gastric lavage. There are 5 major treatments for somebody who presents to you with overdose. The first is gastric lavage. The second is to administer a cathartic agent. The third is to administer Ipecac, which forces vomiting. The fourth is to give high-volume fluids and then subsequent diuresis. And the last is to do whole bowel irrigation. The initial steps in managing a poisoning patient involve gastrointestinal emptying, specifically gastric lavage. Gastric lavage may be useful in the first hour of ingestion, however, it is dangerous in 2 settings. The first setting is when there is a caustic ingestion. Ingesting of a caustic acid or alkali contraindicates using gastric lavage because when you bring those chemicals back up, you might actually cause burning of the esophagus and oropharynx. The other time gastric lavage is contraindicated is in a patient with altered mental status. When you do a gastric lavage in this case, the patient cannot protect their airway, and therefore they may aspirate stomach contents, leading to a pneumonitis or aspiration pneumonia. What should be kept in mind during the exam is that gastric lavage is rarely done. The reason for that is that it only removes about 50% of pills at the 1 hour mark and only 15% of the pills at 2 hours. Therefore, its yield is very, very poor. However, it is still done on some rare occasions. One tip for you to keep in mind during exam is if they ever give you the choice of Ipecac, it is always the wrong answer in the emergency room. If you're presented with a question in which the mother is calling you at home as an outpatient consult, the first thing you want to tell her is get the child to the ED, but remember, it is always the wrong answer in the emergency room. Although Ipecac has been used as a home remedy in those with accidental overdose or pill ingestion prior to coming to the hospital, there is no benefit in using Ipecac as an inpatient. Ipecac requires 15 to 20 minutes of onset and actually delays the administration of other antidotes. Cathartic agents, such as sorbitol, are always the wrong answer on the Usmle. Prokinetic agents, such as metoclopramide and erythromycin, are also the wrong answer. Speeding up gastrointestinal transit time does not eliminate the ingestion without absorption factor in a poisoned patient. Giving fluids and diuretics to accelerate urinary excretion is always a wrong answer. More patients are actually harmed because of the large volume intravascular expansion and develop pulmonary edema rather than being benefited by the forced diuresis. Placing a gastric tube and flushing out the GI tract with polyethylene glycol such as Go-Lightly is almost always the wrong answer. This is the same chemical they use to clean out the bowel prior to a colonoscopy. The only time this is correct, and the indications are very narrow and limited to massive iron ingestion, lithium, and drug-filled packets such as those who are trying to smuggle cocaine in their bum. Say, for example, you're presented with a patient, like earlier in today's slides, that was unclear as to what was ingested. And if they ask you what is the most likely cause of overdose, in the United States, the most common cause is acetaminophen. The second most common ingestion is aspirin. If you're questioned and not sure what to do, what is useless or dangerous is always very clear. That is Ipecac, forced diuresis, and cathartics. You can always rule these three out from the answer choices. If you get these three, you're only left with two choices. Now you've got a 50-50 chance to get the question right. Remember, knowledge is power in this case. A woman presents to your emergency room 1 hour after taking a bottle of pills. Her blood pressure is 118/70, her pulse is 90, her respirations are 14. She is confused, disoriented, and lethargic. What is the next best step in the management of this patient? Is it A, to give flumazenil, B, to perform a gastric lavage, C, psychiatric consultation, D, administer naloxone and dextrose, or E, intubate the patient? The correct answer here is actually to administer naloxone and dextrose. The best initial management of anyone with altered mental status of unclear etiology is an opioid antagonist and glucose. Opioid ingestion and diabetes are extremely common. Naloxone and glucose work instantly and have no adverse effects. Therefore, it doesn't hurt to try. If they do not work and the patient is still lethargic, concern then raises about protecting the airway. Therefore, intubation should be conducted, possibly followed by gastric lavage. Intubation should not be done first, however. Naloxone is faster, and emergency intubation is associated with aspiration, trauma to teeth, and the possibility of intubating the esophagus. Flumazenil only reverses benzos, but can cause seizures from instant withdrawal. So again, flumazenil is the wrong answer, because you can precipitate a seizure. Gastric lavage is dangerous in altered mental status, as we described earlier. Getting a consultation is never done. Remember, you are the MD. And intubation is not the first step. First administer naloxone and dextrose, then consider intubation. I cannot belabor this point enough, but psychiatric consultation is only indicated for suicide attempt, but it is always the wrong answer choice on Usmle Step 2 CK when specific antidotes and diagnostic tests are needed. Opioid overdose is fatal due to the risk of respiratory depression. Therefore, always give naloxone immediately. Contrastingly, benzodiazepine overdose by itself is not fatal, and acute withdrawal can cause seizures. Therefore, do not give flumazenil immediately. Charcoal is a benign substance and should be given to anyone with a suspected pill overdose. Charcoal may not be elective for every overdose, but it's not dangerous in anyone. Charcoal can also remove toxic substances even after they've been absorbed and are superior to lavage and ipecac. Blood levels of toxins actually drop faster in those given repeated doses of charcoal when compared to lavage and ipecac. When you don't know what to do in toxicology, give charcoal. What is interesting is that legal drugs kill more people in the United States than illegal drugs because they're less expensive and more available. Toxicity due to acetaminophen usually occurs with an ingestion of greater than 8 to 10 grams. Fatality due to acetaminophen occurs after an ingestion of greater than 12 to 15 grams. When it's mixed with alcohol, it actually decreases the amount of acetaminophen needed to cause toxicity. The Usmle loves acetaminophen overdose. The four most common acetaminophen overdose questions are as follows. Number 1, if a clearly toxic amount of acetaminophen has been ingested, greater than 8 to 10 grams, what's your next best step? The next best step in this case is to give N-acetylcysteine. If they tell you the overdose was greater than 24 hours ago, unfortunately at that time the next best thing is no therapy at all. If you are told that the amount of ingestion of acetaminophen is unclear, the next best step for your patient is to get a drug level. If you're questioned about the interaction between charcoal and N-acetylcysteine, what you should know is charcoal isn't contraindicated with N-acetylcysteine. When you're presented with the question, what is the most likely diagnosis, and you're told that the patient ingested aspirin, the way to figure out that is the correct diagnosis is 1, look for tinnitus. Then, hyperventilation due to acidosis, respiratory alkalosis with a mixed metabolic acidotic picture, look for renal toxicity, altered mental status, and you'll have an increased anion gap. Aspirin, when ingested in lethal amounts, can cause a diffuse multisystem toxicity. It causes ARDS. It can also interfere with prothrombin production and raise the prothrombin time. It can also increase your partial thromboplastin time. It can cause a lactic acidosis. The way it does so is by interfering with oxidative phosphorylation that results in anaerobic glucose metabolism, which subsequently produces lactate. And lastly, it can produce respiratory failure. The key to treatment in aspirin overdose is alkalizing the urine, which increases the rate of aspirin excretion. You must know the blood gas in aspirin overdose. Why? Because tinnitus, respiratory alkalosis, and metabolic acidosis are the key to diagnosing aspirin overdose on the Usmle. Which of the following is the most likely to be found in aspirin overdose? As you can see here, there are 4 choices in the blood gas. The correct answer is C. The blood gas shows a respiratory alkalosis with a low PCO2 and a metabolic acidosis with decreased bicarbonate. Because the pH is alkalotic, we know that respiratory alkalosis is not simply compensation for a metabolic acidosis. Choice D is a primary metabolic acidosis with a respiratory alkalosis as compensation, as would occur in sepsis, DKA, or uremia. Choice B shows an increased PCO2 and an elevated bicarbonate. This represents a primary respiratory acidosis with bicarbonate retention at the kidney as compensation. This is actually characteristic of COPD. A patient with known depression presents with altered mental status from ingesting multiple toxic substances. You know for certain that he took some lorazepam only today for the first time. There was no response to naloxone or dextrose. The patient is given flumazenil and immediately seizes. What is the most likely cause of the seizure? Is it A, cocaine withdrawal, B, opiate withdrawal, C, tricyclic antidepressants, D, SSRIs, or E, aspirin? The correct answer is tricyclic antidepressants, C. It cannot be A, cocaine withdrawal, because cocaine toxicity causes seizures, not the withdrawal. It cannot be opiate withdrawal, because that does not cause seizures. It cannot be SSRIs, because SSRI toxicity causes serotonin syndrome. And lastly, it cannot be aspirin, because it causes tinnitus, hyperventilation, but not seizures. You might be thinking, well, what if it's the flumazenil relating to the seizure from lorazepam use? Remember, he only took it today for the first time. The answer here is C, tricyclic antidepressants. What is the best initial test for the patient previously described? Is it A, a urine toxicology, B, an electroencephalogram, C, an EKG, D, a head CT, or E, a potassium level? In this patient, the next best step would have been to get an EKG. Urine toxicology, electroencephalogram take too long. A head CT does not show the etiology of a seizure. A potassium level isn't the underlying cause for the seizure. With tricyclic antidepressant toxicity, there is a rapidly detectable change on an EKG. The EKG will show widening of the QRS, which can then lead to fatal arrhythmias. Here's a rhythm strip of a patient with tricyclic antidepressant toxicity. Note the undulating amplitude. It looks like it's twisting around a point. This essentially happens because the QT prolongs until torsades develops. The findings with tricyclic antidepressant toxicity can cause seizures and arrhythmia that lead to death. The seizures are most notable. However, a wide QRS will tell you who is about to have an arrhythmia. The other findings, such as dry mouth, constipation, and urinary retention, are not going to cause death. These are just secondary to the anticholinergic effects of the tricyclic antidepressant. Now, how do you treat the patient with the tricyclic antidepressant toxicity? Well, the best initial treatment for a TCA overdose is with sodium bicarbonate. Bicarbonate will protect the heart against an arrhythmia. However, unlike with aspirin overdose, bicarbonate does not increase urinary excretion of TCAs. Caustic ingestion of acids and alkali, for example drain cleaner, causes mechanical damage to the oropharynx and can lead to esophageal and stomach perforation. Never give alkali chemicals to reverse the acid or give an acid to reverse alkali. Essentially, never try to balance them out. The reason for this is they could release a great deal of heat from the exothermic reaction that occurs when acids and bases come together, and you'll only make the situation worse. Remember, this is not the time for 7th grade chemistry. The mainstay of treatment for caustic ingestion is to flush out the caustics using water in high volumes. Endoscopy is later performed to assess the degree of damage. Remember, steroids don't prevent injury from caustic substances, and therefore is the wrong choice. Carbon monoxide poisoning is the most common cause of death in fires. 60% of deaths on the first day after a fire are from carbon monoxide poisoning. Look for in the history something mentioning about gas heaters or wood-burning stoves, automobile exhaust, particularly in an enclosed environment. Remember, thermal injury is always the wrong answer when asking for the most common cause of death from a fire. Carbon monoxide binds oxygen to hemoglobin so tightly that carboxyhemoglobin will not release oxygen to tissues. Carboxyhemoglobin acts functionally like anemia. Now, there is no functional difference between the absence of blood and carboxyhemoglobin. 60% of carboxyhemoglobin acts like the loss of 60% of your blood. Carbon monoxide poisoning presents with dyspnea, lightheadedness, confusion, seizures, and the cause of death from carbon monoxide poisoning is myocardial infarction. Carbon monoxide poisoning presents with functional anemia. Remember, 60% carboxyhemoglobin acts like the loss of 60% of your blood. The patient will experience shortness of breath and dyspnea. They'll feel like the room is spinning and lightheaded. They will be subsequently confused from lack of oxygen delivery. They may have a seizure, also due to lack of oxygen delivery to the brain. and ultimately they'll die again from lack of oxygen delivery to the heart and experience a myocardial infarction. As I said, there's no functional difference between having carboxyhemoglobin floating around your body and actually hemorrhaging. Remember, 60% carboxyhemoglobin, your body thinks you just lost 60% of your blood volume. The left ventricle can't distinguish between anemia, carboxyhemoglobin, and stenosis of coronary arteries. Which of the following blood gas results would you expect in a person with carbon monoxide poisoning? Here are your choices. The correct answer is D. Choice A is a distractor because it's alkalotic, but remember, the tachypnea does not necessarily result in alkalosis. Choice B is wrong because that's a respiratory acidosis with metabolic alkalosis. Choice C is incorrect because that's showing a respiratory alkalosis with an underlying metabolic acidosis. Choice D is correct because you have an even pH. Carbon monoxide poisoning prevents oxygen release to tissues, so lactic acidosis develops. In carbon monoxide poisoning, the ABG is very misleading. Carbon monoxide poisoning gives a normal PO2. This is because oxygen doesn't detach from hemoglobin. The best diagnostic tests for someone with carbon monoxide poisoning are as follows. Pulse oximetry will be falsely normal and therefore not the best choice. The most accurate test is a level of carboxyhemoglobin. If you obtain an ABG, remember you're expecting to find a low bicarbonate, a low pH from metabolic acidosis. The best initial treatment for someone is to remove them from exposure and give them 100% oxygen, which forces carbon monoxide to detach from hemoglobin and shortens the half-life of carboxyhemoglobin itself. The mainstay of treatment for carbon monoxide poisoning is to remove them from the source of carbon monoxide and give them 100% oxygen. However, for patients with severe disease, the treatment is hyperbaric oxygen. Severe disease is defined as CNS symptoms, cardiac symptoms, or metabolic acidosis. Methemoglobin is oxidized hemoglobin locked into the ferric state. Remember, ferric is iron plus 3, and ferrous is iron plus 2. Oxidized hemoglobin is brown and will not carry oxygen. They love using the buzzword chocolate brown blood on the exam. Methemoglobinemia results from an idiosyncratic reaction of hemoglobin to certain drugs such as benzocaine and anesthetics, nitrites and nitroglycerin, dapsone. So if you take ferrous hemoglobin, the plus 2 form, expose the patient to either benzocaine, nitrites, or dapsone, it will result in methemoglobinemia, or the ferric state, iron plus 3. The effects of methemoglobinemia are similar to carboxyhemoglobin. Basically, oxygen is not delivered to the tissues, and what ends up resulting is a functional anemia, dyspnea with cyanosis, severe lightheadedness, confusion, seizures, headache, and metabolic acidosis. With carboxyhemoglobin, the oxygen is picked up, but will not release to the tissues. Severe symptoms arise when blood levels rise above 40 to 50%. In methemoglobinemia, however, hemoglobin will never pick up the oxygen. Therefore, symptoms begin right away. Remember, in either case, there is no functional difference for end organs such as the brain or the heart. Carbon monoxide blood will look abnormally red on presentation. Methemoglobinemia blood will look abnormally brown. Both methemoglobinemia and carboxyhemoglobin give a normal PO2 on the blood gas. There is no delivery of oxygen to the tissues. The most accurate test is a methemoglobin level. The best initial therapy is 100% oxygen. The most effective therapy is methylene blue, which decreases the half-life of methemoglobin. Remember, if you have cyanosis and a normal PO2, that is always methemoglobinemia. Organophosphate and nerve gas are identical in their effects. Nerve gas, however, is faster and more severe. On the Usmle, they love to present either a farmer or a soldier. Remember, the way these two chemicals work is by increasing acetylcholine in the synaptic cleft by inhibiting its metabolism. Organophosphate poisoning presents with polyuria, lacrimation, which means tearing of the eyes, salivation, bronchospasm and bronchorrhea, which leads to a great deal of secretions, and lastly, respiratory arrest. Acetylcholine constricts the bronchi and increases bronchial secretions. This inhibits both ventilation and respiration. Without gas exchange, the patient will ultimately succumb to respiratory failure. A 56-year-old military commander is attacked with nerve gas. He presents with salivation, lacrimation, urination, and defecation with the feeling of shortness of breath. His pupils are constricted on exam. What is the first step in managing this patient? Is it A, administer atropine? Is it B, decontaminate and wash the patient? Is it C, remove all his clothing? Is it D, pralidoxime? Or is it E, no therapy is effective? Pralidoxime is the specific antidote for organophosphates. However, this is not the case because he was attacked by nerve gas. Pralidoxime reactivates acetylcholinesterase and therefore breaks down acetylcholine in the synaptic cleft. However, it does not work as instantaneously as atropine. So to review, decontaminating the patient, you must stabilize first. Removing his clothing, stabilize first. Pralidoxime will take too long, and remember, no therapy is effective is never the right answer in managing this patient. As the last case illustrated, nerve gases and organophosphates are absorbed through the skin, and washing the patient for decontamination and removing the clothes are important, but not as important as stabilizing the patient first. Hypokalemia can actually predispose a patient to digoxin toxicity because potassium and digoxin itself compete for the same site on the sodium-potassium ATPase pump. When you have less potassium, more digoxin becomes bound. Therefore, if your potassium levels begin to drop, say for example you're given Lasix, or there's a dietary issue, or you're having diarrhea, what will end up happening is your digoxin levels will begin to rise and bind more effectively and more quickly because there's less potassium around. How will a patient with digoxin toxicity present to you? They may present with visual disturbances such as yellow halo vision. They may say they feel strange symptoms in the chest like palpitations. Remember, bradycardia, atrial tachycardia, AV block, ventricular tachycardia, and slow AFib are all very common rhythm disturbances with digoxin toxicity. The most common presentation of dig toxicity is gastrointestinal problems such as nausea, vomiting, and abdominal pain. They may have hyperkalemia from the inhibition of the sodium-potassium pump. And lastly, they may say nothing at all because they're confused. Now, one area with digoxin toxicity that is always a source of confusion, even for myself as a student, was the relationship between dig and potassium. Remember, hypokalemia will lead to digoxin toxicity. However, if you start out by taking too much digoxin, then you're going to end up getting hyperkalemic. The most accurate test for someone with digoxin toxicity is simply obtain a digoxin level. The best initial test, however, is a potassium level and EKG. The EKG will show downsloping of ST segments in all leads. Atrial tachycardia with variable AV block is, however, the most common dig toxicity arrhythmia. But remember, dig can produce any arrhythmia. Now here's an example of an EKG with dig toxicity. If you look at leads 1 and 2, you can actually see downsloping of the ST depression. It's also apparent in AVL and AVF. The best treatment for somebody with dig toxicity is to get control of the potassium level and then subsequently give digoxin-specific antibodies. Dig-binding antibodies actually remove digoxin from circulation. The strongest indication for giving these antibodies are CNS and cardiac involvement. That would be altered mental status, confusion, or some form of an arrhythmia. Our next form of poisoning comes with lead toxicity. Lead is diffusely toxic throughout many organs in the body. Patients will present with abdominal pain, or known as lead colic. They'll be hunched over in pain, and it waxes and wanes. They'll have memory loss and confusion. A lot of patients will say they just feel like pins and needles sensations, and some of them will have a peripheral neuropathy so bad they may even manifest a wrist drop. Sideroblastic anemia is the most common finding on their CBC profile, and many of them will develop acute tubular necrosis due to renal tubular toxicity. The best initial diagnostic test is an increased level of free erythrocyte protoporphyrin. The most accurate test, however, is a lead level. Remember, the most accurate test for sideroblastic anemia is a Prussian blue stain, not a lead level. Lead interferes with hemoglobin production and thus gives anemia. By getting a Prussian blue stain, you can actually see iron buildup in the red cell mitochondria. Chelating agents are the best choice for treating someone with lead poisoning. They actively remove lead from the body. Succimer is the only lead chelator that is oral. EDTA and BAL are parenteral. Mercury can poison the body through two routes. The first is through the oral route. Oral mercury ingestion can cause neurologic problems. The patients present with nervousness, they're jittery, they say they have twitches, and sometimes they even hallucinate. Inhaled mercury vapor actually produces lung toxicity, and the patients will present with signs and symptoms of interstitial fibrosis. There's no therapy to reverse the pulmonary toxicity from mercury poisoning. Chelating agents such as dimercaprol and Succimer are both effective in removing mercury from the body and decreasing neurologic toxicity. They can actually prevent progression of the pulmonary disease, but unfortunately cannot reverse the fibrosis. Alcohol in large amounts is toxic to the human body, but there are two forms of alcohol that are toxic at any quantity. These are methanol and ethylene glycol. These can produce intoxication, metabolic acidosis, an increased anion gap, and will also give you an osmolar gap. The way they're treated is with fomepizole and dialysis. The differences between methanol and ethylene glycol are striking. Methanol is found in wood alcohol, cleaning solutions, and paint thinner, while ethylene glycol is found in antifreeze. Methanol metabolizes to formic acid and formaldehyde, while ethylene glycol forms oxalic acid and oxalate. They present very differently. Methanol will present with ocular toxicity, while ethylene glycol presents with renal toxicity. The initial diagnostic abnormality that you will notice is with methanol, you'll find retinal inflammation, whereas with ethylene glycol, you'll find the classic envelope-shaped oxalate crystals in the urine and hypocalcemia. Now, as we said earlier, the toxic alcohols can give you an increased anion gap, but they can also give you an increased osmolar gap. The osmolar gap is the difference between the measured serum osmolality and the calculated osmolality. The formula is 2 times the sodium plus the BUN over 2.8 plus glucose divided by 18. Now, if you calculate the serum osmolality to be 300, but on measurement you find the osmolality to actually be 350, it is possible that a toxic alcohol, such as methanol or ethylene glycol, is accounting for these extra osmoles in the serum. Remember, ordinary alcohol, that is known as ethanol, also increases the osmolar gap. The best initial therapy is fomepizole. It inhibits alcohol dehydrogenase and prevents the production of the toxic metabolites, with methanol, that's formic acid, with ethylene glycol, that's oxalic acid. Remember, fomepizole does not actually remove the substances. Only dialysis can remove methanol and ethylene glycol from the circulation. Now we're going to move away from poisonous ingestions and start talking about snake bites. The most common injury from a snake bite is actually the local wound. 25 to 35% of the bites are not deep enough to actually deliver the venom to the bloodstream, but they do deposit the venom into the tissue. This venom has proteases and lipases that cause a local inflammation and local damage. How do snake bites then kill people? Well, they have two forms of toxins. The first is a hemolytic toxin, which causes hemolysis and DIC. The next is a neurotoxin that can result in respiratory paralysis, ptosis, dysphagia, and diplopia. Snakebite treatment falls into two categories, those that don't work and those that do. Applying a tourniquet and blocking arterial flow to the area of bite does not work. Applying local pressure does. Applying ice does not work. However, immobilizing decreases the movement of the venom from the bite into the periphery. Incision, suction, especially by someone else's mouth, is definitely not indicated. However, finding a local hospital or somebody with antivenin is the next best step. All spider bites present with a sudden, sharp pain. Your patient might tell you, "I felt like I stepped on a nail," or "Suddenly I felt like there's a piece of glass in my shoe." There's so many different spiders in the world, but the Usmle loves to test on the black widow and the brown recluse. On presentation, a black widow spider will present with abdominal pain and muscle pain, while a brown recluse will have local skin necrosis. On labs, a black widow will have hypocalcemia, while the bite of a brown recluse will cause no lab abnormalities. When it comes to treatment, the best treatment for a black widow spider bite is calcium, as the patient is already hypocalcemic, and to give the appropriate antivenin. Whereas for brown recluse spiders, notice there is no antivenin, but the treatment really is dapsone, steroids, and debridement of the bite. Dog, cats, and human bites, oh my. The good news on the Usmle is if a person is bitten by a dog, a cat, or another human, they're managed identically. They're treated with antibiotics, specifically amoxicillin combined with clovelinate. They're going to be given a tetanus vaccination booster if it's been more than 5 years since their last injection. And the bacterium that you need to know is Pasteurella multicida. This is the one that's given by dogs and cats. Remember, the humans pass on Eikenella corrodens. Remember, most importantly, that human bites are far more damaging than dog and cat bites. So be careful if you're studying with somebody who's really hungry. There are two major instances when a rabies vaccine is given. The first, if the animal had altered mental status or some bizarre behavior. And secondly, if the attack was unprovoked by the human. If it was a stray dog that cannot be observed or diagnosed, give the rabies vaccine. There's always the question, if a tree falls in the woods and there's nobody there to hear it, does it make a noise? In the same instance, if someone says they were asleep, but a bat was noted to be in the room, you must vaccinate the patient against rabies.
Our next section is valvular heart disease. The most difficult thing about this is not the total amount of knowledge, it is answering questions about murmurs and auscultatory maneuvers that are extremely difficult. So this issue about presentation and what are the different maneuvers is going to be intrinsic to what we're doing, what's the best initial test and most accurate test, and you'll walk out of this section knowing the answer to every single question, and it is going to be 100% accurate, I promise. All valvular heart disease can be congenital in nature. Now, rheumatic fever most commonly leads to mitral stenosis, but rheumatic fever can lead to any form of valvular heart disease. Aging, as calcification leaves the bones and enters the valves, is the most common cause by far of aortic stenosis. And regurgitation occurs because of hypertension causing a strain on the heart. Ischemia causes a strain on that heart. And as you infarct, you regurgitate because regurgitation leads to dilation. So ultimately, anything that leads to the heart dilating will lead to leaky, regurgitant lesions. As things infarct and die, they don't become tighter and more narrow. They loosen up in the heart and become more floppy and leaky. In order to answer the question, what is the most likely diagnosis, we have to have something that's unique for each of those diseases. Since all forms of valvular heart disease can present with shortness of breath and congestive heart failure, the presence of shortness of breath enrolls in edema is never going to allow you to answer the question about the specific type of valvular lesion. You can't say that person's short of breath, they must have mitral regurgitation, because shortness of breath could be with pneumonia or mitral regurgitation or aortic stenosis or aortic regurgitation or mitral stenosis. That won't allow you to answer the diagnostic question. Only the murmurs are specific for each of those presentations. Right-sided lesions, such as the tricuspid and pulmonic valve, increase with inhalation because when you inhale, you increase venous return to the right side of the heart. And left-sided lesions, as you exhale and the diaphragm goes up, the lungs become smaller. And as the lungs become smaller, they squeeze blood into the left side of the heart. So left-sided lesions increase with exhalation because you're compressing the heart and you're compressing the lungs. But as you compress the heart and the lungs, you are still squeezing blood out of the lungs and into the left side of the heart. Right-sided lesions increase with inhalation. Left-sided lesions increase with exhalation. The best initial test for all forms of valvular heart disease is the echocardiogram. The transesophageal echo may be more sensitive and specific, but the transthoracic echo is still the best initial test. Now, there's a huge difference between the question, what is the best initial test, and what is the most accurate? What is the most accurate does not necessarily mean what I'm actually going to do. 99% of the time, valvular heart disease is diagnosed off of the echocardiogram. However, when they actually ask you, which of the following is the single most accurate test? If cardiac catheterization, now not the catheterization that puts a catheter into the coronary arteries, but cardiac catheterization where you have a catheter going into one side of the heart, into the chambers, across the valve leaflets that measure the exact valve gradient, the exact valve diameter. The best initial test is the transthoracic echo. Transesophageal echo is more accurate, but the most accurate is catheterization because the valve pressures that you might hear of on a transthoracic, how did we know how it correlates? Because we're comparing it to cardiac catheterization, to left heart cath for the left-sided lesions, and right heart cath for the tricuspid and pulmonic valves. Now remember, you are not going to skip the transthoracic echo and go straight to the transesophageal echo. You're not going to skip the transthoracic. Transthoracic first, transesophageal better, cardiac catheterization the single most accurate. It would be great if the EKG could give you specific diagnostic criteria for valvular heart disease, but it can't. There's nothing specific with valvular heart disease. You can see hypertrophies of things. You can see a biphasic P wave in V1 and V2. Biphasic P wave indicates left atrial hypertrophy. You can see P pulmonale, a big, huge, large P wave. That indicates right atrial hypertrophy. You can see hypertrophy of the chambers. You could see an S in V1 or 2, plus an R in V5 and 6, greater than 35 millimeters. And that greater than 35 millimeters would be left ventricular hypertrophy. But the EKG correlation with chamber hypertrophy is only about 50%. And you can't confirm the diagnosis from an EKG. It's simply not good enough. So where does that leave the test? Most of the time, it leaves it as one of those things we do, but is neither the best initial nor the most accurate. Not for valvular heart disease. For ischemic heart disease, it's always first. So that means for you, on step 2CK, the EKG is one of those answers that's in the choices, but it's never right, because it's not the best initial and not the most accurate, not for detecting the presence of valvular heart disease. In many ways, the chest x-ray is similar to this. The chest x-ray is similar to this because it may show enlargement of the chambers, but the precise anatomic correlation is simply poor, and the x-ray is neither the best initial nor the most accurate test herself. That is for the echocardiogram. Since all forms of valvular heart disease can be associated with fluid overload, all of the forms of valvular heart disease could benefit from diuretics. Now, diuretics are largely symptomatic control. All valvular heart disease can cause congestive heart failure. All valvular heart disease can cause shortness of breath. Therefore, all valvular heart disease will benefit from diuretics. Now, that doesn't mean it'll delay progression. Diuretics don't delay progression of anything in the heart. They don't delay progression of congestive failure. They don't delay progression of regurgent or stenotic lesions. But they are a therapy used simply to decrease fluid overload. But medications alone can't improve the lesions, especially not stenotics. Stenotic lesions cannot be ultimately improved in terms of the progression of the disease by meds alone. Regurgitant lesions can, but symptoms only with diuretics. Mitral stenosis is treated with balloon the mitral, because it's caused by rheumatic fever. Balloon the mitral, particularly in a pregnant woman. Balloon the mitral, because it is fibrotic tissue. But replace the aortic, because the aortic is with calcification. You can't balloon calcification. You have to replace the aortic and balloon the mitral, because you can't balloon calcium, but you balloon that fibrous tissue. The best initial therapy for regurgitant lesions is vasodilators. Now, what does a vasodilator mean to you? The best initial vasodilator for a regurgitant lesion is an ACE inhibitor or angiotensin receptor blocker, nifedipine or hydralazine. Now, if this was congestive heart failure alone from a weak muscle of the left ventricle, then ACE and ARBs are clearly superior to nifedipine and hydralazine. But for a regurgitant lesion, which simply needs vasodilation, the difference between them is pretty similar. As a matter of fact, it's so similar, you won't be asked to choose between them. Now, hydralazine has adverse effects such as lupus, such as a reflex tachycardia, such as the fact that it's difficult to take several times a day. But in terms of efficacy, they're all about the same. Now, when the valve dilates a lot, you have to replace it or repair it. Tighten it up. And those criteria are when the left ventricular end systolic diameter becomes too great, because you can't let it dilate it up. And how you tell if a regurgitant lesion dilates up is how empty can it get on contraction. If you can't contract that thing to being all the way empty, it's time to replace the valve. Because if the heart dilates up too much, if it dilates excessively, then you can't just replace the valves. You can't just replace the valve, because how do you grab those very separate parts of the heart? You got to replace it before it dilates up too much. Well, what does too much actually mean? Well, 55 millimeters in aortic regurgitation or 40 millimeters in mitral regurgitation. That's what it means for too much. 55 for aortic and 40 for mitral. Because if the myocardium stretches too much, it won't be able to return to normal size and shape. Now, this too much thing is very difficult for a medical student. You're like, I understand what you mean by too much, but what does it mean too much? 55 millimeters of left ventricular end systolic diameter for aortic regurg and 40 millimeters for mitral regurgitation. In terms of assessing the ventricular size, we base it on the end systolic diameter, because that's a measure of how strong the heart is. If the heart is strong, you can empty the heart. If the heart is not strong, you can't empty it. How do you know how much you can empty it? At the end of systole. In other words, if you can fill but you can't empty any of it, it's not a very strong heart. We look at the ejection fraction, and we look at the expansion of end systolic diameter to replace the valve. In other words, you can't wait until that end systolic diameter has grown enormously, because if it grows enormously, then you'll never be able to reverse it. So therefore, we are going to look to see whether the end systolic diameter goes above 55 millimeters for aortic regurg, 55 millimeters, 40 millimeters in mitral regurgitation. And remember, endocarditis prophylaxis is not indicated for any of these valve lesions. No longer for AR, MR, AS, MS, no longer for mitral valve prolapse or HOCM. Mitral stenosis is most commonly caused by acute rheumatic fever. You got to look for an immigrant. Very little domestic rheumatic fever in the United States. Very uncommon, because children get so many antibiotics. Now, it's a very low incidence of acute rheumatic fever, so therefore most of the time you're going to do a whole Peds residency, never see one case. If the person is asymptomatic, you're not going to do any treatment. You're going to treat if they're symptomatic and don't do anything if they're asymptomatic, even if it's very narrow. So if you say to a person, hey, listen, you got an opening snap and a diastolic murmur, you'd be like, yeah, but I feel fine, so don't do anything. I feel fine, don't do anything. If you're short of breath, then you'll do something. But if you're asymptomatic, don't do anything. One of the key features of mitral stenosis allowing you to answer what is the most likely diagnosis, is to look for both a pregnant person or an immigrant person, and especially both. Now, step 2 of Usmle has to be able to give you significant clues. Therefore, if they don't give you the murmur, which shows an opening snap and a diastolic rumble, you look for that pregnancy, because in pregnancy there's a massive increase in plasma volume. This has to do with resetting the hypothalamic osmostat. In a normal person, you would shed off ADH at an osmolality of 280, but in a person who's pregnant, in order to increase the plasma volume, it continues to secrete ADH into the posterior pituitary. This 50% increase in plasma volume allows for the perfusion of the baby. In addition, for pregnancy, when you contract the uterus, it squeezes at least 500 milliliters extra into the central circulation. Most our patients with mitral stenosis are immigrants to the United States, and immigrants for places where acute rheumatic fever is still common, it's still endemic, where people simply don't have the same level of access to antibiotics for pharyngitis. Shortness of breath and congestive failure is simply the root base upon which all valvular heart disease occurs. But you're going to have to say they have shortness of breath and congestive failure and dysphagia, as the left atrium presses backwards on the esophagus, and it squeezes your esophagus and causes an obstruction to your swallowing. And you're also going to get, you're going to get hoarseness. You're going to get hoarseness as your left atrium passes on your recurrent laryngeal nerve, and it causes hoarseness in time for your atrial fibrillation, because it has the largest left atrium, so therefore it has the largest amount of stasis and the largest amount of atrial fibrillation, therefore the largest amount of strokes. And hemoptysis, because that backflow of blood into your lungs bursts the blood vessels, and we are going to be looking for a young adult person who is 25 or 30 or 36 years old, who had their rheumatic fever when they were 10 or 12, and now they're 36, and now you're like, oh man, why are you short of breath today? I don't know. Let me hear. Oh, click, click, click. Oh, I hear an opening snap. Are you hearing short of breath? Yes, I am. Are you having hoarseness and dysphagia? I don't know. Let me swallow. Oh, that sucked. Yep, you must have mitral stenosis. Ooh, if it isn't original artwork, and the enlarged left atrium in mitral stenosis presses on that esophagus, causing the dysphagia. And there's the arrow with it pressing backwards. The unique physical findings of mitral stenosis is very straightforward. 200 years ago, it was an opening snap after the S2, and followed by a diastolic rumbling murmur. 200 years ago, it was squatting and leg raise, making it worse. Squatting squeezes the leg veins. When you squeeze the leg veins, it increases venous return to the heart. When you lift the legs up in the air, it increases venous return to the heart. It's that forward. More blood in the heart leads to more murmur. More venous return, more murmur, period. And here's a diagram showing the opening snap, and that extra bulge to the right is showing the beginnings of the murmur when it occurs. As mitral stenosis worsens, does the opening snap happen earlier, or does the opening snap happen later as mitral stenosis worsens? As mitral stenosis worsens, the opening snap happens earlier, because left atrial pressure creates the opening snap. And as mitral stenosis worsens, left atrial pressure goes up. Testing for mitral stenosis is not different than the testing that we've said at the beginning of the section in general. As it is for all valvular heart disease, the best initial test is a transthoracic echo, and TTE means transthoracic echo. Transesophageal echo is more accurate, and catheterization is simply the most accurate. Now, transesophageal echo is not always necessary, because if you can see what you need from the transthoracic, you don't have to do the transesophageal. But it's important to remember that a negative transthoracic doesn't exclude vegetations or small amounts of disease in the mitral valve. What is the most posterior structure in the heart? What is the most posterior? The most posterior structure of the anterior surface of the heart is right ventricle. So therefore, in the right ventricle, the transthoracic and transesophageal for the right side is essentially equal. The EKG will show atrial arrhythmias, atrial fibrillation, atrial flutter, and left atrial hypertrophy, which is a biphasic P wave. Now, biphasic P waves occur because muscle drives the electricity. Electricity follows the muscle. So if the left atrium hypertrophies and the left atrium gets big, where's the left atrium? Posterior. Where's the leads? Anterior. So it pulls the electricity away from the lead, pulls the electricity away from the lead, and that's why the first part of the P wave goes forward to the right atrium, and the second part of the P wave goes backwards to the left atrium. Biphasic. Up, down, up, down. This EKG shows left atrial hypertrophy. If you look at these arrows in V1, you will see that they are pointing at a P wave that first has a positive deflection, then a negative deflection. So mitral stenosis results in a biphasic P wave, particularly in V1. V1 is an anterior lead. The first part is the right atrium, forward with the electricity, forward to the electricity. The second part is the left atrium, backwards. So it goes up, down, up, down. The chest x-ray is going to show left atrial hypertrophy. Well, that's easy to say. What does it mean? What do you actually see? You can't see the left atrium too well. It's not like on an EKG. See, on an EKG, it's normal to have a little bit of biphasic P wave. What's different is that it's a much bigger biphasic P wave in V1 and V2. A bigger one where the second part, the downward part, is bigger than the forward part. That's what's the main thing. It's not so much that it's a little biphasic, but big biphasic, where the second part is bigger than the first part on an EKG. And that's because when you look at the left atrial hypertrophy on the x-ray, you can see straightening of the left heart border. And the elevation of the left main stem bronchus, because you see, ooh, look at that. That left atrium will actually push it up. Left atrium will actually push it up, shoves it up because it's big. And that second bubble behind the heart is what's creating a big second part of the P wave in V1 and V2. The major issue is the second part of the biphasic P wave, the downward deflection, exceeds the size of the initial part in left atrial hypertrophy. The best initial therapy for valve diseases, it's diuretics and sodium restriction. And since we only care about people who are symptomatic, we're only looking at the people who have symptoms of fluid overload. Balloon valvuloplasty. If it's tight, let's get a balloon in it with a catheter. Remember, you can balloon with a catheter the mitrals, but you replace the aortics, and valve replacement for mitrals is the answer when a catheter procedure either can't be done or when it fails. Now, warfarin is not for everybody with mitral stenosis, but only when there's an atrial arrhythmia. Now, you may be looking, if you're a sophisticated student, for the newer anticoagulants, dabigatran, rivaroxaban. But dabigatran and rivaroxaban are specifically indicated for non-valvular atrial fibrillation. And this is valvular atrial fibrillation. In addition, we're going to control that rate with any one of these drugs. Now, ready? You must be prepared that if anything I say disagrees with what you previously been taught, where somebody says, hey, you know what? I think that I was told by my attending, boom, we got to use verapamil. Well, you know what? That is simply local tribal customs. So when you get to something that disagrees with your previous attending, just go with what I'm saying, because this is not based on what's done in a particular state. This is a national, frankly international examination, and any one of these is accurate. You can answer what I tell you, and you can bet your career on it, and we will not let you down. The most common cause of aortic stenosis is a congenital bicuspid valve and calcification with age. Bicuspid valves are much more common than you might think. They really are. They are congenital, we don't know what happens, and then they calcify with age because what happens, the extra pressure damages the endothelial lining. The most common presentation of aortic stenosis, the most common presentation is angina. The most common wrong answer is syncope, because syncope is not the most common presentation. But I thought it was. You're wrong. The worst prognosis is congestive heart failure. You have a survival with congestive failure of aortic stenosis of about 2 years. You see, it's like cancer of the heart. It's about the same survival as metastatic cancer. You got to get in there and replace that valve before it dilates up. The murmur of mitral stenosis can be played for you on step 2. And you will have to know how to recognize it. Because we have isovolumetric contraction at the beginning, isovolumetric where no blood is moving, you don't hear anything at the beginning. That's why it's a crescendo, decrescendo. Because at the beginning, there's no blood moving, no murmur. It peaks in mid-systole. That's why it's diamond-shaped, or crescendo, decrescendo. And it's heard best in the second right intercostal space. Where does it radiate? Well, mitrals radiate to the axilla and aortics radiate to the carotids. And how it looks, here it is. It's a systolic murmur, crescendo, decrescendo, and goes up to the carotids and heard best at the second right intercostals. I cannot overestimate how important the next slide is. The auscultatory maneuvers are critically and indispensably important. You are not to go into step 2 without you knowing that aortic stenosis and that Valsalva and standing, which decrease venous return to the heart, will decrease the intensity of that murmur. Less venous return, less murmur. Hand grip, its effect upon the heart is to increase after load. Increase after load on aortic stenosis softens murmur. Make it hard for blood to get out of the heart. Softens murmur. Less blood ejected, less murmur. Hand grip does not increase venous return. Hand grip, you squeeze on something, and I compress the arteries of the arm, and it makes it hard for blood to get out. Increased afterload, less blood comes out, less murmur. Diagnostic tests for aortic stenosis. Transthoracic echo, then a transesophageal, then a cardiac catheterization is the most accurate test, and a chest x-ray will show left ventricular hypertrophy as the heart works it and gets thicker and thicker, and then you'll have a larger heart as it goes beyond 50% of the transthoracic diameter, and the EKG will show left ventricular hypertrophy, with the S in V1 and the R wave in V5 being greater than 35 millimeters. This is indispensable. Don't go into that test without knowing, and you're going to have to listen to some murmurs and know them for sure. Look, I wish there was medical therapy for aortic stenosis. I wish we had like aortic stenosis O dissolver, O binder, but there isn't. If you have shortness of breath from fluid overload, we can use some diuretics to try and decompress your lungs. But that's not going to treat your aortic stenosis. Not really. It's not getting rid of the aortic stenosis. Best initial therapy may be a diuretic, but the only truly effective therapy is to get rid of the valve. And even old people can tolerate. Even 85 and 90-year-olds tolerate that aortic valve replacement fairly easily. Diuretics decrease the congestive failure, but they don't tolerate the volume depletion to get lightheaded. Balloon valvuloplasty is simply not routine for aortic stenosis. And you can't balloon calcification. You got to replace calcification. And you balloon aortic stenosis only if the person is too fragile or unstable to get the valve replaced. Mitral regurgitation is unbelievably common. First of all, etiology leading to an abnormal backward flow of blood through that valve. And so common to have hypertension dilating up the heart. You might say, well, I thought that causes hypertrophy. Well, it does at the beginning, and then it dilates up. Or endocarditis, making the valve leaky as it cooks that valve and burns through it, and then the valve just becomes leaky, which makes it dilate up some more. Now, papillary muscle rupture from myocardial infarction is a cause of acute mitral regurgitation. You acutely infarct, and the papillary muscle dies, and it's like the float in a parade getting loose by the ropes being cut. The most common cause is hypertension and infection and infarction, and infection and infection, and infection and infarction, and infarction and infection. And anything that dilates up the heart leads to mitral regurgitation, because the leaflets don't actually change in size. So when the heart itself widens, those leaflets have to separate. You can't get the diagnostic question by simply saying, let's look for a person who's short of breath. All the valvular heart diseases make you short of breath. But the unique finding is, boom, 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 pansystolic murmur. Going to the axilla and obscuring S1 and 2. A pansystolic or holosystolic murmur. Remember, those words are interchangeable. They obscure S1 and 2 and it radiates to the axilla. And since hand grip increases, afterload. Hand grip increases, afterload. It pushes that blood backwards because regurgitant lesions are treated with afterload reduction. So there means increasing afterload makes it worse because the increasing afterload pushes the blood backwards. Hand grip worsens all regurgitant lesions because ACE inhibitors treat all regurgitant lesions. Squatting from a standing position squeezes the leg veins. Leg veins are big. Leg veins have big volume. Leg veins, when they're squeezed, put big volume in the heart and increase venous return to the heart. All left-sided lesions except mitral valve prolapse and HOCM are going to get bigger with expiration, and they're going to get bigger with leg raising and squatting, because more blood, more murmur, less blood, less murmur, with everything except mitral valve prolapse and HOCM. Mitral regurgitation and the effect of those murmurs, squatting and leg raise, is super high yield. Knowing that they're all diagnosed with echo is important, but it's not as important as those auscultatory maneuvers. Let's take a look here at the bottom. This shows S1 and S2 being obscured. Remember, pansystolic or holosystolic means the same thing. Regurgitant lesions are treated with ACE inhibitors. Hand grip makes it worse. ARBs make it better. Hydralazine makes it better. Nifedipine makes it better. Vasodilators help. This is one of the most common questions for Step 2 CK. The best initial therapy for regurgitant lesions, even in the absence of symptoms, is vasodilator therapy. As you dilate the peripheral vasculature, it lowers the pressure in front of the heart. This makes it easier for blood to go forward. These are indispensable facts because they are frequently tested, because they are able to decrease the rate of progression of the disease, and digoxin and diuretics simply control symptoms, as they do for almost everything. They don't decrease the rate of progression, they simply control symptoms. Vasodilators make it decrease the rate of progression of disease. Stenotic lesions, when they're symptomatic, always need and drops down to less than 60%. Now you might say, I thought a 60% was a normal ejection fraction. It is, but not in a person who's got mitral regurgitation. In a person who's got mitral regurgitation, an ejection fraction of 57% is abnormal. Valve repair is an exciting new thing over the last couple of years. It means that instead of taking the whole valve out, you could put a clip or a suture, just tighten it up, tighten it up, tighten it up. It's like an episiotomy repair of your heart valve. Put in a couple of sutures and clips and tighten that thing up, and everybody's going to feel better. Our next valve lesion is aortic regurg. Now, the causes of aortic regurg are very similar to the mitral regurgitation, which is infarction or infection, anything that makes the heart or the aorta dilate. Anything that kills off part of the heart makes the heart dilate, or hypertension, where the heart eventually gets tired and starts to dilate. Infection, endocarditis become a pretty rare disease, but if the valves are incompetent, they're going to regurgitate and dilate up the heart. Same as Marfan's or cystic medial necrosis or Ehlers-Danlos syndrome, or any of the things that might make the heart loose and floppy, make those leaflets loose and floppy, such as ankylosing spondylitis. Now, it's only 3 or 4%, and don't answer heart disease as the most common manifestation outside the axial spine of ankylosing spondylitis. The most common extra-axial outside the spine manifestation of ankylosing spondylitis, the most common is the eye at 25, 30, 40%. But you get 3 or 4 good percent with ankylosing spondylitis. Now, Reiter's syndrome is also called reactive arthritis, and it's associated with aortic regurgitation as well. And of course, our old friend syphilis. Even though syphilitic aortitis may be uncommon, it's still important for you to know. There are several unique physical findings for aortic regurg that are indispensable for you to know. Besides congestive heart failure, the unique physical findings: wide pulse pressure, boom, 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 boom. The pulse pressure goes up because you know that a lot of the blood has to regurgitate backwards, so you can end up having a systolic of 150 and 160 and a diastolic of 50 or 60. That's huge. You can have a pulse pressure goes from the normal 40 to a pulse pressure of 60, 70, 80, 100, and that's felt as a water hammer pulse. Not that anybody knows what a water hammer is, but it's also sometimes known as a Corrigan's pulse. Boom, boom, boom. Quincke pulses, pulsations in the nail beds, you see them. Water hammer pulse, you feel. Quincke pulse, you see. Hill's sign is named after a guy named Hill. Not that the pressure goes down a hill. It's that the pressure inside the legs is above the arms. That's Hill's sign. Or whoosh, 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 moving your head up and down, and Demusset's sign. Memorize it. It's very easy for them to play audio recordings for you on step 2. It's a computerized exam, and you have to hear lub, psh, lub, psh, lub, psh, lub, psh. That's me acting out all the murmurs. Wait till I get to vowel sounds. It's heard best at the lower left sternal border because it travels down the root of the aorta, which goes like a cane curving around. The thoracic aorta goes curving down, and then the stick part of the cane goes down along the lower left sternal border. The hemodynamic effect upon the heart of Valsalva and standing. Valsalva, exhalation against a closed glottis. Ooh, like straining at stool. The Valsalva will decrease venous return, as will standing, because the venous capacitance vessels of the legs are opened up, so it makes that lesion smaller, softer, less intense, because less blood, less murmur, less blood, less murmur for all left-sided heart lesions except mitral valve prolapse and HOCM. Hand grip worsens it, because hand grip increases afterload, and increasing afterload makes this worse because you're treating it with an afterload reducer. So hand grip makes it worse because it increases the afterload. Here we have an S1 and a psh, an S1 and a psh, along the lower left sternal border. The diagnostic tests for aortic regurgitation start out with EKGs and X-rays, which show left ventricular hypertrophy. But remember, left ventricular hypertrophy is not any more specific here than it is with aortic stenosis. So although they'll show the heart enlarging to the left side and the S in V1 and the R in V5 greater than 35 millimeters, it still is not enough to tell you it's aortic regurg. The treatment of aortic regurgitation, the best initial therapy, is afterload reduction, as vasodilators make it easier for blood to leave the heart. If you are in the heart in the left ventricle, and you have an easier time ejecting that blood, there is simply less force to dilate the heart abnormally, and the blood will go forward. This is not only going to improve symptoms, it will definitely delay the progression of the disease. And although digoxin and diuretics can be used with severely symptomatic patients, they don't decrease the degree of the disease, they don't delay the progression of the disease. They might be helpful somewhat to decrease symptoms, but that's it. Because we don't want to wait for the lesion to dilate the heart too pathologically, we are going to replace that lesion, or we're going to repair it. First of all, acutely with acute valve rupture, for sure, right away. But in chronic disease, if the ejection fraction reduces under 55% or the end systolic diameter goes above 55 millimeters, you're going to replace the valve. Replace the valve at 55. Ejection fraction coming down. It's hard for people to understand, but I thought that 55 was still the lower limit of normal. It is, but if you're regurgitant, your ejection fraction would be 60 and 70. That's why under 55 is bad. Replace the valve. Despite the fact that mitral valve prolapse is extremely common, it is essentially a normal anatomic variant in 2 to 5% of the population. That's why it's indispensable to understand that when you see a little prolapse, particularly in women, it is not to be treated unless there's symptoms. Marfan's and Ehlers-Danlos, which make all connective tissue loose and floppy, can definitely have mitral valve prolapse. But again, the key feature in mitral valve prolapse is, are there symptoms? And since most of them are asymptomatic, this is a really important source of questions, where it says a person has syncope or some other reason to get an echo. And they have this problem or some other problem. They get an echo and they say, it reports mitral valve prolapse. You say to the patient, hey, are you having any atypical chest pain? And they go, no. Are you having any chest pain? No. Are you having any palpitations? No. They say, well, are you having any anxiety? Well, even if there was just anxiety, you're not going to do anything about the heart valve just for anxiety. You treat it if there's pain or palpitations, atypical chest pain or palpitations. And it's hard for people to understand. Hey, listen, there's valve regurgitation. How come you're not symptomatic for congestive failure? It's a matter of degree. The amount of regurgitation is not enough to result in shortness of breath, and that's why you don't have to treat it. Now, what's unique about the murmur of mitral valve prolapse? Well, there's a couple things. One, a mid-systolic click is quite unique, and that mid-systolic click is followed by a murmur, click-murmur syndrome, click-murmur syndrome. And the murmur is the murmur of mitral regurgitation. Now, let's get to the unique features. Mitral valve prolapse gets worse when the heart is smaller, because the smaller the heart is, the worsening the prolapsing valve, because the valve, prolapse means your valve is simply too big and floppy for the size of your heart. It's like a size small heart wearing an extra large valve, and it goes floppy, floppy, floppy. So anything that makes the heart smaller, such as valsalva, just return, squatting. Decreased emptying, hand grip makes it better. Well, here's a picture of the extra loose floppy valve billowing backward, billowing into the left atrium as the heart contracts. It's going up like a parachute there, and that explains a lot. When it comes to a stop, that's when you get the click. And if it doesn't seal, if it doesn't fit, that's when you get the murmur. The diagnostic tests of mitral valve prolapse are not different from the others. Echo is the best initial test. Catheterization is the most accurate test. But catheterization is almost never done on a lesion that you virtually never replace. You don't even treat most mitral valve prolapse. It's mostly an asymptomatic finding on an echo done for another reason. Don't even treat it asymptomatic echo done for another reason. Asymptomatic echo done for another reason. You would treat it if somebody had severe symptoms, beta blockers first, and you replace it only very rarely. Most mitral valve prolapse doesn't need treatment. It's very simple. No symptoms, no treatment. Click, no symptoms, no treatment. Click murmur, no symptoms, no treatment. Abnormal echo, no symptoms, no treatment. Oh, pain, palpitations. The best initial therapy is beta blockers, but only when there's symptoms. Valve repair is almost never needed. Valve repair with a catheter to clip or tighten those valves, to stitch them together, tighten the leaflets. The surgical repair is rare. But endocarditis prophylaxis is never. You're having all your teeth removed? You don't need prophylaxis. You're having bloody procedures? You don't need prophylaxis. Not even if there's a click? No, not even if there's a click. Not even if there's a click and a murmur? Not even if there's a click and a murmur. The answer for endocarditis prophylaxis from mitral valve prolapse, no matter what procedure you're doing, is always no.
This next section looks specifically at the one subject of microcytic anemia. How are we going to answer what is the most likely diagnosis when they all have the same smear and the same symptoms? What is unique about each one? The smear in microcytic anemia, these red cells are very hollow, very circular and ring-like. They shouldn't be that pale. The rim of hemoglobin should not be so thin. That's too pale in the center here. That is why all the smears of all the microcytics look the same. They look very hollow in the middle. Microcytosis, by definition, means simply an MCV that's less than 80. By far, the most common cause of iron deficiency is blood loss. Malabsorption is rare. Things like celiac disease can give a malabsorption, presents with a malabsorption of iron because of damage to duodenum. But it's far more common, of course, to have blood loss. People who menstruate a lot, people who simply have GI bleeding at various points. And that's because although you need only 2, 3, 4 milligrams a day of iron, you can't increase absorption that much. So if you lose as little as 1 teaspoon a day of blood, it leads to iron deficiency over time because although you may not need much iron, you may only need, well, a non-menstruating man only means 1 to 2 milligrams a day. If you're menstruating, it goes up a little bit, 2 or 3, and pregnant women can go up as much as 5 or 6. But you see, that's not a big range. It's kind of a tiny range. However, your ability to absorb things, the duodenum absorbs maximum 4 milligrams a day. We don't have a lot of variety there. So if you lose 1 or 2 teaspoons a day of blood in your stool, number one, you wouldn't notice it. It would come out as brown blood. You don't get melanoma. How much blood do you have to lose a day to get melanoma? Well, black stool doesn't start till you lose 100 ml. So you wouldn't even notice 5 or 10. You wouldn't notice 15 or 20. So therefore, all blood loss will eventually give you iron deficiency anemia. In the anemia of chronic disease, the MCV initially is normal, then it'll decrease. The anemia of chronic disease is just unknown. We don't know exactly what shuts down the marrow in chronic diseases like infections and cancer. We just don't know why it stops working. The clear mechanism is only in renal failure because of deficiency of erythropoietin. That's very straightforward. And hemoglobin synthesis just doesn't go forward. It doesn't occur because the iron doesn't move forward. The iron gets locked up in storage. Heme is not made because iron is locked in storage. It's trapped in the macrophages. It's trapped as ferritin. That's why the ferritin level stays normal or even goes up. That's why the iron binding capacity is down.
The empty spots is down. It's locked in storage, but you can't make cells from it. Sideroblastic anemia is very unusual. It can be a macrocytic anemia when it's associated with myelodysplasia. It's most commonly from alcohol, not lead. Lead can do it. Less common is lead. Lead is the most common wrong answer. It just sticks out in people's mind. Lead is not the most common cause of sideroblastic anemia. There's not much lead out there in society. You can't go down the street and get a lead and tonic. You can't go get a case of lead at the supermarket. Isoniazid can do it, and there are some people who have a congenital B6 deficiency, aminolevulonic acid synthetase, ALA synthetase deficiency, and that small number of people, small variant, will respond to pyridoxine, which is vitamin B6. The majority of sideroblastic is alcohol. You have to stop the alcohol, and you will get an improvement. Thalassemia means a decreased ability to make particular hemoglobin chains. Alpha thalassemia means I don't make alpha chains. Beta thalassemia, I don't make beta chains. It's extremely common, and that is because most of them are simply traits. They are heterozygotes, and they're asymptomatic. It's the most common cause of a lifelong microcytosis. Most of them are asymptomatic. You simply can't distinguish the causes of microcytic anemia based on the symptoms. Impossible. You have to have a suggestion for the history, or you'll never figure it out. You can figure it out once you get lab tests, but surely not from just the knowing that there's a microcytic anemia. Well, how do you answer the question, what's the most likely diagnosis for anemia? Well, here we go. If there is in the history blood loss, such as GI bleeding, the most likely diagnosis is iron deficiency. And that also would mean things like menstruation as a cause of blood loss. Now, cancer or chronic infection gives anemia chronic disease. And the classic is rheumatoid arthritis. Now, part of the same idiopathic disorder, rheumatoid arthritis, I mean, the whole disorder is idiopathic. But the same antibodies, the same autoantibodies are going to damage the bone marrow and you stop making cells. Alcoholics can have just a macrocytosis, but they can also have a microcytosis from sideroblastic anemia. And the most common cause of very small cells, but being asymptomatic, is thalassemia. They have very small cells, but you don't feel symptoms because the body increases the cell count. It's like a tachycardia. You go down in size, so you increase the number. The peripheral smear is not useful. They're all hypochromic. They all can be associated with target cells. The unique finding on iron studies, the unique finding on iron studies is the best initial test to determine the specific cause of microcytosis. Ooh, what a cute picture of target cells. Why, they look like a target. That's right. This is extramembrane bunched up in the center. This is like a size 2 cell wearing a size 15 membrane. It just bunches up in there because it's extra floppy membrane. Now, although it is most commonly with thalassemia, you can get it with any form of microcytic anemia. The unique features in diagnosis of iron studies are that you see a low ferritin, and only one thing gives a low ferritin. The only thing that gives a low ferritin is iron deficiency anemia, nothing else. Now, unfortunately, not everybody has a low ferritin because the ferritin level is an acute phase reactant, meaning that a normal ferritin, or low normal, I should say to be precise, can be present when you have iron deficiency. But when the low ferritin is there, you automatically know you have iron deficiency. There's only one thing that gives a high circulating iron. The only thing with a high circulating iron is sideroblastic anemia. And the only thing infection or inflammation can artificially raise the ferritin level. Now, although the only thing that gives a high iron level, circulating iron, is sideroblastic anemia, both iron deficiency and anemia of chronic disease are associated with a low serum iron. So that won't help you answer the question. Iron deficiency increases the total iron binding capacity. Now, this is indispensably important. The TIBC is a measure of the unbound sites on transferrin. It's the unoccupied sites. It's the open sites on transferrin. So if you have open sites on transferrin, you have an increased capacity or high number of unbound sites. If all the chairs are filled, then there's no capacity. If all the chairs are empty, there's a high capacity. In iron deficiency, you got a high capacity because you are empty. Now, the anemia of chronic disease has a low serum iron, low in circulation, but it's trapped in storage. The ferritin, the stored iron, is elevated or normal. This is the circulating iron that's decreased, the circulating amount. The major difference is the iron binding capacity is low. The capacity is low because you're packed up with iron, man. So you have no capacity. You can't fit any in. Sideroblastic anemia has a unique increase in the circulating iron level, and that's because it's all packed up inside the mitochondria in circulation. That's one thing. And thalassemia is a genetic disease that by definition has normal iron studies. Iron deficiency gives you an increased red cell distribution of width. Now, the red cell distribution of width, the RDW, is a measure of whether the cells are the same or different in size. Are they the same or different? It doesn't tell you whether they're big or small, it just tells you whether they're the same or not. It's rather like standard deviation. Standard deviation doesn't tell you the score, it just tells you are they bunched up. So in iron deficiency anemia, are the new cells bigger or the new cells smaller? Well, in iron deficiency anemia, the new cells are smaller. Newer cells are more deficient in iron, so they're smaller. Now, normally, new cells are bigger because reticulocytes are bigger. So the most common wrong answer is saying new cells are bigger. Yeah, that's true in a normal person, but not if you're iron deficient. If you're iron deficient, as the body runs out of iron, newer cells have smaller amounts of hemoglobin. Less hemoglobin, they get progressively smaller. We're running out of food, we make smaller sandwiches. There's an elevated platelet count. It's very common, and that's a tested question, ladies and gentlemen. That is a tested question. Hi, this guy has a microcytic anemia. Why is his platelet count up? You are expected to know not to go chasing a cause of a high platelet count. You don't have to go do something. You don't have to go do JAK2 testing looking for essential thrombocythemia. You have to simply know, hey, I understand that iron deficiency anemia gives you an elevated platelet count. I understand it. I don't have to do anything about it. It's fine. Just part of the disease. We think it's because erythropoietin has some stimulatory effect on megakaryocytes. Now, the single most accurate test is a bone marrow for stainable iron. I never said I was going to do it. We don't have to do it, but it is the most accurate test. What we do is look at the iron studies. Sideroblastic anemia, the most accurate test is Prussian blue. What a beautiful picture here. It's a picture from my own chief resident, and this is iron built up inside the rings of the mitochondria around a red cell. See, this is not basophilic stippling. Basophilic stippling occurs throughout the entire red cell. Now, ring sideroblasts are specific for sideroblastic anemia. Thalassemias all give normal iron studies, so a normal iron study can't tell you which type of thalassemia you have. The most accurate test to tell you which type of thalassemia you have is the electrophoresis. You have to look at different bands of the hemoglobins. That's the only way to tell. Is this alpha thalassemia or beta thalassemia? Tells you that you have abnormal bands of hemoglobin on the electrophoresis. Electrophoresis is the answer for basically any hemoglobinopathy. For you on step 2, it's the answer for thalassemia and for sickle cell. Thalassemia and sickle cell electrophoresis. The most accurate test for alpha thalassemia is genetic studies. That's because there's nothing on electrophoresis that can tell you, hey, this is alpha thalassemia for sure. 1 gene deleted is normal. 4 gene deleted, they're dead. And remember that 3 gene deleted thalassemia, alpha thalassemia, is the only thing that's microcytic. The only microcytic gives you increased reticulocyte count. Only 3 gene deleted alpha thalassemia is a high reticulocyte count. All thalassemias will have a normal RDW because they may be small cells, but they're all small. Let's review the difference between these. With alpha thalassemia, with 1 of the 4 genes missing, you are normal, completely normal. Whereas beta thalassemia trait, you'll have an increased fetal, an increased A2, because you have decrease in the hemoglobin A, but an increase in the fetal in the A2. 2 genes deleted, you'll have a mild anemia, but a normal electrophoresis. You can't find it. You can't find it because there's alpha chains in all the hemoglobins. Now, this concept of 2 gene deleted doesn't apply to beta thalassemia because beta chain only has 2 genes, only has 2 genes. Now, when there's 3 gene deleted, you have moderate anemia and beta 4 tetrads, known as hemoglobin H. It's the only one with increased reticulocyte count. There is a beta thalassemia intermedia, and that's a good name because it tells you, well, it's got a normal hemoglobin F, and there's no transfusion dependence. 4 gene deleted, you're dead. That's gamma 4 tetrads or hemoglobin Barts, and they die in utero. This concept does not exist for beta thalassemia. Now, the reason we emphasize diagnostic testing so much in hematology is because what do you think they're going to ask you about on your test? They're going to ask you like, hey, what do you treat iron deficiency with? What do you treat folate deficiency with? No. Yeah, iron deficient replaced with iron, oral ferrous sulfate. And if it's not enough, it's insufficient. In other words, if oral therapy is insufficient, you get intramuscular iron. Now, because the majority of iron given orally is not absorbed, you should be telling people, hey, your stool will turn black. Well, how are you on the test supposed to distinguish between the black stool of bleeding and the black stool of ferrous sulfate replacement? Well, ferrous sulfate replacement makes you constipated, and bleeding gives you diarrhea. Ferrous sulfate makes you constipated, bleeding gives you diarrhea. The other thing is ferrous sulfate won't make the stool guaiac positive. Stool guaiacs only become positive with heme iron. That basically means hemoglobin, myoglobin. And you won't get the black stool of iron replacement to make the heme card positive. In the anemia of chronic disease, there's nothing to do except correct the underlying disease. Erythropoietin will only work with end-stage renal disease. Only end-stage renal failure responds to erythropoietin. In sideroblastic anemia, you have to correct the underlying cause, like alcohol. That's the biggie. Got to make them stop drinking. You can't get around their alcoholism. And a small, rare number will respond to pyridoxine, because a small, rare number are from pyridoxine deficiency or pyridoxine developmental defect. For thalassemia, there is no specific therapy for trait. Don't build up recessives. For beta thalassemia major or Cooley's anemia, well, we have to transfuse those kids every 1 to 2 weeks for their entire life. Actually, for chronic transfusion is the only way to fix it. You have to transfuse them for their entire life. And that's why iron overload is managed with D-ferrocerox. D-ferrocerox is one of the oral iron chelators. Deferoxamine given by subcutaneous injection. Deferoxamine is given by subcutaneous injection. But Cooley's anemia or beta thalassemia major will give you iron overload because you have a milligram of iron in every milliliter of packed cells. Now, since you only need 1 to 2 milligrams a day, and you get a milligram per milliliter, if you get 2 units of packed cells, you just got 2 years worth of iron. Wow, no wonder it builds up if you do this for 5 or 10 years. Hi, it's Conrad Fisher, and here's our next section, Hematology. I'm the Associate Professor of Medicine at Truro College of Medicine and the Director of Educational Development for the Jamaica Hospital System. Welcome to Heme. This first section of hematology is anemia. We're going to look at the presentation, diagnostic tests, symptoms, and most importantly, start the largest collection of individual tests where they have only one disease for each of these tests. We're going to look at them based on cell size. Is it micro? Is it macro? Is it normocytic? Normal cell size, and what's the treatment? All forms of anemia present with identical symptoms if they have the same hematocrit. You see, it's not the etiology, it's based on the severity. It's not the etiology, it's based on the severity. The symptoms are based on the severity of the anemia, not the etiology of that anemia. So the answer to the question, what is the most likely diagnosis, simply cannot be answered based on the symptoms alone. You can't say you're fatigued, you must have iron deficiency, or you're really fatigued, you must have sideroblastic. It's not possible. You need diagnostic tests. And the best initial test to evaluate anemia is always the CBC, the complete blood count. The symptoms of anemia are entirely based on what is the hematocrit and what is the underlying condition of that patient. If you have a person who's generally healthy and has no underlying medical conditions, they will feel nothing at a hematocrit of 30 to 35, and they won't even feel hematocrit of 25 to 30. You would only start to feel a hematocrit of 25 and 30 if you were a person who had underlying heart and lung disease. If you have underlying heart and lung disease, you'll start to feel a little tired, a little fatigued, a little short of breath at 25 and 30. A generally healthy person won't start to feel a hematocrit until it gets down as low as 20. Now, a person who has underlying heart disease will actually have chest pain, lightheadedness, and at 20 or lower, you'll actually get syncope and chest pain. Remember, it's not the etiology that gives the symptoms, it's the severity. You feel nothing at hematocrits above 30 to 35, and everybody feels tired under 20 to 25. And if you have underlying heart and lung disease, you will have chest pain and syncope under hematocrit of 20. Ultimately, cardiac ischemia from anemia proves fatal. And the myocytes just can't distinguish between anemia, hypoxia, coronary artery disease, or carbon monoxide poisoning. All of these conditions result in decreased oxygen delivery to tissues. In anemia, you don't have red cells to carry the oxygen, so how's the oxygen supposed to get to the heart? If you're hypoxic, there is no oxygen delivery. If you have coronary disease, there's stenosis, and there's a simple blockage of the flow of blood. How can you deliver oxygen if you can't get the red cells there? And in carbon monoxide poisoning, you have cells that are fantastically fully saturated with oxygen, but they're simply not going to release it to the tissues. They'll hold on to that oxygen. It's like having a rich boyfriend that still makes you pay for dinner. Now, the first clue to knowing the etiology is the cell size, that MCV, the mean corpuscular average cell size. If the MCV is low, it's a microcytosis, and the MCV is high, it's a macrocytosis. Now, macro just means large cells above an MCV of 100. Doesn't mean megaloblastic. Megaloblastic means hypersegmented neutrophils. Macrocytosis is common. High cell size can be from alcohol and nutritional deficiencies, from folate, and from various toxins on the bone marrow, liver disease, but hypersegmented things with megaloblastic, now that's rare. The cause of microcytosis are indispensable for you. All the microcytic anemias are iron deficiency, thalassemia, sideroblastic anemia, and chronic disease can be both microcytic and normocytic, but it fits in more easy to understand with microcytics because the reticulocyte count is low and there's no elevation in bilirubin. That's why the anemia of chronic disease is easier to understand with the microcytics. These are indispensable. Don't walk onto your test without knowing what causes microcytosis. Now, there is a lot of similarity amongst the microcytic anemias. For instance, all of them have a low reticulocyte count. So that's why we don't describe the anemias first based on reticulocyte count, because you can't tell which one you have based on reticulocytes. And most of the macrocytics have a low reticulocyte count as well. B12 and folate deficiency have a low reticulocyte count because the cells are just not made correctly. So whether it's iron deficiency, I can't make cells without iron, or anemia of chronic disease, if I'm overwhelmingly ill, if I have a chronic infection or cancer, I can't make cells, so no reticulocytes. Now remember, reticulocytes are cells that are the newer cells. They're the newborns, the neonates of cells. Only alpha thalassemia with 3 genes deleted elevates the reticulocyte count. Amen. And that's because alpha thalassemia here, the cells are made, but they're very, very defective, like making a lot of extra cars that don't work. Now, this statement here about these 3 gene deleted people, this is a very rare disorder, but we're not here just to pass our exam. We're here to excel. We are not here to pass, we're here to kick ass. Microcytic anemias are due to production problems, so therefore that's why it's nearly synonymous with decreased reticulocyte counts. A routine blood smear, looking at those cells, simply is not effective in telling the difference between the different types of microcytosis. They're not. They are all hypochromic, and potentially they can all give target cells. Now, target cells may be most common with thalassemia, but they all could give target cells in hypochromic cells. We want to answer the questions. We want to be able to say, what do we need to know to answer the questions? Reticulocyte count smear is not going to do it. You start with microcytosis, then get on to the iron studies. High MCV anemias, large cells, macrocytosis, B12 and folate are both macrocytic and megaloblastic. Alcohol raises the cell size. Sideroblastic anemia can also raise the cell size. Liver disease or hypothyroidism can also raise cell size. Remember, sideroblastic with the extra iron built up in the mitochondria can be micro or macrocytic anemia. Medications like the AZT medication, zidovudine, now called zidovudine AZT, the HIV medication, zidovudine, phenytoin. Phenytoin also does it because phenytoin causes folate loss in the urine. So anti-metabolite medications like azathioprine, or its metabolite, 6-mercaptopurine. Remember, azathioprine is metabolized to 6-MP, and hydroxyurea can do it. And the myelodysplastic syndrome, these are all the causes of macrocytosis. Macrocytic anemias all have a low reticulocyte count because they're all a decrease in production. Normocytic anemias are two major things: acute blood loss and hemolysis. These are both a rapid drop in hematocrit, and there's no time for MCV changes. You see, you need days or weeks for MCV changes to happen. Now, you can have a slight increase in the MCV with hemolysis because reticulocyte counts are a little larger. So hemolysis can increase the reticulocyte count, and blood loss leads to iron deficiency and microcytosis chronically. But it's acute blood loss. Acute blood loss. That's normocytic. Over time, blood loss makes you iron deficient. Hemolysis increases the reticulocyte count, and reticulocytes are larger. So if you go to a 10 or 15% reticulocyte count, it can raise the MCV a little bit. Reticulocytes are slightly larger. They're about an MCV of 120. So blood loss and hemolysis raise the reticulocyte count. The treatment of anemia, if it's severe, you're going to get packed red blood cells. Now, nobody gets whole blood anymore. Whole blood is always wrong. Now, answering the question, at what hematocrit do I transfuse, really depends on the nature of the patient. First of all, are they symptomatic? If they're symptomatic, it's easy. You can't let people walk around being short of breath and lightheaded. Anybody who's symptomatic needs to have the tank filled, period. Young, old, healthy, unhealthy. You can't breathe, you get lightheaded, you got to get transfused. Now, hematocrit in a very elderly, ill person with heart disease, in other words, a hematocrit that's very low in the elderly, needs to be transfused if it's very low, and very low means less than 25 to 30, because if you're elderly and have heart disease, you may infarct as your first symptom. So if you're a 70-year-old guy who's got coronary disease, even if they're asymptomatic, you can't let them walk out of the hospital with a hematocrit at 24, they're going to infarct. Fix it. So you transfuse patients when they're symptomatic of anemia. Well, what does symptomatic mean? It means you're short of breath. It means you're lightheaded or confused, or sometimes you have syncope, or it means you have low blood pressure or tachycardia, or you have chest pain. Now, the tachycardia is the hardest one to relate to because you can have tachycardia for a lot of things. But if the person's only reason for tachycardia is anemia, well, you can't let people walk around having chest pain, hypotension, tachycardia, and you don't have to have all of these to indicate a need for transfusion. All symptomatic patients have to be transfused. Remember, no transfusion if the person's young and asymptomatic. They will make their own reticulocytes. Give them time. There's no rush. They're asymptomatic and they'll get their own reticulocytes in a couple of days. Let's be 100% clear when each of the blood products is to be used. When you see someone talk about transfusion of red cells means always packed cells. This is a concentrated form of blood. If you take whole blood, what a person donates, and remove the plasma, that's the packed cells. And that's why removing that plasma makes the hematocrit in the packed cells around 70 or 80. Now that means you got to understand that that's why you can get such a big increase in the hematocrit with 1 or 2 units of packed cells. If you remove the plasma, it doubles the hematocrit, and each unit of packed cells raises the hematocrit by 3 points. Why is this important? A person comes in, they're bleeding. You transfuse 2 units of packed cells, and the hematocrit stays the same, or goes up by 1 point. Your hematocrit is 25. I gave you 2 units of cells. Your hematocrit goes to 26. Uh-oh! You're still bleeding. You're still bleeding. How come you only went up by 1 point? Now, if you don't know how much the hematocrit's supposed to go up with each unit of packed cells, how are you supposed to know whether the person's still bleeding? Hydration only lowers the hematocrit by 2 or 3 points, maybe 4. Based on body size, giving 2-3 liters of fluids can only make the hematocrit go down by 3 or 4 points tops. So if I give you 2 units and 4 units and your hematocrit stays the same, that's a big problem. It means you're still bleeding. Get scoped. Fresh frozen plasma is 150 mLs of plasma that we take out to make the packed cells. It replaces clotting factors, and you use it when there's an elevated prothrombin time, APTT, or INR. Most important, it is used when you're actively bleeding. We rarely use FFP if people are not bleeding because the clotting factors don't last forever. They last for a day or two. Some even last for hours. So if you have a person who's bleeding, who's got a coagulopathy from high PT, PTT, or INR, you need to use those fresh frozen plasma clotting factors to stop the bleeding. Fresh frozen plasma is also used as replacement with plasmapheresis, sometimes called plasma exchange. So FFP, though, doesn't give you hemophilia A or B factor. It doesn't give you factor 8 or factor 9. Hemophilia A factor is factor 8. Hemophilia B factor is factor 9. It doesn't work with von Willebrand's because those factors are not put into fresh frozen plasma. If you go to give a unit of blood, I can't give. You can't give. When you donate, you cannot donate factor 8, factor 9, and von Willebrand's factor. Why not? I'm giving you my blood. How come you can't take it? Because in a normal person, where is the factor 8 and 9? It's under the endothelial cells lining the blood vessels. So I can't donate factor 8 and 9 because it's stored underneath those endothelial cells. So therefore, you have to give people desmopressin for those factors to help them release their own, or give them recombinant versions of factor 8 and factor 9. Fresh frozen plasma is the standard for people who are having acute bleeding and an elevated PT-PTT, except for those with hemophilia or von Willebrand's. Cryoprecipitate is a pooled blood product. It's used to replace fibrinogen. It has some utility in disseminated intravascular coagulation in DIC. We rarely use it anymore, and it's never first for anything. It provides a high amount of clotting factor in a small volume. It won't collect factor 8, 9, or von Willebrand's factor because you can't donate it. It's like taking all the clotting factors in FFP and you scoop out almost all the clotting factors, like 50 or 60% of the clotting factors, but if you freeze it, it's like making butter. You can skim the clotting factors off in where you get 50% of the clotting factors in 10% of the volume, 50% of the clotting factors in 10% of the volume. And you never use it first for anything, and neither do you use whole blood for anything. Whole blood is absolutely never correct. 0 right answers. Whole blood is divided either into packed cells or FFP. So cryoprecipitate may never be used first, but if you have a person who's really bleeding out from DIC, we can use it if the FFP doesn't work. Whole blood, on the other hand, is easy for you as a question on step 2. It's easy because it's never right.
We will now move on to hot swollen joints, septic arthritis. Septic arthritis is an infection of any kind that finds its way into the joint space. It occurs because synovial lining has no basement membrane. It is relatively loose, and both bacteria and antibiotics easily find their way across it. Septic arthritis is rare in an undamaged joint, and the risk of infection is directly proportional to the degree of joint damage. Osteoarthritis provides a slight risk. Rheumatoid arthritis, slightly greater risk. The greatest risk is those with a prosthetic joint. Bacteremia can spread into the joint space. This is why patients with endocarditis and injection drug users can cause septic arthritis. The culprits for septic arthritis are as follows. Staphylococcus can be found in up to 40% of cultures, Streptococcus about 30% of the time, and gram-negative rods 20% of the time. A patient will present with a joint, any joint, that's warm, red, and immobile. It will often have a palpable effusion. The patients will complain of chills and fever because of the bacteremia that seeded the joint. The best initial and most accurate test is an arthrocentesis of the joint with a needle. X-ray, CT, and MRI are always the wrong answer and are never useful. The joint fluid aspiration is going to show a leukocytosis with more than 50 to 100,000 cells, predominantly neutrophils. The gram stain will have anywhere between 50% of the time positive for gram-negative bacilli and 75% of the time with staphylococcus. Synovial fluid culture has a sensitivity between 70 and 90%, and the blood cultures are 50% sensitive for the infectious agent that may have seeded the joint. Ceftriaxone and vancomycin are the best initial empiric antibiotic therapy for septic arthritis. Once you have your gram stain, you can then tailor your antibiotics appropriately. If they present to you with gram-negative bacilli, you have the option of treating with quinolones, aztreonam, cefotaxime, piperacillin, or aminoglycosides. If they tell you have gram-positive cocci that are sensitive, you can use oxacillin, cefazolin, or piperacillin with tazobactam. If they tell you have gram-positive cocci that are resistant, you're limited to linezolid, daptomycin, ceftaroline, or tigecycline. As with all antibiotic therapy, you must adjust your antibiotics to the culture results. If staph is sensitive, what's interesting is vancomycin is actually associated with a worse outcome than beta-lactam antibiotics, such as oxacillin or cefazolin. So switch drugs if the organism is sensitive. An infected prosthetic joint will give you a warm red and a mobile tender joint. But remember, without an X-ray or CT scan, you cannot tell whether this infection is limited to the joint space or has already spread into the bone around the implantation of the joint. Bottom line, you must do imaging. An MRI is difficult to perform with prosthetic joints because they're made of metal. If there is lucency around an implantation of the joint on radiologic imaging, or if the joint is physically loose, infection is likely present at the implantation site. It is much harder to clear or sterilize septic arthritis associated with the prosthetic joint without removing the actual joint. Therefore, the first step is to remove the joint, treat with antibiotics for 6 to 8 weeks, and then replace the joint. The most common organism for recently placed artificial joints is actually Staph epidermidis. We will now talk about gonococcal arthritis. For gonococcal arthritis, look for a history of STDs or a sexually active young person. The difference in presentation from septic arthritis, however, is polyarticular involvement or multiple joints. They will have tenosynovitis, which is inflammation of the tendon sheaths, making finger movement very painful. Lastly, they may describe a petechial rash. Keep in mind that gonococcal arthritis is more frequently during the menses. Detecting gonorrhea is much more difficult than detecting staphylococcus, streptococcus, or gram-negative bacilli that cause septic arthritis. When you aspirate a septic arthritic joint, remember the cell count is 50 to 100,000, but with gonococcus, it's only 30 to 50,000. The gram stain is 50 to 70% sensitive with septic arthritis, but only 25% sensitive with gonococcal arthritis. Now you can see why it's so difficult to diagnose. The culture is 90% sensitive of the aspirate in septic arthritis, but it's less than 50% sensitive with gonococcal arthritis. Blood cultures are 50% sensitive for septic arthritis, but less than 10 for gonococcal arthritis. Now you understand why it's so difficult to diagnose. So to reach maximum sensitivity, multiple diffuse sites must be cultured for gonorrhea, such as the pharynx, rectum, urethra, and cervix. How do you know to culture everywhere? If a patient has a rash, tenosynovitis, and polyarticular involvement, don't just culture one place, culture everywhere. Ceftriaxone, cefotaxime, or ceftazocime is the best empiric therapy for disseminated gonorrhea. Fluoroquinolones are not the best initial therapy because more than 5% are resistant. Use quinolones only if the organism is confirmed to be sensitive. If recurrent gonorrhea infection is described, test for complement deficiency. It's a favorite subject of the Usmle Step 2. We will now be discussing osteomyelitis. Osteomyelitis is an infection of the bone. Staph aureus is the most common cause, but any other organism can infect the bone. Children get osteomyelitis through hematogenous spread, but adults get it from a contiguous nearby infection, most often as a result of vascular insufficiency or diabetes. One thing to keep in mind, Salmonella is the most commonly identified organism in patients with sickle cell disease and osteomyelitis. The best initial test for osteomyelitis is an X-ray. The most accurate test is a biopsy. If they tell you the X-ray is normal, the most appropriate next step in your management is to get an MRI. CT scan is always the wrong answer. But what about the ESR? When is it the answer? It is the answer when you want to follow the response to therapy. So you get one at baseline, and then you measure it after antibiotics are initiated to see a response. Here's an example of osteomyelitis on a plain diagnostic film. Two questions that come up with osteomyelitis. The first is, when is culturing the drainage from the wound the answer? It's actually never. You can never reliably distinguish superficial colonization of the skin from whatever organism is inside the bone causing the infection. The second is when to get a bone scan. You only get a bone scan for osteomyelitis if you want to get an MRI, but it's contraindicated, such as in a patient with a pacemaker. Osteomyelitis takes weeks to progress. Therefore, obtain a biopsy and treat the organism that is found. Without a biopsy, it's impossible to know what organism is present and what is sensitive to. We don't want to subject the patient to too many antibiotics. Sensitive staph are best treated with oxacillin, cefazolin, nafcillin, or ceftriaxone. Resistant staph are treated with Vanc or linezolid. Gram-negative bacilli such as E. coli are treated with fluoroquinolones, such as ciprofloxacin, but it's essential to confirm the sensitivity of the organism prior to treating with Cipro. Why is this? It is the only oral therapy for osteomyelitis, but should only be used if the organism is confirmed as a sensitive gram-negative bacillus. We don't want to engender resistance. Fluoroquinolones can cause Achilles tendon rupture from interference with the growth of chondrocytes. They are also contraindicated in pregnancy and in children because they interfere with bone growth. Ladies and gentlemen, that is the end of rheumatology. I hope you've enjoyed our lecture so far in the Step 2 High Yield series. I'll see you next time.
Hi, I'm Conrad Fisher, and welcome to Dermatology. I'm an Associate Professor of Medicine, Physiology, and Pharmacology at Touro College of Medicine. We'll be covering cutaneous malignancies, atopic dermatitis, also known as eczema, psoriasis, pityriasis rosea, and seborrheic dermatitis, which in common parlance is called dandruff, and blistering diseases, which is bullous pemphigoid and pemphigus vulgaris. Cutaneous malignancies are certainly more common. They are certainly greater with pale skin and in more sun-exposed areas. The diagnosis of all cutaneous malignancies is a biopsy. There is no substitute for biopsy. There is no blood test for any of them, not for melanoma, not for squamous cell, not for basal cell, and not for Kaposi's sarcoma. The treatment for almost all of them, with the exception of Kaposi's sarcoma, is surgical removal. There's very limited chemotherapy, and it would never be a substitute for the surgical removal of the disease. And there is no truly effective chemotherapy. We use interferon for melanomas, and virtually nothing for squamous cell or basal cell. For skin cancer, more sun means more cancer, period. It's carcinogenic. Biopsy is the only way to make the diagnosis, and you got to remove it. Malignant melanoma is certainly more frequent in sun-exposed areas, but it is not exclusive to those areas. It's the most extraordinary thing. Why is it that it can also grow in the areas that are under cover? Why is it that it can grow in the back of the eye or under the nail folds? Well, our most important issue for skin cancer is simply for you to be able to tell the qualities of a benign versus a malignant lesion. Melanoma is clinically defined as an asymmetrical lesion, one that has an irregular border, irregular colors, irregular diameter, and expanding evolution and changing over time. Look, ladies and gentlemen, this is Step 2 exam. For dermatology, if you could basically tell what needs to be biopsied, you're good, okay? That's what you need to be able to tell. No one expects you to be able to understand complex things. You're expected at your level to be able to know basically which lesions can be left alone and which lesions have to be biopsied, and not to do a shave biopsy and a melanoma. That's it. How do we diagnose malignant melanoma? What's suspicious? Biopsy!
And you got to include the entire thickness of the lesion, if at all possible, because the worst prognosis is growing lesions, but we don't just mean growing side to side. We mean growing in terms of total depth, top to bottom. And you could have something that's raised just a millimeter above the skin, but it's going deep under the skin. That's why you can't shave it. You've got to do the entire thickness. If you have a lesion that's very thin, it's not going to have metastasized. Basically, if you had a melanoma, the first question out of your mouth should be, how thick was that thing? Because honestly, if it's more than a millimeter or two thick, you've got a very high likelihood of it going to your local lymph nodes, and it's very bad. So benign lesions are round, whereas malignant lesions are asymmetric. Benign lesions have even borders, and malignant lesions have uneven borders. Benign lesions have an even color throughout the entire lesion. Even borders, even color. Malignant lesions they could be darker in one part, lighter in another part, really dark in one part. And benign lesions simply don't grow, whereas a malignant lesion, the diameter increases over time. This is a perfect example of a benign lesion. It's got an even color, even borders, and it's quite symmetrical. The diagnostic test for melanoma is a full thickness biopsy. This is absolutely indispensable. Do not shave that lesion because it has a huge implication for whether you need prophylactic radiation, chemotherapy, and simply prognosis. The treatment is surgical removal, and you've got to include normal skin surrounding the lesion. Now, because it's a step 2 exam, no one expects you to know exactly how much. The bigger the lesion, the greater the size of the border of normal skin. Interferon injection is helpful in widespread disease. That's because melanoma is an immunologically active lesion, and therefore a lesion which would otherwise be considered to be cancer, here in this case can get an immunologically active manipulation like interferon. Melanoma has a strong tendency to metastasize to the brain, and although melanoma is about only 1% to 2% of all cancer deaths in the United States, it's the number 4 lesion to go into the brain. Squamous cell cancer is straight on ahead sunlight, and this is the most frequently tested thing. There's an enormously greater incidence in organ transplantation. It is not so much the organ transplant, but the immunosuppressive drugs. Now, it might be a little artificial to break that up as to whether it's a transplant or immunosuppressive drugs. But if you were asked, and I have seen questions like this, immunosuppressive drugs is the correct answer. You see, we have cancer cells arising in us all the time. And there's immune surveillance. The immune system is like police, really. They're to pick up criminals, and the cancer cells are like the criminals. And basically, immunosuppressive drugs make the surveillance of those small individual cancer cells ineffective, and they are allowed to grow, just like a criminal in the system. Squamous cell starts looking like an ulcer. It just doesn't heal, it keeps growing. You have to biopsy and remove. Squamous cell starts out as an ulcer, but you also notice that it's on a very sun-exposed area, and the baseline color of the patient's skin is extremely pale. It'll also describe people who are outdoors a lot, people who work on roofs, people who are house painters, people who work outside, people who spend a lot of time on boats outside, Australians. None of these skin lesions are as common as this cause of skin cancer as basal cell carcinoma. Well, that's the good news, actually, because it's very benign compared to the others and takes a very, very long time to go anywhere. The question is going to describe something as waxy. Now, that waxy is because it's not ulcerated and not hyperpigmented. It'll be shiny like a pearl for the same reason. Unlike melanoma, wide margins are not necessary because the metastatic potential into local skin or elsewhere into lymph nodes is extremely small. A shave biopsy is fine in this case. It's diagnostic because since it's so rarely metastasized and since there is no chemotherapy, we don't have the same considerations of chemotherapy and knowing whether it's going to go metastatically into the local lymph nodes. The recurrence rate is much less than 5%, and basal cell use Mbbs microsurgery, a very interesting thing, mostly to prevent deformity. There's a basal cell carcinoma. Well, if you look at it, you wouldn't really know now, would you? You wouldn't know until you'd taken a biopsy. And that's the whole point. A pale gentleman, sun-exposed areas, not hyperpigmented, waxy, and shiny like a pearl. Mohs microsurgery is basically a dissecting microscope. You remove the skin cancer under a dissecting microscope, but the most important thing is look at the lesions. It was on the person's nose. This is very thin slices of skin removed. Basically, when you have a lesion that's on a face in a sun-exposed area there, an extra couple of millimeters makes a huge difference in terms of the cosmetic appearance. You do an immediate frozen section as you make thin little slices because you will cut just to the point where you know you've removed the cancer, and you'll stop cutting as soon as you hit normal tissue. So this is an extremely precise way to treat skin cancer. Mohs will remove the cancer and keep the normal skin intact. And that's because you can stop resecting when the margin is cancer-free. There's no need to remove wide margins, and Mohs is best in the delicate areas around the eyelid and around the ear. The ear is especially problematic. We just don't have a good way to grow cartilage. If you have to remove something around the ear, you can't fold the cartilage, you can't pull it, there's no stretch in cartilage, and there's virtually no vascular supply to it. So it's a very difficult area to manipulate. Kaposi sarcoma, or KS, is very interesting because in the past, KS was seen only in older men of Mediterranean origin. It was felt to be a very slow, non-pathologic, non-pathogenic, not growing very fast lesion in the legs of old guys who hung out on the beach in Sicily for 25 years. And then all of a sudden it shows up in AIDS in the 1980s. And we know then it took a long time, but to find out that it was from human herpes virus 8, HHV8, which is an oncogenic virus. And that's one of the characteristics of HIV. HIV unlocks the Epstein-Barr virus, then you get lymphoma. It unlocks the papillomavirus, then you get cervical cancer or anal cancer. It unlocks oncogenic viruses to give more cancer. And that's why lymphoma and cervical dysplasia are AIDS-defining diagnoses. Now, it's reddish-purplish, which we'll show in a second. It's more vascular than the others. That's why it is reddish-purplish. And generally speaking, we don't biopsy it because it's more vascular and tends to bleed. So what's different about Kaposi sarcoma is that we diagnose it by how it looks. This is true both on the skin and when we see it in structures such as the bronchial tree or when it's in the gastrointestinal tract. And the reason we don't biopsy it is because it bleeds. And bleeding in the bronchial tree is especially problematic because it obviously is like drowning a little way. So Kaposi sarcoma will be these reddish-purplish lesions in a person with HIV, and that's all you have to do as a diagnosis. Because it's also in the GI tract and the lung, it's also in HIV via sexual contact that's associated with Kaposi sarcoma. And when it's in the GI tract, you see it on endoscopy, and it's its visual appearance. It looks just like it does on the skin, but inside your lung and inside your guts. Injection drug use AIDS is rarely associated with Kaposi sarcoma. Now, we knew for the first 15 years of the HIV epidemic that it followed the epidemiologic patterns of a sexually transmitted disease. But it wasn't until little bits of genetic elements of human herpes virus 8 were identified by PCR technology that it finally took 15 years of straight experimentation to be able to finally say, it's an STD. Unlike other skin cancers, KS is not routinely removed surgically. You treat the AIDS with antiretrovirals, and the majority will disappear as the CD4 improves. It is so dramatic that you rarely need intralesional injections of vincristine or interferon, and a few people fail to resolve by raising the T-cell count. We use chemotherapy with liposomal doxorubicin. When you want to protect people from the adverse effects of chemotherapy, you encase it in a liposome, and this basically simply reduces the toxicity. You can be covered from head to toe with KS lesions and have zero T cells, give up your kids for adoption and be DNR in a nursing home weighing 75 pounds. Go on antiretrovirals, and within 2 weeks to 6 weeks, you will get up, tear up your DNR,
take your kids back and walk out of the nursing home. Actinic keratosis is premalignant. It's like cervical dysplasia. It's from high-intensity sun exposure in fair-skinned people, and there's a very small risk of squamous cell cancer in each individual lesion, but if you can consider that people might have 100 of these lesions, even though it might have only a 2 or 3% chance per lesion, it means that if you have hundreds of them, you're going to get squamous cell over time. Actinic is a sun ray. The word keratosis doesn't mean anything bad. I mean, seborrheic keratosis goes on to nothing. That's basically just the skin lesion's benign liver spot. So it's not the word keratosis that's bad. It's the actinic part that's bad. Well, this you would not pick up as a actinic keratosis unless you biopsied, and that's the whole point. Fair-skinned person, sun-exposed area, and you'd have to take a little sample of it, in much the same way that you'd have to do a pap smear. You couldn't tell by looking at the cervix it was premalignant or had dysplasia. You'd have to take a scraping. Here's a close-up of the same lesion, same principle. Scrape it, biopsy it, take a sample to see if it's premalignant. And if it is, remove it. Finally, remember that many of these occur in a single person. The risk is cumulative. The more you got, the more risk you have. And like cervical dysplasia and cervical cancer, it is slow to progress. And you can remove them with curettage, cryotherapy, or liquid nitrogen, laser, topical 5-FU, or imiquimod. Imiquimod is a local immunostimulant that basically tells your T cells that the cells on the surface are foreign. It makes your own T cells slough them off. This is the same treatment as you could use for a person with molluscum contagiosum or venereal warts, condyloma acuminatum. It is self-administered, it never burns, and doesn't go too far. It's like vitamins for T cells. Seborrheic keratosis, the very word seborrheic means benign. It's very common in the elderly. They're hyperpigmented lesions. They can be called liver spots. They just appear stuck on, and they look like melanoma, but the key issue is they're not melanoma. They have zero malignant potential, and they are here so that you don't biopsy them. Don't remove them unless it's for cosmetic reasons. Now, when you do want to remove them, you remove them by using the same sorts of cryotherapy with liquid nitrogen and the same sorts of surgery and laser, and only for cosmetic reasons. You just don't like the way they look, but you don't have to remove them because they're going to go on to cancer or metastasize. They never go on to cancer or metastasize. But here they can look bad, can't they? Well, if this was melanoma, this person would be dead a long time ago. If you had melanoma this widespread, that would be metastatic. This would be a picture of a cadaver. Well, this is so common, they start off as tiny and they just grow over time. It depends what people like. You can leave it alone or you can just cover them up. But you don't have to do it because of medical reasons. They never go into the lymph nodes, ever. Atopic dermatitis is incredibly common skin disorder. It's kind of like a seizure disorder of your T cells, and it's associated with overactivity of mast cells in the immune system. And you look for a history of people who have asthma and allergic rhinitis and a family history of atopic disorders. In other words, allergies are associated with this. Allergies in families and allergies in skin. And it's very rare to start over the age of 30. It starts in kids, very uncomfortable for them. And the same way it would be very rare for somebody to start being asthmatic when they're 50. It's a seizure of those mast cells. In the same way, we don't call it atopic dermatitis if you eat chocolate and you're allergic to chocolate and you release some of the mast cells and you have histamine. This is from unprovoked release of histamine. Premature and idiosyncratic release of transmitters like histamine, and that means it's not from an allergic reaction. Now you itch like it's an allergic reaction. You itch, you scratch, and that scratching leads to scaling rough areas of thickened skin, especially on the face, neck, and skin folds, and behind the back of your knee, and it's uncomfortable. And the problem is the more you itch, the more you scratch, the more you scratch, the more you itch. That's why this image is just of what happens when somebody scratch, makes the skin thick, scratch, breaks it down, scratch, and you drive Staphylococcus under your skin, which makes you itch and scratch some more. This could be elbows, in which case this is, or backs of knees. The skin folds are just where you itch and scratch an awful lot. It's very uncomfortable. Got to cut those fingernails down and make sure you don't use too much hot water or soap or you itch and scratch some more. So when you itch and you're uncomfortable, you scratch. When you scratch, it irritates the skin and the mast cells, which release more histamine and make you have more itching. Then the superficial skin infections from Staphylococcus happen as you drive those antigens and drive the bacteria under your skin with your own fingernails. And as the microorganisms are driven under the epidermis by the scratching, this in turn makes more itching, and the skin gets thickened because of the scratching and the drying, and that is termed lichenified. The CH here is pronounced like a K, lichenified. And this is just not a food allergy. It's not. This is not like I'm allergic to peanuts. It's not. It just happens. It's a seizure disorder. If you have a brain tumor and you seize, that's not epilepsy. That's having a brain tumor. The key here is to stay moisturized so your dry skin doesn't remain as itchy. Stay moisturized. Dry skin is more itchy. Use a humidifier, especially in winter, because dry skin is more itchy. Now I feel like I work on the first floor of a department store here where I want to have you buy soaps and cleansers and various lubricants and avoid bathing too much. Stay a little dirty. Harsh soaps and anything that irritates your skin, makes you itch and scratch some more, like brushes or washcloths, hot water, anything that rubs on the skin. And cotton is less irritating than wool. Wool is simply much more irritating to all skin. Yeah, you had to go to medical school to learn that, right? Don't wear wool. It makes your skin irritated. IgE levels are elevated in atopic dermatitis, but we're not doing that as a clinical test. Here we go. Back to the doctor part. Topical corticosteroids are used in flares of disease, and we really try and avoid oral steroids. Oral steroids are only in the most severe acute flares. Now, tacrolimus and pimecrolimus, sirolimus, these medications are T-cell inhibitors. They're useful in organ transplant patients, in bone marrow transplant patients, longer-term control, and we can use them topically to help stop the need for steroids. And we want to get you off of steroids because steroids cause atrophy. They cause atrophy of skin. And they're used systemically in the organ transplant patients for the same reason, to get them off of steroids and to prevent the organ rejection, but topically for atopic dermatitis. The antihistamines of atopic dermatitis are newer non-sedating medications like cetirizine, fexofenadine, loratadine, which some of you may know as Zyrtec, Allegra, and Claritin. They're all the same. They're identical. Anyone who says something different is selling something. Severe disease is hydroxydine and diphenhydramine and doxepin because those drugs are far more sedating. Remember, diphenhydramine is so sedating. It's sold as a sleeping aid. But if you have very severe disease, you might have to use it. Antibiotics, orally we have cephalexin, known as Keflex, mupirocin, vertepamulin. That is something that be new for people. And that's basically an improved version of bacitracin. And these medications are used when impetigo occurs to try and stop you from itching and scratching. Ultraviolet light, which is phototherapy, also works for recalcitrant disease, the same as it would for psoriasis. Psoriasis is an incredibly common disorder. 2 million people in the United States. Wow. Silvery, scaly plaques. Not itching most of the time because it's a superficial. It's on top of where you'd have the immune system. It's in the epidermis more. It's actually not as much a lymphocytic release of histamine problem like atopic dermatitis is. Psoriatic arthritis with nail pitting is only in about 10% of patients. And you can have psoriatic arthritis with only a small amount of psoriasis. It's not like you get a ton of psoriasis and then you get the arthritis. You can have the psoriatic arthritis with a small amount of it. And extensive disease, though, is associated with depression just because people's life is miserable. Who wants to walk around with that stuff? Psoriasis has extensive silvery scales. When you have someone with lesions as widespread as this, you can't cover them with topicals. This is a person who needs ultraviolet light or tumor necrosis factor inhibitor, TNF inhibitor, or methotrexate rarely. But this is too extensive for a person to use just topicals. Psoriasis treatment is by far the most complicated of all treatments in all of dermatology because you have to start out with a lot of steps. Localized disease is treated with topicals. Psoriatic disease is never treated with oral steroids. It's just not. Topical high-potency steroids like fluocinolone, triamcinolone, betamethasone, clobetasol. But like steroids anywhere, they become complicated from adverse effects. They atrophy the skin. They take skin and they melt it, and they turn the amino acids of collagen into sugar. So to get you off of steroids, we use vitamin A and vitamin D ointments to help get the patients off of steroids. The vitamin D agent is calcipotriene, like vitamin D3, tri-3-ene, calcipotriene. And steroids cause skin atrophy. Coal tars are a very difficult thing to take because how do they look? Really covering yourself in oil is not too pleasant. Pimecrolimus and tacrolimus are not as strong, but they can be used in delicate areas of the face and the penis. They're an alternative to steroids, and they're certainly less deforming than steroids and less messy than a coal tar. Steroids cause atrophy. They stop collagen growth and formation and convert it through gluconeogenesis, convert the amino acids into glucose. You can't use topical steroids forever. It'll harm the skin. You can't use topicals for disease spread up and down and all around the body. Ultraviolet light. You can select out the version of it that controls disease without the version that causes skin cancer. However, TNF inhibitors are what you're going to use if the UV light doesn't control your disease. Etanercept, adalimumab, infliximab. Yes, these drugs actually are pronounced that way and spelled that way. Yes, they're correct. And yes, you got to learn them. They are a miracle. They shut it down, and they're not as toxic as methotrexate. Methotrexate is after those. You'd only use methotrexate if the TNF inhibitors failed because methotrexate causes liver and lung fibrosis. Liver and lung fibrosis for methotrexate. But you'd have to use them on psoriatic arthritis, the methotrexate for psoriatic arthritis, because you can't use light for joint involvement. Well, here's a nice frequent question that you'll be asked and you'll know. TNF inhibitors, adalimumab, infliximab, etanercept, can reactivate tuberculosis. You screen with a PPD, no big deal. Your PPD is positive, just take the INH and start your drug. Pityriasis rosea is problematic only in the sense that it looks like syphilis. It's an idiopathic transient dermatitis. It starts with a single lesion, a herald patch, then disseminates out through the rest of the body. It looks like secondary syphilis, but definitely spares the palms and the soles. It's transient, and some people, because it itches a lot, you can use steroids or UV light. The biggest issue with pityriasis rosea for you is unquestionably the diagnosis. Looks like secondary syphilis, excludes secondary syphilis because it's not on the palms and soles, and the VDRL and RPR is negative. Now, pityriasis rosea, here's a picture of it. Woo, look at this. Disseminates around, flat, reddish-brown lesions. And the good news is that it doesn't go anywhere, it doesn't do anything. It will always resolve. Seborrheic dermatitis is a hypersensitive reaction to a fungus in the skin. It is a dermatophyte that causes a kind of a oversecretion of sebum, makes the lesions look oily and greasy. It's dandruff. And because it's a hypersensitivity to a fungus, that's why you can use both antifungals and steroids. That's why you can use both topical steroids and antifungal agents like ketoconazole are useful. And this is one of the only places you do use ketoconazole, because we don't use ketoconazole systemically too much because it causes liver toxicity because ketoconazole is profoundly anti-androgenic. Seborrheic dermatitis occurs more frequently in HIV and Parkinson's disease and in the elderly, and the very word seborrheic, which means flow of sebum, equals benign. Pemphigus vulgaris is a type of idiopathic autoimmune, and there is a form that's drug-induced. And it can be associated with ACE inhibitors and penicillamine, phenobarbital, penicillin. Well, in many of the same ways, that's what causes allergic interstitial nephritis. Penicillin, sulfa drugs, allopurinol, phenytoin, and you make an allergic reaction against your skin. Well, you might say, well, isn't this very similar to the types of drugs that might also cause Stevens-Johnson? Yes, but the reaction is markedly different. Pemphigus vulgaris is from autoantibodies that split the epidermis. Now, this may sound like no big thing to you, but this is exactly why it is that Pemphigus vulgaris is so dangerous. Splitting a very thin structure like epidermis results in bulli that easily rupture. They're just too thin. They're thin-walled. And they involve the mouth. And because they involve the mouth, and because they're thin-walled, and because they break off, you lose a lot of fluids and you get infected. And that's why, widespread, they act like a burn. And that's why untreated, Pemphigus vulgaris has a 40 to 60% mortality. Wow. Here's a picture of this in the mouth. And remember, bullous pemphigoid does not go into the mouth. It's a photomicrograph of the splitting of the epidermis. That's why that big open thing on the top that looks like a dome is the splitting of the epidermis. See how tiny that is? See how thin, how fragile? Of course it breaks off, and you get infection and fluid loss. Nikolsky's sign means that you can remove skin, which is the finger's worth of pressure. That's the characteristic finding of Pemphigus vulgaris, or any disease in which there's such tremendous loss of skin that just touching the skin pulls the skin off and you denude the skin from mild pressure. This Nikolsky's sign is something that means that the person could die without treatment, because it's removal of superficial layers of the skin in a whole sheet while pulling on it with just a tiny bit finger's worth of pressure. Well, welcome to dermatology, the most accurate test of biopsy for almost everything. And so it is with the blistering disease as well. The biopsy will show autoantibodies on immunofluorescence studies that show the splitting of the epidermis. And without treatment, pemphigus is incredibly fatal. You die of an infection. Steroids are life-saving. Systemic steroids, like prednisone, are life-saving. Azathioprine or mycophenolate are used to keep people off of steroids, as they also are in many immune diseases, such as glomerulonephritis or lupus nephritis. Rituximab, which is a monoclonal antibody against CD20 cells, removes the lymphocytes that make autoantibodies. They're anti-CD20 cells, so they're anti the cells that make the antibodies, or intravenous immunoglobulin in refractory cases that just don't get better. Bullous pemphigoid is like pemphigus. That's what the word means. Like pemphigus, pemphigoid. Like the difference between erysipelas and erysipeloid, or leukemia or leukemoid reaction. Similar to. It's similar to pemphigus in that it's a bullous disease, but the bulli stay intact, and they stay intact because they're thicker, and there's less loss of fluid, less infection, and less mouth involvement, and all this is related to the top thing, which is the bulli stay intact. You can't get infected if you're covered with skin. The best covering for skin is skin. And here's a picture of intact bulli. Bullous pemphigoid, biopsy, steroids. In bullous pemphigoid, biopsy with immunofluorescence stains is definitely the most accurate test. The best initial therapy is prednisone, and to get patients off of steroids, because in the long term, even after a few weeks, steroids can be very deforming, have many adverse effects. We have to use azathioprine, cyclophosphamide, or mycophenolate to get them off of steroids.
Mild bullous pemphigoid responds to erythromycin, dapsone, strangely nicotinamide, not niacin. Remember, Nikolsky sign is absent in bullous pemphigoid. The lesions stay intact. Nikolsky sign specifically implies a lesion that is so large and so extensive that only the slightest pressure will completely denude the skin.
Other blistering skin disease, such as porphyria cutanea tarda, happens because sun-exposed areas release an abnormal reaction to porphyrins. This is an abnormal porphyrin metabolism problem. So in sun-exposed areas, the sun hits those porphyrins, causes a very bad blistering skin disease. Now, it's more common in people with a history of liver disease and cirrhosis and hepatitis C, alcoholic destruction of liver. Well, now we're just listing things that cause liver damage. Ooh, but this is unique. Estrogen use. Why? I don't know. It's an idiopathic disorder. Iron overload, for sure. Hemochromatosis and iron overload are associated with porphyria cutanea tarda. The most frequently asked of these associations is hepatitis C. It's not that the others don't do it, it's just hepatitis C is the most frequently asked. Hepatitis C is just a favorite question for porphyria cutanea tarda. They could be asking about the other ones, but it's just popular because you can fix and eradicate the hepatitis C with interferon, ribavirin, and either boceprevir or telaprevir, so you can eradicate it, you can treat it. Look for involvement in the back of the hands and face, simply because those are the most sun-exposed areas in the body. The most accurate test for porphyria cutanea tarda is uroporphyrins on the 24-hour urine. After all, it's a problem with porphyrin metabolism, and they go into the urine. So a deficiency of uroporphyrin decarboxylase activity is what causes this. So the porphyrins just build up in the urine. The treatment is based on stopping the estrogen, stopping the alcohol, stop the cause, stop the estrogens, and remove iron with phlebotomy, and certainly treat the hepatitis C.
Leukemia, acute leukemia, chronic myelogenous leukemia, the leukostasis reaction, which is sledging. Myelodysplastic syndromes want to become acute leukemia. Chronic lymphocytic leukemia doesn't get treated in the majority of cases, and hairy cell leukemia. For acute leukemia, you can look for a history of myelodysplasia and signs of pancytopenia, such as fatigue, infection, and bleeding. Now, the signs of infection happen even if the white cell count is normal or even increased, and that's because infection is a common presentation because leukemic cells, blasts, just don't function normally. The white cell count can be up, down, or normal, but they always present as if the white countation, so you can't construct a question about things that are all the same. This is the only one that's different and unique. The best initial test of acute leukemia is the blood smear, because on the blood smear you see blasts. Blasts are never a normal variant, ever. Blasts are never to be considered a normal variant. People don't harbor asymptomatically blasts. The most accurate test is to sort out the cells, to see what you've got in there with flow cytometry. Cell sorting. It distinguishes between the different subtypes of acute leukemia. It distinguishes the specific CD subtypes with each type of leukemia. Older tests like myeloperoxidase are characteristic of acute myelogenous leukemia, but it's not as specific as sorting it by cell surface subtype, like CD receptors. The Auer rod is an eosinophilic inclusion body characteristic exclusively of acute myelocytic leukemia. It is most often in the APL. Now, this Auer rod, although it may not be as useful as flow cytometry, is a very common question on step 2. Both forms of acute leukemia, AML and ALL, are treated initially with chemotherapy. The goal of this is to go into remission. Well, what does remission mean? It means you remove blasts from the peripheral blood smear. That's what inducing a remission is. Now, when you induce a remission, the question is, are you going to stay in remission? See, we don't know for sure whether chemotherapy alone will keep the leukemia away or whether it will come back. Ultimately, only 30 to 40% of patients with acute leukemia are controlled just with chemotherapy. So the question is, should you proceed to bone marrow transplant after remission or just continue with more chemotherapy?
Now, the reason why this is important is that bone marrow transplant is an extremely dangerous procedure. Even in a healthy person, it will kill 10 to 15%. In an older person, above 40, 50, 55 years old, it can have a mortality of 20 and 30%. So would you subject yourself to a bone marrow transplant if you went into acute remission? If you went into remission, would you go for bone marrow transplant or wait for more chemo? The answer to that is if your prognosis is poor. In other words, hey man, you're going to recur. It's going to come back. You should go straight to bone marrow transplant. If your prognosis is good, meaning, oh, you're not going to come back, yours isn't going to come back, you got a 95% chance that it's going to stay in remission, well, then just keep chemotherapy. Now, you might say, why not just wait for it to relapse? Well, there's a very good reason for that. Relapsing acute leukemia is extremely difficult to control. It's very hard to beat it back under control. So that's why once you get it into remission, you've got to decide. And how do you decide? The answer is cytogenetics. That's why the answer to the question, which of the following is the best indicator of prognosis in acute leukemia, is cytogenetics. Cytogenetics, kind of like an individual assessment of chromosomal characteristics found in each patient. In a way, it's like a fingerprint of your own individual characteristics. In other words, you could have 3 people with acute myelogenous leukemia. One might have chromosomal abnormalities that indicate a 5% chance of recurrence, another 50%, another 70%. That's why you use cytogenetics to say, hey, good cytogenetics, less chance of relapse, just give more chemotherapy. Oh, I'm sorry, sir. Your genetic testing shows that you have a very high chance of your cancer recurring. I think we really need to transplant you right now. When is all trans retinoic acid ATRA the answer? It is for M3 acute promyelocytic leukemia. ATRA is basically a derivative of the same stuff we use for acne. Cis retinoic acid is what we use on top of pimples on acne. Trans retinoic acid takes, and this is a miracle, it takes promyelocytic leukemia, which is the most fatal form of cancer in all of humanity. It is a disease where 90% of people are dead within 6 weeks, and transform it into the most curable form of leukemia. It's amazing. M3 promyelocytic leukemia is a disorder that if you don't treat them on the first day you meet them, once the diagnosis is made, people start to bleed to death on the very first day. You've got to treat them immediately. The other question is about intrathecal chemotherapy, such as methotrexate in acute lymphocytic leukemia, ALL patients, acute lymphocytic leukemia. It prevents the relapse of ALL in the central nervous system. This is superior to using cranial radiation. It's superior to radiating the spine and the brain because the radiation of the spine and the brain results in growth abnormalities. Now you've got to sterilize the CSF of leukemia or it will recur there. The most tested facts for acute leukemia are M3 promyelocytic leukemia gives DIC, M3 DIC, all trans retinoic acid for M3 and ARRAS and AML, and intrathecal methotrexate for ALL. Next disorder is chronic myelogenous leukemia, CML. CML presents with a high white cell count that's all neutrophils, and those neutrophils look normal on a smear. There are no blasts on the smear in CML. The blood cells are part of acute leukemia, not chronic leukemia. Now, this is very important because there really is no single diagnostic characteristic on physical or history that will tell you it's CML. A big spleen or fatigue, night sweats, and fever are simply not specific enough to allow you to answer what's the most likely diagnosis as CML. It's rather vague. Big spleen is certainly not specific. Early satiety is because the spleen is right next to the stomach. It actually presses on the stomach. So a large spleen, that's because it's like autism. You can't tell. You have to look at function. You can't tell by looking. There's no ultra-structural abnormality. When you have a person presenting with a high white count, it's very unusual for it to be CML. Not even 1% of high white counts in a hospital are CML. So how do you determine if it's a reaction to another infection, such as stress or leukemoid reaction or leukemia? CML rarely gives a small number of blasts and should be under 5%. The basophils are increased, but that by itself is not sufficient. If the leukocyte alkaline phosphatase score, the LAP score, is a choice, then this is first. Leukemic cells don't have normal amounts of alkaline phosphatase. Alkaline phosphatase is a characteristic of normal cells. Normal cells have alkaline phosphatase, and therefore, if your white count is up as a reaction to another infection, you'll have a high alkaline phosphatase score. Now, leukemic cells don't have a normal amount of alkaline phosphatase score, and the LAP score is low in CML. If the LAP score is not a choice, or the question says, what is the most accurate test, then the answer is BCR-ABL. BCR-ABL can be done by PCR on peripheral blood. The BCR-ABL is the Philadelphia chromosome. The BCR-ABL is the right term for the 922 translocation. It is clearly superior to the LAP score because it is clearly the most accurate test of CML. Now, in the past, we used to have to do a BCR-ABL on the bone marrow. And that made LAP scores more useful because it determined who you would do a bone marrow on. But since we now have PCR and peripheral blood, if BCR-ABL is in the answer, that's the right test to do, BCR-ABL. The best initial therapy for CML is imatinib, the tyrosine kinase inhibitors. Imatinib, dasatinib, nilotinib, they're the best initial therapy. CML is the greatest likelihood, however, of all the myeloproliferative disorders to transform into acute leukemia, about 20% of the year. Imatinib and the tyrosine kinase inhibitors stop that. They really do. They take a disorder, CML, that was almost 100% fatal at 5 years and make it almost 100% survivable at 5 years. Wow. So the question says, initial therapy, it's imatinib, dasatinib, nilotinib. If the question says, what cures it, only bone marrow transplant will cure CML. However, bone marrow transplant is never the first therapy. It is the cure, but it's not first, and we generally don't use it anymore. CML is a routine miracle where we use imatinib to stop the disorder. It may not cure it, but it controls it in most everybody. A 54-year-old man with shortness of breath, blurry vision, confusion, priapism. Its white cell count is extremely high, 224,000, 225,000. Wow. Remember, normal white cell count is under 10,000, 4 to 10,000. Now, this is predominantly neutrophils with a small number of blasts. What's the next step in the management of this patient? Well, this person's symptomatic. They're short of breath. They have blurry vision. They're confused. The initial therapy for controlling the white count is leukapheresis. What this is a person who has sludging from white cells. This, in a way, looks like polycythemia vera because that also is sludging. There's sludging from extremely high white cells over 100,000. It's extraordinarily rare to have this under a white count of 100,000. It's almost impossible in CLL because lymphocytes are very small. So it happens when acute myelogenous leukemia because blasts are big, and CML when the count goes up very high. Now, BCR-ABL is the most accurate, and bone marrow biopsy can be used sometimes. Transplant is done as a cure. Consulting people is never the right answer in step 2. But leukostasis reaction is an emergency, a hematologic emergency, and it is important to remove excessive white cells in the blood, then establish a specific diagnosis later. No matter what the etiology, take the white cells off. With a plasmapheresis machine, you simply put it in a centrifuge and you can convert it to taking off the white cells. So it's like plasmapheresis. Matter of fact, you can use the same machine, but you take off white cells, so it becomes the leukapheresis. Hydroxyurea does help and will help lower the cell count, but not as rapidly as leukapheresis. Myelodysplastic syndrome, or MDS, is a pre-leukemic disorder. It's extremely uncommon under the age of 60. It presents with pancytopenia despite the fact that the bone marrow is working overtime. The cells are made a lot. There's a hypercellular bone marrow, but they get destroyed easily. The cells are defective. They break. It's like buying TVs that just don't work. They make a lot of them, and then they're broken right away. Now, most never develop AML. A small number can, and it is pre-leukemic, but most never make it there. Well, that's not unusual in terms of pre-leukemic syndromes. I mean, most people with cervical dysplasia don't develop cervical cancer. Infection and bleeding is the answer to which of the following is the most common cause of death in myelodysplastic syndrome. There is a very important genetic defect called a 5q deletion. This is the most characteristic abnormality of MDS, and patients with 5Q actually have a better prognosis than those who do without it. And that's because there's more to block. But MDS, older person, hypercellular, some go on to AML, most bleed and die of infection before they get there. Because the CBC is such a common test, MDS can present as an asymptomatic pancytopenia on a CBC in an older person done for some other reason. When symptoms occur, the symptoms are, I feel tired because I'm anemic and weight loss. I have infection because my white cells don't work like normal. And I bleed because the platelets can be low in number and low in function. And sometimes there's a big spleen, extramedullary hematopoiesis. There is no single pathognomonic finding in the history or physical. There's no single presentation that says, oh, that's MDS. It's pancytopenia, macrocytosis, normal B12 and folate level in an older person. Let's summarize those findings again. The CBC shows anemia. There's a macrocytosis. Well, there's a stressed marrow, so there's nucleated red cells. Remember, nucleated red cells go out early. They're like cells that should have waited in the marrow till they became reticulocytes, but they leave early because the marrow is stressed. There's a small number of blasts. The marrow is hypercellular. And there's ring sideroblasts. Ring sideroblasts is iron built up inside the red cell in the mitochondria. The severity of disease is based on, well, do you have 1%, 5%, 10% blasts? Now, there is a characteristic cell, a bilobed nucleated cell, bilobe nucleus. It's not a band. A band is not two lobes. And this is the Pelger-Hewitt cell. And this is distinct. This is the single most distinct lab abnormality in myelodysplastic syndrome, the Pelger-Hewitt cell. But there's much more of a presentation as a whole, saying older person, pancytopenia, but a high MCV. Yeah, you know what? The B12 and folate level is low. If there's a Prussian blue showing ring sideroblasts, or there's a few number of blasts, that will help you establish the diagnosis. The best initial therapy is to transfuse those blood products as needed. You give red cells most of the time. We don't transfuse white cells because they don't work. We use erythropoietin, although 80% of people don't respond, but you try it and see who does respond. Lenalidomide, especially for those with the 5q deletion. Lenalidomide, which is a derivative of thalidomide, a TNF inhibitor. Lenalidomide decreases the need for transfusions. Very important. Azacitidine is another chemotherapeutic agent that decreases transfusion dependence, but unfortunately it doesn't increase survival. It's hard to find a drug that increases survival in myelodysplastic syndrome, and lenalidomide is a fantastic, terrific thing because it's melphalan substitute in myeloma. So it's in myeloma as a melphalan substitute sometimes. It is for myelofibrosis, and it's for myelodysplasia. That's a lot of myelo. Myelofibrosis, myelodysplasia, multiple myeloma, lenalidomide. CLL is a clonal proliferation of normal, mature B cells that function abnormally. This is a disease of older persons. 90% of people are over the age of 50. Most are asymptomatic at presentation. Now, when they are symptomatic, they present with fatigue. They're tired. They can present with big swollen lymph nodes or a big spleen or big liver or infection because you see those lymphocytes don't make normal immunoglobulins. Infections come into the body and the lymphocytes are supposed to process it and make antibodies against those infections. Pneumococcus comes into the body and says, oh, pneumococcus is here to kill you, but doesn't make the required amount of immunoglobulins. Now, as a biggie, there is no unique physical finding. And a small number, the Richter phenomenon, means that it converts CLL into lymphoma. 5% of CLL patients will spontaneously convert into lymphoma because lymphoma is a solid CLL, and CLL is kind of a liquidy lymphoma. CLL, the white count is usually above 20,000, and almost all of this is lymphocytes, 80 to 98, 99% lymphocytes. Half of them are hypogammaglobulinic. That means they just don't make gamma globulins. The cells are there, but they don't function. They don't work. It's like having a TV that doesn't turn on. Anemia and thrombocytopenia occur because the abnormal cells can, instead of making antibodies against infections, are making autoantibodies against the other red cells or against platelets. And occurs from bone marrow infiltration as well. Now, if you have anemia on the basis of bone marrow infiltration, it's very bad. That's stage 3 CLL. That is a 1 to 2 year survival. If your anemia is on the basis of an autoantibody, you could fix that with steroids. That's like an IgG warm antibody. Now, this smudge cell you see here, this squished cell, is a lab artifact that happens in CLL. A cover slip crushes the nucleus and it squishes it or smudges it. Now, it is not a normal cell. It basically says CLL cells are more fragile. They break and they form smudge cells. If you have early stage disease, stage 0, just a high white count, or stage 1, big lymph nodes, no treatments needed, because these patients have a survival between 10 and 12 years. However, if you have advanced stage disease, these patients have to be treated. They get fludarabine and rituximab, in much the same way as think of it like non-Hodgkin's lymphoma. Now, advanced stage disease, a big liver and spleen or anemia or thrombocytopenia, this is the anemia and thrombocytopenia not from autoimmune disease, not from a circulating IgG, but from people whose bone marrow has been infiltrated with lymphomatous cells. It's a person whose bone marrow has been infiltrated with leukemic cells. These are people whose bone marrows have been crowded out with CLL. That is advanced stage disease and needs fludarabine, or if the choices list fludarabine and rituximab, then this is the best initial therapy for advanced stage 2, 3, and 4 disease. Remember, any patient who's symptomatic with severe fatigue and painful nodes must be treated. The most common wrong answer is mistaking advanced disease and thinking it's early disease and saying no treatment. The most common wrong answer is they present an old guy, 75, 80-year-old man with advanced stage disease, and because he's older, students say no treatment. Not correct. If it's advanced stage disease with anemia, thrombocytopenia, big splenia, or if they're symptomatic, they must be treated. In addition, don't forget, CLL acts a bit like HIV. The lymphocytes don't work, and they need pneumocystis prophylaxis in the same way you would for a person with HIV. Refractory cases that are not getting better with fludarabine need cyclophosphamide. In other words, if you have a person who's been getting fludarabine and rituximab and they're not getting better, you need to try something that may have more toxicity but also more efficacy. Try and get it under control. Now, mild cases with just a high lymphocyte count can still be treated with chlorambucil, which is rather cosmetic. It just brings down cell counts. Now, remember that if you have infections, those CLL cells don't make immunoglobulins. You got to lend them some immunoglobulins to help fight their infections. Autoimmune thrombocytopenia or hemolysis gets treated with prednisone the same as anybody else who's got autoimmune thrombocytopenia or hemolysis. The CLL cells might make no immunoglobulin. Lend them some with IVIG. Abnormal immunoglobulin that attacks its own white cells and also its own platelets or its own red cells, prednisone. Hairy cell leukemia is an unusual disorder. Look for middle-aged people who have pancytopenia, big splenia, monocytopenia, very low number of monocytes, and an inaspirable dry tap, despite there being a hypercellular marrow. But remember, there's no reticulin fibers. That's how you know it's not a person with myelofibrosis. No reticulin fibers, okay? And there's also no teardrops. Teardrops and reticulin fibers are part of myelofibrosis. And the hairy cells have filamentous projections on the cells, or hairy cells. Now remember, that filament projection is not reticulin fibers on a marrow. This is off the white cell itself. The most accurate test is we use the CD11 or tartrate-resistant acid phosphatase. Tartrate-resistant acid phosphatase and TRAP has been used. And the treatment is cladribine. Cladribine is specific for hairy cell leukemia. Section 4 of Endocrinology, Adrenal Disorders, Hypercortisolism, Hyperparathyroidism, and Hypocalcemia. If you understood Usmle Step 1 Physiology for endocrinology. You'll be at a huge advantage here for your Step 2 because you will now recall that every morning out of your hypothalamus comes corticotropin-releasing hormone, CRH, which goes down to your pituitary and makes ACTH and down to the adrenals to make cortisol, and you must intrinsically understand this axis to understand anything we're going to say in this entire section because cortisol's function is to go throughout the body and make free fatty acids and glucose go up because that's what you get every morning. You get a cheese Danish in bed with fat and sugar, and that's it. The demarcations between Cushing's disease and Cushing's syndrome are not as important as simply saying, is this a pituitary overproduction of ACTH, or is this a problem with the ectopic production of ACTH? That's the most important thing because that's what drives the testing and the treatment. See, what the problem really is trying to identify where it's from. That's the number one issue for you with hypercortisolism. Is it originating in a carcinoid, such as the most common is a small cell carcinoma of the lung? Or is it autonomously overproduced in the adrenal gland? And the reason why this is important is because since prednisone or any glucocorticoid use can also cause the same manifestations of hypercortisolism, your big issue is where's it coming from so I can remove the right organ? The causes of hypercortisolism, the majority of them are from the pituitary. Now you see that we put as the major calling of it, the major naming of it is pituitary, because that's clear. It's different than saying, well, Cushing's disease, Cushing's syndrome. Pituitary is overproducing. Now I know where it is. The adrenals is simply much less common. Ectopic is even less common at only 10%. And then, unfortunately, about 5%, we just never figure out the cause. The reason why this is so critically indispensable is that people have had their pituitaries removed when it was really coming from the adrenals. So make sure you know where it's coming from so you remove only the correct organ. You can't determine the site of the origin of the disorder just by the symptoms. You see, no matter where it's coming from, they all cause a moon face, truncal obesity, buffalo hump, thin extremities, abdominal fat. Why does the fat redistribute? Well, nobody really knows. We do know that Cushing's disease and hypercortisolism in general raises free fatty acid levels because we want that fat so you can run away from things. That's a tremendous stress hormone. Now, why does it melt the fat in your extremities and increase the fat in your neck and your abdomen? Man, nobody knows. And if you figure it out, get a Nobel Prize. But all we know is that the skin gets thin, but stria and bruising and decreased wound healing, thinning of that skin, because we're taking the collagen in the skin and transforming it into sugar for gluconeogenesis. We're taking the proteins in the bone, and remember, bone is calcium encrusted amino acids. Calcium encrusted amino acids. Melt that bone to make the sugar. Hypertension is for two reasons. One, there's increased sodium reabsorption, and that's because no steroid is entirely glucocorticoid or entirely mineralocorticoid, and glucocorticoids like prednisone, glucocorticoids like cortisol have some mineralocorticoid activity as well, such as aldosterone-like effect. Therefore, you get hypertension because all steroids are a bit mixed, and it is the mineralocorticoid or aldosterone-like effect of the cortisols that make it increase sodium and therefore increase water reactivity. It means it gives your blood vessels a greater squeeze. Menstrual disorders are part of that fact that the steroids are not pure. The same way that even the glucocorticoids have a little mineralocorticoid activity, a little hypertension. There's also some androgen-like activity, and that's not really cool for your menstruations. Erectile dysfunction as well in some patients. That one's not as clear. And polyuria because of the hyperglycemia. The hyperglycemia causes an osmotic diuresis and increased free water clearance because it literally sucks the water right out of you. The bottom line is, number one thing, always confirm the source of hypercortisolism with biochemical tests. Before you image, do biochemical tests. That is because 4% of the population has adrenal tumors and 10% of the population has abnormalities of the pituitary. If you start with a scan, you may remove the pituitary when the source is really in the adrenals. What'd you do? Oh, I scanned you. What happened? Well, we took out the pituitary with transsphenoidal surgery. How'd it go? Well, the surgery went very well, except for the fact that the problem was originating as in adrenals. Oh, you didn't check the ACTH level first? No. Oh, that's bad. Biochemical confirmation so that the scan is more or less after the fact. Hey, I got a high 24-hour urine cortisol. I know you got hypercortisolism. Oh, and there's a high ACTH. It's in the pituitary. It's in the pituitary. By far, the most complex thing in hypercortisolism is the diagnostic evaluation. If you start out with a chief complaint like, I feel weak and tired, and I notice that the hair growth on my face is abnormal, and there's some strange marks on my belly, which is basically stria. The hair growth is because of the androgenic capacity of the cortisol. The first thing, and this is not random, by the way, there's nothing random on this algorithm. The first thing to do is the 24-hour urine cortisol. You see, if the 24-hour urine cortisol is normal, you have essentially excluded a person's hypercortisolism. A normal 24-hour urine cortisol 100% excludes it. Now, the question is, a 1 milligram low-dose dexamethasone suppression test, a one-night overnight dexamethasone suppression test, this is a fast screening test that, if it's normal, excludes it as well. If it's elevated, you're not sure what to do with it. The same with late-night cortisol studies. See, a late-night salivary cortisol, although it's not done very much, it's still important. It could still appear on your test. You see, when is cortisol normally high? The daytime, morning, or night? When is the cortisol high? Well, cortisol is high in the morning because it's what gets you your get up and go in that morning. So at 11 o'clock at night, it should be at its lowest. So if your late-night cortisol is up, ooh, that's bad. You probably have hypercortisolism. Now, a 24-hour urine cortisol is increased. The reason why we do that test, even though it's harder to do, is because if it's increased, it really means you have hypercortisolism. There are very few false positives on a 24-hour urine cortisol. When we're upset, when we've got to run for a bus, when we're late for something, our cortisol level goes up. However, it goes up just for a second, a few minutes. It doesn't go up all the time. How do I tell if your cortisol level's up all the time during the day? 24-hour urine cortisol. The same way, if the police are doing surveillance on you and they want to know what you've been doing for the last couple of weeks, they go through your garbage. Just what it's like in the urine. Going through the garbage, seeing what you got in there. Now, a low dose or 1 milligram overnight dexamethasone test, if it's normal, if it's decreased, disease is excluded. In other words, if it suppresses, you have conclusively proven that there's not hypercortisolism. A 1 milligram overnight means no disease if it's normal. The problem with that test is that if it's up, there's a lot of false positives. But if it's down, you've excluded the disease. That's the 1 milligram overnight dexamethasone suppression test. An increased late-night cortisol in the saliva is very strongly suggestive of hypercortisolism. So 24-hour urine cortisol is the answer to best initial test, and it is also the answer to more specific. These tests, however, are all to prove that you have hypercortisolism. These are tests to prove, disprove whether you have hypercortisolism. They are not to determine the etiology. The etiology is determined by ACTH levels. Once the 24-hour urine cortisol, late-night salivary cortisol is up, then we get an ACTH level because that's going to help us to know, hey, man, it's high, it's ACTH dependent. Oh, man, it's in the pituitary or ectopic. It's in the pituitary or ectopic. Oh, no, it's low. Ooh, it's adrenal overproduction because if it's low ACTH, it's adrenal overproduction. It is the adrenal gland making cortisol independently. And that's why we use the ACTH to tell you, hey, If the ACTH level is up, it is from the pituitary or an ectopic focus. If the ACTH level is down, ACTH independent Cushing syndrome means it's happening in the adrenal gland. By far the most complicated feature of all questions on hypercortisolism is the diagnostic test. Ultimately, we're simply going to remove anything we find. But you've got to make sure you're going to remove the right part of the body. This is because 4% of the population has an adrenal lesion, an adrenal incidentaloma. 10% of the population, which increases, frankly, even larger above that, in an older population, can have a pituitary lesion. Therefore, unless you're certain biochemically before you remove the organ from the person, you could very well end up removing the wrong source. So the rule for you in endocrine is never start with a scan, and the second thing is confirm the location biochemically before you do any imaging studies. So ACTH-dependent Cushing syndrome means that it's originating from where ACTH is made, and ACTH is generally made in the pituitary. Now, an ACTH-independent lesion means that the adrenal is making the cortisol independently without stimulation from its master gland in the pituitary. You'd start with a CT scan of the adrenals after you see that the person has hypercortisolism and a low ACTH. Hypercortisolism, such as an increased level on a 24-hour urine cortisol, plus a low ACTH level equals scan the adrenal. Low ACTH equals scan the adrenals. When the ACTH level is high, it could be either from the pituitary or ectopic production. Now, ectopic production can be either, say, a carcinoid lesion or an ectopic focus of ACTH-producing tissue, or it can be from a cancer. What we know is that cancers and ectopic foci simply don't suppress. They don't suppress. They don't subject themselves to the normal feedback inhibition. We know that the pituitary will. So we know that if there's an increased ACTH and a high cortisol, that what you'll see is that there's still a failure of suppression. If high-dose dexamethasone does not suppress that production, there's ACTH secreting ectopic tissue. And we look for that first inside the chest. Now, if there is suppression with high-dose dexamethasone, it turns out pituitary lesions, such as pituitary adenomas, still retain enough normal function that it will suppress. So therefore, at high dose, the dexamethasone will suppress pituitary lesions. So the bottom line is pituitaries suppress and ectopics don't. After you have suppressed it with high-dose dexamethasone, you will scan that pituitary. Remember how we said don't start with the scan? Well, you can certainly end with the scan. Now, if there is still, you don't see a lesion in there, well, there still is a lesion in there. That's the problem with the scanning. 10% of the general population has a pituitary lesion. If you start with a scan, you might remove the pituitary incorrectly. The other part of it is that you could still have pituitary secretion of ACTH with no mass seen. That's why we sample the petrosal sinus for ACTH. Now, this is the most complicated version of all of the endocrine lesions, and therefore you should expect to have to go through this a couple of times. This bottom line, literally the bottom line in this algorithm is this. If you have hypercortisolism, do an ACTH level. If the ACTH level is high, you should try and suppress it with high-dose dexamethasone. Ectopic foci and cancers simply won't suppress. Go looking for them inside the chest CT. Pituitary lesions will suppress. So if you suppress them, but you still can't find the thing on a pituitary MRI, you've got to actually put a catheter up there into the petrosal sinus, which is the venous sinus that drains the pituitary, and find the high ACTH level, which confirms it's an ACTH-producing pituitary adenoma. Let's summarize out the confirmatory laboratory findings in adrenal disorders and hypercortisolism. First off, the ACTH level. Now remember, this is in a person we've already established has hypercortisolism. If you know that there's hypercortisolism, where is it from? The first thing is If there's a low ACTH level, it's inside the adrenals, because the adrenals overproducing cortisol and resulting in feedback inhibition on the pituitary. The adrenals overproducing cortisol and having feedback inhibition on the pituitary, so it's shutting off the ACTH. Now, pituitary and ectopic foci are a failure of normal feedback inhibition. They're a failure of normal feedback inhibition, so that's why the ACTH level is abnormally high in the presence of hypercortisolism. So when are we going to do the petrosal sinus sampling? Well, the petrosal sinus sampling is not for the adrenals, because the petrosal sinus is what drains out the pituitary. This is done if the MRI is negative. We go, wait, man, you got a high cortisol and a high ACTH. It must be in the pituitary. Yeah, but my MRI didn't show me anything. Nah, get in the petrosal sinus. It's there. Ectopic foci won't have anything in the petrosal sinus, won't have ACTH in the petrosal sinus, because the petrosal sinus is draining the pituitary, not that ectopic focus. High-dose dexamethasone is very straightforward. High-dose dexamethasone has nothing to do with the adrenals. It has to do with telling the fact that ectopic things don't suppress. Ectopic things don't suppress, and pituitaries will suppress cortisol. Pituitaries are suppressed by high-dose dexamethasone. Pituitary lesions are suppressed by high-dose dexamethasone. The other laboratory findings of hypercortisolism are easier for us to understand because there's only one uniform presentation. Since cortisol is an anti-insulin stress hormone, you will see high sugar and high lipids. It is, in fact, exactly like insulin in the sense that if insulin lowers glucose, lowers lipids, and builds protein, cortisol raises glucose, raises lipids, and destroys protein because it wants the protein for gluconeogenesis. That is the basis of the bone and skin findings. Melts that protein. Now, because there's some aldosterone-like effect to cortisol, you should expect to see hypokalemia, because aldosterone makes you retain sodium and excrete potassium. Makes you retain sodium and excrete acid. So there'll be metabolic alkalosis, because the aldosterone is making you retain sodium and excrete potassium and excrete acid. In addition, everyone will have a leukocytosis because the stress hormone demarginates white cells. Demargination means half of white cells are normally in circulation, the others are on the edge of the blood vessel, the margins, so to speak, and steroids will pull them off the margins. So working backwards, what is the point of torturing ourselves learning all of those diagnostic tests for hypercortisol? And the answer to that is very straightforward. Whatever we find, we have surgical removal. The point is surgical removal of the source of the hypercortisolism. If it's in the pituitary, crawl up your sphenoids and transsphenoidal surgery for pituitary sources. If it's in the adrenal, laparoscopic removal of the adrenal source, or inside the lung. The major point of all of those diagnostic tests is help me to make sure I remove the correct part of the body. An adrenal incidentalloma means a lesion in the adrenal found when the abdominal CAT scan is done for other reasons. With the advent of so much widespread radiologic evaluation, I had appendectomy last year, and I had an abdominal CT. What if they'd gone through my adrenals and they'd seen an adrenal incidentalloma? Oh my God, hey fishy fish. Conrad Fisher, you've got a lesion in your adrenals. What are we going to do about it? Well, this is very straightforward. How far should you go in the evaluation of an unexpected asymptomatic lesion? And there's the recommendation by the American Endocrine Association. The endocrinologists basically say, do the metanephrines of blood or urine to exclude pheochromocytoma, renin and aldosterone levels to exclude hypercortisolism, because hypercortisolism will have a high aldosterone and a low renin, high aldosterone and a low renin. And this is the only time that a 1 milligram overnight dexamethasone suppression test is all you have to do. The reason is you're doing this test to be negative. Since it's an asymptomatic person, you should expect it to be negative. And what we're doing is we're saying, give me 3 fast tests to make sure that I don't really have anything in that adrenal incidentalloma. You are going to get more and more questions on adrenal and pituitary incidentallomas because we CT and MRI everything. So we've got to be sure we don't overtreat people. Addison's disease is easier than hypercortisolism, mostly because the number of causes of Addison's disease are much smaller. There's much fewer causes. The days of so many infections doing it in Waterhouse-Friderichsen syndrome and meningococcus causing a problem inside the adrenals, that's rather passé. The vast majority of Addison's disease is chronic hypoadrenalism, which in the majority of cases, more common than everything else put together, is simply autoimmune destruction. It goes along with vitiligo, and it goes along with monoclonal gammopathy of unknown significance. And it goes along with pernicious anemia, vitiligo, monoclonal gammopathy of unknown significance, and Hashimoto's thyroiditis. Those things travel together. They are basically antibody noise, autoimmune noise throughout the body. So when you see Addison's, you should be thinking about Hashimoto's and vitiligo and pernicious anemia. And when you see pernicious anemia, you should be thinking about Hashimoto's and Addison's disease. Infections can do it in tuberculosis, but infections are much less common. And this is adrenoleukodystrophy is a congenital genetic anomaly of unclear etiology, and sometimes cancer metastasizes to the adrenal and unfortunately can destroy it. Our question about adrenal crisis, well, we have to think backwards from what do we know that adrenal hormones do? Adrenal hormone, most importantly, maintains blood pressure with aldosterone, maintains acid-base status, potassium, acid-base, and blood pressure. So if you have acute adrenal crisis, interestingly enough, the thing that kills you when it says which of the following is most likely to kill the patient, or what will you notice most importantly, that the most important thing is not the loss of the cortisol. The most important thing, the acute adrenal insufficiency, is that your blood pressure drops. Now, sometimes this can be hard to determine because hemorrhage, surgery, hypotension, and trauma don't just result from adrenal crisis. They, in fact, cause adrenal crisis when you underperfuse those adrenals. In addition, suddenly stopping chronic high-dose prednisone can result in adrenal crisis because the body gets used to those hormones all the time. When you suddenly stop them, all of a sudden, bang, they're out of gas and hypotensive. No matter what the etiology is of the low adrenal function, patients are weak and fatigued. Remember that cortisol is a get-up-and-go hormone. It's a get-up-out-of-bed, circadian rhythm, how do I get some energy in the morning hormone. You get altered mental status because the hypoperfusion, the low blood volume, can also contribute to nausea and vomiting, anorexia, hypotension. And if it's chronic, there's hyperpigmentation because there's an increased ACTH coming out of that pituitary, trying to stimulate your adrenals. Acute adrenal crisis presents with profound hypotension, fever, confusion, coma. Holy crap, man, let's draw a cortisol level and give us a stress dose of steroids. In most patients who have hypoadrenalism, because cortisol raises glucose, there's a profound hypoglycemia because adrenal hormones such as aldosterone make you excrete potassium. There's hyperkalemia. And because it also makes you excrete acid, you should see metabolic acidosis, hyponatremia. Well, that's because aldosterone makes you retain sodium and excrete potassium and excrete hydrogen ions. So you don't have aldosterone, you retain potassium and retain the hydrogen ions and excrete the sodium instead. Because you're pre-renal, because you're volume depleted, because you're intravascularly volume depleted and hypotensive, you get a high BUN. Because of the etiology such as being autoimmune or allergic, eosinophilia is common. Also, steroids get rid of eosinophils. Eosinophils are a sign of allergy. Cancer, allergy, Addison's, wow. So that's why it is steroids get rid of allergies, and if you have no steroids, it's like you're allergic to your own adrenal. Now, with pituitary failure, your ACTH level is low, and with adrenal failure, your ACTH level is high, because when you have pituitary failure, your adrenals are failing at least for the sex hormones and the cortisol. It's failing from the fasciculata, which makes cortisol, and the reticularis, which makes androgens, and therefore your ACTH level will be low because this leads to the failure of the fasciculata and reticularis. Now, when there's adrenal failure, your ACTH level will be high because remember, the only feedback inhibition on that pituitary is cortisol, and if you have no cortisol, you lose feedback inhibition, the pituitary shoots up the ACTH. Hypoadrenalism of any cause results in weakness and hypotension. If it goes on for a while, weight loss and hyperpigmentation, because when you have an insufficient adrenal, you often can have hyperpigmentation from pro-opiomelanocortin. Pro-opiomelanocortin is the precursor protein that comes out of that pituitary. It's like the precursor hormone. Now, we don't know what melanocyte-stimulating hormone does in the normal person. We do know that it results in hyperpigmentation in people who have chronic insufficiency. Now, what we want to do is we want to give that person to test their adrenals to see if we can give their adrenal gland a kick in the pants. So we give artificial ACTH and say, okay, did your plasma cortisol level go up when we gave you the ACTH? Are your adrenals, are they functional at least? Well, if we see a lack of rise of cortisol, then we got to think about two things. Number one, is it that the ACTH is high and the aldosterone is low too, because there's just the adrenal gland has failed. The whole adrenal has failed, and that's because the ACTH level is high all the time, and even the extra kick in the pants didn't work because it's basically dead gland. Dead gland. How do we know it's a dead gland? Because the cortisol doesn't rise, and the aldosterone is low too. Now, what if there's a low ACTH and the aldosterone is able to stay up? Well, that is a person who has basically an insufficient pituitary. See, their pituitary is gone, so what's ended up happening is that the adrenals have atrophied. I don't like terms like secondary adrenal insufficiency, but that's the term. It means that the adrenal is insufficient secondary to a weak pituitary. The adrenal gland is insufficient from a weak pituitary, and it's atrophied from pituitary insufficiency. Now, in an acute adrenal crisis, you are going to die if you don't get some treatment. Treatment is far more important than testing an acute adrenal crisis. You take that cortisol level, you take a cortisol level, and instantly hit them with steroids and hydrocortisone and fludrocortisone sometimes. Remember, fludrocortisone is the steroid that has the highest mineralocorticoid activity. But in acute adrenal crisis, checking the level of cortisol, you don't wait for the results. You take the cortisol level, and if the question is very clear, it's going to say, what is the next best step in the management of this patient? And your answer is cortisol level and replace the steroids. But if you actually had to choose one thing, fluids and steroids is more important than testing. Fludrocortisol is for people who are orthostatic from postural instability. In other words, what keeps your blood pressure up when you go from sitting down to standing up is that you have aldosterone coming out of your adrenals that maintains your blood pressure. And if you don't have enough aldosterone, let's replace it with fludrocortisone. Now, this is a steroid hormone that's particularly high in the mineralocorticoid or aldosterone-like effect. It's a steroid that basically is like eating aldosterone. A person is brought to the emergency department after severe abdominal trauma in a motor vehicle accident. On the second hospital day, becomes markedly hypotensive without bleeding, and there's a fever and a high eosinophil count and hyperkalemia and low sodium and low glucose. What's the next step in the management of this patient? The answer is do a cortisol level and administer hydrocortisone, because norepinephrine is going to constrict blood vessels more effectively when there is steroids on board. So norepinephrine will constrict blood vessels better if you have those glucocorticoids. And treating severe hypotension is more important than finding the etiology. So CT scan of the adrenals is good, and cochentropin stimulation test is good, and even ACTH levels sometime. Dexamethasone suppression testing is the opposite. That's for hypercortisolism, not low. So choice C is important, but it's not as important as preventing you from dying of hypotension today. Primary hyperaldosteronism, sometimes known as Conn syndrome, is actually much easier. It's basically an autonomous overproduction of aldosterone despite a high blood pressure. And it's an autonomous overproduction of aldosterone despite a high blood pressure and having a low renin. So that is from a solitary adenoma in 4 out of 5 patients. A smaller number have hyperplasia, and cancer, actual malignancy, is relatively uncommon. All forms of secondary hypertension are more likely in those who've had their onset of the hypertension too young, very young. You shouldn't be having high blood pressure when you're 20 and 25. And if you made it to 60 and 65, you shouldn't be starting. So if you're under 30 or over 60 or 65, Or you're a person who can't get controlled by 2 meds. Wow, you need a 3rd med and you're still not controlled? You need 3 meds? Wow, why? These are the people that we should be chasing secondary hypertension. Or if a person has something characteristic in the history and physical examination, such as primary hyperaldosteronism is characterized by high blood pressure and a low potassium. Those 2 facts alone are enough to tell you, hey, I think there's a primary hyperaldosteronism, high blood pressure, and a low potassium. Aldosterone's raising your blood pressure, aldosterone's kicking out your potassium. For primary hyperaldosteronism, the best initial test is the plasma aldosterone to plasma renin ratio. In other words, a low plasma renin with a high aldosterone is primary hyperaldosteronism. It went up without renin. Now, the most accurate test is the adrenal venous sampling for high aldosterone. That's not necessary most of the time, but it is the most accurate test. And for the CT scan, well, like everything else in endocrine, only after the laboratory test reveals the diagnosis. A low potassium, low plasma renin, and high aldosterone despite a high salt diet. Remember, salt should shut off that aldosterone. If I give you a lot of salt, why is your aldosterone still up? Failure of feedback inhibition. Only scan after you already know it's there. A unilateral adenoma is easily removed with laparoscopy. That's why you're CT scanning them, to find out which side. Now, bilateral hyperplasia you don't want to remove, so we use eplerenone or spironolactone to block it. Now, this question, spironolactone causes gynecomastia, decreased libido. It's anti-androgenic, very high yield because it's clear. It's a clear question. Pheochromocytoma is a non-malignant lesion of the adrenal medulla. It's the autonomous overproduction of catecholamines despite a high blood pressure. Like most of these tumors, it is the failure of feedback inhibition to shut it down. And a pheochromocytoma is the answer if there is episodic hypertension. That's the number one thing. It's the only thing that's episodic. You don't have episodic renal artery stenosis. Oh, it came, it went, it came, it went. You don't have episodic Cushing's disease. Oh, I was humping and not humping. Oh, I had truncal obesity, no truncal obesity. It's the only one that's episodic. Headache and sweating, palpitations and tremor are certainly there. But it'd be very hard to extrapolate and say, you have a headache, you must have pheochromocytoma. The answers for pheochromocytoma haven't changed in 30 years. We're going to get them right now. The best initial test, people sweat about this one a lot, so to speak, because people are torturing them with, well, what should be? Plasma catecholamines, 24-hour metanephrines, catecholamines. Only thing we can say is that all of those are more accurate than VMA levels, vanilla mandelic acid, and you're not going to get asked to choose between them because it's just not too clear. Plasma catecholamines, 24-hour urine metanephrines, 24-hour catecholamines. Look, catecholamine levels go up, they go down, they go up, they go down. They last for a minute or two, and then they're gone. The urine tells you on average for 24 hours what's been going on. As in all of endocrinology, we only do scanning after we have confirmed it biochemically. You see symptoms, episodic hypertension, sweating, headache, palpitations, then the catecholamines and metanephrines. Then, after biochemical testing, then we scan the adrenals. Now, 10% are outside the adrenals. How would we find it? How do you find a pheochromocytoma that's not on that adrenal scan? Well, we have a specialized test that picks up occult pockets of enterochromaffin-like tissue. That's an Mbbg scan, the abbreviation of which I don't want you to know. What does it stand for? It's a nuclear isotope scan, and it detects the location of pheochromocytoma that's outside the adrenal gland. Now, it's 10% are bilateral. 10% are outside the adrenal. 10% are malignant. We want to get rid of them. It's very important to determine the location so we can resect it. Mbbg scan is a way of detecting occult pockets of pheochromocytoma. Now, this image is not because we expect you to be reading Mbbg scans. We just want you to know, like, hey, isn't this cool? Look at this cool stuff we can do that can find occult pockets of these tissues. Wow. Mistress. Wow, look at that, spooky. The best initial therapy is phenoxybenzamine, an IV alpha blocker that we give so that when we squeeze those adrenals, we don't cause your head to explode by a massive release of catecholamines. This is followed by beta blockers and rarely a calcium channel blocker, then remove it laparoscopically. These answers have not changed in 35 years. And you can occasionally be asked, episodic hypertension, catecholamines, metanephrines, scan, Mbbg scan, phenoxybenzamine, beta blockers, and removal. Our next section is various movement disorders, amyotrophic lateral sclerosis or Lou Gehrig's disease, Charcot-Marie-Tooth disease, peripheral neuropathies, facial nerve palsy, also known as a Bell's palsy, and Guillain-Barré, which is sometimes called acute inflammatory polyneuropathy, and myasthenia gravis. ALS is exclusively a loss of motor neurons. Now, it may be both upper and lower motor neurons, but it's only motor. There is no sensory loss. The sphincters are spared. But it's not just the sensory and the sphincters that are spared. It's cognitive defects are spared, and sexual defects are spared, and, well, everything is spared. It's only motor disease. It is idiopathic, and it is very frustrating because we have nothing to reverse it. Since there is no specific diagnostic test for ALS, the most likely diagnosis question is a symptom complex. You will answer ALS as the most likely diagnosis when you look for weakness, motor weakness, starting in the 20s to 40s age, and a combination of upper and motor lower neuron loss with an initial presentation that tends to be a bit more descending, chewing and swallowing, and disordered swallowing. When a patient has a decreased gag reflex, this results in a person who is pooling of saliva in the pharynx and weak cough, leads to frequent episodes of aspiration. Because normally we make 1 to 2 liters a day of saliva, and you take it for granted because you just swallow that. Wow, did you know that you make more saliva each day than urine? Well, where does it go? Well, I swallow it and you don't even notice it. But if you have ALS and you have disordered swallowing, it's going to go into your lung. And that is why death can occur in patients within 3 to 5 years because they continue to have recurrent pneumonia and aspiration, lung abscesses, and respiratory failure. The survival in ALS is exclusively dependent upon how clean, how accurate, and how tidy. The phrase pulmonary toilet would not be inappropriate. That's an accurate phrase. How clean do you keep your lungs? You keep your lungs clean, you'll live. Since there is no diagnostic test for ALS, the diagnostic test is really a definition of symptom complex. And that symptom complex is the combination of upper motor neuron defects such as weakness, simple weakness. Spasticity happens only with upper motor neurons. Spasticity only in the upper. Now, upper motor neuron gives you weakness, but you don't actually have wasting. The muscle actually doesn't dissolve because it's hyper-stimulated in a way from an overactive reflex arc. Whereas lower motor neuron defects is like the puppet strings being cut. It just wastes away. It's like a cut flower. Upper motor neuron defect gives you hyperreflexia, whereas lower motor neuron defect, for unclear reasons, there's fasciculations, a rapid, tremulous state of muscles that nobody understands. And upper motor neuron defects is upgoing toes, extensor plantar reflexes.
Okay, can you go back and forth? There you go.
Although electromyography is certainly abnormal in ALS and there'll be loss of neural innervation in multiple muscle groups, after all, that is how you get the wasting and the weakness. This is not the same thing as saying that this is a specific diagnostic test, but you do see high CPK levels because the muscles become atrophic, and as they atrophy, they die and release CPK. Riluzole is a medication to help reduce glutamate buildup in the neurons. Now, this doesn't cure the disease, it just delays the progression of the disease. Baclofen is used, as it is in multiple sclerosis, to decrease spasticity, as you can also use tizanidine. CPAP and BiPAP, positive airway pressure, a mask on the face to blow the uvula out of the way, is far more important because these modalities help respiratory difficulties secondary to the muscle weakness. The major problem in ALS is that you can't take a good deep breath, you can't cough. This means that you need extra help in your inhalation. That's what CPAP and BiPAP do. Daytime somnolence, sleepy during the day, don't intubate. CPAP. Now, when all the other modalities fail, tracheostomy and putting a cuffed tracheostomy tube in to maintain people on a ventilator, such as at night. Instead of aspirating, go on a ventilator at night. And maintenance on a ventilator is necessary when the disease advances, and the cuffed trach and positive pressure airway ventilation helps protect you from having aspiration pneumonia, particularly when you can't cough it up at night. Charcot-Marie-Tooth is an uncommon genetic disorder where you lose both motor and sensory. ALS is just motor. This is motor and sensory innervation, leading to distal weakness and sensory loss, wasting in the legs in particular, decreased deep tendon reflexes, and a tremor. Now, we have two relatively unique physical findings here that are indispensable for you to learn. After all, they are pes cavus, a high-arched foot deformity, and legs that look like inverted champagne bottles. That's the term. I don't make this stuff up. Champagne bottle legs and Charcot-Marie-Tooth syndrome. And the most accurate test is electromyography, showing decreased innervation, and there is no treatment for this disorder. This is a very small knowledge base on Charcot-Marie-Tooth. Basically, you know the champagne bottle legs and the pes cavus, and you are done. The opposite of Charcot-Marie-Tooth in frequency is the peripheral neuropathy of diabetes mellitus, which is the most common cause of peripheral neuropathy by far. Glove and stocking distribution, small neurons, diabetes mellitus. Now, uremia, renal insufficiency, also causes neurologic dysfunction. Alcohol is a direct toxin to nerves, and paraproteinemia is for unclear reasons. Monoclonal gammopathy of unknown significance, Mbbs, is associated with a peripheral neuropathy. Nobody knows why this happens, but in a disorder that is generally asymptomatic in the majority of patients. The most common symptom when it does occur of Mbbs is actually peripheral neuropathy. The initial therapy for peripheral neuropathy, regardless of the cause, is pregabalin or gabapentin. And although tricyclic antidepressants such as amitriptyline can be used, these medications have less adverse effects. They can cause some sedation, pregabalin, gabapentin, but they don't cause the dry mouth you get with tricyclics. Tricyclics cause dry mouth, urinary retention, constipation. Dry mouth, urinary retention, constipation. Pregabalin and gabapentin don't do that. You will not be asked to choose between these three drugs. They're not going to say which of the following is the most effective drug and ask you to choose between three drugs that are interchangeable. If these drugs are in the same question, it means they're asking about adverse effects, because that's the only thing that's truly different. Now, no matter the etiology, it's always control the etiology and use pregabalin, gabapentin, tricyclics. Seizure medications are effective in some people, most of them, and phenytoin or carbamazepine, lamotrigine, well, all of these could be used, so can valproic acid, in the same way as we talked about in the headache section. So in the headache section, these are for neuropathic pain and for peripheral neuropathy as well. Specific peripheral neuropathy, such as the ulnar nerve, can be precipitated by, well, when you ride a bicycle and you're leaning forward on the palms of your hands, it causes a vibratory damage to the ulnar nerve that can cause numbness and tingling, of the side of your hands, where the ring and the pinky finger are. Wasting of the hypothenar eminence. Thenar eminence is with your thumb. Thenar, thumb. Hypothenar is the other side from your thumb. The radial nerve travels underneath your humerus. So that's why it is that if you have pressure on the inner or upper part of the arm, like in crutches or Saturday night palsy is when you fall asleep with your arm over the back of a chair, that's exactly where the radial nerve travels. And that's why the radial nerve will result also in wrist drop, radial wrist drop. The lateral cutaneous nerve of the thigh is stretched when people have pregnant women, obese people, pregnant, particularly with sitting with crossed legs. It stretches it even more and causes pain and numbness on the outer aspect of the thigh by stretching it. It's also L2. Sometimes asked, they say, what nerve root is lateral cutaneous nerve of the thigh? And go think of it like this. Lateral, lateral, L2 for lateral. The tibial nerve is in the foot. It gets worse with walking. It results in pain and soreness of the ankle and sole of the foot. It's kind of like carpal tunnel syndrome, but of the foot. Carpal tunnel, that median nerve gets overused and causes numbness and tingling in your hand with the thumb and the first three fingers. This is the same thing, just in your foot. The peroneal nerve is rather like the radial nerve of your leg. High boots hit under the back of your knee, and the pressure on the back of your knee results in foot drop. Weak foot with decreased dorsiflexion. Dorsiflexion is like saying pull your toes towards your nose. Pull your toes backwards and up towards your nose. And that's what gets weak with a peroneal foot drop. Radial wrist drop, peroneal foot drop. The median nerve is our good old friend, carpal tunnel syndrome, typists, carpenters, those working with their hands. Is there somebody not working with their hands? But working with their hands a lot. And the thenar eminence, remember, thenar means thumb. First three fingers, the thumb, the index, and the middle finger become numb, pain, burning, and wasting, particularly with use. The seventh cranial nerve palsy, or Bell's palsy, is almost always idiopathic. There are a couple of identifiable causes, and some of those identifiable causes, Lyme disease can cause bilateral too, sarcoidosis can cause bilateral too, and zoster, and sometimes some tumors that go and press on the seventh cranial nerve as it's coming out of the canal. But most are idiopathic. Now, you have to also look for this phrase that says the face feels stiff, or the face feels like it's been pulled to one side. Because remember, sensation is intact. Sensation in the face is controlled by the fifth cranial nerve, the trigeminal. So when you have abnormal muscles of the face, you can feel it with the intact trigeminal. But we have to answer the question, what's the most likely diagnosis? So seventh cranial nerve palsy is paralysis of the entire side of the face, including the eyebrow and the forehead. And that's how you distinguish it from a stroke. The stroke paralyzes only the lower half of the face. The upper part, the forehead, has bilateral innervation. Stroke is only the lower. Seventh cranial is the whole half the face. And the upper half of the face is innervated from both cerebral hemispheres. That's why you can't stroke out the upper half of the face. But you do have in Bell's palsy or seventh cranial nerve palsy a tremendous difficulty closing the eye. The orbicularis oculi muscle, orbicularis oculi, is innervated by the seventh cranial nerve. And when that's damaged, you lose the ability to wrinkle your forehead and close the eye. And that's why it says if they cannot wrinkle the forehead, can't lift it up, can't lift up your eyebrows, it's Bell's palsy, a seventh cranial nerve palsy. Hyperacusis means you hear things extra loud. And the seventh cranial nerve supplies the stapedius muscle. Now, there's two muscles in the middle ear that act as shock absorbers on the ossicles of the middle ear. The incus malleus and stapes, it's like saying the hammer and the anvil. That's what that means. The malleus, like a mallet. And the stapes, a stirrup. Well, in that hammer, anvil, and stirrup, the sounds hit it and create vibrations. And one of the reasons that gunshots and sudden sounds can really deafen you is that they don't allow time for the stapedius under the seventh cranial nerve to tighten it up and act as a shock absorber. Damages your ears. Now, the taste disturbance is because the seventh cranial nerve supplies taste, but only to the anterior two-thirds of the tongue. The facial nerve supplies the sweet sensation of taste. The bitter taste is in the posterior third of the tongue. The posterior third of the tongue is bitter taste, and the posterior third is controlled by the same nerves that control the gag reflex, and the gag reflex is controlled by cranial nerves 9 and 10. Gag, 9 and 10. Posterior, anterior, seventh cranial nerve, anterior two-thirds. Now, I saw a case of Bell's palsy just 2 weeks ago, and I didn't do any test because it's obvious. But I could have said, well, the most accurate is electromyography in nerve conduction studies. No test is usually done, so you've got to distinguish between the phrase, what is the most accurate, and what would I do? What would I do? I'd give him some steroids and send him home. What is the most accurate? Electromyography, nerve conduction. The best initial therapy of seventh cranial nerve palsy is under the presumed mechanism that swelling of the seventh cranial nerve as it proceeds through a narrow bony canal in the face can be improved with prednisone as a steroid. But 60% would have full recovery even without treatment. But you will use it in everybody because it's short-term steroids, and a week or two of steroids never hurt anybody. You don't reactivate your tuberculosis in 2 weeks of steroids. In the past, there was a consideration about using acyclovir, valacyclovir, or famciclovir to treat herpes as well. If it is in your answer choice, the answer is no. This has now been disproven. However, if you're looking at some other sources or question bank questions from various sources, it may say it. That's an indication to you that that question is left over from the past. No acyclovir on a routine basis. A 38-year-old man with pain near his ear, followed by weakness of one side of his face. Both upper and lower parts of the face are weak. Both of them. Sensation is intact. What's the most common complication of this? The most common complication of this person has? A facial nerve palsy. A facial nerve palsy is both upper and lower, and the most common complication is a corneal ulceration. That's because you can't close your eyes. You can't close that eye, so the eye gets dry and it ulcerates, particularly at night. Patch and lubricate at night. Patch and lubricate at night so you don't get an ulceration. Aspiration pneumonia doesn't happen because it's the 9th and 10th cranial nerve that control gag and cough up there, that control the sensation of gag that leads to the cough. Sinusitis causes nasal discharge and face pain. Doesn't have anything to do with weakness. Otitis media is ear pain, decreased hearing, but it doesn't have anything to do with facial weakness and deafness. It's the other way around. The sounds are heard extra loud because you lose stapedius innervation, and dental caries don't have anything to do with it because you're not paralyzing the face does not involve your salivary glands. Guillain-Barré is acute inflammatory polyneuropathy. And there's autoimmune damage of multiple peripheral nerves. There is, by definition of the disorder, no CNS involvement. Guillain-Barré is 100% peripheral nervous system. We think the mechanism is that there's circulating antibodies resulting in attacks on the myelin sheaths of the peripheral nerves, and it's associated with Campylobacter jejuni. Remember, association does not mean that it caused it. It doesn't mean it caused it. It means that people with Campylobacter have an increased frequency of Guillain-Barré. We don't know that it actually caused it. That's a different thing. We just know it's associated. In one sentence, Guillain-Barré is diagnosed by ascending weakness and a loss of reflexes. Ascending means it starts out in the feet and moves upwards into the legs and into the abdomen. Ascending weakness and a loss of reflex is Guillain-Barré and nothing else. So the answer to the question, what's the most likely diagnosis, is a matter of looking for weakness of both legs. Remember, it's bilateral. It ascends from the feet and goes towards the chest, and on the way up there, you lose your reflexes. So they'll say areflexia. Areflexia, no ankle jerks, no knee jerks. Start with ankles, goes up to knees. Ankles are lost first. Now, some people might have some mild sensory disturbance, but the big issue is ding, 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 respiratory muscle weakness. As you go up from the toes to the nose, Guillain-Barré hits the diaphragm. It's going to zap your diaphragm and it's going to kill you. Autonomic dysfunction is much less common, 10 to 20%. Big drops in blood pressure, then up to hypertension, then down to low blood pressure. Up and down. Autonomic instability and dysfunction with tachycardia are definitely part of it. The CSF in Guillain-Barré will show an increased protein with a normal cell count. Now, that's not the most specific test. The most specific test is nerve conduction velocities in electromyography, where you'll see a decrease in the propagation of electrical impulses along the nerves. That's the most specific test. That's why in Guillain-Barré you'll frequently see intense descriptions and questioning about respiratory muscle involvement, because the inspiration is the active part of breathing and the patient loses the strength to inhale. As you go from your toes up to your nose, as you ascend up, you can hit your diaphragm and you will see a decrease in forced vital capacity and a decrease in the peak inspiratory pressure, because inspiration is the part that's the active part of your breathing, and pulmonary function tests tell who might die. PFTs tell who's going to die. And that's why it really depends on Guillain-Barré. Are they asking you most accurate? Well, that's a nerve conduction velocity. Or are they asking you what's the most important thing to do first? A person's in the emergency room. The most important thing to do first is make sure he's not going to die from ventilatory failure, respiratory failure. Death from Guillain-Barré, although it's rare, can be from dysautonomia and especially respiratory failure. That's why kids with polio in the 1940s and 50s ended up on the iron lung. Because before the eradication of polio, it functioned in much the same way as Guillain-Barré. Ascending weakness, loss of reflexes, and watch out for the diaphragm involvement. Treatment for Guillain-Barré is straightforward. Intravenous immunoglobulins or plasmapheresis are equal in efficacy, but if they're both in the choice, you're going to choose intravenous immunoglobulins. IVIG is simply much easier to give. It's a bag of liquid like giving an antibiotic. You hang the bag, it's in, you're done. Plasmapheresis is very similar to doing dialysis. You got to hook them up to a machine, put a big catheter in a big central line, and take out all their plasma and blood and exchange it. And that is really much, 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 much more difficult. So IVIG is generally first, even though they're both equal in efficacy. The number one wrong answer is saying to use prednisone. Prednisone is a wrong answer for Guillain-Barré. It simply doesn't help. Combining IVIG and plasmapheresis doesn't help. If you gave intravenous immunoglobulins and you did plasmapheresis, it would remove the intravenous immunoglobulins you just gave. And prednisone and steroids are very easy to make wrong answer. After all, it is an autoimmune event. It is antibodies attacking your peripheral nerve. So if I didn't know better, I would say prednisone as well. After all, it's autoimmune. Let's stop it. Nice idea. It just doesn't help. Just say no to steroids in Guillain-Barré. A woman comes with bilateral leg weakness over the last few days. She's lost her reflexes in the legs. The weakness starts in the feet, goes up to the calves, up to the thighs. What's the most urgent thing to do? The most urgent thing to do is, well, pulmonary function tests make sure that you understand that Guillain-Barré will hit that diaphragm and kill you. And you want to know before they have respiratory failure. If you wait for an increase in CO2 on ABG because of ventilatory distress, they're about to die. Too late. Nerve conduction studies may be the most accurate test, but they're not the first thing to do. You put a needle in their nerve and send an electrical impulse, look for decreased F-wave propagation. Maybe the most accurate, but certainly not as important as knowing whether this lady is going to go to the ICU. Lumbar puncture is okay, it shows a high protein, but it's neither the most urgent test nor is it the most accurate. Peak flow meter is for asthma. Peak flow measures the exhale, expiratory flow. Guillain-Barré is a problem with inhalation, not exhalation, because exhalation is mostly passive. Myasthenia gravis is muscular weakness from antibodies against the acetylcholine receptors at the neuromuscular junction. Now, severe myasthenia can also affect the respiratory muscles, and that's important to know when to answer intravenous immunoglobulin and plasmapheresis acutely. Answering the question, what's the most likely diagnosis? Well, we know it's muscle weakness, so it's what the word means. Myasthenia. My means muscle. A without. Stenos is the Greek word for strength. Muscles without strength. But which muscles? You're going to look for double vision, decreased chewing. Double vision, because the extraocular muscles get weak. And those muscles get weak particularly towards the end of the day. And difficulty chewing, because it's a repetitive muscular exercise. The strongest muscle in the male body is the masseter. The second strongest in a woman. The single strongest is the uterus. But the strongest in the male body, and the one most commonly used, is simply chewing. Weakness of the limb muscles is definitely at the end of the day, because what ends up happening is that you have a limited number of receptors and you simply don't have enough stimulation to create the strength you need. Ptosis is your eyelids are drooping because the muscles get weak. The levator palpebrae superioris muscle gets weak, especially towards the end of the day. And the key feature is that the more you exercise, the weaker you get. But this doesn't affect the pupils, interestingly enough. Now, extraocular muscles and the muscles of mastication are virtually the only two muscular activities that is done by everybody. Reading these words right now requires muscular exertion on the part of your eyeballs. So if you start seeing two words here, or fuzziness, it could be myasthenia gravis. The best initial test for myasthenia gravis is acetylcholine receptor antibodies. That's the fundamental defect here. The most common wrong answer is edrophonium testing. Acetylcholine receptor antibodies can be done more easily and have more sensitivity and specificity. They are definitely a better answer than edrophonium testing. Edrophonium is a short-acting inhibitor of acetylcholine esterase. Temporarily, it bumps up acetylcholine levels, and there should be a very clear improvement in motor function, but it only lasts a few minutes. Now, this is something where you say, hey, hold your arms out, and we'll see how long you can hold them out in front of you before and after edrophonium. But this is a test that's fraught with inaccuracies, these types of functional tests. Acetylcholine receptor antibodies is a much better choice, and the right answer on your test. Receptor antibodies is not as accurate as electromyography, particularly single fiber electromyography. Put a needle into that muscle and see what happens to the muscular contraction with repetitive stimulation. Now, when the question says what imaging should be done, the imaging is always chest x-ray, chest CT, chest MRI. We're looking for thymoma, we're looking for thymic hyperplasia, and that is especially important because when the initial set of drugs don't work, we're going to take out that thymus. Thymectomy is to myasthenia as splenectomy is to ITP, immune thrombocytopenic purpura. The initial therapy doesn't work, get rid of the organ controlling the immune response. In this case, the thymus. The best initial therapy from myasthenia gravis is pyridostigmine or neostigmine. Neostigmine and pyridostigmine, which are simply longer-acting versions of edrophonium. Now, the problem is that these drugs don't stop progression of the disease. They just don't. They don't stop progression of the disease because the antibodies are still ripping up your receptors, but they are the initial therapy. Thymectomy and myasthenia. Just remember, this is a big deal if you have myasthenia and you're not controlled by these drugs. Getting rid of the thymus, thymectomy and myasthenia is like a splenectomy and ITP, and it's going to improve that recurrent hard-to-control disease, I promise. It works in 60 to 80%. So when do I answer thymectomy? If medications don't control the disease, and what I mean by medications is pyridostigmine, neostigmine, the most appropriate next step in management is thymectomy if they're under the age of 60 or 70. If they're over age 60, you can't teach an old T-cell new tricks, and you gotta find a different way to control those T-cells. So therefore, if they're too old for thymectomy, you use steroids while waiting for azathioprine cyclophosphamide or mycophenolate, which are used to get the patient off the steroids. And then you can lower the dose of prednisone. And that's what azathioprine and mycophenolate are used for in a lot of things. Immunosuppressives, and later you get them off the steroids. And this is a person who is life-threateningly ill, severe overwhelming disease, profound weakness, respiratory involvement, and just like Guillain-Barré, intravenous immunoglobulins or plasmapheresis, no combinations. Combo, no help. Hemolysis can be very challenging for people, but we're going to make it super easy for you, and you're going to get the answer to every question on all these hemolytic anemias. That's because all forms of hemolysis have an awful lot in common. There's a lot more in common than people think. They all cause a sudden decrease in hematocrit. They all cause an increase in LDH. LDH comes out of cells. You destroy cells of any kind, the cells release LDH. So anything that breaks down cells, whether it's heart or brain or muscle or red cells, cause a high LDH. That means a high LDH is irrelevant. A normal LDH really helps exclude hemolysis. You get an increased indirect bilirubin because newly released hemoglobin needs time to be recycled. And reticulocytes will go up. Now, it may need a couple days for the reticulocytes to go up, but they will go up in a day or two or three. And they all can decrease the haptoglobin. They all can. Even the extravascular ones, even the ones that are happening inside the spleen, can decrease the haptoglobin. Haptoglobin is a plasma protein that takes newly released hemoglobin and brings it around and recycles it in the system. Haptoglobin is like yellow taxi cabs that pick up all the people outside the theater on Broadway here, and they recycle them around to their homes and hotels. But it gets used up. Now, there's a slight increase in MCV, and that's because reticulocytes are slightly larger. If every cell in the body was a reticulocyte, the MCV would be about 120. However, since we're talking about just 10 or 20% reticulocytes, a reticulocytosis alone just brings up the MCV 5 or 6 points. Hyperkalemia can happen if it's really massive, because 95% of the potassium in the body is intracellular. Chronic hemolysis with chronic indirect bilirubin increase, with chronic saturation of indirect bilirubin, can cause bilirubin gallstones. You should expect to see that in sickle cell. Chronic hemolysis, you should expect to see that in spherocytosis. Sickle cell disease is extremely common. It is a chronic, well-compensated hemolytic anemia. As a medical student, it won't seem that way to you, but that's because you're seeing the 1% of people who are the most ill. You're seeing the person with sickle cell who's admitted, but there are many people living with sickle cell at home who are just fine. The reticulocyte count is always high. That's very important that you understand that a low reticulocyte count in sickle cell is extremely dangerous. You should look for a disease like parvovirus, because a person who has sickle cell disease should be living at a reticulocyte count of 5, 10, 15, 20. It should be 5 to 20 times higher. Painful acute vaso-occlusive crises can happen just any time. They can. They don't have to have a reason, but they're definitely increased by hypoxia. That's the whole fundamental illness. You see, sickle hemoglobin functions pretty normally at a normal oxygen level, but when they become hypoxic, they definitely sickle. Now remember, a sickle crisis is not a hemolytic crisis. It doesn't mean that all the cells are disappearing. It means they change in shape. Hypoxia changes that shape. Dehydration changes that shape. Infection, cold temperatures. Sickle cell is caused by one single point mutation at position 6 of the beta-globin chain. Valine replaces glutamic acid. This is one of the few mechanism questions asked on step 2. Just because it's step 2 doesn't mean you don't get a handful of mechanism questions, and this is one of them. So before I get a blood smear and electrophoresis, how will I suspect it or answer the most likely diagnosis of sickle cell? The answer is you're going to look for an African-American person with a sudden onset of pain in the back, the chest, the thighs, the back, the chest, the thighs, and they may have a fever. Now, we don't know why it's pain in thighs. It's just not clear, but we do know that that's the presentation. They may have fever, and that fever is extremely important, because if you have fever with sickle cell, you don't wait to give the antibiotics for the cultures. You got to give those antibiotics right away. They're going to die of sepsis. Jump on it. You can save somebody's life today. Now, it is rare for an adult to present with acute crisis without a clear history of sickle cell. That's being generous, actually. The short answer is it's almost impossible/impossible for you to get to adulthood without a history of clearly having sickle cell disease. Let's look at the complications of sickle cell, and you have to know these all the way. Bilirubin gallstones from high, chronic, indirect bilirubin levels. You get an increased infection because you got no spleen. If you got no spleen, you get encapsulated organisms. This is extraordinarily important because let's say you're on your medicine rotation now and you're using this modality for your shelf exam, as you should. And just as you go back to the floor because you sneak off into your call room to listen to this on your laptop or something, and you find that the person's got 101 fever or 102 fever and your resident, your attending missed it. You gotta stop what you're doing right now and page or call your resident and say, hey, listen, the sickle patient has 101 fever. We need to give antibiotics right now. They get osteomyelitis. And although Staph aureus happens, the answer is still salmonella. Yes, salmonella, because that's the published figure. That's it. Now, you don't have to agree with everything I say, but when it comes to your test on test day, just answer what I say. Even though you don't agree with it, it's still the answer. It's salmonella is the most common. Retinopathy happens because the sickle cells infarct the eyes. You get visual disturbance. The sickle cells actually infarct the eyes. They infarct the brain. That's why outside developed countries or in places where you don't have access to transfusion, all these little kids stroke out at the age of 5. Man, it's terrible because it infarcts the brain, infarcts the eye, and infarcts the bone. You get an enlarged heart, hyperdynamic features from the chronic anemia. You get a systolic murmur. Skin ulcers, this is particularly of the lower extremities happen. We're not clear why, but you do get them. And avascular necrosis of the femoral head happens because the sickle cells infarct that bone. Now this one's special. This is a point that changes the person from the 230 to the 260, from the 240 to the 270. Children with dactylitis. Children will present with dactylitis. Inflammation of the fingers. Not clear why, but you get it. The best initial test for that sickle cell disease is the peripheral smear. Look at those sickled cells. Look at those sickled cells. One of our own patients at Jamaica Hospital. And my very own chief resident there, here, because there's our own patient showing you, that's it. And they'll show you that smear. They'll show you that smear and say, that's it. Now, can a sickle cell smear, can that tell you the difference between the heterozygote and the homozygote? Can I tell you whether it's a trait or sickle cell disease for the smear? The answer is, yes, you can. Interestingly, if you thought no, that's very common as a wrong answer. See, sickle cell disease gives sickled cells. But trait, the heterozygote, is hematologically normal. You don't have sickle cells in trait, period. That's it. The most accurate test is a hemoglobin electrophoresis. Because trait will not give sickled cells, you have to do the electrophoresis to see if somebody's got a trait. Now those features on the previous slide of knowing that there's bilirubin gallstones and osteomyelitis and you can have a stroke and visual disturbance, you must know them to the marrow of your own bones. What's there? It's not going to change. Which of the following is found on a smear in the patient with sickle cell disease, the homozygote? The answer is Howell Jolly bodies. Howell Jolly bodies are a sign of autosplenectomized patients. If you got no spleen, you have Howell Jolly bodies in the red cells. Basophilic stippling is an unusual thing from little dots across the red cells with lead poisoning. Bite cells are when the Heinz bodies get bitten out by the spleen. That's a test you can do today in G6PD, glucose 6-phosphate dehydrogenase deficiency. These Heinz bodies get bitten out, removed. The schistocytes are fragmented cells that seen with intravascular hemolysis, such as DIC, TTP, HUS, and morula are seen inside neutrophils with Ehrlichia. Nucleated red cells are found with premature release of cells. It's like little child soldiers. It's the step just before reticulocytes is nucleated red cells. The initial therapy of sickle cell disease hasn't changed in many years. It is oxygen, hydration, and analgesia. Analgesia, of course, because the person's in tremendous discomfort. Oxygen is indispensable to reversing the cause of the sickle crisis because sickle hemoglobin is normal at normal oxygen levels. A fever or a white count higher than usual makes antibiotics indispensable. Ceftriaxone, levofloxacin, moxifloxacin. If it looks like the treatment for community-acquired pneumonia, that's because it is, because it's many of the same organisms. I cannot overestimate this, because this is where people are going to get their lives saved. Folic acid is in everyone because there's a chronic hemolysis. People are producing cells all the time, and they use up their folic acid. And cell production becomes like driving your car. In other words, the cells will continue to be made and made and made, and the folic acid used and used and used until, bing, it just runs out, and the car stops. So it's kind of like saying, well, the car was running until it stopped, and that's what happens with folic acid deficiency. It will continue to make cells until you just run out. So everybody's got to be on folic acid. Because they're autosplenectomized, you should get a pneumococcal vaccine from childhood, as a matter of fact, and you should get one revaccination 5 years after the disease is found. Hydroxyurea prevents recurrences by increasing hemoglobin F. Now, it doesn't increase hemoglobin F by like 40%, but just an extra 2 or 3 or 4% of fetal hemoglobin is enough to decrease the recurrences of crises. You use hydroxyurea if people have 3 or 4 crises a year or more. You don't use it on someone who has 1 crisis a year because, 1, it's hard to demonstrate a benefit. 2, in long-term use, hydroxyurea is associated with a risk of secondary malignancy. So you don't wait for the results of testing when you have a fever. You must start antibiotics. No spleen means overwhelming infection, means death. Save someone's life today. You're going to do it. We love in Step 2 High Yield to work backwards from the answers because there's less of them. There are many questions on your Step 2 test, but very few times where the answer is exchange transfusion. So work backwards from answers in all of your studying. It'll make it easier for you. Exchange transfusion is the answer when you have a severe vaso-occlusive crisis with acute chest syndrome, you're infarcting your lungs, priapism, stroke, or visual disturbance from retinal infarction, because these are the circumstances in which you've got to correct it instantaneously. Exchange transfusion or transfuse, get that percentage of sickle hemoglobin down. A patient with sickle cell crisis is admitted. 43-year-old man with sickle cell disease is admitted with a pain crisis. His only medication is folic acid. He is taking folic acid. His hematocrit goes from 34% and on the third hospital day drops to 22%. What is it? What's the test? This is parvovirus. But parvovirus, the first thing you do to see whether it's freezing that marrow is the reticulocyte count. Remember, the peripheral smear can't gauge the severity of hemolysis, and the peripheral smear doesn't help us here. We know the guy's got sickle cell disease. If he's on folic acid, there's no point doing a folic acid level right now. You see, folic acid causes aplastic crisis, which freezes the growth of the marrow, but he's on folic acid. Parvovirus suddenly freezes the marrow in people with hemoglobinopathies. And by the way, there's only parvovirus B19. There's no B1 through 19. There's no B12, for instance. There's no parvovirus A19, just B19. And it infects the marrow and freezes it and stops it. And what's the first cell that goes? The reticulocyte count. People with sickle cell disease should have 10 and 20% reticulocytes, and now it goes down to 1 or 2%. Now, these reticulocyte count should be done first, not the IgM level, because the IgM level takes time. Now, overall, the most accurate test for parvovirus is the PCR for DNA. But you're not going to do that first, because the PCR for DNA is the most accurate, because the actual organism. If the question should ask you the therapy, intravenous immunoglobulins is the best initial therapy. Bone marrow will show giant pronormoplasts, but it isn't better than a reticulocyte count at measuring the severity of hemolysis. We rarely do the bone marrow for parvovirus. To summarize, the only manifestation is that they can't concentrate their urine. That's called iso, meaning same, stenos, urine, same strength urine as the blood. This may seem like a small issue, but if you have a person who's admitted with diabetic ketoacidosis or hypernatremia or non-ketotic coma, it's a big deal. It means you're not able to concentrate that urine. Now remember, patients with trait are hematologically normal. They have normal CBCs, normal smears. And just because they have a little hematuria in the urine does not mean that they have any hematologic manifestations, and there's no treat for sickle cell trait. There's no treatment for trait. Hereditary spherocytosis is a genetic defect in the cytoskeleton of red cells. You see, red cells have a biconcave disc. That's not exactly a natural shape. There's no natural shape in the world. There's a biconcave disc hollow in the center. It has to be forced into it. It needs a skeleton, ankyrin, and spectrin. Force it into that shape. So if you don't have that cytoskeleton, it leads to an abnormal shape, which is round. So that means you also lose the flexibility. See, red cells have a tremendous flexibility to get around corners, go through the spleen, go around narrow vessels, squish themselves through capillaries. But if you have spherocytosis, if you've lost the cytoskeleton, if you have an abnormal round shape, you lose the normal flexibility characteristic of biconcave discs that allows red cells to bend in places like the spleen or the blood vessels. And the problem with this is they get crunched in the spleen. What is the answer to the most likely diagnosis question, spherocytosis? You're going to look for recurrent episodes of hemolysis in a young child or a newborn. The patient has intermittent jaundice. They have a big spleen because that's where the cells are getting crunched up. And there's a family history, usually, of hemolysis and anemia and bilirubin gallstones because there's a chronic hemolysis leading to chronically elevated levels of bilirubin. So this is not going to be a one-time deal, and also because it goes on for a long time, the spleen has time to enlarge. When you have a single episode of hemolysis, let's say autoimmune hemolysis from penicillin, you don't have time for that spleen to get big. But it does get big when you have spherocytosis, and there's time for it to enlarge. The cell size is a little small in spherocytosis, a slight microcytosis. This is because the abnormal cytoskeleton makes the cells lose volume. They actually lose a little liquid. They become a little dry in a way. That's why the cell size goes down. Now, MCV is a volume. It's not just a shape. In other words, if it was a totally normal volume and you just squished it into a ball, it wouldn't be a low MCV. The MCV measures the total volume of the cell. It's because there's an increased mean corpuscular hemoglobin concentration. And I must tell you, this is an indispensably important feature because this one feature alone will allow you to answer what is the most likely diagnosis. Each red cell has more hemoglobin than it's meant to have. So there's an increased MCHC. The Coombs test negative tells you, hey, we don't have autoimmune hemolysis. And the other reason this is important is because most people don't know that autoimmune hemolysis also gives spherocytes. Did you know that? Because the antibodies grab a piece out of the red cell membrane and make the cells a little small and spherocytic. The most accurate test is osmotic fragility. This means that when you place cells in a hypotonic solution, they burst. Normal cells that are placed in a slightly hypotonic solution should be able to swell a little bit, but these don't. They go pop. Spherocytosis simply needs chronic folic acid replacement because it supports the red cell production. If people have really bad disease, you need to remove the spleen. The spleen is the site of where the red cells are destroyed. You don't get rid of the spherocytes, but splenectomy stops the hemolysis. Even if it doesn't eliminate the spherocytes, it does stop the destruction. Autoimmune hemolysis can also be known as warm or IgG hemolysis. Although we see it from penicillin and sulfa drugs, allopurinol, phenytoin, and rifampin, half the cases are unknown. See, clear causes are things like CLL. Those lymphocytes make abnormal antibodies. Lymphocytes in CLL are not just a large number of normal cells. They make antibodies that are ineffective, so they don't fight infection. They make antibodies that are dangerous. They attack your own body, like hemolysis. Or they just don't make antibodies at all and you die of an infection. Lymphoma is the same thing because, after all, a CLL is a liquidy lymphoma, and a lymphoma is a solid CLL. In lupus, the lymphocytes also are either making antibodies that are not effective. They're not fighting that pneumococcus. The lymphocyte's supposed to be like a cop in the corner. Hey, fight that infection, fight that criminal, but it doesn't. Or what's worse, it attacks you, the normal person. Drugs such as penicillin, sulfa drugs, allopurinol, alpha-methyl-dopa is a drug we don't use at all anymore. It's safe in pregnancy, but we don't routinely use that as a blood pressure medication, but it does show up a lot as a cause of hemolysis on Step 2 Usmle exams. The most accurate test is Coombs test, which detects IgG on the surface of those red cells. And the direct and indirect tests basically tell you the same thing. The indirect is associated with greater amount of antibody because indirect basically means that there's so much antibody, there's some left circulating around in plasma that can adhere to new cells left in or thrown into the mix. But Coombs' test is basically a test of seeing whether the cells agglutinate with IgGs on their surface. It's the most accurate test for autoimmune hemolysis with IgG. With IgG. Not the IgMs, but the IgG. Now remember, the autoantibodies can remove a small amount of the red cell membrane. It can make the membrane smaller, and it could force it to become round. Biconcave discs have a much greater surface area than a sphere. That's good, so it can take up carbon dioxide and get rid of oxygen. But autoimmune hemolysis is also associated with spherocytes as we force the cell into being somewhat smaller. The smear in autoimmune hemolysis will not show fragmented cells because the destruction occurs inside the spleen or the liver. It's not inside the blood vessel. It's extravascular, and extravascular means spleen and liver. The best initial therapy is steroids, glucocorticoids. And now, what happens if there's recurrences? You stop the steroids and it comes back, and you start the steroids again and it gets better. It stops the steroids and it comes back. You got to remove that spleen. Now, when the question describes somebody who gets a person with steroids and they continue to hemolyze, and you give them transfusion, you give them steroids, and they continue to hemolyze, severe acute hemolysis not responding to prednisone is controlled with intravenous immunoglobulins, and rituximab is sometimes used when splenectomy won't control the hemolysis. Rituximab gets rid of the lymphocytes that make the autoantibodies. Steroids in the long term can be deforming, so we need alternate treatments for that. Steroid cyclophosphamide calms down that immune system. Cyclosporin gets rid of those T cells. Azathioprine, 6-mercaptopurin, and mycophenolate mofetil all help control that immune system. Our next section is cardiomyopathy and pericardial disease. Dilated cardiomyopathy is very similar to the systolic dysfunction, congestive failure in the previous section, so this will be easy. Hypertrophic cardiomyopathy from hypertension, restrictive cardiomyopathy, and acute pericarditis. All the things that cause acute pericarditis can also cause tamponade if they make fluid, and if they're chronic and cause fibrosis, they become constrictive. A cardiomyopathy literally means the abnormal function of heart muscle. It means that the heart is not contracting in a normal fashion. And although there are frequently valve and auscultatory abnormalities, the major origin of the problem is that the muscle itself is diseased. So it's a muscle problem leading to a valve problem, not the valve problem leading to a muscle problem. Cardiomyopathies can be dilated, hypertrophic, restrictive. The term dilated cardiomyopathy, systolic dysfunction, low ejection fraction are often used interchangeably. Hypertrophic cardiomyopathy is interchangeable with diastolic dysfunction or cardiac failure with a preserved ejection fraction. This is why all forms of cardiomyopathy lead to shortness of breath, particularly worsened by exertion. They can all cause backflow of blood, leading to edema from increased hydrostatic pressure in the blood vessels. They all cause congestion in the lungs, leading to rolls on exam, sometimes called crepitations, worse in the bases than in the apex, and all lead to jugular venous distension in severe and especially in decompensated cases. All forms of cardiomyopathy, the most accurate test that we use. And EKG and chest x-ray, although they should be performed, there's really nothing specific on them that confirms a diagnosis. You can't really look at a EKG and go, that EKG definitely shows cardiomyopathy. Impossible. There's nothing on an EKG that can tell you that that EKG shows cardiomyopathy. There's things on the EKG that can show, well, you had an old infarction or you have hypertrophy, but you can't tell symptoms from it. You can't tell wall motion from it. You can't tell wall motion from an x-ray. It might be dilated, but you can't tell how it moves. You're going to look for murmurs that are not increasing with expiration, such as HOCM or mitral valve prolapse as well. The best initial therapy for all forms of cardiomyopathy is a diuretic. That's because we're not talking about hypertrophic obstructive cardiomyopathy. That hypertrophic obstructive cardiomyopathy doesn't get treated with the diuretic because hypertrophic obstructive cardiomyopathy, the obstruction increases. The other treatments and what else you'll do and what it says as the next best step after the diuretic is based on, well, which type of cardiomyopathy is it? Fundamentally, in terms of different answers, the only difference is the management question, the answer to the question on treatment. That's it. Shortness of breath is the same on all of them. EKG and chest x-ray are non-specific on all of them. Echocardiogram is the most accurate on all of them. So what's different? Treatment. Now to go one step further, in addition to myocardial infarction and ischemia, because MI and ischemia make everything dilate. Infarction leads to dilation. But in addition to infarction and ischemia, which make it dilate, because dead things dilate and don't move, dilated cardiomyopathy is also from alcohol, because it's a direct poison. The alcohol poisons and pickles that heart, just doesn't move. And many of them are viral myocarditises that were never really diagnosed. We presume that they're viral myocarditis. Radiation can do it, although it's rare. Toxins are obvious from the history. Nobody suddenly shows up with doxorubicin or adriamycin-induced cardiomyopathy. They know it. They took doxorubicin and adriamycin. They had chemotherapy. They had lymphoma. They got their chest radiated. It's not like it's a surprise. You can see it in the history. It has to be in the history. If someone goes home and takes doxorubicin and they didn't tell you, you would never be able to figure it out. You can't do a blood adriamycin level. It's in the history. Chagas disease does it because that infection infects the heart valve. It's very rare in the United States. And once again, they'd have to tell you. They'd have to tell you that the person traveled. They'd have to tell you they went to Brazil. It would have to be in the history. The presentation of physical finding, shortness of breath, and S3 gallop, edema, the tests are all the same as what we did in the CHF section. The only good thing about having dilated cardiomyopathy, as opposed to the other forms of cardiomyopathy, is that you have multiple medications that can decrease mortality. No, it's not good to have a disease, but it's good to have a disease you can do something about. Vasodilators are good. ACE inhibitors are vasodilators that are even gooder because they decrease the pressure work of the heart. Now, what's more costly to the heart for myocardial oxygen consumption? Is it pressure or is it volume? Well, pressure work is more costly. That's why these drugs really lower mortality, because they decrease the pressure work and the myocardial oxygen consumption. Now, both of them are class effects. That means whether it's captopril, enalapril, ramipril, fascinolopril, amipril, they're all okay. And in terms of ARBs, valsartan, losartan, irbesartan, candesartan, telmisartan, anisartan, all okay. Beta blockers is different. Atenolol is not good. Atenolol. Metoprolol, carvedilol, bisoprolol are the beta blockers proven to lower mortality in dilated cardiomyopathy. And this question will be very specific for you. It'll say a person's on an ACE or an ARB and on a beta blocker and say which of the following is most likely to benefit this patient. The right answer will be spironolactone or eplerenone. The wrong answers will be diuretics and digoxin. Diuretics and digoxin are good because they control symptoms and make you less short of breath. Digoxin decreases the frequency of hospitalization. Digoxin decreases the frequency of hospitalization. But that's different than saying it adds years to your life. The most common source of confusion is using spironolactone because we think it's in a diuretic dose. We're not giving it as a diuretic. We're giving it to be an aft load reducer and to decrease the renin-angiotensin-aldosterone system. A patient is on an ACE inhibitor or an ARB, a beta blocker, and spironolactone, they have the use of diuretics and digoxin, and they're still symptomatic. They're still short of breath. What is the next best step in the management of this patient? Because if you have all of those therapies and you're still short of breath, well, we want to try and keep you off of the cardiac transplant list. What else can you do? The wrong answer is warfarin. The wrong answer is combining ACE and ARBs. Combo ACE and ARBs is no good. If there's a wide QRS, the answer is a biventricular pacemaker, both ventricles at the same time. They increase survival, decrease symptoms, and you can also use the implantable defibrillator because the biventricular pacemaker also has implantable defibrillator function, which definitely lowers mortality. The biventricular pacer decreases symptoms. People get off that table and they walk home. It's amazing what the synchronization will do. And the implantable defibrillator keeps you alive. MCC means most common cause. The most common cause of hypertrophic cardiomyopathy is high blood pressure. Now, you have to distinguish for sure between HOCM and HCM. Hypertrophic obstructive cardiomyopathy is colossally different. Hypertrophic obstructive cardiomyopathy causes syncope and sudden death. Hypertrophic cardiomyopathy is just a reaction to high blood pressure. The heart hypertrophies carry the load, law of Laplace. The thicker the wall thickness, the less the load. The thicker the wall thickness, the less the load. And the problem is that this is a person who has difficulty relaxing in their heart. And they can't relax, they can't receive blood. They can't receive blood, they can't pump blood forward, and the patient becomes short of breath. Hypertrophic obstructive cardiomyopathy. Genetic disorder, familial disorder, it just happens. It's an abnormal shape of that septum. The septum bumps up against the other parts of the heart because it's asymmetrically hypertrophied. That's one of the names of it, asymmetric septal hypertrophy. And you can see the arrow is showing you an obstructed left ventricular outflow tract. That's why anything that makes the heart smaller increases the obstruction. Anything that causes a tachycardia will make the heart smaller. That's why when you exercise, dehydrated diuretic, exercise, dehydrated diuretic, anything that empties the heart, like digoxin or ACE inhibitors, increase the obstruction. All forms of hypertrophic cardiomyopathy can have an S4 gallop. S4 gallop is atrial systole against a stiff, non-compliant ventricle. Boom! It hits with a boom! It hits with a boom! It hits with a boom! 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 Instead of a nice relaxation. Now, there's less signs of right heart failure and hypertrophic cardiomyopathy, less ascites, and less enlargement of liver and spleen, because you see, hypertrophic cardiomyopathy is really hypertrophic cardiomyopathy, the left side of the heart, not the right. That's why there's less ascites and less enlargement of the liver and the spleen. Because ascites, liver, and spleen are signs of right heart failure. Hypertrophic obstructive cardiomyopathy. The most common presentation is still shortness of breath. It is. The most common presentation is not sudden death. You can get some chest pain. You have syncope, lightheadedness. But sudden death, particularly in athletes, is a very unusual finding. It's the most common wrong answer. Which of the following is the most common presentation? It's not sudden death, but it does occur. It's worsened by an increased heart rate, because anything that increases the heart rate, such as dehydration, exercise, diuretics, all these things are going to make the heart chamber smaller. That increases the obstruction because it empties the heart. That's why ACE inhibitors and ARBs, hydrolysine, Valsalva, standing, empty heart, whether it's decreased filling with Valsalva and standing, decreased filling or increased emptying, the heart is emptier and there's more obstruction. As it is in all valvular and all cardiomyopathy diseases, the best initial test is an echocardiogram. Again, follow the same pattern of transthoracic echo. First, transesophageal echo is more accurate. The septum should be unusually thick, more than 1.5 times the thickness of the posterior wall. And systolic anterior motion of the mitral valve, basically the mitral valve with the obstruction sort of gets sucked into the wrong direction. Gets sucked anteriorly and helps contribute to the obstruction. And catheterization may be the most accurate test, but is again rarely necessary for a specific diagnosis. The EKG is going to show left ventricular hypertrophy, and although it could even be normal, if you have an abnormal echo and a normal EKG, go with the echo. Always go with the echo. Septal Q waves are not here a sign of infarction. They're not. Q waves, everything else would be a sign of infarction. But in HOCM, they're not a sign of infarction. They're simply a sign of an abnormal septal thickening. The best initial therapy for patients with hypertrophic cardiomyopathy and hypertrophic obstructive cardiomyopathy is a beta blocker. Now, for the first 40 years they were used, we thought the most important feature was that they were negative inotropes. Well, it turns out that the most important feature is that they slow the heart rate. When you slow the heart rate, you allow an increased diastolic filling time. So if you go from a heart rate of 90 to a heart rate of 60, you have given a 50% increase in diastolic filling time. That's really useful because they really help. Now, diuretics help hypertrophic cardiomyopathy because it's a fluid overload state, but diuretics harm HOCM because they increase the obstruction. Spironolactone, digoxin are basically not helpful in hypertrophic cardiomyopathy. That's one of the reasons you have to do an echocardiogram in everyone who's got congestive failure, because you ultimately just can't tell who's got which type of cardiomyopathy. The implantable defibrillator is for people who have the HOCM, the obstructive cardiomyopathy, and develop syncope. Beta blockers, syncope, gets the implantable defibrillator. Well, what would you do next if they continue to have symptoms? Then the next best step in the therapy is ablation. Cut it out. Ooh, cutting it out is very difficult. Let's try a catheter in there first. Catheter to ablate the septum. The catheter. Put absolute alcohol in the septum. Put little micro infarctions. Basically just kill off little parts of it. Just kill off little parts of it so it gets smaller. And then if the symptoms persist, you'll do a surgical myomectomy. But surgical myomectomy is definitely only when the other procedures fail. Now, you don't have to be a mind reader on step 2. They have to tell you. They have to tell you they got symptoms despite beta blockers and despite the implantable defibrillator that had syncope and despite the ablation with the alcohol. They continue to have shortness of breath and lightheadedness. Surgical myomectomy. Because you can't do ACE inhibitors or diuretics. You can't use in HOCM the blockers. Well, they both get diuretics. And remember, we mean hypertrophic cardiomyopathy, not labeling it hypertrophic obstructive. And in terms of ACE inhibitors, they unclear benefit in hypertrophic cardiomyopathy. Unclear benefit in hypertrophic cardiomyopathy. Definitely beneficial and dilated. The biggest clear differences is that spironolactone doesn't help hypertrophic cardiomyopathy, but spironolactone definitely helps dilated cardiomyopathy, and digoxin doesn't help hypertrophic cardiomyopathy, and digoxin may not lower mortality in dilated, but it certainly decreases symptoms, so it helps. Wow, at least I'm glad I don't have a restrictive cardiomyopathy because it's got the worst aspects of dilated and hypertrophic. A dilated cardiomyopathy may not be able to contract, but at least dilated can relax. But restrictive can't. Hypertrophic cardiomyopathy may not be able to relax, but at least it can contract. But restrictive doesn't. Restrictive cardiomyopathy neither contracts nor relaxes. It's just immobile because of infiltrating substances, making it just freeze. Which of the following is the most likely diagnosis? Let's look for some things in the history. Do you have a history of sarcoid, amyloid, hemochromatosis, cancer, and fibrosis, scleroderma fibrosis? Well, these are all things: sarcoid, amyloid, hemochromatosis, cancer, and fibrosis, that simply make it that the heart does not move. The heart does not move. You treat the underlying cause. And if, like something like endomyocardial fibrosis, you really can't treat the underlying cause, well, then you really can't treat the restrictive cardiomyopathy. And all you can give is diuretics for symptomatic control. That's not very satisfying, but it is the answer. It would be very hard for you to detect restrictive cardiomyopathy simply from a presentation. And that's because fundamentally the presentation of shortness of breath, right heart failure, ascites, edema, and JVD, a big liver and a big spleen, is simply not enough to be able to say it's restrictive cardiomyopathy. Now, the right heart failure, where the right heart doesn't fill with ascites and edema and JVD, is certainly more unique to restrictive cardiomyopathy, but by itself it's not enough, not even the presence of pulmonary hypertension. Now, the single most specific physical finding is Usmle sign. Usmle is increase in jugular venous pressure on inhalation. That's certainly the most unique of the physical findings. It's in constrictive pericarditis as well, but in terms of cardiomyopathy, it's the most unique finding for the restrictive cardiomyopathy. The best initial test is the echocardiogram. The ejection fraction will be normal sometimes. Occasionally it's elevated. The EKG shows nothing specific. Low voltage, low voltage. Obese people can have low voltage, and barrel chest and fat people and people with large breasts can have low voltage, and pericardial tamponade and effusion can have low voltage. It just means that the impulses are not able to transmit through too much, but that's pretty nonspecific. Amyloidosis does have a very specific echo finding, and this is important. Bum, 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 bum. Amyloid will find on the echocardiogram. On the echo, you will see speckling pattern, speckling. Like glass, like light going through crystals, speckled. The most accurate test is frankly rarely if ever done, and that's an endomyocardial biopsy. That's rarely if ever done, but is the most accurate. Rarely done, but is the most accurate, because you can make your diagnosis by taking samples elsewhere, other tests. The best initial therapy: treat the underlying cause. Diuretics will help decrease the fluid overload, decrease some pulmonary hypertension, decrease the ascites and the edema, but there's no other clear therapy. You gotta give steroids for the sarcoid, and you gotta do phlebotomy for the hemochromatosis, and you gotta give a person with eosinophils some steroids too, but there's no other really specific therapy just to say restrictive cardiomyopathy. I'm sure a number of you are very high-functioning people that got this on the first time. But in my experience, auscultatory maneuvers, let's repeat it. Let's make 100% sure. Squatting and leg raise. Squatting, you go from a standing position, squat, and squeeze your leg vein, squeeze your leg vein. Same as leg raising. More blood returns to the heart and will increase both mitral and aortic stenosis. Standing opens the venous capacitance vessels. Valsalva decreases venous return. Exhalation against the closed glottis and will decrease both of them. Less blood, less murmur. And these same findings will occur in regurgitant lesions. More blood, more murmur. Less blood, less murmur. Mitral valve prolapse is quite simply knowing it is the opposite, and so is HOCM. Less blood, less murmur. More blood, more murmur, except for mitral valve prolapse and hypertrophic obstructive cardiomyopathy, where a smaller, emptier heart makes more murmur. More blood increases the intensity of all those murmurs but not mitral valve prolapse or HOCM. Less blood decreases all the murmurs except mitral valve prolapse and HOCM. And this is very simple why we're being repetitive on this. If you actually said, hey, Conrad Fisher, what is the most frequently asked auscultatory question on step 2 CK? Conrad Fisher says, the two things in front of you right now. When you stand from a squatting position, it opens the leg vessels. It simply makes it so the blood can't go up into the heart. You could pool a liter in each leg if you open up those leg veins. If you stand for half an hour without moving at all, you're going to be lightheaded. Valsalva does the same thing simply by increasing intrathoracic pressure and makes it so heart is just simply empty. And when you have decreased heart filling, you have less murmur, with the exception of those two lesions, mitral valve prolapse and HOCM, which increase. The auscultatory maneuvers, you see, they simulate the treatment. So if you have a lesion that gets better with diuretics, like aortic regurg, mitral regurg, aortic stenosis, mitral stenosis, if you have a lesion that gets better with the use of diuretics, then standing or Valsalva will make it better. Stenotic and regurgitant lesions all are treated with diuretics and salt restriction. That's why standing and Valsalva will improve them. That's why mitral valve prolapse and HOCM, which worsen with diuretics, because diuretics will make the left ventricular size smaller. That's why diuretics worsen mitral valve prolapse and worsen the obstruction of HOCM, and standing and Valsalva will worsen them. Hand grip, squeezing the muscles of the arm, squeezes the arteries of the arm, which increases afterload. The contraction of those arm muscles compressing those arteries will decrease emptying of the heart. It is the opposite of an ACE inhibitor. Since aortic regurg and mitral regurg get treated with an ACE inhibitor, hand grip will worsen them because it prevents blood from getting out of the heart. It pushes the blood backwards. It makes it worse. The maneuvers follow the treatment. The treatment follows the maneuvers. Amyl nitrate is rarely, if ever, done clinically. It acts as a direct-acting arterial or vasodilator, but the question that says, do you understand the auscultatory maneuvers with amyl nitrate is still important. It decreases afterload by being a vasodilator. It simulates ACE inhibitors or ARBs in the heart, and valvular lesions that get better with ACE or ARBs will get better with amyl nitrate, and therefore, since aortic regurgitation and mitral regurgitation get better with ACE inhibitors to increase the forward flow of the blood, amyl nitrate will improve them, and that is why amyl nitrate will worsen mitral valve prolapse and hypertrophic obstructive cardiomyopathy. We'll do the opposite. Hand grip is a fuller left ventricle. Amyl nitrate, like an ACE inhibitor, is an emptier left ventricle. That's why, in summarizing the effect of hand grip and amyl nitrate, we can see that these are clearly the opposite. We can see that mitral stenosis, the same way that there's no effect of hand grip, there'll be no effect of amyl nitrate. And there'll be no effect because mitral stenosis is not affected by ACE inhibitors or ARBs. Because ACE inhibitors and ARBs affect ventricular emptying. And mitral stenosis is a problem with ventricular filling. Aortic regurg is a problem with ventricular emptying. That's why hand grip will push it backwards and make it worse, and amyl nitrate will help it go forward because it's like an ACE inhibitor. And the same with mitral regurgitation. It follows it precisely. Now, if you weren't already clear, mitral valve prolapse does the opposite. HOCM does the opposite. Get it through the head. Hand grip and amyl nitrate have no effect on mitral stenosis in the same way that ACE inhibitors have no meaningful effect on mitral stenosis. For our next section, pericardial diseases. Now, pericarditis, pericardial tamponade, and constrictive pericarditis overlap because the etiology of them overlap. You see, if you have a cause of pericarditis that extravasates a ton of fluid, then you're going to get tamponade because that fluid can compress the heart. And if the pericarditis causes chronicity and time for it to fibrose and calcify, then that pericarditis can cause constrictive pericarditis by making it fibrose into constriction. That's why any infection, although virus is the most common as a cause of pericarditis, and any inflammatory disorder or connective tissue disorder, although lupus and uremia are the most common, and any chest wall trauma or cancer near the heart can cause pericarditis. Which of the following is the most common cause? And the answer is virus. Although lupus is the most common connective tissue disorder to cause pericarditis, any of them can do it. Wegener's granulomatosis is a vasculitis that can do it. Goodpasture syndrome causes inflammation of the lungs, and rheumatoid arthritis causes vasculitis, and polyarteritis nodosa, and Churg-Strauss syndrome, and microscopic polyangiitis, and any cause of vasculitis can inflame the heart, make it upset and angry with you, and cause pain, and cause pericarditis. The cool thing about pericarditis is that you have a very clear presentation of sharp chest pain that changes with respiration. That gets worse when you take a deep breath in and changes with bodily position. It's better when I sit up and worse when I lie down. Better when I sit up and worse when I lie down, because when I sit up, I relieve stretch on the pericardium. When I lie back, I stretch the pericardium. And that's why answering the question, what is the most likely diagnosis, is much easier with pericarditis. The best initial test for pericarditis is an EKG. You see ST segment elevation everywhere, just about in almost every single lead. And PR segment depression is the single most specific finding. And look at the nice blue arrow showing the ST segment elevation everywhere. And look close for the PR depression, because that's going to really help you. And it is unique, the PR depression. Which of the following is the best initial therapy in the management of pericarditis? Number 1, treat the cause. Except it's idiopathic most of the time, so you can't treat the cause. So we treat it symptomatically. Therefore, the best initial therapy of that Coxsackie B virus, which is idiopathic, is non-steroidal, such as ibuprofen or naproxen, which should make most people get better. Colchicine decreases recurrences. That's new. Colchicine is to decrease recurrences of pericarditis. The same way that any pneumonia can cause a pleural effusion, any cause of pericarditis can extravasate enough fluid to cause tamponade. Well, why do we say tamponade, not tamponade? Why do we drink lemonade and treat tamponade? And that's because lemonade is not a French word. See, tamponade means to compress something. And that's fluid compressing it, and the fluid starts to compress it on the right side simply because the walls are thinner. That's why the right side, the right atrium, the right ventricle will collapse before the left atrium and the left ventricle. And if you get as little as 50 milliliters of fluid acutely, it can cause tamponade. But if it accumulates slowly, you can get liters of fluid in that pericardium because it gives it time for it to stretch. But if it's from trauma, it doesn't have time to stretch, and you need to get that blood out of there in a big super emergency with a thoracotomy and a needle. The reason why this question, what's the most likely diagnosis, is so indispensably important in tamponade is that you often have to know it's there so you can say, hey, I need my echo now. It's the middle of the night. Give me an echo this second. So you know you have to recognize it from hypotension, tachycardia, distended neck veins, hypotension, tachycardia, distended neck veins, clear lungs too, because congestive heart failure and pulmonary edema gives you hypotension, tachycardia, and distended neck veins. But pulmonary edema gives you pulmonary edema. And here the lungs are clear. And you may have to even put a needle in someone's chest for pericardiocentesis. But that question, which of the following is the most specific physical finding, is critically important. The most specific physical finding for that tamponade is the pulsus paradoxus. Pulsus paradoxus is defined as a decrease in blood pressure of greater than 10 millimeters of mercury upon inhalation. When you inhale, you increase venous return to the right side of the heart. In the normal person, the entire heart simply increases in external diameter, just gets bigger. But if your heart is compressed, and it's like living in a really small studio apartment in Queens, and 3 fat people move into your apartment, it displaces the left ventricle. That's what it's like in pulsus paradoxus. It's being compressed, and therefore it shoves over the left ventricle, and you get hypotensive. That's what pulsus paradoxus is. There's increased venous return at the expense of the left ventricle. It compresses, gets smaller, blood pressure drops. Pulsus paradoxus, very big deal, because it's the indication for the emergency pericardiocentesis. That is a truly, truly beautiful picture of a massive pericardial effusion. And I know that because it's my own resident and my own picture of my own patient in my own hospital. And that gray stuff is the pericardial fluid. You can even see the cool septum going diagonally across the middle of the heart. The heart is the part with the white stuff. The septum is the darker thing crossing in the middle. And the big black arrow points to the pericardial effusion. And that's a beautiful picture of pericardial effusion. You can't tell it's tamponading from a CT. You can tell it's tamponading from a pulsus paradoxus or from the echocardiogram, but not from the CT itself. The EKG most of the time in tamponade just shows tachycardia. But electrical alternans, sometimes hard to tell apart from the normal respiratory beat-to-beat variation. You see, when you have a heart that is swimming in that big puddle of fluid, and the heart flops backwards and forwards and backwards and forwards and backwards and forwards, when the heart moves forwards, the complexes get big. When the heart moves backwards, the complexes get small. And that's because where are the EKG leads? Are they in the anterior, the front of the chest, or the back? Well, they're in the front. I never saw an EKG put on someone's back. Even when they're lying on their stomach, I never saw it happen. So since the EKG leads are on the front, when the heart flops forward, it's closer to the EKG leads, and the complexes are bigger. When the heart moves back, it's further away. Complexes smaller. Electrical alternans is an essential feature of pericardial tamponade. The chest X-ray can find in a pericardial effusion that has been present for some time, a few days to a few weeks, an enlarged globular heart expanding in both directions. Emergency tamponade will not show this because you need time for the pericardium to stretch. The right atrium and the right ventricle will show diastolic collapse. As the heart is relaxing, the tamponade fluid will squish it. Right heart catheterization is the most accurate test with equalization of pressures. I didn't say I'd do it, but it is often the most accurate test, although we use the echo day to day most of the time. A 78-year-old man with lung cancer has several days of increasing shortness of breath. He's lightheaded. He's hypotensive a little bit, but he's tachycardic and his blood pressure drops. And you can see that there's clear lungs, tachycardia, hypotension, distended neck veins, and most importantly, it drops by 14 points of systolic pressure on inhalation. 14 points. What's the most appropriate to confirm this diagnosis? And the answer is most appropriate. Well, that's a tough question, isn't it, sometimes? What does it mean, appropriate? It means accurate enough, but not having to put a catheter in them. That's what it means. See, the echocardiogram will show right atrium, right ventricular diastolic collapse. The EKG is okay, but low voltage is pretty nonspecific, and electrical alternans, obviously, too rare. So what we want you to know is we want you to say, although the chest X-ray may show dilation in the globular heart later on, well, you can't count on that today. It needs time. It's still not as specific as seeing right atrium, right ventricular diastolic collapse. Catheterization may be good, but you know what? I need to know right now. And the other thing is, we just simply don't need to put needles into people's chests and catheter inside them when the echo simply can show it much easier. And cardiac MRI, honestly, is not right for anything at this time. Even if your attending said just today, oh, y'all always doing a cardiac MRI, It's a Usmle, not a my attending who writes my evaluation MLE. Cardiac MRI is unclear at this time for when it is ever the right answer. The emergency treatment for tamponade is unquestionably that pericardiocentesis needle. The needle rapidly expands the heart, and that's because at 50 mLs acutely will compress that heart. Removing 50 mLs acutely will allow that heart to re-expand. IV fluids is incredibly important because the most common wrong answer is you see someone who's short of breath and you incorrectly say diuretics. Diuretics in a little bit of tamponade will kill the person because it will allow the right atrium and the right ventricle to collapse even more. Long-term therapy requires a hole, but that's not very precise. The window is a poetic way for saying a hole into the pericardium to prevent recurrences, to treat recurrent cases. And diuretics, I cannot overestimate how dangerous that is if you make that mistake. Diuretics will kill somebody. And let us point out at this time that if you think there's a difference between the questions you get wrong on your Step 2 practice questions and the patients you might harm as a doctor next year, you're wrong. You're wrong. It's medicine. It's not just a bunch of questions. It matters. Constrictive pericarditis is a rare and unusual entity. If you're not around people who have tuberculosis, you may never see it. It prevents filling of the right side of the heart, and tuberculosis is frankly one of the only causes because viruses don't cause it because they're not chronic, and uremia doesn't do it because we have dialysis and we simply correct the cause. But tuberculosis, particularly in immigrants from endemic countries, is probably the single most common cause of a constrictive and fibrotic pericarditis, and you can see it definitely on the scan of the chest. What is the most likely diagnosis on constrictive? The heart can't fill. The heart can't fill. And I get edema because the heart can't fill. The heart can't fill and it backs up in myositis because the heart can't fill. The heart can't fill and it backs up in my liver and a big liver and a big spleen and a big hemorrhoids and jugular venous distension. And constrictive pericarditis gives several of these signs because the heart can't fill. Calcification on a chest x-ray and chest CT confirm the diagnosis. Which of the following physical findings is most likely to be found in this patient? And the answer is small sign. What happens to your neck veins when you inhale? What happens to a normal person when you inhale? Does your neck vein go up or down? And you can't feel them, so take your hand off your own neck. You see them. A normal person's neck vein should go down when you inhale. But in constrictive pericarditis, they go up. It's an increase in jugular venous distension on inhalation because normally those neck veins should go down. There's also pericardial knock, knock, knock. It can't fill. Filling, 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 filling. When it fills up to its maximum, it knocks. I know you couldn't hear what I was saying because of that knocking sound as your mind was filling up with knowledge. Oh, this is beautiful picture of calcification of constrictive pericarditis. Look at that white line. Look at that beautiful picture. And here it is on the lateral. And look at that beautiful picture of the constrictive pericarditis as the line of calcification goes around the heart. Isn't that wonderful? When I lean closer to the computer, I bet you can hear the knock right now just by looking at that picture. Constrictive pericarditis is an anatomic disease. It has an anatomic test, an x-ray, and a CT, or an MRI. It has an anatomic treatment, which is to remove it. The echocardiogram is okay, but the myocardium moves normally, and it more or less excludes other diseases. It's not so much the echo diagnoses it, as it excludes myocardial disease. Constrictive pericarditis is an anatomic disease. It has an anatomic presentation. Big edema, big liver, big spleen. It has an anatomic test, X-ray, CT. It has an anatomic treatment. Remove it. There's just no good medical therapy for constrictive pericarditis. Diuretics will decrease the fluid overload that's in people's edema and in their liver and their spleen and decompress the filling of the heart, but you can't diurese your way out of a constrictive pericarditis. You can't diurese your way out of calcification. Pericardial disease, viral pericarditis, is a functional disease, electrical function. You have a functional presentation, pain that's positional pleuritic and positional pleuritic. You have a functional unique finding called pericardial rub. You have a functional test for pericarditis called ST elevation, electrical function, PR depression. You have a functional treatment called anti-inflammatory function. Steroids if it doesn't work. Colchicine to prevent recurrences. It's a functional disease, electrical function. Tamponade is a hemodynamic disease. You have fluid extravasating from infection or cancer or inflammatory diseases, and you have a hemodynamic presentation with tachycardia, hypotension, extended neck veins, tachycardia, hypotension, extended neck veins. It has a hemodynamic test, the echocardiogram, looking for fluid pressing on the right side of the heart. A hemodynamic test, most accurately with catheterization, equalization of pressures, even if it's rarely done. You have a hemodynamic therapy, which is pericardiocentesis. A hemodynamic therapy, put a window and drain it. And constrictive pericarditis is an anatomic disease. Big liver, big spleen, big organs, big ascites, an anatomic test, which is an X-ray, a CT, and an MRI, an anatomic treatment, which is to surgically remove it. Pericarditis hasn't changed in 50 years. Learn it now, and you'll be good for the next 50.
This section labeled lymphoma will also include myeloma, monoclonal gammopathy of unknown significance, and Waldenstrom's macroglobulinemia. Non-Hodgkin's lymphoma is a proliferation of lymphocytes in the nodes in the spleen. Non-Hodgkin's lymphoma is most often widespread at presentation. In other words, 80 to 90% present in stage 3 or 4. Very rarely do you have a localized non-Hodgkin's. Non-Hodgkin's and CLL are virtually identical. Non-Hodgkin's is a solid CLL, and CLL is like a liquidy non-Hodgkin's. Non-Hodgkin's is solid. You need to do an excisional biopsy, and CLL is liquid or circulating. Both of them are characterized by lymphocytes that individually look normal. You can only tell that they're a disease by looking at the group of them and seeing how they function. Lymphadenopathy is worse for you prognostically if it's not painful. Painless lymphadenopathy is cancerous. Cancers are not tender. Infections are tender. Infections are tender, warm, and red. Lymphoma is not. Now, these lymph nodes can also involve the pelvic, retroperitoneal, and mesenteric structures. And it's not good to have pain, but it's good in terms of not having cancer. Cancerous nodes are not warm, not red, not tender. Now, sometimes people with lymphoma can have what we call B symptoms, and as a group, there's a sign of spread. We believe that B symptoms means that even though you cannot see it, it means that that lymphomatous cell tissue is spread around the body, causing fever and weight loss and really, truly drenching night sweats. People feel like they have to change the sheets during the night, twice even, like somebody came and threw a bucket of water on the bed. Now, non-Hodgkin's is advanced in 80 to 90%, and it's infection, not non-Hodgkin's, that gives nodes that are warm, red, and tender. And when we say weight loss, we mean more than 10% of body weight. 5% weight loss often doesn't count. 5%, 6% doesn't count. 5 pounds, 6 pounds don't count. It has to be 10% to count. For lymphoma, both Hodgkin's and non-Hodgkin's, the best initial test for both of them is excisional biopsy. And this is because you've got to see the architecture of the whole node. You can't just do a needle. A needle is good for infections. A needle is good for tuberculosis or for fungus, for TB or for fungus. Needle at TB or fungus. But you've got an excisional lymph node biopsy. It means it takes the whole node and see what the architecture is like. The CBC is normal in most cases. That's the number one clue to why it's not CLL. CLL has a very high white count. It's all lymphocytes. But lymphoma is localized lymph nodes. And this is very important because remember that CLL can give big lymph nodes as well. How would you know it's not CLL? The answer is
CLL is always a high white count, that's lymphocytes, and lymphoma rarely has a white count, that's all lymphocytes. Rarely it's localized to the nodes in lymphoma. Both of them can have a high LDH, and both of them have an LDH, and in lymphoma, it really does correlate with the severity or extent of disease. The higher the LDH, the worse the severity. Now, staging is important because localized disease is treated often with more radiation than chemotherapy. So localized disease can be radiated. You can't radiate extensive disease. Also, localized disease does just not need as much chemotherapy and hence doesn't need all the adverse effects of that chemotherapy. So staging determines the intensity of therapy. So the staging procedures are a CT scan of the chest, the abdomen, and the pelvis. Let's see how far it is. Is it on both sides? Both sides of the diaphragm. Both sides of the diaphragm, stage 3. Much worse. And a bone marrow biopsy. You do not have to do laparotomy, which is to cut the abdomen over and take a look inside. You do not have to do lymphangiography. Lymphangiography is never correct under any circumstances for any disease anymore. Lymphangiography, when you see it, is a dead test. The staging for Hodgkin's and non-Hodgkin's is the same. Stage 1 is one lymph node group. Now, one lymph node group doesn't mean one lymph node. It means that it's just the cervical, or just the axillary, or just the supraclavicular. Stage 2 means 2 or more lymph node groups, but they're on the same side of the diaphragm. Now, this is critically important because stage 3, both sides of the diaphragm, has a much worse prognosis. First, there's a much greater burden of disease. Second, you can't radiate both sides of the diaphragm. You'd have to give combination chemotherapy and have to give it at higher intensity, higher dose, and longer. And that means you're subject the person to more vincristine-induced neuropathy, more vinblastine-induced neuropathy, more bleomycin-induced lung fibrosis if it's Hodgkin's disease. So the wider spread the disease, the more likely you are to have the complications of chemotherapy. Stage 4 is generalized widespread disease. Now, the most common wrong answer is a needle aspiration of the node. Aspiration is simply not enough. You can't needle cancers because the individual lymphocytes look normal. Local disease is radiated. Local means stage 1A and 2A disease. Any B symptoms or anybody with stage 3 and 4 gets treated with combination chemotherapy, and if their CD20 is positive, with rituximab as well. Now, C means cyclophosphamide, and H is hydroxyadriamycin, hydroxydaunorubicin. O is oncovin, but that really means vincristine, and P is prednisone. Now, mucosal associated lymphoid tissue is a lymphoma of the stomach in association with Helicobacter pylori. It's much more minor and it's treated with proton pump inhibitors, clarithromycin, and amoxicillin. So it's PPIs, clarithra, and amoxicillin. So we chop the non-Hodgkin's and ABVD and MOP the Hodgkin's. It's very rare that we treat a non-Hodgkin's with radiation because most of the time they're too widespread. Remember, it's mostly diffuse at presentation in a non-Hodgkin's. In Hodgkin's disease, the presentation, diagnostic test, B symptoms, and staging are the same, except for the fact that it's far more local. It's stage 1 and 2 in most cases. The big issue is the histology. Hodgkin's disease has a Reed-Sternberg cell on pathology. Now, lymphocyte predominant is the best prognosis. Lymphocyte depleted is the worst prognosis. So it means that the major difference between these is the histology. Now, you do not have to learn the difference between 14 separate types of non-Hodgkin's lymphoma. That's not the point here. The point here is that don't needle lymphomas, do an excisional biopsy, that you have to stage them to know if it's local disease because we want to try and use more radiation and less chemotherapy because there's less long-term adverse effects. And the major difference is not the staging is the same, not the B symptoms. Fever, weight loss, and night sweats are the same for both. The difference is the histology. So the differences between Hodgkin's and non-Hodgkin's lymphoma is that Hodgkin's is stage 1 and 2 in 80 to 90%, whereas Hodgkin's is stage 3 and 4. This basically says, if you look at the left side of your screen, radiate me. If you look at the right side of your screen, chemo me. Hodgkin's disease starts at the neck, at the cervical area, and spreads outward from there. Non-Hodgkin's is disseminated at presentation. Hodgkin's has a different pathology, notably the Reed-Sternberg cell. Non-Hodgkin's has no Reed-Sternberg cell and a much more complicated pathologic system that you don't have to learn here. The pathologic classification for Hodgkin's you have to know as far as lymphocyte predominant has the best prognosis, lymphocyte depleted has the worst prognosis, and in non-Hodgkin's, the pathologic classification that Burkitt's and immunoblastic have the worst prognosis. That's called high-grade lymphomas. Now, I got to tell you something about non-Hodgkin's. High-grade lymphomas may be the most aggressive. High-grade lymphomas may grow the fastest. High-grade lymphomas may be the most likely to kill you. But because they divide very quickly, because they're aggressive and they change and divide and grow. Does chemotherapy work on you when the cell is at rest, or does chemotherapy work when the cell is dividing? Chemotherapy works when the cell is dividing. So if you have a rapidly dividing cell, you have a greater chance to cure. So the good news is you have a greater chance of curing it outright with high-grade lymphoma, Burkitt's and immunoblastic. The bad news is if you can't cure it, you have a greater chance of dying. Stage 1A and 2A disease is treated by a combination of local radiation and chemotherapy. There's a change in the sense that virtually no one is treated with radiation alone anymore. It's a combination of radiation and chemotherapy. Although in stage 1A and 2A disease, at least you can use much less chemotherapy and therefore avoid a lot of the toxicity. Stage 3 and 4 disease is treated essentially exclusively with chemotherapy, or anyone with B symptoms gets ABVD. Adriamycin, bleomycin, vinblastine, dacarbazine. And remember, relapses after radiation are treated with chemotherapy, but relapses after chemo have to be treated with super extra high dose chemo with a bone marrow transplantation. Bone marrow transplantation actually allows you to really bump up the volume on that chemotherapy, bump up the dosing to try and cure someone's disease that was initially refractory to therapy. The complications of radiation and chemotherapy are that radiation increases the risk of solid tumors such as breast cancer and lung cancer, sometimes thyroid cancer, depending on where the radiation is aimed. And you have to screen for breast cancer earlier after the treatment. Now, radiation also increases the risk of premature coronary disease. When you zap that chest with radiation, you can age those coronaries, cooks them, fries them. And the risk of acute leukemia, MDS means myelodysplastic syndrome, and non-Hodgkin's lymphoma from chemotherapy is about 1% a year. You can throw in aplastic anemia there too. And basically, chemotherapy gives a risk of secondary malignancies. But it's not enormous, except if you're thinking that people can get radiated and chemotherapy over a period that lasts for a few weeks and months, and then they might live after the chemotherapy for 30 years. So 1% a year becomes quite a lot when you consider that you get radiated and chemoed at the age of 30, and then you might get your lung or breast cancer when you're 60, or your leukemia from your chemotherapy at the age of 60 or 70. Then it's quite a lot. So which of the following is the most useful to determine the dosing of chemotherapy in Hodgkin's disease? In other words, you've got to really bump up that volume of chemo to cure it. If you give too much, it's toxic. If you give too little, you don't cure them. So what do you use to determine the dosing of the chemotherapy? The answer is the Mbbs, or nuclear ventriculogram. This is probably the single most clear use of the Mbbs, or nuclear ventriculogram. How do I precisely dose the chemotherapy to make sure I've eradicated people's lymphoma but not killed them from the toxicity? See, the echocardiogram is just not accurate enough, and bone marrow biopsy is not accurate at all. Gender is essentially irrelevant, and the hematocrit and symptoms aren't good enough to tell me, hey, the nuclear ventriculogram is going to allow very precise dosimetry of adriamycin, enough to cure the lymphoma, but not so much to cause cardiotoxicity. The two most frequently tested facts for oncology are what are the screening tests and what are the toxicities of chemotherapy. It is absolutely indispensable that you understand doxorubicin is cardiotoxic, vincristine and vinblastine give a peripheral neuropathy. It is permanent, vincristine, vinblastine, peripheral neuropathy. Bleomycin with an irreversible lung fibrosis. Cyclophosphamide with a hemorrhagic cystitis that can be prevented by MESNA, M-E-S-N-A. Cisplatin is renal and oto and renal toxicity. Indispensable for you to know. Myeloma is plasma cell cancer. It's the unregulated production of useless plasma cells that make useless immunoglobulin. And it is usually IgG or IgA, but infections come into the body, and instead of making useful immunoglobulins that fight the infection, it makes an unlimited amount of useless immunoglobulin. That is a monoclonal spike. Monoclonal spike, sometimes called an M spike. And guess what the most common wrong answer is for students? Confusing the word M spike with IgM. It's a natural mistake, but IgM does not mean an M spike. Myeloma makes IgG and IgA. Waldenstrom's macroglobulinemia makes a monoclonal spike with IgM. Myeloma is like having a TV that plays one channel very loud and unclearly. Immunoglobulins don't fight infection. They're abnormal. They're crappy. They just clog up the kidneys. And the IgM is just not myeloma. The most common presentation of myeloma is bone pain from pathologic fracture. The plasma cells make a kind of an osteoclast activating factor. The pathologic fracture means it breaks under normal use. If you get hit by a car or fall off a roof, that's not a pathologic fracture. It's unfortunate, but you fell down, you get hit by a car. Pathologic fracture means you're working normally, you're living normally, and the thing still broke. Ouch. Osteoclast activating factor is made by the plasma cells. Basically, the plasma cells make a factor that melts bones and causes lytic lesions. And they are purely lytic lesions, no blastic activity. That's why they don't light up in a bone scan. Ding, 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 ding. Important question, don't light up in a bone scan. And they do create hypercalcemia as they melt your bones and melt the calcium out of your bones. Infection is common because the abnormal plasma cells don't make immunoglobulins that are effective against infection. So the two most common causes of death in myeloma are 1, infection, 2, renal failure. Hyperuricemia happens because there's an increased turnover of nuclear material in plasma cells. Why doesn't this happen in hemolysis? Because red cells don't have nuclei. Red cells don't have nuclei, so you don't get hyperuricemia. You just get the hemoglobin released. So the uric acid comes out of purines and pyrimidines, which are only in the nucleus, and that's why they're quite politely called nucleic acids, because they're in the nucleus. Oh, yeah. And you can prevent the damage from pegloticase and rasburicase. Pegloticase and rasburicase, what they do is they melt uric acid. They're uricase. They melt it away into a puff of smoke called allantoin. And that's one of the treatments you give prior to chemotherapy. It basically helps, in addition to allopurinol, to prevent tumor lysis syndrome. You get anemia because these big fat extra abnormal plasma cells move into your marrow by the billion and crowd out the nice normal cells. And renal failure happens because immunoglobulins clog up your glomeruli, Bence-Jones proteins damage your kidney tubule, and the kidney doesn't like the high calcium either. Hypercalcemia by itself is toxic to kidney tubules. So between the hyperuricemia, the Bence-Jones proteins in the kidney tubules, your kidneys have a lot of damage, and that's why these are the two most common causes of death in myeloma. The best initial test is an X-ray of the affected bone. You're going to see lytic lesions. A serum protein electrophoresis is not the single most accurate test because monoclonal gammopathy of unknown significance is far more common than myeloma. Now, serum protein electrophoresis, the SPEP, shows an IgG in most people, an IgA in the others, and some people can have two types, both an IgG and an IgA. Remember, one type of immunoglobulin, monoclonal or M spike, but it doesn't mean it's an IgM. 15% have light chains or Bence-Jones proteins only. But this also is why Bence-Jones proteinuria is not the most accurate test for myeloma. Myeloma is first with bone pain. Therefore, X-ray that bone for lytic lesions. The bone scan won't show anything. SPEP helps to confirm it. Hypercalcemia is non-specific, and so is hyperuricemia. The additional abnormalities of myeloma is hypercalcemia. The bone's destroyed. Of course there's hypercalcemia. Bence-Jones proteins are immunoglobulin parts that appear in the urine. But remember, you can't see Bence-Jones proteins on a urinalysis. The urinalysis only detects albumin as a protein. As a protein, it does not pick up the Bence-Jones proteins. You got to do a urine immunoelectrophoresis. Beta 2 microglobulin is a one disease test. It looks for the severity of disease and corresponds to the prognosis in people with myeloma. We don't use it for anything else except myeloma. Now, rouleau is a fancy French way of saying rolls, red cells in rolls. And they are because the red cells literally stick together because they get covered with sticky plasma proteins, which make them form into rolls, rouleau. Bench-Jones proteins create an elevated BUN and creatinine, as well as hypercalcemia, hyperuricemia. But if you had to choose the single most accurate test, the one test that is the most specific, it is plasma cells on bone marrow biopsy. 10% plasma cells in combination with lytic lesions and an SPAP is enough. 30% plasma cells as a single finding with nothing else is myeloma. But in combination with SPAP, hypercalcemia, 10% plasma cells. Nothing else causes that level of plasma cells in a bone marrow. There is an elevated total protein with a normal albumin, and that's why you should get the serum protein electrophoresis, the SPEP, to dissect it. As a single test, plasma cells. Urinalysis doesn't show Bench-Jones protein, and bone scan won't show lytic lesions. Those are the questions. Learn them. Well, everything is more exciting in French, I suppose. Do you have rolls? No, I have rouleau. That's the IgG paraprotein. Paraprotein means an abnormal extra protein. It means non-albumin. That's what it basically means. It's non-albumin extra protein. They make the red cells sticky to each other in a stack. Now, rouleau don't have an effect. It's not like spherocytes, which actually damage your spleen and make the spleen big. They don't clog things up like Waldenstrom's clog up your brain and your eye and cause a stroke. They don't cause priapism like in sickle cell. They're just a laboratory artifact, really. And as such, they're just a tested question. Which of the following is associated with rouleau? Myeloma. Rouleau were found. What's most likely to be the diagnosis? Myeloma. That's the only question. Just remember, there it is. M spike doesn't mean IgM. Myeloma has a decreased anion gap. This is a tough to understand point. Since IgG is cationic, positive, it actually lifts up the chloride and bicarb, which are anions. Now, there's a lot of things that cause an increased anion gap, but few that cause a decreased anion gap. The anion gap is 6 to 12 points of difference between sodium, which is a cation, and the anions, which is chloride and bicarb. If you raise the chloride of the bicarb, the gap, the difference between the sodium and the chloride of bicarb goes down. So since the IgG is cationic, there is an increased number of chloride and bicarb atoms that match it, and hence the gap goes down. And therefore, you could also memorize which of the following is the only thing that has a decreased anion gap: myeloma. IgG cationic. Well, here we have a 69-year-old woman with back pain, and it worsens, it pops. When she coughs, it feels worse, tenderness over the ribs. She's got lytic lesions on x-ray. Calcium is 2 points above normal. She's anemic. She's got renal failure. She's got trace protein, but 5 grams of protein on 24-hour urine. What is that? Well, that's Bench-Jones protein. What are you going to find on that bone scan? The answer is nothing. It's nothing because lytic lesions don't light up a bone scan. Lytic lesions don't light up a bone scan. You don't have any increase in uptake and doesn't change anything. It's just invisible. Nuclear bone scan only shows increased uptake with osteoblastic activity, which is absent in myeloma. You see, other cancers, when they form metastasis, have lytic and blastic and lytic and blastic. Osteomyelitis had lytic and blastic and lytic and blastic. There's destruction, formation, destruction, formation. But myeloma is one of the only things that's purely lytic. Why the difference between the protein on urinalysis, 24-hour urine? It is, read, Bench-Jones protein isn't picked up by a dipstick. Bench-Jones protein needs a urine electrophoresis. Urine dipstick only detects albumin. What is the single most accurate test for myeloma? The single test that's the most accurate is the bone marrow biopsy, because nothing besides myeloma has 10% plasma cells on bone marrow biopsy. Skull x-ray shows lytic lesions, but it's not as specific. We rarely do skeletal survey anymore, and the others are simply not as specific. The best initial therapy for myeloma. Now, this is a moving target, and so I want to assure you that the wrong answers will be really wrong. The wrong answers will be like cisplatin, something really horrible. See, it's one or a combination of these drugs. Lenalidomide with steroids, bortezomib and lenalidomide, melphalan and steroids, melphalan, lenalidomide and steroids. A combination of these things. Now, not necessarily all of them together, can be one or two of them, all four of them sometimes. The most effective thing under 70, you can do an autologous bone marrow stem cell transplant. Why can you do autologous and stem cells up to 70? Because with stem cells, the bone marrow recovers faster. Stem cells are already a little pre-grown, so instead of waiting 14 days for the bone marrow to come back to life, or 21 days for some people with allogeneics, the cells will come back to life in 7 or 10 days. You see, you can stop bone marrow growth in anybody for a day or two. But after 4 or 5 days of having no bone marrow growth, you start to get infections. After 2 weeks, you start to get fungi. And after 3 or 4 weeks, you get CMV and you die, get aspergillus. So the faster you can get the white cells back, the faster you will recover and the less infections you'll have. The other reason you could do this up to 70 or so is that it's autologous. And autologous means it's you. There's no rejection. There's no rejection, no graft versus host. Now, I know it may seem fuzzy on my therapy question here, the therapy issue, but that's because myeloma therapy is in a state of flux, and it's just not a step 2 question for you. What do you have to know? That some of these drugs are the drugs for myeloma. It's not methotrexate, it's not cisplatin, it's not cyclophosphamide. The monoclonal gammopathy of unknown significance, or Mbbs, is super common. It's an IgG or IgA spike on an SPEP. It's extremely common in older persons, 5 and 10% of people above 80. It's a disorder that we didn't even know existed 30 years ago because we weren't doing routine protein testing on everybody. Now you have to see who's got myeloma or not. In other words, are we doing an early detection of myeloma? So you've got to do a bone marrow biopsy to exclude myeloma. See, Mbbs has a small number of plasma cells, less than 10%. And there's no therapy for Mbbs, but you just got to make sure it is Mbbs. In other words, normal calcium, normal renal function, no anemia, no bone lesions, less than 10% plasma cells. It's got to have none of that. Then it's Mbbs, then no therapy. And it's not mean that it's no significance. We don't call it monoclonal gammopathy of no significance because it's not no significance to say 1% a year transform the myeloma. I would not consider a 1% a year chance of death to be no significance. It's just unknown who's going to go. So the quantity of immunoglobulin, though, is a really good predictor of who's going to transform. The quantity of the immunoglobulin in the spike is the main correlate of the risk for myeloma. The more monoclonal gammopathy of unknown significance, the more the myeloma. Waldenström's macroglobulinemia is an overproduction of IgM. Malignant B cells lead to the hyperviscosity because IgM is 5 times larger than an IgG, so it gets thicker. And that hyperviscosity presents with lethargy, blurred vision, vertigo. And vertigo is also because it sludges your brainstem, man. Engorged vessels that look like sausages in your eyes and the retina. And mucosal bleeding because it basically just makes extra sticky, abnormal IgMs. And anemia is common because the abnormal cells crowd out the normal marrow. The IgM spike on SPEP makes the hyperviscosity, and the absence of bone lesions is the major distinguishing characteristic for myeloma. Plasmapheresis is the initial therapy to get rid of that viscosity. Now, how come myeloma didn't give hyperviscosity? Well, the answer is simply because IgGs are too small. They're too small to clog you up. But you got to do plasmapheresis to basically send your blood to a dry cleaner. Whip those off and lower the viscosity. It removes the IgM and lowers the viscosity. The long-term treatment, chlorambucil, melphalan, fludarabine, prednisone, basically if it looks like it's a cross between lymphoma and CLL and myeloma, it's because it is. It is. It's abnormal white cells making an abnormal immunoglobulins. You're never going to get asked to choose which single thing is the best therapy because nobody knows. You're going to get asked to recognize the disease, hyperviscosity, and to know that it's plasmapheresis. That's your level of question. Because you got to control the cells to make the abnormal immunoglobulins, Igs, immunoglobulins, and decrease the means of their production. Our next section is spine disorders. Now, those spine disorders will include anterior spinal artery infarction and subacute combined degeneration of the cord from B12 deficiency, spinal trauma, spinal shock, Brown-Séquard syndrome, which is a classic from the War of 1812, getting bayoneted in the back, and syringomyelia. Fortunately, anterior spinal artery infarction is uncommon. We lose all function of the cord except the posterior column because the anterior spinal artery will supply everything in terms of motor and sensory sense except for what controls position and vibratory sensation, which remains intact. There's going to be flaccid paralysis below the level of the infarction because all the motor pathways have been cut. There's going to be a loss of deep tendon reflexes precisely at the level of the infarction. But below the level of the infarction, there will be evolution into spastic paraplegia several weeks later, which means that there will also be hyperreflexia below the level of the infarction. You get loss of pain and temperature because it's controlled by the decussation in the center of the cord, which has now been killed by the infarction. And you have an extensor plantar response because it's like cord compression or transverse myelitis. The whole cord has been cut above, so there's an exaggerated reflex of the extensor plantars. Now, you notice we're not using the term positive or negative Babinski because that's not precise. It is more precise to say there's an extensor plantar response. Unfortunately, the therapy for anterior spinal artery infarction is there is no specific therapy. And this issue of everything is lost except the posterior column is the most frequently tested question for this disorder on step 2. Subacute combined degeneration of the cord, generally speaking, from B12 or neurosyphilis. I'd like to point out folate deficiency may cause the same hematologic manifestation as B12, but folate deficiency is distinguished by having no neurological abnormalities in an adult from its deficiency. You lose only position and vibratory sense. Everything remains intact except position and vibratory sense. So in that sense, with everything else intact, this is exactly the opposite of anterior spinal artery infarction. In the anterior spinal artery infarction, everything is lost except position and vibratory. In subacute combined degeneration of the cord, everything is kept intact except position and vibratory sensation. Spinal trauma, particularly from motor vehicle accidents, results in acute limb weakness and sensory disturbance. It's exclusively below the level, just at and below the level of that injury, and its severity is in proportion to the degree of injury. Really meaning that if your degree of injury is extremely severe, you're essentially become paralyzed. And that's because the spinal canal is very narrow. You get banged in the back, it swells, the swelling compresses your cord, and you are paralyzed. Not just paralyzed, sphincter function is impaired, and you are having urinary and fecal problems, loss of deep tendon reflexes at the level of the injury, and hyperreflexia is followed by hyperreflexia below the level of the trauma. The best initial therapy is treat it with glucocorticoids. Remember, you get banged in the spine, it swells. There's no room. You use steroids to decrease the pressure, just like cord compression from cancer. The Brown-Séquard syndrome is a making carpaccio out of your spine. It's a unilateral hemisection of the cord. It's due to injury exclusively. It's a rare disorder. Nevertheless, doesn't matter if it's rare if it shows up on step 2, a knife or a bayonet cutting your cord in half from behind. And on physical exam, you will find, well, on one side, you're going to lose position and vibratory sense and motor, but you lose the contralateral pain and temperature. And although there's no treatment, the most frequent question is simply, what's the most likely diagnosis? And the diagnosis is based on the fact that pain and temperature cross as soon as they go into the cord and go up on the other side. So if I cut the left cord, I'm losing the right pain and temperature. If I cut the left cord, I'm losing the right pain and temperature. But if I cut the left cord, I lose the left-sided position and vibratory sense. Syringomyelia is a fluid-filled dilated central canal of the spinal cord. It's a widening dilated central canal. You can call it a bubble or cavitation. The neural fibers in the center of the spine get ripped, they get broken. Well, we don't go to medical school to just say a bubble in my cord. We say a syrinx in my myelia. Now, part of the difficulty here is myelia is the word that we use both for the white matter of the cord and white matter inside of bone marrow, so it can be confusing. Myelodysplasia is pre-leukemic in the bone marrow, but myelitis is an inflammation of the spinal cord. Syringomyelia is a bubble, cavity, or syrinx, and syrinx is an ancient Greek word for cavity in the center of your cord. It's caused by a tumor or severe trauma to the spine. How do I answer the question, what's the most likely diagnosis? I'm going to look for loss of pain and temperature bilaterally. I'm going to look for it across the upper back in both arms. I'm going to look for this phrase that's called cape-like distribution, as if I'm wearing a cape across your back, across your shoulders, neck, and arms. And there's loss of reflexes at that level. Muscle atrophy occurs because if we cut all those neural innervation cells, you're simply going to have no neural innervation. The muscles die away without stimulation. Now, this is a very unique presentation. You should have no trouble at all because there just isn't anything that does bilateral pain and temperature just across the back of the arms. You might say, well, how come it's across the back of the arms? How come it's not lower in the legs? And the answer is very simple. It is the upper thoracic cord is simply more vulnerable to injury. There is a bigger space, it's more vulnerable, and because the trauma simply occurs there more often, the lower spine, although there may be a lot of low back pain, simply doesn't cause that type of injury down the lower spine. A bubble or syrinx in the lower cord is simply not as common. Which of the following is the most accurate test for syringomyelia? Which of the following is the most accurate test for a person with loss of pain and temperature bilaterally across the upper arms? The answer is MRI. Well, it's not really that hard a point. You could actually say anything in the spine is MRI. Multiple sclerosis, most accurate for almost anything. Transverse myelitis, MRI, it's most accurate. Yes, and the best treatment is, well, if it happens from trauma and cancer, it is time to do surgical treatment to remove that cancer, surgical treatment for removal of the tumor, surgical treatment to drain the cavity that happens. Bang! I formed a bubble. Let's drain it.
This next section of Step 2 High Yield will focus on chronic obstructive pulmonary disease, also known as COPD. COPD is a disease characterized by airflow obstruction secondary to emphysema and/or chronic bronchitis. Emphysema and chronic bronchitis are really part of the same disease process. It's just that they are two slightly different manifestations. Firstly, emphysema is defined by terminal airway destruction resulting in decreased elastic recoil of the lungs. In the normal healthy lung, elastin fibers are what allow for passive exhalation. In the emphysematous lung, this terminal airway destruction actually results in destruction of the elastin fibers as well, and hence decreased elastic recoil of the lungs. You can imagine that if elastic recoil of the lungs is not working so well, there is going to be obstruction to exhalation of air. Chronic bronchitis is defined as a productive cough for greater than 3 months per year for 2 consecutive years. Both emphysema and chronic bronchitis are part of the COPD spectrum. They result in a decrease in the FEV1 and the FVC with an increase in the TLC. The FEV1 is the forced expiratory volume in 1 second, the FVC the forced vital capacity, and the TLC the total lung capacity. You can imagine that obstruction to exhalation of air is going to result in a decrease in the FEV1 and the FVC. These patients also, over time, because of their extremely poor ability to exhale air, are going to develop air trapping, their residual volumes will increase, and hence their total lung capacities will increase as well. The major etiology of COPD is tobacco smoke. This leads to almost all cases, and that's because tobacco smoke destroys elastin fibers in the lung. If you have a patient, however, who is young and a non-smoker, the correct answer on step 2 is almost always going to be alpha-1 antitrypsin deficiency. With a deficiency of this enzyme, you're unable to break down certain molecules in the lung that destroy elastin. If you're unable to break those molecules down, you're going to have an excess in elastin destruction. And this leads to a clinical syndrome very similar to emphysema in a tobacco smoker. COPD typically presents as shortness of breath worsened by exertion. It is generally a disease characterized by intermittent exacerbations, with increased cough, sputum, and dyspnea, all of which are often brought on by infection. These patients on physical exam will be noted to have a barrel chest, or a wide expanded chest wall. This is again because of increased air trapping and the inability to effectively expire air. They often have muscle wasting and cachexia, and that's because, as we've learned more and more in recent years, COPD is actually an inflammatory disorder that can result in systemic symptoms such as wasting and cachexia.
As we discussed with asthma, the Usmle Step 2 will often test us on what is the best initial test to order in a certain clinical scenario. In the case of COPD, a chest x-ray is a logical choice, mostly because these patients will present with shortness of breath, large amounts of sputum production, and a cough. Pneumonia is definitely on the differential and must be ruled out. Most often on a COPD x-ray, you're going to see the following: an increased AP diameter, which, as we already discussed, is a result of this hyperinflation of the lungs, an increase in the total lung capacity with years and years of expiration obstruction. You will also see air trapping and flattened diaphragms. Air trapping is usually seen as hyperlucency in the upper lung lobes, as seen on a chest x-ray. The flattened diaphragms, as pointed out by the blue arrows on your screen, are typical of a COPD patient, and these flat diaphragms can actually worsen the respiratory mechanics of these patients, and that's because a flattened diaphragm does not work as effectively as a nice, rounded, dome-shaped diaphragm seen in a healthy patient. If we ask ourselves a slightly different question, which is what is the most accurate diagnostic test for COPD, the answer becomes pulmonary function testing. In COPD, PFTs will reveal a decrease in the FEV1, in the FVC, and most importantly, a decrease in the FEV1 to FVC ratio, which must be less than 70% in order to diagnose COPD. In addition, you'll see an increase in the total lung capacity. As we already mentioned, these patients are going to have a large degree of airflow obstruction, and because they're unable to expire the full amount of air over time, they start to develop an increase in their residual volume. With an increase in the residual volume, you're going to see an increase in the total lung capacity. In patients with emphysema, there will be destruction of the alveolar septae in the terminal airways, and this happens to be where the capillaries of the lung are found. So with destruction of capillaries, you can imagine you're going to have poor diffusion of gases across that membrane. With poor diffusion of gases into the bloodstream, you're going to see a decrease in the amount of oxygen being delivered from the alveolus into the capillaries of the lung. On pulmonary function testing, we use the diffusion capacity of carbon monoxide, or the DLCO, to estimate the degree of alveolar destruction seen in emphysema. Lastly, you're going to see incomplete improvement with albuterol in a patient with COPD, whereas a patient with asthma is going to show good amount of reversibility when administered albuterol. Similarly, there's no worsening or only some small degree of worsening if you administer methacholine. If you recall back to our asthma lecture, you'll remember that while asthma is primarily a disease of reversible airway obstruction,
Some patients with chronic asthma can develop a degree of chronic inflammation and a chronic fixed obstruction. Similarly, patients with COPD generally have an irreversible airway obstruction. However, just like asthma can go both ways, so can COPD. Some patients with COPD will have a broad response to inhaled bronchodilators, for example albuterol. This can range from no reversibility whatsoever, which is the classic teaching for COPD, to complete reversibility. And those patients with COPD actually do have some very large degree of reversible airway obstruction. For these patients, on PFTs, you're going to see a greater than 12% increase in their FEV1 if you give them a bronchodilator such as albuterol. For these types of patients, you want to give them albuterol or the long-acting version, salmeterol, to better treat their COPD since they do seem to have some degree of reversibility. Continuing on with further diagnostic tests for COPD, the ABG, just like in asthma, becomes critically important. Acute exacerbations are going to be associated with a large degree of carbon dioxide retention as well as hypoxia. Remember, respiratory acidosis may be present if there is not sufficient metabolic compensation. The bicarbonate level will be elevated to compensate. In between exacerbations, not all patients with COPD will retain carbon dioxide. However, some patients will, and the patients who are chronic carbon dioxide retainers will show some increase in their bicarbonate level because the kidneys will be compensating for this chronic respiratory acidosis over time. The pH in these patients will be close to normal at around 7.4. In terms of cardiac testing for patients with COPD, both the EKG and the echocardiogram can be useful. As we'll discuss in a future lecture, patients with certain types of lung disease are prone to develop pulmonary hypertension. As you can imagine, chronic pulmonary hypertension is going to result in increased afterload on the right side of the heart, and both the right ventricle and the right atrium are going to hypertrophy and dilate over time. The EKG will show right atrial hypertrophy as well as right ventricular hypertrophy. Sometimes patients with COPD can end up in atrial fibrillation or a multifocal atrial tachycardia, and MAT in particular is very commonly associated with lung disease. The echocardiogram will show right atrial and right ventricular hypertrophy, as well as evidence of pulmonary hypertension.
In COPD, there have only been 2 interventions that have been shown to improve mortality and to delay progression of disease. The first is smoking cessation, and the second is oxygen therapy. The indications for oxygen therapy in COPD include the following: having a PaO2 less than 55 or an oxygen saturation less than 90%, or having a PaO2 less than 60 or a SAT less than 90% if the patient has pulmonary hypertension, cor pulmonale, or polycythemia. And remember, the mortality benefit from oxygen is directly proportional to the number of hours that the patient actually uses their oxygen.
In addition, a number of therapies have been shown to decrease symptoms for these patients, but do not decrease disease progression. The first of these is short-acting beta agonists, such as albuterol, which are particularly helpful for those patients who do have some degree of airway reversibility in their obstruction. Anticholinergic agents, tiotropium, which is long-acting, or ipratropium, its short-acting version, have been very helpful in COPD symptoms. While we mentioned before that these are not so well studied for asthma, they are very well studied for COPD. Inhaled steroids can be helpful to decrease the degree of inflammation in these patients and to prevent COPD exacerbations. And long-acting beta agonists, such as salmeterol, can also be helpful in preventing COPD flares. Lastly, pulmonary rehabilitation can be quite helpful in helping patients to improve their quality of life when living with COPD. In order to better understand obstructive lung diseases, it's often very helpful to compare asthma with COPD. And the treatment in these 2 diseases, while quite similar, is actually different in the initial steps. In an asthmatic whose disease is not well controlled with albuterol alone, as we already discussed, the first step is going to be to add an inhaled steroid. In a patient with COPD who is not well controlled with albuterol alone, you're going to go ahead and add an anticholinergic agent such as tiotropium, a long-acting version of ipratropium. If that does not relieve the patient's symptoms with COPD, you then add an inhaled steroid. Inhaled anticholinergic agents are most effective in COPD, although as we said before, we do sometimes use them in asthma. In addition to those therapies already mentioned, there are a few other that might improve symptoms for some patients, but again, are not shown to change disease progression or mortality. The first of these is theophylline, which we already mentioned as being used for asthma as well. Lung volume reduction surgery, which involves cutting out portions of the upper lobes in patients with upper lobe predominant disease. This can actually help the rest of the healthy lung to expand and can help patients with symptoms, but again, no effect on mortality or disease progression. There are some drugs that you should be aware of that have no benefit whatsoever in COPD. These include cromolyn, leukotriene modifiers such as montelukast, and you should be aware that when all medical therapy is insufficient, the correct answer is going to be to refer the patient for lung transplantation. In terms of an acute exacerbation of COPD, the treatment is actually quite similar to an acute exacerbation of asthma. You're going to be using a combination of bronchodilators, often in the nebulized form, and systemic corticosteroid therapy. COPD, in the setting of an acute flare, the treatment is identical to asthma. However, there is less proven benefit. One difference is that antibiotics are often considered in the setting of a COPD flare, while these are rarely used in the setting of an asthma flare. In a patient with a moderate to severe COPD flare, antibiotics are indicated. We define a moderate to severe COPD flare as the following: requiring hospitalization or having at least 2 of the 3 cardinal symptoms of a COPD flare. These include dyspnea that's increased from the patient's baseline, sputum production increased from the patient's baseline, or a change in the sputum purulence from the patient's baseline. So, for example, the patient might make clear sputum on an everyday basis, but for the few days prior to their COPD flare, they started making green or brown colored sputum. That would change the sputum purulence and would count as one of the cardinal symptoms of a COPD flare. So, for any of these indications, you're going to use antibiotics to treat the COPD flare. In terms of which antibiotics to choose, we must remember that while viruses cause 20 to 50% of episodes of COPD flares, our antibiotic coverage should be targeted against strep pneumo, H. flu, and moraxella, these being the 3 most common bacterial pathogens to cause a COPD flare. Therefore, macrolides, such as azithromycin or clarithromycin, are first-line agents, cephalosporins like cefuroxime or cefixime, amoxicillin clavulanic acid, or quinolones such as levofloxacin and moxifloxacin. In terms of second-line agents, for patients who might have an allergy to the above-listed agents, we can use doxycycline or trimethoprim sulfamethoxazole. Before we end this lecture, it is worth briefly discussing the role of oxygen in the acute setting of a COPD flare. We must note that the hypoxic drive elimination concept is incorrect. Oftentimes, we are taught that we should avoid reflexively placing a patient with COPD on a very high-flow, 100% non-rebreather mask. In other words, we want to avoid putting these patients on extremely high concentrations of pure oxygen for very long periods of time. Because patients with COPD end up retaining carbon dioxide chronically, they lose their hypercarbic drive to breathe, and therefore in their brain stems, it's hypoxia that stimulates them to continue breathing. The fear is that if we put large amounts of oxygen on the patient, you're going to remove their hypoxic drive to breathe, and without a hypercarbic drive to breathe, they'll stop breathing. This is only true again if you use extremely high concentrations of oxygen for long periods of time. In general, the hypoxic drive elimination concept is incorrect,
and in fact, oxygen is quite indicated in the setting of an acute COPD flare. The best way to use it is to only use as much oxygen as is necessary to raise the PO2 to above 90% saturation. Remember, dyspneic, hypoxic patients with COPD must get oxygen.
In contrast to hematology, which is the study of blood-based disorders including the hematologic malignancies like leukemia and lymphoma, in the oncology section we will be covering the solid tumors. The cancer types that are most commonly tested on the Usmle Step 2 include breast, prostate, lung, ovarian, testicular, and cervical cancer. We'll begin our discussion with breast cancer. In this section, we'll cover how the test makers may describe a woman presenting with breast cancer, the diagnostic workup, including special genetic markers such as BRCA1 and 2, as well as treatment options for patients with breast cancer. Most breast cancer is detected when a woman herself notices a lump or mass in her own breast. However, with the increase in the prevalence of screening mammography, more and more asymptomatic women are diagnosed with early-stage, small breast cancers, which is a good thing. Less commonly, a medical practitioner can sometimes detect a mass on physical exam, although the recommendations regarding routine self-breast exams and physician breast exams are controversial, so they'll probably not be tested on the Usmle Step 2. What you should know is how test makers will describe the case presentation when they want you to know breast cancer is the diagnosis. Keywords they may throw into the clinical vignette when they're describing a malignant breast mass include a firm or a hard texture, fixed or immobile feeling on palpation, or in more advanced tumors, fixation of the mass to the chest wall itself. Breast cancer can present with several manifestations. Most often it presents as a palpable lump, but can also cause skin changes like dimpling or changes in the color or texture of the skin. It can cause nipple retraction if the tumor involves the ligaments within the breast, and can also cause nipple discharge. If the nipple discharge is bloody, that's classically associated with something called intraductal papilloma, but bloody nipple discharge can be seen with any tumor that invades the ductal system. Here are some illustrations to help you remember the changes associated with breast cancer. Now, an important thing to remember is that masses due to breast cancer are typically painless. This distinguishes them from things like fibrocystic disease of the breast, which presents as multiple, painful, round, and mobile breast lesions. Breast abscesses are often also described as very painful to palpation. So now that you know the classic clinical presentation describing when to suspect breast cancer, how do we go about diagnosing it? The best initial test for breast cancer, once a mass is identified, is to biopsy it. So whether the mass is found by palpation, ultrasound, or mammogram, it's important to actually obtain cells from microscopic examination. There are many ways to obtain cells for biopsy. From least to most invasive, the three ways we can obtain a biopsy include fine needle aspiration, or FNA, core needle biopsy, and open or surgical biopsy. Now, FNA is the best initial biopsy because it's the least invasive. This test has a really small false positive rate, only about 2%, but since it only samples a small amount of tumor cells, the false negative rate is as high as 10%. Core needle biopsy is one step in the more invasive direction, and it has several distinct advantages over FNA. First, it gives you more tissue, and second, it allows for the detection of estrogen and progesterone receptors as well as the presence of the HER2 or NU receptor. These receptors, as we'll talk about a little bit later, are really important for prognosis and for choosing the right treatment. However, the need for a larger needle for this core needle biopsy means that it can be more deforming as it removes more tissue from the breast itself. Also, there is a small chance of seeding the needle tract as you put the needle in and pull it out from the body, seeding that needle tract with tumor cells. Now, if the question asks you for the most accurate diagnostic test for breast cancer, the correct answer is going to be an open or surgical biopsy. This is obviously most accurate because it obtains the most amount of tissue, and with all diagnosis of cancer, more is better in terms of tissue. With this type of biopsy, the patient is actually taken to the OR and put under general anesthesia, and the biopsy tissue is sent to the pathology lab to look at it with frozen section while the patient is still under anesthesia. When the results come back, the pathologist tells the surgeon whether or not cancer cells are present, and if cancer cells are there, the tumor resection is done right then and there under the same general anesthesia. Recommendations regarding screening mammography have recently become a source of controversy that you may have heard about or read about in the media. The confusing thing, for both medical professionals and for patients themselves, is that there are two major medical organizations that have made conflicting recommendations regarding when to start screening, when to stop screening, and how often the screening should be performed. The American Cancer Society recommends that screening mammograms start at age 40 and continue yearly. However, the U.S. Preventative Services Task Force came out with recommendations recently that mammograms should start at age 50 and then should be repeated every 2 years until a woman reaches the age of 74, after which mammograms can be discontinued altogether. So what do you need to know? The bottom line is, on the USMLE Step 2, the correct answer for when a healthy woman should begin to have routine mammograms is at age 50. The caveat is, if a woman younger than 50 has a strong family history or otherwise desires to begin screening earlier, that can be discussed between the physician and the patient on a case-by-case basis. Next, let's apply what we've learned so far to a clinical vignette. We've got a woman who finds a hard, non-tender breast mass on self-examination. So far, it sounds like breast cancer. There's no alteration of the mass with menstruation, which makes something like fibrocystic change of the breast less common. She's scheduled to undergo an FNA biopsy, which we've said is the best initial biopsy of choice. So the question here, which of the following is most likely to benefit the patient? Our answer choices are mammography, BRCA testing, ultrasound, bone scan, and PET scan. So looking through this case presentation, the case presentation is typical for breast cancer, and she's already scheduled to undergo the test of choice. So which of these might also benefit her? The correct answer is A, mammography. So you might be asking yourself, if we're already going to do a biopsy, what's the point in doing a mammogram? We already know that there's a mass there. The reason a mammogram might benefit this woman is that 5 to 10% of women with one breast mass also have bilateral disease in the contralateral breast. This is important to know because there's a huge difference in the management of breast cancer, whether there's a single lesion, lesion in both breasts, or even multiple lesions in the same breast. So all of this information is important to know before treatment is planned. And now that we know the right answer, let's take a look at the other answer choices and discuss briefly why they're wrong. BRCA testing is not the right answer because although we know that people with a positive BRCA mutation are at increased risk for cancer, it doesn't really give us any additional information on how best to treat them. We'll talk a little bit more about this controversy later. Ultrasound is not really an important test once we know a mass is suspicious for cancer because it only tells us whether the mass is cystic or solid. Here, the physical exam gave us all the information we needed to know. The mass was hard and non-tender on self-examination. Now, a bone scan really just gives us information on whether or not there are metastases present in the bones. And PET scan similarly. It just tells us whether there may be suspicious lesions in lymph nodes or other parts of the body suspicious for cancer. We mentioned ultrasound as one of the wrong answers to our previous question, so when is ultrasound the right answer? Ultrasound is the most useful when a mass is felt by either the patient or the physician, and it's not exactly clear by the physical exam whether the mass is cystic or solid. Ultrasound is sometimes a better test in young women because young women have more dense glandular tissue in their breast, and that makes mammograms a little bit less reliable. But on the whole, you should choose ultrasound as the best first test if the question stem gives you every reason in the world to think this woman does not have cancer. and perhaps she has instead a fibrocystic breast condition. Typically, the women will be young, in their 20s, the mass will be painful, and they'll get larger and smaller. The pain will get better and worse at various times in her menstrual cycle. We also saw a PET scan as an answer choice in our last clinical vignette. A PET scan is a nuclear medicine study, and it uses tagged glucose and takes special pictures to show where it accumulates in the body. Cancer cells grow much, much faster than normal cells, and to grow that much faster, they need to take up more glucose. Therefore, they take up more of this tagged glucose, and that's what makes them light up on the PET scan. Now remember, a PET scan is far from a perfect test, because things like infection also cause increased glucose uptake. It's also a common misconception that if something is positive on a PET scan, you don't have to biopsy it. That's not the case. Biopsy is still the very best test for diagnosing cancer, and most oncologists won't even treat a patient unless their cancer is proven by biopsy. So when is PET scan the right answer? PET scan is the right answer on the Usmle Step 2 if you have an enlarged or abnormal-looking lymph node or other mass that's somewhere in the body where you cannot easily obtain a biopsy. You can also use PET scan to follow or look for recurrence in a cancer you've already proven with biopsy. Let's take this case as an example. Here we have an 80-year-old woman with biopsy-proven breast cancer. She has no nodes with cancer in the axilla, and the primary lesion is small. Therefore, the woman may not need adjuvant chemotherapy, which we'll talk more about later. She has a chest CT that shows an abnormal hilar lymph node. In this case, a PET scan may be useful because it can exclude the abnormal hilar lymph node as a metastasis. Therefore, if the PET scan is negative, she may not need additional chemotherapy. But if the PET scan is positive, the doctor may go ahead and treat her with adjuvant chemotherapy. Genetic and molecular medicine and the assessment of cancer risk is a really hot topic right now in research. As is the case with most controversial topics, the Usmle Step 2 question writers tend to shy away from questions about the exact meaning of BRCA test results, unless the findings are really straightforward. So here's what we know for sure. BRCA mutations can be inherited and tend to run in families. They definitely increase your risk of breast cancer, and in a woman who presents with breast or ovarian cancer at a young age, she may have a BRCA mutation. What's not clear is what to do with those test results. And because it's controversial, the Usmle Step 2 will not, for example, ask you who should or should not receive a test for the BRCA mutation, or how the treatment should be altered whether or not BRCA is positive. Another area of controversy is the breast MRI. So some physicians find it useful in certain populations, but since its benefit has not been proven, it will not likely be the correct answer for any Usmle Step 2 question. Years ago, all breast cancer was treated with mastectomy and the removal of all the axillary lymph nodes. That's because breast cancer first spreads to lymph nodes under the arm. Now, breast cancer can be removed either with a lumpectomy or a mastectomy, more about that later, but all the lymph nodes are not always removed in all patients. This is because we've found removing all of the axillary lymph nodes can cause really severe side effects and problems down the road, mainly lymphedema, which is the painful swelling of the arm that's on the same side as surgery. Instead, what we typically do to examine the lymph nodes in a patient with breast cancer is at the time of lumpectomy or mastectomy, we do something called a sentinel lymph node biopsy. We do this because we want to know the risk that the breast cancer has spread to the lymph nodes under the arms. So the sentinel lymph node is the place that receives the lymphatic drainage from the place where the cancer is in the breast. It's identified by injecting contrast or a special dye into the tumor or the tumor bed, and it lights up the first lymph node that drains lymphatic flow from that area. So the lymph node that lights up first is called the sentinel lymph node. It's usually surgically removed at the time of lumpectomy or mastectomy, and it's checked under the microscope for cancer. If the sentinel lymph node is negative, it's really unlikely that any other lymph nodes or places elsewhere in the body will have cancer, so in those cases a total lymph node dissection is not done. If the sentinel lymph node is positive, meaning the cancer is spread from the area in the breast to that one lymph node under the arm, additional lymph nodes from the axilla will be taken and sampled to determine how much lymphatic spread is present. Breast cancer cells can have several hormonal receptors on their surface. They can have estrogen receptors, progesterone receptors, or they can have receptors for the human epidermal growth factor 2, which is known as HER2 or new receptor. The receptor status of breast cancer cells is really important to know because it helps give information about prognosis. You may have heard of the triple negative breast cancer, that's negative for ER, PR, and HER2 new, has the worst prognosis. But receptor status also gives you information about additional therapies that may be beneficial in treating breast cancer. We'll talk more about these, the estrogen receptor antagonists like tamoxifen or raloxifene. There are 3 main surgical options for removing breast cancer. Lumpectomy is just what it sounds like. It's where you surgically remove just the tumor and spare as much of the normal breast tissue and skin and muscle as possible. It usually gives the best cosmetic outcomes, especially if the tumor itself is small. The modified radical mastectomy is a little bit more radical. It involves removal of all the breast tissue as well as lymph nodes under the arm. The radical mastectomy is the most radical surgery, and it involves removal of all the breast tissue as well as the skin above the breast tissue and the muscles beneath the breast tissue, the pectoralis muscles. Also, in a radical mastectomy, all of the lymph nodes are removed. It's important to know that because a radical mastectomy has never been proven to be more beneficial or have a better survival than the less invasive surgeries, it will always be the wrong answer on Usmle Step 2. And that makes sense. Why would you do such a radical surgery that removes more skin and muscle from the body if it doesn't give any benefit to the patient? The other thing to remember about these surgical options is that a lumpectomy followed by radiation therapy gives just as good an outcome as a modified radical mastectomy. So in this case, for early stage breast cancer, the treatment option is really left up to the patient. If the patient would rather spare as much breast tissue as possible, she can have a lumpectomy followed by radiation. Or if she'd rather just have the whole breast removed and not have to undergo radiation, she can have a modified radical mastectomy. It's just important to know for the test and for counseling patients in the future that both will have the same results in terms of risk of cancer recurrence as well as the chances of dying from breast cancer. After surgery and possibly radiation therapy, women who have estrogen or progesterone receptor positive cancer should receive hormonal therapy. People who have ER or PR positive breast cancer have a better survival and less recurrence if they take one of these hormonal treatments. Tamoxifen is an estrogen antagonist that acts as an antagonist in the breast and an agonist in the endometrium. So it's important to remember about tamoxifen that women who have not yet had a hysterectomy have an increased risk of uterine or endometrial cancer. Raloxifene has a benefit that it is an antagonist both in the breast and in the endometrium, so it has much less risk of increasing chances for uterine cancer. The aromatase inhibitors work by blocking the production of estrogen, and studies have actually shown that aromatase inhibitors work better than either tamoxifen or raloxifene. So, if all of these are present as answer choices, you should choose one of the aromatase inhibitors. It's going to be most likely to benefit the patient. It's important to keep in mind the key differences in the side effects of these oral hormonal therapies, so let's review them here. It's important to remember that tamoxifen increases the risk of both endometrial cancer and blood clots. That's because tamoxifen acts as an agonist in the endometrium and an antagonist in breast tissue. Raloxifene increases the risk of blood clots, but it has much less risk of endometrial cancer because it acts as an antagonist in the endometrium. Aromatase inhibitors increase the risk for osteoporosis because they block the effects of estrogen everywhere in the body, including their beneficial effects of estrogen in the bone density. You may have heard of this monoclonal antibody medication called trastuzumab. So when is trastuzumab the right answer on test day? It is a monoclonal antibody that is made against the HER2/neu receptor. So, all breast cancers should be tested for the HER2/neu receptor, and trastuzumab should be given if HER2/neu is positive. Its main benefit is that it decreases the risk of breast cancer recurrence after surgery. Not all women with breast cancer need chemotherapy, but when chemotherapy is given, it's either given before or after the definitive treatment, which in the case of breast cancer is surgery. Neoadjuvant means that the therapy is given before definitive treatment, and adjuvant means that chemotherapy is given after the definitive treatment. The goal of neoadjuvant chemo is to reduce the amount of cancer in the body and to make the surgery more likely to be successful, whereas adjuvant chemotherapy is given to kill any cancer cells that may have been left behind after surgery or may have spread to other parts of the body before the surgery was performed, but that are too small to be detected by imaging or other diagnostic tools. Indications for adjuvant chemotherapy after breast cancer surgery and maybe radiation include tumors that are big, that are larger than 1 centimeter, or the presence of cancer in the axillary lymph nodes. It's important to remember that in addition to being useful as an adjuvant hormonal agent, tamoxifen has been shown to reduce the risk of developing breast cancer. So it's sometimes given to women who don't have breast cancer, but have multiple first-degree relatives with the disease. Again, the BRCA mutation is a source of controversy. We know a positive mutation increases a person's risk for cancer, both breast and ovarian, but we don't yet know exactly what to do with that information in terms of either prevention or treatment. What does that mean to you? It's unlikely to be a source of questions on your USMLE Step 2. To wrap up this section, let's review some things that have been definitely shown to lower mortality in breast cancer. That means they're likely sources of questions on the USMLE Step 2. Mammograms pick up smaller, earlier stage cancer, so they improve mortality by detecting the cancers when they're more likely to be treated to a total cure. All tumors should be tested for estrogen and progesterone receptors, and if it's appropriate, should be followed by the use of hormonal therapy. Remember that aromatase inhibitors have better effects than tamoxifen or raloxifene, so if all of them are correct answers, choose aromatase inhibitors. Adjuvant chemotherapy improves survival if the tumor is large, greater than 1 centimeter, or if lymph nodes are positive. And remember that lumpectomy plus radiation has equal survival to a modified radical mastectomy, so it should be left up to patient preference. Trastuzumab can improve mortality if the patient is positive for the HER2/neu receptor. And in a patient with many first-degree relatives with breast cancer, we can improve mortality, we can prevent breast cancer by doing prophylactic tamoxifen. And this concludes our section on breast cancer. We will discuss the key details regarding the presentation, treatment, and screening for prostate cancer, focusing how these concepts may appear in a clinical vignette. There are 3 ways prostate cancer can come to the attention of the patient and the physician. The presenting symptoms a patient may notice himself are related to the mass causing obstruction of urine. Men may complain of a feeling of incomplete emptying, frequency, hesitancy, weak stream, or nocturia. However, it's important to realize that benign prostatic hypertrophy has the exact same symptoms, so they're by no means specific to prostate cancer. Now, unfortunately, the mass typically has to get pretty big in order for it to cause obstructive symptoms, and prostate cancer carries a worse prognosis when there's a larger tumor burden. If the cancer is even more advanced, such as in stage 4, where it's metastasized outside the prostate gland, the patient can sometimes present with bone pain or symptoms of hypercalcemia due to metastasis to the bone. Now, the vast majority of patients with prostate cancer are asymptomatic at diagnosis, so the patients get diagnosed either by the physician palpating a mass on digital rectal exam or noticing an elevated or rising prostate-specific antigen, or PSA. It's important to remember, though, that no matter what raises the suspicion for prostate cancer, the only way to make the definitive diagnosis is to perform a biopsy. As with the diagnosis of all cancers, the most accurate test for prostate cancer is biopsy. A prostate biopsy is typically performed by passing a small needle through the rectum, usually under the guidance of ultrasound. But in some cases, the biopsy needle can be passed either transurethral or through the perineum. Prostate cancer in general is described as a very indolent cancer. That means it grows very slowly. We know that because examination of prostates of men on autopsy specimens have shown that more than half of all men older than 80 have prostate cancer. The majority of these men never even knew they had cancer, and that's because it grew so slowly that they lived their lives and ended up dying of something else before it ever caused them symptoms. This indolent natural history of prostate cancer is an important thing to keep in mind when deciding whether or not to put an older man with early-stage prostate cancer through aggressive treatment. Once prostate cancer is diagnosed, there are 5 main treatment options available. A surgery to remove the whole prostate, called a prostatectomy, is one option to treat prostate cancer if it has not yet spread beyond the prostate itself. Radiation therapy is another option where radiation is directed at the prostate from an external source. Brachytherapy is another flavor of radiation where radioactive implants or seeds are actually placed within the prostate to treat it from the inside out. Hormonal therapy is geared towards blocking the effects of testosterone on the prostate cancer. It doesn't cure prostate cancer by itself, but it can add benefit to either surgery or radiation in certain circumstances, and we'll talk more about that a little bit later. Something they call watchful waiting is another option, especially given what we just talked about concerning the slow-growing, indolent nature of most prostate cancers. Depending on the age, health status, and personal preferences of the patient, sometimes watching the cancer with parameters such as PSA, physical exam, and imaging can be a reasonable approach. On the Usmle Step 2, they will not ask you which of the treatment options is best, because for localized prostate cancer, the literature is mixed. However, you should be familiar with the side effects and how they differ among these treatment options. It's controversial, but there are some studies that suggest prostatectomy may have a slight benefit over radiation therapy in terms of overall survival. However, there are some significant complications associated with prostatectomy, including erectile dysfunction and urinary incontinence, that patients have to keep in mind when choosing treatment. It's well established that the side effects of erectile dysfunction and incontinence are much more common after prostatectomy than after radiation therapy. So we've said a biopsy is of the utmost importance in making the diagnosis of prostate cancer. So what do we look for when we examine a prostate biopsy? The Gleason score is a number from 2 to 10 that describes the histologic grade of the tumor. A higher Gleason score means the cancer looks less like the normal prostate with small unified glands and more like a dedifferentiated anaplastic tumor. A Gleason score is obtained by a pathologist looking at the biopsy specimen under the microscope, and the oncologist or urologist uses the Gleason score to help estimate prognosis and choose treatment. Studies suggest that a high Gleason score means a patient may derive more benefit from prostatectomy rather than radiation or one of the other first-line treatment options. As we mentioned before, hormone therapy is one treatment option for prostate cancer. Typically, it's not a curative treatment, but rather helps control the size and progression of metastasis once they've occurred. Hormone therapy is different between prostate and breast cancer in that tamoxifen, remember, helps to prevent breast cancer recurrence, whereas hormone therapy for prostate cancer simply shrinks recurrence or metastasis that have already occurred. Flutamide is one option for hormonal therapy, and it works by blocking the action of testosterone and DHT on prostate cancer cells, and it does that by acting as a competitive antagonist. Leuprolide and goserelin are GnRH agonists. They first act to actually stimulate a burst of LH and FSH release from the anterior pituitary, but then eventually they downregulate LH and FSH, which leads to an overall decrease in production of endogenous testosterone. Ketoconazole is actually an antifungal medication, but it also acts to suppress testosterone production. And finally, orchiectomy stops endogenous production of testosterone by the testes altogether with surgical removal. We've discussed on prior slides some of the beneficial treatments for patients with prostate cancer. As with most cancer therapies, it's not clear exactly which treatment modality is clearly superior. It's often left up to the patient and the individual characteristics of that patient's cancer stage, grade, and other medical problems as to which treatment they decide to undergo. With so much controversy, it's important not to get too wrapped up in the details and to focus on the clear-cut points that are not up for debate, and therefore much more likely to be tested on your Usmle Step 2. Here are some statements that are incorrect and will never be the right answer when asked about the treatment of a patient with prostate cancer. First, screening for prostate cancer is controversial enough, but using imaging like prostate ultrasound or pelvic CT scan is never indicated for prostate cancer screening. Prostate ultrasound is not a screening test. What it's used for is to localize lesions to biopsy when the prostate-specific antigen, or PSA, is found to be high or rising. Partial surgeries, analogous to the lumpectomy for breast cancer, are also never the right answer. With prostate cancer, you either remove the whole prostate or nothing at all. Chemotherapy has not been shown to be beneficial in curing prostate cancer. What it's used for is a treatment of last resort to control metastatic disease that has failed either local therapy or hormonal therapy. Also remember, we've said this before, the key difference between hormonal therapy for breast cancer and prostate cancer is that in breast cancer, tamoxifen or other estrogen antagonists have been shown to prevent the recurrence of disease and even to prevent disease in the first place if there's a strong family history. In prostate cancer, anti-androgen medications simply shrink disease that is already present. Prostate-specific antigen screening is another controversial subject. When to start, how often to screen, and who needs screening in the first place are all up for debate, and different organizations such as the American Urologic Society and the U.S. Preventative Services Task Force have differing opinions as to whether or not it should be done in the first place. Here are the key facts to know. Although PSA screening may detect prostate cancer earlier, it has never been shown that regular PSA screening reduces the mortality associated with prostate cancer. Therefore, it should not be routinely offered to all men. It's important to keep in mind that a normal PSA definitely does not exclude the possibility of prostate cancer, and a high PSA can be caused by conditions other than prostate cancer, most notably BPH or prostatitis. However, if prostate cancer is known to be present after being diagnosed by biopsy, we do know that the higher the PSA, the larger the volume of cancer that's likely to be present in the body. PSA is also a valuable tumor marker to survey for the recurrence of prostate cancer after prostatectomy or radiation therapy. Even though PSA screening isn't indicated for all men, the medical community does agree that PSA screening should be discussed between the patient and his doctor on a case-by-case basis. People with a strong family history or other risk factors for prostate cancer may benefit from screening. Therefore, on the Usmle Step 2, if you're faced with a question stem that mentions a patient is requesting a PSA test, the correct answer is to order that test for the patient. As we finish up this section, let's talk about what to do once you get the results of that PSA test you ordered. This algorithm is also without controversy. If the PSA test is found to be high, and high is defined as a number greater than 4 nanograms per deciliter, the next best step is to perform a digital rectal exam. If there's a palpable mass or nodule, the next best step is to biopsy that mass and to send it for pathologic examination. By doing this, we want to determine the presence of cancer, and if cancer is present, we want to know what the Gleason score is. If there is no mass or nodule appreciated on a digital rectal exam, the next step would then be to perform a transrectal ultrasound. Ultrasound can sometimes detect a nodule that's too small or in a location that cannot be palpated. So if a mass is seen on ultrasound, it should be biopsied. But if no mass is appreciated, then multiple blind biopsies should be done by both sides of the prostate in as many areas as possible. This concludes our section on prostate cancer. There isn't much that the USMLE Step 2 test makers expect you to know regarding the management of patients with lung cancer, and that's because lung cancers are typically and unfortunately diagnosed pretty late and are treated palliatively, that is, without curative intent, using chemo, radiation, molecular therapies, or some combination of the three. However, there are a few key details you need to know, so in the next couple slides, we'll hit those highlights of what you might actually be tested on. When faced with a patient, either in a clinical vignette on Step 2 or in real life, who has lung cancer, the most important question to ask yourself first and foremost is, can this patient be treated with surgery? This question is vital because if a lung cancer is caught early enough, and more accurately, if a lung cancer is caught when it is small enough, it can sometimes be completely resected with surgery and give that patient their best shot at a cure. What you need to know for Step 2 is the most important factor determining resectability is the size of the tumor. Now, if the tumor is larger, but the patient has otherwise healthy lungs and their lung function is good enough for the patient to ventilate adequately after a larger resection, some surgeons will still consider surgery. However, preoperative pulmonary function tests are part of the workup to determine whether or not this will be possible on a case-by-case basis. If a lung cancer is deemed resectable, there are 3 surgeries that can be done to remove a lung mass, and these vary based on the amount of lung tissue that's removed. The first is a wedge resection, and this is performed when the lesion is very small. Second, a lobectomy can be performed, and this is a surgery where the affected area of lung tissue is removed. Usually it's done when the lesion is bigger or it has more infiltration into a specific section of the lung. Third, and most extensively, a surgery to remove the entire affected lung can be performed. This surgery is typically only done in young patients or patients with otherwise healthy lungs. Unfortunately, the majority of patients with lung cancer are smokers and often have emphysema or chronic bronchitis or other lung disease that makes the rest of their lung not healthy enough to compensate for removing such a large amount of lung tissue along with the tumor. For this last slide, we'll talk about the situations in which surgery is never an option, at least as far as a correct answer on the USMLE Step 2 is concerned. First, when there are cancerous lung masses in both lungs, surgery is never appropriate. Second, anytime you have a malignant pleural effusion accompanying a lung mass, surgery is not a curative treatment either. And remember from the pulmonary section that a malignant effusion is typically exudative by Light's criteria. Third, anytime there are other thoracic organs involved, such as the heart, carina, aorta, or vena cava, a surgical resection of a lung cancer is not an appropriate treatment because it's not feasible to remove parts of these other organs as well. Finally, if on biopsy the lung cancer is found to be small cell in origin, it's nearly always considered unresectable. And this is because in greater than 95% of cases, small cell carcinoma is metastatic on diagnosis, often going to the brain or adrenal glands. And this concludes our section on lung cancer. Though the gynecology section of USMLE's Step 2 review discusses the gynecologic malignancies in more detail, we'll review the highlights regarding screening, diagnosis, and treatment of ovarian cancer in the next couple slides. It's important to remember that, in contrast to breast and cervical cancer, there is no effective screening test for ovarian cancer, so it's often not caught until it's very late in the progression of disease. How a USMLE Step 2 clinical vignette will describe a patient with ovarian cancer is by telling you there's a woman who's greater than the age of 50, with increasing abdominal girth and possibly other constitutional symptoms such as fatigue and weight loss. They will often also tell you that the patient has no history of drinking alcohol or being diagnosed with hepatitis or other liver disease to help you distinguish increased abdominal girth from ascites versus the collection of abnormal fluid due to ovarian cancer. There are several established risk factors for ovarian cancer that you should know for your test. These include the BRCA1 and 2 mutations that we talked about in reference to breast cancer, as well as using estrogen replacement therapy. Some protective factors, including having a greater number of children or using hormonal contraception. Both of these things actually reduce the risk of ovarian cancer. When a clinical scenario suggests that ovarian cancer is the diagnosis, the best initial test to confirm that is to either order an ultrasound, transabdominally or transvaginally, or to order an abdominal CT scan. Both of these will show both the mass as well as the accumulation of abnormal fluid within the peritoneal cavity. Like with all cancers, the most accurate diagnostic test for ovarian cancer is a biopsy. This gives you a piece of tissue to look at under the microscope and not only confirm that cancer is present, but to make the diagnosis of what type of ovarian cancer the patient has. The vast majority of ovarian cancers are adenocarcinomas, and these arise from the lining of the ovary itself, but there are more rare forms of ovarian cancer that include the germ cell tumors. The treatment for ovarian cancer typically consists of surgery followed by chemotherapy. And there's one important thing to keep in mind regarding the treatment of ovarian cancer. It's one of the few times where we do a surgery even in patients who have widespread metastatic disease. That's not usually the case for most other forms of cancer. The surgery for ovarian cancer is pretty extensive. You basically cut out as much as you need to remove all of the visible tumor. If the tumor is small and only present on one ovary, you can get away with just removing the ovary on that side in addition to the fallopian tube. But in bigger tumors or more widespread disease, the surgeries can be as extensive as removing all of the pelvic organs, including the uterus, both ovaries and fallopian tubes, as well as the bladder in some cases. Now, the prognosis, even after all of this, for patients with ovarian cancer is pretty poor. And that's because ovarian cancer is diagnosed so late in stage. Over half of women are already at stage 3 or 4 when they're diagnosed, and because of that, only about 50% of women diagnosed with ovarian cancer will be alive in 5 years. This concludes our discussion of ovarian cancer. In contrast to ovarian cancer, testicular cancers are often detected at an earlier stage because the symptoms are more easily noticed by the patient, and the cancer is in a more easily accessible location by physical exam. In this section, we'll discuss the presentation, diagnosis, and treatment of testicular cancer. Testicular cancer is generally a disease of younger men. The peak age of diagnosis is anywhere between 20 to 40 years old. The classic presentation of testicular cancer is the patient himself noticing a painless lump in his scrotum. And unlike ovarian cancer, most testicular cancers are diagnosed early because the area in question is so much more easily accessible to physical exam. So if you're presented with a patient who has a painless lump that they noticed themselves or that the physician noticed on physical exam, what is the next best step in making the diagnosis? Well, the correct answer is either going to be to perform transillumination, which is where you shine a light through the mass to see if it is solid or if it is cystic, transmitting light, or to perform a scrotal ultrasound. And scrotal ultrasound gives you the same information. It tells you whether the mass is solid, in which case it would be more concerning for cancer, or whether it's cystic. And cystic masses typically will mean that the diagnosis is one of the others on the differential. So what other diagnoses can be confused with testicular cancer? The most common ones are infectious, something like epididymitis, or an infection from either a UTI or an STD, a hematocele, or a varicocele. And again, you can tell these three apart from testicular cancer because they will have positive transillumination, light will transmit through these masses, and they will be cystic on scrotal ultrasound. So once you've recognized the classic presentation and you've performed your initial tests to confirm your suspicions that this mass is indeed cancerous, what do you do to confirm the diagnosis? Well, like with most cancers, you want tissue to examine under the microscope. So the difference between testicular cancer and other cancers is you don't want to do a biopsy of a testicular mass. Anytime you see a solid mass on ultrasound or it doesn't illuminate light on transillumination, what you want to do is to remove the whole testicle in question. The approach to this is called an inguinal orchiectomy. It's important not to cut the scrotum during this excision because it can spread disease and seed unaffected skin and soft tissue with cancer cells. For the same reason, you will never do a needle biopsy on a suspected testicular mass. The same thing can happen if you stick a needle into an area that contains cancer cells. As you retract the needle, you're going to seed cancer cells all along the route that the needle's taking. There are certain tumor markers that can be helpful in the diagnosis and prognosis of different testicular germ cell tumors. Diagnosis is best made by examination of the cancer cells under the microscope and identifying the cell of origin. However, these tumor markers can help with prognosis, higher is typically worse, and with detecting recurrence after surgery and/or chemotherapy. Some medical oncologists follow these tumor markers after each cycle of chemo to monitor response to therapy and to decide whether or not to continue or change agents. Seminomas have a normal alpha-fetoprotein, but can have an elevated beta-HCG. LDH is not specific to seminoma, but it can correlate with extent of disease burden. Non-seminomas have different tumor markers depending on type. Yolk sac tumors, also known as endodermal sinus tumors, have elevated alpha-fetoprotein but normal beta-HCG. Embryonal, choriocarcinoma, and teratomas can all have both alpha-fetoprotein and beta-HCG levels elevated. Once the diagnosis of testicular cancer has been made, and the tissue has been looked at under the microscope by a pathologist and the exact histologic type of cancer has been determined, the next best step is to perform a staging workup. The best staging exam for testicular cancer is a CT scan that includes the abdomen, pelvis, and chest. And this is because lymphatic channels in the retroperitoneum are the first place that testicular cancer spreads. And those channels lead right up into the chest and mediastinum and can allow the testicular cancer to spread rather quickly. Here we have a CT scan in which you can see a large mass in the retroperitoneum that actually encases the abdominal aorta. This is a classic pattern of spread for testicular cancer. The treatment of testicular cancer is largely surgical. Remember that once a testicular mass is concerning for testicular cancer, the next best step is to perform an orchiectomy. So, in that case, an orchiectomy is actually both diagnostic and therapeutic, because remember, a biopsy is never appropriate in a testicular mass concerning for cancer. Now, once the testicular mass is taken out, examined by a pathologist, and the type of cancer is determined by looking at the tissue under the microscope, the patient may or may not need radiation as part of their regimen to treat any local disease left behind at the tumor bed. Chemotherapy is often included in the regimen as well because it acts systemically to treat any disease that's spread throughout the body through the lymphatics to other sites. It's important to remember that in contrast to ovarian cancer, testicular cancer actually has a pretty good prognosis, and that's because the site of disease is easily accessible to palpation by the patient himself and to healthcare providers, so it's usually diagnosed pretty early. 3/4 of men have local disease at diagnosis, and that means that there's actually a 90% cure rate when the disease is caught early. And even if it's not, testicular cancer is actually one of the only cancers in which chemotherapy can actually cure widespread metastatic disease. So even a man who has lung or even brain metastasis at diagnosis can be cured with chemotherapy. And this concludes our section on testicular cancer. In this section, we'll cover the prevention and early detection of cervical cancer, its clinical presentation, and treatment. Although the oncologic community has made great progress in the last few decades in the treatment of cancer, our biggest gains in preventing death from cancer has actually been in either preventing cancer from arising in the first place by identifying major risk factors, or in performing effective screening to catch cancer when it's at an early, non-invasive, and more easily treatable stage. Now, there's no better example of this than cervical cancer. The more we understand about cervical cancer, the better we realize that almost all cases are associated with an infection with the human papillomavirus. Particularly, serotypes 16 and 18 are very likely to cause cervical cancer. Therefore, in the last few years, there's been a lot of attention in developing and promoting a vaccine against the human papillomavirus. It's recommended that this vaccine be given to all women between ages 11 and 26, and the vaccination of men is in discussion now as well. All the vaccines against human papillomavirus include serotypes 16 and 18 because they're most commonly associated with cervical cancer. Some vaccines also include the serotypes 6 and 11, which are more associated with genital warts. Now, aside from prevention, early detection is the other cornerstone in preventing death from cancer, and cervical cancer is no exception. The rate of death from cervical cancer has declined sharply since the routine initiation of Pap smear screening. There have been a lot of back and forth and changes of opinion in when Pap smear screening should start and how often it should happen, but the most current guidelines, the most current recommendations, which are what you'll be tested on the Usmle Step 2, include the initiation of Pap smear screening starting for women at age 21. Now that's regardless of sexual activity. The frequency is recommended to be every 2 to 3 years until the woman reaches the age of 65 or has a hysterectomy without evidence or history of prior cancer. The results of a Pap smear can range from totally normal cervical cells all the way to frank cancer. In the middle of the spectrum include different degrees of dysplasia or abnormality in the cervical cells themselves. The most common abnormal Pap is a finding called atypical squamous cells of undetermined significance, or ASCUS for short. So, what happens when a woman has ASCUS on her Pap? Well, the next best step is to perform HPV testing. If the ASCUS is HPV positive, the next step is to send the woman for a colposcopy and to perform a cervical biopsy to get more cells in order to get more information on whether or not a pre-invasive form of cervical cancer is present. If the ASCUS is HPV negative, the woman can go ahead and come back for a repeat Pap smear in 6 months to make sure that the ASCUS has resolved or hasn't progressed into a more high-grade dysplasia. In addition to ASCUS, further along the spectrum of cervical dysplasia include low-grade and high-grade dysplasia. If these findings are found on Pap smear, the woman is sent directly for colposcopy and biopsy of the lesion. Now, it's important to remember that the finding of ASCUS doesn't necessarily mean the woman has cancer or definitely will develop cancer. It can simply be a false positive, and the younger a woman is, the more likely it is that the ASCUS is a false positive. It's also important to remember that although the Pap smear has decreased the deaths from cervical cancer and helps detect it early, all in all, it does not lower mortality as much as other screening tests such as mammography or colonoscopy. Most cases of cervical cancer are detected when the woman is asymptomatic based on her abnormal Pap results, as we discussed previously. If the woman is symptomatic from her cervical cancer, the common presenting symptoms are most likely to be abnormal vaginal bleeding. The hallmark or the key words to note in a clinical vignette are postcoital bleeding, or bleeding after sexual intercourse. Other symptoms from cervical cancer can include abnormal vaginal discharge, a dull pelvic pain or a sensation of fullness in the pelvis, as well as dysuria. If cervical cancer is caught early, before it's spread beyond the pelvis, the treatment of choice is hysterectomy. Here we see the surgical cuts made in the removal of the pelvic organs. A hysterectomy removes not only the uterus, but also the perimetrial tissues that flank the cervix, as well as the upper portion of the vagina. If cervical cancer is diagnosed at a more advanced stage, where it's spread to the lymph nodes or other areas in the pelvis, surgery isn't enough. Radiation, with or without the addition of chemotherapy, gives the patient her best chance of cure in more advanced cases. In cases of widely metastatic disease, where disease is spread beyond the pelvis, unfortunately a cure is not possible, but chemotherapy and radiation therapy can be given to control the symptoms of the cervical cancer and to improve the patient's quality of life. And this concludes our section on cervical cancer.
The key to answering the questions for infectious diarrhea is there blood or white cells in the stool, or is there no blood or white cells in the stool? When you see blank blank in the history, the answer is. When you see poultry in the history, then the answer is salmonella, chickens and eggs and chickens. It hasn't changed. Campylobacter, most common thing in the history will be Guillain-Barré. It's associated with Guillain-Barré, and you can't identify it to a particular food too easily. E. coli 015787. When you see hemolytic uremic syndrome, don't expect them always to say hemolytic uremic. They'll probably describe it to you. Say, hey, there's fragmented cells and low platelets and high BUN and creatinine. Fragmented cells and low platelets and high BUN and creatinine. The answer is most likely hemolytic uremic syndrome. And the second most common thing associated with the hemolytic uremic is Shigella. Shiga toxin does it too. So these associations are important, but they're not as important as the question, is there blood in the stool or white cells in the stool? Blood and white cells. Blood or white cells. Blood and white cells. Either one or both help you to know it's Salmonella, Shigella, Yersinia, Vibrio parahemolyticus. That's how you know. So the individual presentation is more important than the history of what you ate. When you see shellfish in the history, the answer is most likely Vibrio vulnificus or Vibrio parahemolyticus. Shellfish, liver, and skin disease is Vibrio vulnificus. Now, liver disease in general, alcoholic cirrhosis, Wilson's disease, hemochromatosis, predisposes you to Vibrio vulnificus. The Vibrio vulnificus causes bullous skin lesions. Hemochromatosis and blood transfusions, that one particular type of liver disease, Yersinia, is frequently associated with that because Yersinia grows in cold, like blood transfusions, and also likes to eat iron. Antibiotics in the history in both white and red cells. Now, it won't determine a specific organism, but it will tell you that you're in the Salmonella, Shigella, Yersinia, E. coli, Vibrio vulnificus, Vibrio parahemolyticus group, the Salmonella or Campylobacter group. Stool lactoferrin. Well, I expect that some of you, this is the first time you're hearing this, and lactoferrin actually has greater sensitivity and specificity than stool leukocytes. Yeah, lactoferrin, if it's in the choice with fecal leukocytes, if it's one of the choices, it's actually a better answer than fecal leukocytes. Wowie gazowie! And of course, the most accurate is stool culture. How do we diagnose the etiology of diarrhea when there's no blood and no white cells in the stool? It could be viral. It could be giardia. Now, in giardia, you should be looking for a person who's on a camping or hiking in unfiltered fresh water. Cryptosporidiosis is almost certainly exclusively an HIV and sometimes in outbreaks, but it's a sign of an opportunistic infection in very far advanced HIV. The test is an acid-fast
stain, a modified acid-fast stain. The most common wrong answer is expecting to see it on the ova and parasite exam. You cannot see it on the ova and parasite exam. Bacillus cereus is associated with vomiting, never has blood, never has fever. Staphylococcus is the same thing. These preformed toxins are associated with a mild self-limited form of vomiting and diarrhea. Scombroid is a histamine fish poisoning. It's very rapid in onset, and it's associated with wheezing and flushing and rash. It's found in fish, and you treat it with antihistamines, and it can happen 10 to 20 minutes after you eat it.
What's the best initial therapy? Well, it depends on the severity of the disease. The best initial therapy for mild disease is simply oral fluid, Gatorade, salt, sugar, liquid. Just water them, they'll be fine. Now, severe disease is treated with the fluids and a quinolone, fluoroquinolone, ciprofloxacin. Now, that's because at the time you're making the treatment decision, you never have the organism. So you can talk about, gee, wouldn't it be great to use erythromycin for Campylobacter? That's true. But how do you know it's Campylobacter? You don't know. See, the problem with this is that infectious diarrhea, when it gets taught by basic scientists, they teach you based on the time course. They say, oh, wow, 2 to 6 hours after you eat it, you get a Staph aureus, and 12 and 24 hours, you get other infections. But how do you know when the thing is that you ate that caused the disease? You don't. All you know is there blood or no blood, white cells, no white cells, and the severity of disease. That's all you know. Blood, white cells, and severity. Severe disease basically means that you are hypotensive and tachycardic, you have a fever, abdominal pain, you have blood in it, metabolic acidosis, because the colon is a bicarb secreting organ. So if you have severe infectious diarrhea, it means that you have all of these things. And this is when you're going to give antibiotics. Now, you don't have to have every single one of them, but you would have to have 2 or 3 minimum. Just having tachycardia or just having a fever is not enough, or just having abdominal pain. And don't worry, it'll be clear. They'll give you a bunch of it, and then you say ciprofloxacin or fluoroquinolone. Now, disease-specific therapy for the things not covered by the quinolones, such as Giardia, for instance, is not covered by quinolones, metronidazole, tinidazole. Well, this is why you have to know the diagnostic test, because for Giardia, this ciprofloxacin and quinolones you'd use for empiric therapy won't cover Giardia. That's why you have to know. Ova and parasite exam, stool ELISA antigen. 1 stool ELISA antigen, better than 3 ova and parasites for Giardia. Cryptosporidiosis, that's why you have to know about the acid-fast stain. Other than that, how would you know what to treat them with? Now, this is something that many people get wrong. Nitazoxanide is a specific therapy for cryptosporidiosis. You treat the underlying AIDS and nitazoxanide. Now, this drug has been around for about 3-4 years at this point and is eligible. And also, not is it eligible, you will start to see it because this is a unique drug. For decades, we've never had a drug for cryptosporidiosis. Now we do. Nitazoxanide is how you squeak out your 265. There's no specific therapy for viral diarrhea, and neither is there for Staphylococcus nor Bacillus cereus. Just fluid support is needed, and that's it. Learn that nitazoxanide. Look it up. Become a 30-second genius.
We will now move on. If he is truly unresponsive, start chest compressions and give rescue breaths. After the patient has been shown to be unresponsive and EMS is on the way, the next step is to open the airway, head tilt, chin lift, jaw thrust, check for a pulse and start compressions if pulseless. Give rescue breaths if not breathing. Remember, CPR doesn't restart the heart. CPR keeps the patient alive until cardioversion can be performed. The precordial thump has been sensationalized by TV. But when is it the correct answer? When there's been a very recent onset of arrest, that means less than 10 minutes with no defibrillator available, or you know it's recent because you saw it and witnessed it yourself. There are 4 major arrhythmias that can cause a sudden loss of pulse. The first is asystole, ventricular fibrillation, ventricular tachycardia, and pulseless electrical activity. The best initial management for all forms of pulselessness is always CPR, CPR, CPR. When presented with a pulseless patient who is in asystole, besides CPR, the best therapy is epinephrine. Vasopressin is an alternative to epinephrine. What they do is they constrict blood vessels in the tissue and raise your blood pressure. They also shunt blood to critical central areas, such as the heart and brain. The best initial therapy for somebody in ventricular fibrillation is an immediate unsynchronized cardioversion followed by CPR. Unsynchronized equals defibrillation always. Why is that? Well, generally, all electrical cardioversions should be synchronized to cardiac cycle, except for VFib and pulseless VTAC. The reason is in VFib, there is no organized electrical activity to synchronize with, so shock them right away. Only VFib and VTAC without a pulse get unsynchronized cardioversion. Everybody else needs to be synchronized. Now here's an example of a 12-lead EKG with a patient in ventricular fibrillation. Notice there's no organized electrical activity. After an attempt at defibrillation, the most appropriate next step in management is epinephrine or vasopressin, then follow with another shock. Medications do not restart the heart. They simply make the next attempt at a defibrillation more likely to succeed. Amiodarone and lidocaine is given to try to get subsequent shocks to be more successful, and magnesium is given with ventricular arrhythmias without waiting for a level. Lastly, remember, beryllium is always the wrong answer on the Usmle. Ventricular tachycardia is a wide complex tachycardia with a regular rate. The management, however, is based purely on the patient's hemodynamic status. If they have pulseless VTAC, you manage it exactly the same way as if they were in VFib. If they're hemodynamically stable and having VTAC, start with amiodarone, then lidocaine, then proceed to procainamide. If all medical therapy fails you, then cardiovert the patient. Hemodynamically unstable VTAC is managed with electrical cardioversions followed by medications such as amiodarone or lidocaine. Remember, VTAC is managed with shock and drugs and CPR at all times in between the shocks. This short run of non-sustained ventricular tachycardia is very evident by its wide complex and regular rate on the 6-lead rhythm strip. What qualifies somebody as hemodynamically unstable? Chest pain, shortness of breath, hypotension, confusion. If they have these, they're not perfusing. These qualities of instability are the same for all rhythm disturbances. And a little quick tip, if you're ever given the answer choice to give direct intracardiac medication, that's always the wrong answer. Pulseless electrical activity, or PEA, is the rhythm formerly known as electrical mechanical dissociation. This means that the heart is electrically normal, but there's no motor contraction. In other causes of PEA, the heart may still be contracting, but without blood inside, there will be no meaningful cardiac output. Here's an example of pulseless electrical activity on a V2 and V3 rhythm strip. We synchronize the delivery of electricity and cardioversion of VTAC to prevent worsening of the arrhythmia into something like ventricular fibrillation or asystole. When you have PEA, look for a normal EKG and no pulse. To treat someone in PEA, you must always correct the underlying cause. The causes of PEA can be tension pneumothorax, the H's, hypovolemia, hypoglycemia, hypoxia, hypothermia, metabolic acidosis, and look at this, hyper or hypokalemia can cause PEA. A massive PE could do it, as well as a tamponade. Atrial rhythm disturbances are rarely associated with hemodynamic compromise. This is because cardiac output is dependent upon the ventricle, not the atria. Look for the following findings in the history to suggest someone is having an atrial arrhythmia. The first is palpitations, dizziness, lightheadedness, exercise intolerance, or dyspnea. And lastly, if they had an embolic stroke, you got to look at the heart as the source. When reading the vignette, if you come across irregularly irregular rhythm, this suggests AFib as the most likely diagnosis even before the EKG is done. This is because AFib is the most common arrhythmia in the United States. Atrial fibrillation and atrial flutter are two disorders with nearly identical management. So how do they differ? Well, atrial flutter is a regular rhythm, whereas atrial fibrillation is irregular. Lastly, atrial flutter is extremely indecisive. Sometimes it can change into sinus rhythm. Other times, it can bounce into fibrillation. Here's a 12-lead EKG with somebody in atrial fibrillation. Notice the irregular rhythm. Here's a 12-lead EKG of somebody in atrial flutter. Notice how there's a sawtooth pattern and a regular rate. Hemodynamically unstable atrial arrhythmias are managed with synchronized cardioversion. The reason for synchronization is to prevent the electricity from being delivered during the refractory period. That period is the STT wave. Synchronization also helps prevent deterioration into VTAC or VFib. Hemodynamic instability, as it is defined for VTAC, is hypotension, confusion, development of CHF, or chest pain. By definition, chronic atrial fibrillation is defined as lasting for more than 2 days. However, after 7 days, there is a risk of clot formation, but routine cardioversion is not indicated. The majority of those who are converted into sinus rhythm do not stay in sinus. Atrial fib and flutter are caused by anatomic abnormalities of the atria from hypertension or valvular disease. Shocking the patient into sinus rhythm does not correct a dilated left atrium. Over 90% of these patients will revert to fibrillation even with the use of antiarrhythmic medications. Therefore, rate control and warfarin for anticoagulation is the standard of care for AFib. Chronic AFib should be anticoagulated before cardioversion. Unstable, acute disease does not need anticoagulation. The best initial therapy for fibrillation and flutter is to control the rate with beta blockers, calcium channel blockers, or digoxin. Our goal heart rate is less than 100. The next step after rate control is to give warfarin until the INR is between 2 and 3. So remember, slow the rate and anticoagulate. Lastly, rate-controlling drugs do not convert a patient into sinus rhythm, so if you're given this as a choice, don't choose it. The 2 calcium channel blockers used to control heart rate with atrial arrhythmias are diltiazem and verapamil. This is because they actually block conduction at the AV node. The other calcium channel blockers only control blood pressure. Remember, no matter how much you might think it's better to shock every patient to sinus, it just doesn't work in the long run. Without anticoagulation, there will actually be about 6 embolic strokes per year for every 100 patients, thus a 6% a year stroke risk. When the INR is actually maintained between 2 and 3 reliably, the rate drops to 2 to 3%. You need to use heparin before warfarin only if there is a current clot in the atrium. Remember, there are 2 new drugs on the market, dabigatran and rivaroxaban. They may show up on your exams. These are alternatives to warfarin. They are for non-valvular AFib. And the great thing is, you don't need to monitor the INR. Atrial fibrillation is caused by anatomic cardiac defects that dilate the atrium. These defects do not go away with cardioversion. That's why the vast majority revert. Many patients with acute AFib from alcohol use, caffeine, cocaine, or transient ischemia will simply convert back to sinus rhythm on their own. Therefore, acute disease normalizes spontaneously, so don't force it. And chronic disease reverts into arrhythmia as well, so don't force it either. Atrial rhythm problems can cause acute pulmonary edema from the loss of atrial kick in those patients with a pre-existing cardiomyopathy. Patients with a low risk of stroke can have their embolic phenomenon safely prevented with using aspirin rather than warfarin as an anticoagulant. If the annual risk of stroke is only 2 to 3% per year, there's no point in subjecting them to the 1% a year risk of major bleeding. This is called the CHAD score. It stands for congestive heart failure, hypertension, age greater than 75, diabetes, and a prior stroke or TIA. Anyone with a CHAD score greater than or equal to 2 should be on warfarin, dabigatran, or rivaroxaban. Major bleeding from warfarin is defined as having an intracranial hemorrhage or at some point requiring a transfusion. The criteria for low risk of stroke from AFib, that means to be able to use aspirin, you must not have cardiomyopathy, congestive heart failure, or atherosclerosis, no hypertension, an age less than 75, no diabetes, no stroke in the past. Thus, the answer for management of lone AFib is rate control, but you can use aspirin as opposed to warfarin or dabigatran. Supraventricular tachycardia presents with palpitations in a patient who is usually hemodynamically stable. The best initial step is vagal maneuvers, such as carotid massage, valsalva, dive reflex, or ice immersion. If those don't work, proceed to adenosine. Remember, adenosine can only be therapeutically used for SVT. This is then followed by beta blockers such as metoprolol, calcium channel blockers such as diltiazem, or digoxin if adenosine is not effective. Here's a 12-lead EKG showing no P waves or fibrillatory waves. The QRS is less than 100 milliseconds, and the rate is 160 to 180. The complexes are narrow. This fits SVT. Wolff-Parkinson-White is an anatomic abnormality in the cardiac conduction pathway. They're going to present it to you with 3 different scenarios. The first is SVT alternating with ventricular tachycardia. The second is SVT that gets worse after diltiazem or digoxin. And last, if you see a delta wave on the EKG, click Wolff-Parkinson-White. Remember, vagal maneuvers slow and convert SVT. They don't work at all with atrial fibrillation. On this 12-lead EKG, we notice a short PR that's less than 120 milliseconds and a delta wave at V2 and V3. This is classic Wolff-Parkinson-White syndrome. Remember, the short PR is due to early depolarization of the ventricle. The most accurate test for Wolff-Parkinson-White is cardiac electrophysiology studies. Procainamide or amiodarone are both useful for atrial and ventricular rhythm disturbances. Use them only if Wolff-Parkinson-White is currently presenting with an arrhythmia. Radiofrequency catheter ablation is curative for Wolff-Parkinson-White. The tip of the catheter is heated and simply ablates or eliminates the abnormal conduction tract around the AV node. EP studies actually tell you where the anatomic defect is. Digoxin and calcium channel blockers are dangerous in Wolff-Parkinson-White. They block the normal AV node and actually force the conduction into the abnormal pathway. Multifocal atrial tachycardia is associated with chronic lung diseases such as COPD. Job 1 is always to treat the underlying disease. For the rhythm, treat MAT as you would AFib. But remember, avoid beta blockers as they are detrimental